Good morning, everyone. I am Sophia, created by Keeney Think Tank, and welcome to CCC Symposium 2026. Thank you all for joining us today and for being part of this ever-growing symposium. It is wonderful to see so many colleagues, faculty, and guests come together for another year of learning, discussion, and collaboration. We are honored to be joined by Dr. Annapurna Keeney and Dr. Samin Sharma, who will be leading the cases, and Dr. Roxana Mehran, who will be moderating the event. Their leadership and expertise continue to shape CCC into the outstanding and growing program it is today. As CCC continues to grow year after year, it remains a unique forum for sharing knowledge, exploring complex coronary cases, and advancing the field together. Thank you again for being here. We're delighted to welcome you, and we look forward to an engaging and inspiring program.
Started with the AI symposium, cardiology. Let's come out. You go first. Well, I'll have my share a little later. Welcome all of you. That this time, although the numbers were better compared to last year, but attendance in the room at 8 o'clock is definitely slightly slimmer than last year. Hopefully, it is just the matter of traffic, but we'll see. But anyway, still, I would say a lot of people here, but we want this house full. Because I was thinking to make a bigger room for the next year, but it might put a dampen in my enthusiasm if this remains the attendance. But most important, as everybody has said here, in our AI generated as well as the voiceover, that we try to do, of course, the top lectures with the key faculty, you have it, everybody's bio is there, and the topics. That is what we always hear from our attendees, that they want to hear the latest in the, not only interventional cardiology, other topics. And that's what Roxana Mehran puts together, special sessions, and bring those special topics which are interest and everybody wants to learn. With that, and of course, the key will be those 9-10 cases which we'll perform right from start to finish, not just showcase. And that has been our hallmark, that show step by step. Cases will be done, of course, by Dr. AK, we call it, Annu Keeney, and myself, and with a lot of our assistants and fellows, all are backbone of this program, which still remain number one in our intervention. Only thing is the safety. Last data we have 2019. Nothing has been published from New York State yet. Hopefully, they say that there was a gap of the COVID, and soon they will come, the data of 22, 21 half, and 22. That 1.5 year of the COVID will be eliminated from the data reporting. That has happened to many other services, many other organizations also. With that note, I'll just ask my colleagues to just make brief comment, and we will start the day with our same top 10 advances in interventional cardiology.
Good morning, everybody. I know despite we are saying the great thing was we have made it to this place, and I'm going to be very brief, saying yes, newer technology, newer technique will be shown with the AI assistance, because that's going to be the future. But of course, we have Dr. Roxana Mehran, who is the current ACC president, starting and leading this session.
Thank you. Good morning, everyone, and welcome to the 29th annual CCC Live. I have been involved here, and this is my 17th year working with Drs. Sharma and Kinney at Mount Sinai side by side, and really observing the kind of work that's being done in absolutely not just performing procedures, but teaching the next generation. And this kind of training is really, really incredibly unique, that is experienced at Mount Sinai and shared with the entire world. And this is what CCC Live is about. There is one thing that AI will not take over. It will not take over the personal connection of performing procedures, but it will enable us to do things better, more efficiently, and much more precisely. And that is sort of what we are going to see. Dr. Kinney and her think tank has done a lot of work in enhancing and incorporating AI in pretty much everything that we do, including introducing our luminary speakers here today and also beginning this work. CCC Live and what we do in that first session, bringing in the luminaries of the world to tell us what is going on. The lens to the future of cardiovascular disease will be evaluated this morning on so many levels with our incredible speakers and the incredible work that's been done by them and their colleagues in enhancing and reducing the global burden of cardiovascular disease. We are in the bottleneck of performing procedures, but also saving lives for acute coronary syndromes and acute MI and shock patients. These should not be left undone, and improving the quality of life of patients with the procedures that are being done, and of course, marrying that to the prevention that needs to happen immediately as we have contact with these patients. This is what CCC Live is all about. I hope you're as excited as I am. This is the 29th year. Just wait to see what we have planned for you for the 30th year anniversary. Welcome to CCC Live.
All right. We have one more small event, if you can show the slides. So everybody who could be wondering what is KTT, which is Kidney Think Tank. You see this little logo pin. This is me, profile with the brain, what we do. So this is a small group of people, we say. To become a member, you need to show dedication to innovation in the cath lab, which includes research, education, digital transformation, which we'll talk a lot later on, procedural guidance, and personalized care. And we had one of the patients, Samuel Feynman, who donated, philanthropy. We have an artificial intelligence research lab right now in the cath lab. Now the question is, how can you become the member? So every member, we meet once a week, talk about various projects. They get this pin. You see this pin? This is the pin. But then we want to go to the next step. We have a VIP member today. If you can see here, this is a special pin made in India. It's an 18-karat gold with diamonds and all the precious gems. So that's where we are. We are getting in, but make sure you attend our meeting. We'll get you a solitaire. Okay, so now that's where we are. Welcome, Dr. Sharma, to our KTT group. Okay. Thank you.
All right. Okay, so now we start the daily, our session, and hopefully...
My dream was to disseminate this technique.
No, one second. What is going on, guys? We make sure somebody paying attention. We have to start the presentation from here. Okay, as usual, top 10, 20, 25, 26, and it was very interesting. We actually was in Las Vegas in one of the common conference, which I go every year, and Paul Tierstein was there, and Paul was, before I went to the stage to talk, he said, you know what, I learned from the YouTube with your very beautiful jacket from last year. I said, well, I can tell you, Paul, in this today's presentation, maybe 5 slides will be from last year. Everything else will be new, and that is what the purpose is. So yes, it's very busy, but in the end, I put it as a central figure, but key is that try to present all the latest data. With that note, we'll start entering another AI into our presentation.
My dream was to disseminate this technique of catheter-based percutaneous treatment of vascular disease, commonly called PCI, in awake patients by seeing one, doing one, and teaching one. Now, this field has advanced so much with the utmost safety MACE less than 1% at 30 days and less than 5% at 1 year. Less than 3% of cases were inappropriate, and more than 60% were appropriate. More than 60% of patients were discharged same day, and over 95% were discharged by the next day.
And next year, AI goal, you'll be surprised what we are going to do with Andrews Brunswick. You'll see. Just keep, I would say that AI in the background will be tremendous. This is all have been possible by AI and, of course, the KTT, as Anu mentioned. Okay, let's go over top 10, starting with the number first one, which is the MCS trials with the shock, L-shock, chip BCIS, STEMI D2U, 3 devices, balloon pump, Impella, and cardio health, which is ECMO. 2 trials of the ECLS shock and L-shock, one using the ECMO, other using the balloon pump in heart cardiogenic shock. Both basically showed no difference, rather a little more vascular bleeding. And that actually we learned has happened. And now, biggest topic was, when do we use more mechanical circulatory support like Impella? Usually in the complex PCI. In the shock and all very small numbers. The real number is for the in the high-risk intervention, and that is what evaluated by BCIS. That's their CHIP BCIS 3. Remember BCIS 1 against balloon pump. BCIS 2 was the ischemic cardiomyopathy. Both were negative. One for balloon pump negative, the other one PCI was negative, and let's see what they have. Is it truly the population? EF less than 35%, significant coronary artery disease, randomized to balloon pump, Impella with our standard of care versus just standard of care, and truly complex cases with a low ejection fraction, high syntax score of 38. Only criticism was that many of these patients, or half of them, were in 3 and 4 heart failure. Patient with advanced CAD, of course, they may have unstable angina, but not that common. So that was one of the criticisms of the trial. Rest is all shown here. Bleeding, more intervention was done when you use the Impella, and associated with the major bleeding and vascular complication higher. This I put it together very simple way, that axial flow pump versus standard of care. You can see height of the red bar, and it turns out to be Impella did not do good what it's supposed to do. And more important, with the cardiovascular death was significantly higher in the Impella group, which is a surprise. The other thing was that at least Impella will prevent additional myocardial injury. And this was the periprocedural myocardial injury, which was defined as more than 20% increase on the baseline of your troponin levels, and even that didn't work out. So it was really surprised that how it failed. We know that bleeding and all those will be there, but this was a trouble. Then, this is both were presented in ACC. So I think maybe, we call it the planet position for Impella was not correct, because not only one, there is a second trial, which is the door to unload trial, which is a randomized trial with the concept that we open the PCI, we open the vessel, but then there is a lot of edema and increased diastolic pressure, and therefore infarct size increases, and we know that is associated with subsequent bad outcome. So what if the reperfusion injury and free radical and LV distensions are taken care before you do the PCI? And that was the concept. They put the Impella for half hour. Wait, patient having ST elevation MI, but you are not doing anything, you just put the Impella. Compared to other group, you start the PCI right away, and this was the treatment versus control. Just want to tell you the pilot study, which was done for 50 patients, was negative. Despite that, they went ahead to this randomized trial. I predicted back then, this will not work, and actually, yes, there are additional time taken for PCI symptom to coronary balloon time, 212 versus 165, same 35-40 minutes, more in the treatment group that was expected with the guidelines. And what we found, at 1 year, no difference in mortality in both the groups, and you see the primary point was infarct size reduction, and answer was no, 30.8 in the Impella group and 31.9 in the control group. So basically, no benefit. We know the vascular complications are higher, and those are the ones associated with the higher mortality. So key is, again, second trial, which was negative, and we know the guidelines basically are patient with a STEMI, with a refractory cardiogenic shock. You can put an Impella, which is a 2A, and of course, using ECMO or balloon pump is no good, which is a class 3. Now, for high-risk PCI, we have the guideline from the 2021 that in 2B, in selected high-risk patient, elective insertion of an appropriate hemodynamic support device as an adjunct to PCI may be reasonable to prevent hemodynamic compromise, although they don't say support device. Could be balloon pump or could be impeller. So key is we have the guideline of the 2B, and it's big trouble what's going to happen for high-risk PCI or the STEMI, stable hemodynamics, but we still have the hopes. Hopes will be this PROTECT 4 trial, which has been completed with 1,200 plus cases done in United States, globally actually, more than 100 countries. And this is the trial which typical case of the BCIS3. Complex disease, low ejection fraction, initially started with the 40, then became 30, and randomized to impeller versus control. 80+% people got the balloon pump in the control group, with the primary endpoint is composite rate of all-cause death, stroke, durable LVAD or transplant, MI or cardiovascular hospitalization for 3 years. Not the re-PCI, but hospitalization. And this trial, as I said, completed, need to have a last case 1 year, which is now. Yesterday we completed last case. We did the first case and the last case with the highest enroller in the trial, and it was done on 16th of June. So 1 year now, and now the data have to be put together. Will be at least 2.5 year follow-up of the average patient. Will be likely to be presented in ACC, but that we need to see. So the field is not gone yet, although just to say how impact these trials are, since the BCIS2 trial 3 was presented in March, April time, the volume of the impeller cases had reduced by 50% in America. Just everybody feel that now we don't need it. Maybe we don't need it, but we'll know. Second is immediate versus stage, complete revascularization in MI. What does that mean? We learned over the years, multi-vessel STEMI PCI, we do culprit or complete. Remember, 20 years ago, we used to say do culprit only. Then we did multiple trials to answer that question, that complete revascularization is better. Then we came with now you had done complete, now you do stage, do the culprit, discharge, and bring back the patient, or do during same hospitalization. And that we did the trials. There are few of them, All-Star, BioVasc, basically showed that the waiting for the stage PCI, the patients come back with MI. So therefore, try to do at the same time, the same hospital admission. Now, question was, do you same hospitalization, do you do at the time of culprit vessel PCI, which we have never done? Or you do it stage PCI during the hospital stay. Culprit followed by stage within 2-3 days when patient is in the hospital. That was the question needed to be answered, and that was done with the option STEMI trial done in Korea. So answer was same, that patients, you do PCI, all of them on day 1, or you do it day 2, 3, but during same hospital admission. And as you can see here, the overall revascularization of the non-culprit vessel was about equal. Of course, you did a more, the contrast use when you did it the primary way, and although length of hospital stay was 1 day higher when we did the stage, because stage was done 3rd and 4th. And guess what we found? Height of the red bar is the immediate complete, blue bar is the stage complete, and you see nowhere the stage complete revascularization group was bad. So compared to immediate was, although non-statistical, but clearly had a higher event rate, numerically higher compared to stage complete revascularization. And you can see the bleeding and other things were not different. There was slightly higher CIN. Why? This is what Roxana had taught us over the years, that you do contrast exposure. Within 7 days of the first one, you'll have higher CIN. And that exactly was seen in this trial, but also they found some subgroups where it was even worse than that. That is, if patient were in heart failure. CLIP classification, 1, 2, 3, patients who are elderly, and those who have multi-vessel disease. So it turns out to be, then what is the benefit? So overall you can say, do not do the additional PCI at the time of culprit, just wait 2 days or so, maybe don't wait 3 days so the length of stay does not increase. The third one is the DCB strategy. DCB came to United States about 2 years ago with the agent from Boston Scientific with paclitaxel. All the drugs are being used now. Sirolimus trials are ongoing, and of course, everolimus, biolimus, whole benefit of DCB we know, short DAPT, no issue of stent thrombosis, less inflammation, less side branch closure, can be done for ISR as well as for native vessel. And the trial which led to approval of the agent by the FDA was the agent ID trial, which was done for ISR patient, which was the DCB versus balloon angioplasty, not the stent. balloon angioplasty, we'll know when your DES ISR, what is the class 1 recommendation by our guidelines? Read DES, but that was not the part. Part was compared against the balloon angioplasty agent DES, and then what was positive, and I'm just showing the second part of the subgroup stratification, that when you have more than one layer or two layers, stent multi-layer or two-layer, single layer, and basically showed with the multi-layer you have additional benefit compared to single layer of the various outcomes. So more the layers, the DCB did better. They didn't show third or three or four layers what the outcome will be. Second drug, which is just around the corner, we are expected to have approval today. Would have used it, but no, they say it's delayed, of the sirolimus, the solution SLR, at least for about they say about 6 weeks. But this is the special, same. Everybody felt that you cannot have paclitaxel because the lipophilic is good, but sirolimus may not work, but they have the whole biodegradable polymer and proprietary phospholipid coating, so dissolves and goes inside the vessel wall, and it has shown the initial good data. And we did the trial, and I was the lead enroller in this trial of 400 patients, the solution DEB versus standard of care, in which 80% were stented. That is what we do. And the question we wanted to see that by putting a stent or the DCB, we did not do any harm to the patients. And this is where it comes out to be that yes, by solution DEB is standard of care in which 80% were the stent, there was no difference, and you see stent thrombosis were identical. Then this is now ISR. Now you go to the native vessel. Native vessel, first trial, which was in the large scale, was the RAC cage-free 1, which compared paclitaxel-coated DCB versus the sirolimus Firebird eluting DES. This is both Chinese product, made in China, and in the DCB group, 9% required stenting, and basically found now we have the data of the 3 years, and as you can see on this, the DCB on the blue and DES in brown, that clearly the DCB failed against the DES. And not only that, once you go to the individual vessel, in a small vessel were identical, kind of okay, but at the large vessel, event rate was 3 times higher. So you can say the DCB may work in the small vessel, but in the native large vessel, as used in this trial, did not do its job and should not be used, and you should go with the DES. Then common issue is the bifurcation. Bifurcation, so many times you put a stent, or you do just a drug-coated balloon, or just do a high-pressure balloon. So this is what the trial looked into, evaluated the stent of the main vessel, DES, and then side branch, either DCB or just non-compliant balloon, not another stent. Because many times we do, in a good bifurcation, we do 2-stent approach, but that was not the part of the trial. And this basically showed the DCB group had a lower event rate compared to the non-compliant balloon, and as shown here, overall outcomes were superior using the DCB. So you can make it a point. The left main was only 2%, so it's not you can do in the circumflex, but other non-left main bifurcation, want to use the drug-coated balloon is reasonable, and you'll see that demonstration today in 1 or 2 of cases. Then issue was, now we have the 2 drugs available, sirolimus and paclitaxel. Which one is better? We have one randomized trial called TIS2, and showed that whichever drug you use did not make any difference. P-value was all significant, no difference, except the second MACE. With sirolimus, that patient after procedure, they did whatever intervention, then they came back, and it seems to be that little more recurrence of the sirolimus eluting balloon. And they have the area in terms of the late loss and reference vessel diameter, and so they were kind of equal, but was not non-inferior. So sirolimus was okay. Based on this, I would say, if you want, once it will be available, our biggest reason will be availability is competition. You know what the agent DCB cost? $5,500. You know what is the cost of the regular balloon? $180. So we learn with the Cypher, 3,200, Texas became 2,500. When the Zions came, all stents became 1,200. So we are trying to hope that this competition will drive the cost. And this is what we do nowadays, lesion preparation, and then you decide good angiographic result, and whether you do angiography or hemodynamic or physiological testing, then you go with the DCB, and which is good for ISR, small vessel, side branch, and high bleeding risk patient. If angiographically does not look good, then you go with your stenting, and then in the DES you do imaging post, and of course with the DCB we try to avoid imaging in the end. Now we know the guidelines still remain that the DES is recommended for the re-DES is recommended for DES ISR, and drug-coated balloon also recommended, but DES is preferred until they change. Now, another thing which I wanted to add was multi-layer DES. We, of course, the brachytherapy and this whole field of radiation into coronary artery disease. Paul is the leader in his time using the gamma radiation. Now it's the beta. Only beta radiation is only available. We have published few papers in the past, and we were told lot of the letters were that it catches up. After 1 year, both will be equal. So that was the purpose after following paper which we had. The multi-layer, usually that's what we do, IBBT, only has to minimum 2 layers, and then follow them with a controlled treatment, and we found that there was no catch-up phenomena. And there is, if you even take from the 1 year time period, difference remain, although non-significant. So just to say that IBBT does work in appropriate cases with a multi-layer stenting already there. And we have no thrombosis because of the 700 patients plus we have done, only 1 case required re-stent. No stent at the time of the IBBT. And then very nice editorial by Roxana's team that one of the advantages of the DCB is simple, that you are not putting the second layer of metal. So there are a lot of other chances in the future which can be used, including brachytherapy and so. Then we go to number 4, angio FFR versus Doppler FFR. What does that mean? Clearly that with the AI, the data of the AI, over the years, last 15, 20 years, multiple trials of the FFR or guided PCI has shown that it is beneficial, became class 1 indication, and it is cost value is high cost value because repeat revascularization is lower. So this is what we had taught. And we do it with the wire. IFR without giving adenosine, with FFR giving adenosine. The what if? You can just do it by the angiogram with the use of your AI. AI can tell you FFR. Why? Because CT FFR, we get that anyway. CT, just by the CT angio, they don't put any wire, and we have the FFR of the CT. So what if you can do it based on the angiogram, which is various types of flow reserve. It has been approved, it has been incorporated in the guidance. See the QFR of the less than 0.8, which is done by the angio, not the physiological, just by the Doppler wire. QFR has incorporated in the guidelines. So what if you compare these two, that FFR done by the just angio versus your physiology done by the wire. And this is, what is the advantage? Because then you do multiple times. Many times we are reluctant after the PCI, do we check, we have to take the wire again, now wire is broken, disconnected, nothing. Just angiogram will tell you, do you check the FFR again, because that's just the software. And this is basically the FAST-3 trial was looked into this aspect of the patient VFFR versus FFR-guided revascularization, and outcomes were identical. So at least reassuring that whatever we are getting FFR based on the angio has similar outcomes to our FFR, which we did with the wire, and outcomes were similar at 1 year. Second trial, also, they all presented in ACC, was the angio-derived fractional flow. In this case, the FFR angio, coronary physiology versus same with the X-ray. FFR angio-guided, pressure wire-guided, protocol remain the same, less than 0.8 get the stent, more than 0.8 you wait. And what they found, again, no difference. And this is very important, but except that when we did our pressure wire, we have more time, we use more contrast, so it could be, once we this or validated, it has been in many trials now, and this is the CathWorks is one of the company which was taken up by another bigger company for $1.2 billion. And they just basically do this angio FFR. This is just amazing, but key is the angio FFR seems to be taking the stage in our interventional cardiology. So basically is not that it's going to replace our invasive FFR. When there is a questionable, you always have to answer with the invasive FFR, but more importantly, it can be done easily. So it's complemented and easily and can be repeated multiple times without advancing the wire and so. Okay, then we go to the plaque modification. Multiple trials have shown in last 1 year comparing various of these plaque modification devices, whether NC balloon, open NC, cutting balloon, angiosculpt, rotablation, orbital, laser, lithotripsy, all have their own use and niche. And question is which one is better versus other. And there are few trials. I'm just going to go briefly to understand. One of them was RA, IVL, and ELCA. When this calcific lesion, 10% required second device. Procedure success was very good. complication were lowest with the IVL, and when you compare the rota versus laser, laser lost. Rota versus IVL were identical, and same way was the minimum stent area that in case of ALCA was the lowest compared to other two. So basically what it learned, that IVL and rota equal, laser not good in patient with calcific lesion. Then another trial was IVL versus just high pressure balloon dilatation, which showed that your stent lumen much better with the IVL, and the primary endpoint that you are able to bring the lesion down to less than 20% was higher in the IVL group. So IVL was better than high pressure balloon in this trial. Then Eclipse trial, you are aware of the 2,000 patient comparing orbital atherectomy compared to high pressure balloon dilatation, and basically showed no outcome, no difference at 12 months, no difference in the stent area, and rather slightly higher complication of the slow flow and perforation in the orbital atherectomy group. But if you did the imaging did better irrespective of the whether you use OA or the balloon angioplasty. But overall says that OA did not work here. Then another question, this was a major trial in terms of the concept. Shortcut. Shortcut is using lithotripsy or cutting balloon. Many times you cannot use these devices because disease is very calcific and long. So whether you have a planned rota or no rota, then you randomize the patient to Wolverine or Shockwave, Wolverine and Shockwave in both the groups. So that's the concept we wanted to understand, that do we need these devices? Overall, because they take all the cases together, which is puts it together, IVL and cutting balloon was not similar, but you had to go deep down into the trial. And basically the trial is atherectomy cohort, as you can see here. Here you use IVL versus cutting balloon, MSA was identical. But if you're not did the rotablation, then non-atherectomy group, the IVL was superior to cutting balloon. So that's basically what we learned. And the cost-wise, clearly the cutting balloon was cheaper. But in this group, it was inferior. So you could say, if you're using a rota, after that you use IVL and cutting balloon doesn't matter. But if you're not doing a rota because that lesion is not that complex, then IVL will do a better job than the cutting balloon. There is another trial which looked into a double-layer open NC, which is the double-layer high-pressure balloon compared with the IVL, and turns out to be outcomes were identical because of the procedural success, which here, and rest of the outcomes were all open NC. IVL were all similar. IVL had non-statistically higher perforation rate was 3% versus 1% here, but overall seems to be did good with the procedural type. So again, another device, the open NC did as good as the IVL, which I put it here because there was no other room for this trial, very important trial to put in our top advantage. Over the years, it is a controversial. You have a discrete lesion in the, or doable lesion, I would not say discrete, doable lesion in the vein graft, and you have the 90%, 95% native vessel. Question is, which lesion you do? A lot of people prefer to do the native vessel compared to graft. So these are the type of cases were enrolled in this trial. Proctor, 108 versus 112. Only thing I want to say in the PCI group, many were CTO, 80+%. So 80+% were CTO. This is a kind of a more doable lesion. And what we found is, what our practice has been, we always went to the vein graft. And this is supported by this. You can see SVG PCI has a lower event rate compared to native vessel PCI. And particularly if you have too complex lesion, calcific, bifurcation, you go retrograde, you'll have more trouble compared to just put a stent in the vein graft. Although this data is only for 1 year, question is what will happen 2 or 3 years, we do not know. So let's go to colchicine acute MI. We know that multiple trials were done. Colchicine came up almost as a 2A guideline recommendation because worked in every case to decrease the MACE rate, work through the tubule. It prevents the tubular formation and positive outcome. Then the major trial was done called Clear Synergy. The patients, large number of patients, follow up to 5 years, colchicine versus placebo after STEMI PCI, and randomized to the drug after 2 to 3 days of the STEMI. STEMI, stenting, then 2 to 3 days later put a colchicine, and of course second part was the spironolactone. Colchicine decreased inflammation that appeared in this trial, but more important, outcome, identical. So all of that, we say that bubble of the colchicine burst. In this case, there's no, at 5 years, no outcome difference. Actually, in the some symptoms, colchicine caused major diarrhea and GI symptoms. So therefore, you can say that it didn't work particularly in patient with STEMI. Now, question always comes, why STEMI? Maybe that's the decrease, because they also work on the tubular cells, decrease vascular and endothelial growth factor decrease, and maybe that was the factor, and they gave very early. But this field is not going away. A lot of trials still continued in this colchicine. This is a trial for plaque volume, showed that at follow-up, where colchicine patients got lower plaque volume compared to if they did not receive colchicine. All right, now go to FFR trial, which has been a part of our bread and butter. FAME3 compared FFR-guided PCI with cabbage. 1 year, it was inferior to cabbage. Cabbage was better. At 3 years, kind of little p-value of 0.78, 0.7 in terms of death, MI, and stroke in favor of still cabbage. Then at 5 years, happy to report that overall major endpoint, primary endpoint, was no longer different at 5 years. So you say that you're doing a PCI, patient lives 5 years, so you're okay to do PCI in these non-left main patients, and of course other endpoints. But yes, you'll still have higher MI and higher repeat revascularization, similar type of data which we have from the Syntax trial. And more complex, the PCI, the lesion was higher Syntax score, cabbage did better compared to simple lesion where PCI was good. The flower MI, which is a follow-up of 3 years of a FFR-guided PCI in STEMI, and angiographic at 3 years showed no difference. So seems to be that acute MI, FFR may not be needed. Okay, let's go to next one, clopidogrel versus aspirin post-PCI. We know we give out 6 months, 12 months, or 18 months of DAPT post-DES. And what is our usual practice after that? We say stop the clopidogrel and continue aspirin lifelong, right? That's what our usually practice was. Unless somebody GI upset, we knew that clopidogrel better for the GI upset patient. So what if the randomized way that you do one versus other? So after the set duration, randomized to clopidogrel alone or aspirin alone? That's the really question we needed to answer. What we do after 1 year? And answer is very simple. The MACI is combined, but more importantly, that every aspect was lower in the clopidogrel group, individual endpoint of the MACI and the MACI itself, lower event rate, and also the bleeding was no different. The stroke was no different. Death actually was almost lower, just about p-value. But to say that alone clopidogrel, after, on the long term, did better compared to aspirin. And you know, remember, we always don't believe in, and also the aspirin caused more GI upset compared to clopidogrel, but we don't change our practice based on one trial. There is another trial which was presented, host exam. Now we have a 3-year data, has a similar message. That clopidogrel alone did better compared to aspirin alone. So this is now, let's get to antiplatelet with oral anticoagulation post-DES. This question was always there. And our practice, what our practice was and what we learned. What is our practice usually? After 1 year, initially we give clopidogrel with the NOAC, and after 1 year, we clopidogrel continue or we change it to aspirin. That has been practiced. We have our set orders in our cath lab. Is that the right approach? And this actually question was answered by 3 trials, but I'm going to show you 2, again presented. So just to say guideline-wise, there's no guideline what you should do after 1 year until now. Within 1 year, there are some variation. Give 6 months, 12 months, but don't give triple therapy. Some studies do say that maybe for 1 month or few weeks, high risk you can give triple, but should be dual antiplatelet therapy. But the question was, what do you do after 12 months? This was the first one was adapt AFib DES, AFib patient with a drug-eluting stent, and randomized to either continue the NOAC plus single antiplatelet therapy of clopidogrel or continue only NOAC. And I would have predicted that will be bad. This is a DS patient, we are not giving any antiplatelet therapy. How can it be? And answer is right here. From the randomized trial of the large number of 1,000 patients, that event rate of NACE, particularly death rate even favored the NOAC monotherapy. And of course, you have lower bleeding, we understand. No difference in stent thrombosis and even MI lower, so surprise. Again, as I said, we don't believe in the only one trial. We used to have more trials. This is the same way outcome showing that the lower bleeding, lower MACE, and that actually no higher event of the ischemic point. Second, another trial, aquatic trial. Now they took patient, all kinds who were on oral anticoagulation, not only the AFib patient, and they say that let's give aspirin or no aspirin. So these are the OAC, oral anticoagulation alone or oral anticoagulation plus single therapy of aspirin, and the answer was about similar. Actually, even more, that there was a mortality benefit. oral anticoagulation. Now this is the practice changing. What we always have been doing, we wanted some antiplatelet continue. And there is another Japanese trial had the same message. And of course, the bleeding we understand. But more important is the practice that by stopping aspirin, after 1 year of your patients who are on NOAC or OAC plus and single antiplatelet therapy, by aspirin or clopidogrel, you actually do better to the patient on long term. Now, these are the follow-up up to 2 to 3 years. Whether something will happen after 5 years, I do not know. But I can tell you, since these were presented last year in AHA, we have changed our practice in many of these patients that after 1 year, actually, when I presented data, some of the private practitioners said, that's what we have been doing. After 1 year, we don't give any antiplatelet therapy. That was a surprise to me, but we used to, and I'm sure each of you will have their own practice. Then the last one is, what is the last trial, which put a lot of controversy, and this just came out from American College of Cardiology meeting, is the imaging trials. And what the controversy is, which I'm going to show, because we have a lot of trials of the imaging over the years that do complex case, do a good imaging, stent expansion, no dissection, angiography can fool you, you can miss it, you should do imaging, whether the OCT, IVUS criteria all have been made, and because pre, post, or final, and then we have done so many trials in every part of the vascular tree in last 8 to 10 years, and everyone single trial, multi-center trials, all supported use of imaging compared to angiography alone. And this is a meta-analysis of the 20 randomized trial by Greg Stone, showing that that all endpoint of the Mackey are at least 20 to 50% decrease. Biggest thing is the stent thrombosis become half by imaging. So we were taught imaging is great, and that is what 2 trials were presented. One was the DK Crus 8 from China. A patient with a DK Crus got imaging-guided, IVUS-guided versus angio-guided PCI, and the IVUS-guided PCI had DK Crus has a significantly lower event rate compared to angio-guided PCI, although there was no difference in stent thrombosis. So we say, yes, we still learn, continue to doing imaging. The second, Renovate Complex trial, they presented 5-year data that imaging was better in these complex cases. Particularly, you do a good imaging. The good imaging-guided PCI with optimization had event rate of 9. If you do angio, was 14.9, in between was 11.7. So told that good imaging will decrease the event rate. We were taught that, we are all happy, lot of editorial. You cannot, many of the people who did not do the imaging in complex case felt guilty, as if we had committed the crime, even after the results are very good and you have very low complication. And I'm probably one of them, because my imaging numbers are always in single digit, yet have the best statistics of the New York State with a double star lower mortality. And this became the guidelines as class 1, both for acute coronary syndrome as well as for the chronic coronary syndrome, particularly complex cases, left main, bifurcation, CTO, and long lesions and so. Now, all of a sudden, what happens in our medicine is kind of breaks all the concept, what we are taught, learn over the years. And I say one of the simple one was the digoxin story. Digoxin in early 200s, and of course, Sean is here. I grew up giving digoxin to heart failure patient, and all of a sudden trials came, digoxin kills the patient because the new drugs came. So just to say that always something happens. And it happened with the 2 trials in the ACC. One was the IVUS chip. Chip basically means these are the complex cases. They have characteristics that what you need to do with the optimization, randomize about 1,000 patients to the PCI versus, of PCI, but imaging guided versus no imaging guided, and basically showed what? At 2 years follow-up, IVUS guided PCI, blue, numerically higher event rate. Except the stent thrombosis definitely was lower. So just to say, angio-guided PCI was as good as. A lot of people got relief. I'm sure many of you might be in my category. That's okay. It's not unethical to do the complex PCI without imaging. So this is one of them. But you have to have optimization. They told that even these were expert people. Optimization could only be done in 50% of cases, even if they did as much as possible. So therefore, it shows that stent optimization criteria, our imaging was not superior. Then, optimal trial, left main. Left main, almost 10 years ago, we were told you cannot do the left main PCI without imaging. Well, we learned, we started doing it, even if we didn't like it. start doing. And now we have the major trial, the left main in Italy, Spain, and UK, called optimal trial for the left main PCI. Again, large number of patients, about 800, doing with the imaging versus no imaging, all got PCI, IVUS guided versus angio guided PCI. And guess what? Once again, our angio guided PCI height in every aspect of our MECI is lower compared to IVUS guided, except IVUS guided has a higher CVA rate. All of a sudden, first time we had, the explanation was in the left main, your catheter comes multiple times in and out. Then you probably embolize some of the ostial left main fragment and the particle into the brain, and that created this higher CVA rate in the PCI group compared to the imaging group compared to non-imaging group. First time. And another one is stent thrombosis. Until now, every trial showed lower stent thrombosis, even if their overall trial was negative. Here, stent thrombosis 2% in the IVUS guided, 0.7 in the imaging guided, or angio guided. So this was 3.7, 30.9. Procedure time was more in the imaging, 2.9 year of follow-up at 3 years, 89 minutes versus 64 minutes. But overall message was that in this trial, imaging guided left main PCI did not do better compared to regular PCI, rather had a higher CVA rate and non-statistically higher stent thrombosis. Surprise. Then a lot of editorial tried to explain and try to basically say that now with a drug-coated balloon, we may not need to be that perfect in the angioplasty. So this is one of the recommendation is, since the drug-coated balloon coming into our practice, this whole optimization, this probably may not be needed. And therefore, maybe imaging should go down, because after DCB, you don't do imaging anyway, because you're worried about scraping the drug from the vessel wall. So this basically a lot of editorial to support this, or explain why we had this zigzag path to success, some negative, some positive. So let me tell you what my the analysis for this is. Explanation of the disparate contradictory finding of the randomized trial of the imaging in ACC 2026. You can always say there were difference in complex bifurcation, calcific, long lesion, experience. But most of the actually trials outside USA showed more positive data on the imaging, like Korea and so, compared to United States. Then strict adherence to performance, that just doing imaging alone is not enough. You have to do all criteria you need to set forth in the algorithm. And then lastly, our stent designs have become so good, and many of them getting PCSK9 have shown that you decrease the event rate anyway in these patients by all this therapy with optimal medical therapy. Maybe now we'll see no difference in trials coming. We do not know yet, 2 of them. But now how do you explain what we have? Because I would say the high volume experienced operator, just like me, over the years, about angio, and then we started incorporated imaging in, we learned what we should do, how should we take care of the lesion. And that's what we did. Performance guided by angiography until now, optimal stent optimization, reasonable long-term outcome. But we knew you do PCI, guided by imaging and angio, you have optimal stent optimization, excellent long-term outcome, lower MACE, particularly decrease in stent thrombosis. But now, how do you explain the data of the 2 trials which were presented? I think it has to be that what we learn from the imaging trial, we are doing it based on the angio. And sometimes you do a stent boost to see your stent has been fully expanded. So implement all the IVUS protocol, learned expertly, guided by angio, and no IVUS need routinely. So this basically we learned that IVUS taught us where we should be, and now we don't need the IVUS. That's probably the explanation. So this I call the recalibration of the angio. I used to call EB IVUS, eyeball IVUS, but Keeney did actually a very interesting word. Coined the term called IVUS. So eye intravascular ultrasound, and which we did first time way before the ACC came, April 15th.
So, based on the EYE IVUS, I'm taking a 3 to 528.
Just to say that what IVUS has taught us, probably we do better. I would not say that still go away from the imaging. I think questionable cases, then you see a little dent, your hazy edges. I think imaging will help those cases. And one thing for sure, edge dissection. Many times you will not know the angiogram on the angio. Because remember what we say, little haziness, little step down. But those are the 1.5 or 1 or 2% develop thrombosis. But if you know that as dissection can only be seen by imaging, your thrombosis, stent thrombosis rate goes down. And the field is evolving, new devices are coming. We are going to show you this Terumo first time in the United States, which shows IVUS and OCT with a one catheter. You'll show a few cases, the spectra wave, and of course the new Abbott Ultron, which has just implemented now. All these show the field will continue and a lot of AI assistance will be done. So let's put it together. These were the trials, and as always say, central illustration, the term coined by Dr. Fuster in his first, when he's the first editor of the JAC, that let all article, the all 10, 20, 30 page article has to be summarized in one page. And he was very clear that if the authors cannot put all the concept in one page, means they don't know the subject. So this is the central illustration. I've shown you very many things, but I'll go through it, what we have. ECMO, balloon pump in cardiogenic shock. Impella in chip PCI in STEMI, non-cardiogenic. DCB in large vessel, no good. Second, FFR-guided PCI in multi-vessel STEMI, orbital atherectomy, laser or cutting balloon in calcific lesion, colchicine in acute MI. Again, do not work. Then FFR-guided PCI in cabbage at 5 years, in hospital stage, rather than you do immediate, complete revascularization, multi-vessel PCI, angio-FFR or physio-FFR, sirolimus eluting DCB, as good as paclitaxel for the MACE, although may still say the paclitaxel, I still give one thumb higher compared to sirolimus, what we learned so far, but more data needed, but I would say one thumb up. Then IVL, rotational atherectomy, open NC in calcific lesion, all have shown to be better. Then clopidogrel compared to aspirin long-term, then IVBT for multi-layered DSISR, and the vein graft PCI or native vessel PCI is a 2 thumbs up. Then the major understanding was DCB in ISR and side branch, and oral anticoagulation alone. No antiplatelet therapy, long-term after 1 year post-DSPCI. We had data up to 3 years. The really, I would say, the practice changing. The last one, which I still say, that I'll keep it controversial, is what we learned in the last one, that imaging guided versus angio guided, which is called IBUS guided, complex PCI. I think the jury is still out there, and further trials which will be presented in TCT and then AHA may make this balance go in one way or other, and to make us better interventionalists and improve survival. So with that note, I'll just complete it. This is our data of the 2019. We still have the highest volume, and double star means lower than state complications. And we, for last 24 years, since the report started in 1995, we actually had double star in 24 years. The 25th year will happen or not, will based on the next, when the report will come, because as I said, last one was 2019. More important is, we are very happy that every week there is a teaching. The CCC coronary cases for many years, then peripheral about 7, 8 years, then structural for about 7 years. Then we added imaging and microvascular. So each week there is a teaching from Mount Sinai with the CCC webcast, which has grown tremendously with average about 20,000+ viewers per year, and we keep changing per month, and we keep changing the contribution of various countries. India is really rising superb. Used to be USA and India tie, but now last 6 months, we have big following from India. And as you know, India is a large population. I won't be surprised, they may be even double the participant than in USA in coming months. With that note, I'll stop here. And of course, the lot of app, which Anu keeps making for any disease process, app is there to make our life easier in every aspect of interventional cardiology. And with that note, I'll stop here. Thank you very much. And with that note, we continue as usual.
I now invite Dr. Valentin Fuster, President of Mount Sinai Fuster Heart Hospital, Physician-in-Chief of the Mount Sinai Hospital, and General Director of CNIC in Madrid, Spain. He previously served as President of the American Heart Association and the World Heart Federation. Please welcome Dr. Valentin Fuster.
All right. Dr. Fuster, besides all those awards and so, has been my mentor. As you know, that I came to Mount Sinai by his, I'd say interaction, and has been my mentor. And even now, we have everybody busy life, but once or twice a week, we always meet and I take the guidance from Dr. Fuster in all operational aspects.
Thank you.
Thank you.
Well, thank you very much. So we have a pressure with time. Let me begin by saying that for the last 15 years, I have been involved in the understanding of health rather than the understanding of disease, that is prevention. Two institutions, Mount Sinai Medical Center and the National Center of Cardiovascular Investigation in Madrid, with two key objectives. First, the integration of the heart and the brain, and second, the movement from basic to clinical application. We choose to understand health with these two objectives, 3 different ages, from birth to age 20, age 20 to 60, and age 60 to 100. These are the two institutions. I'd like to say a word about the National Center of Cardiovascular Investigation in Madrid, like NHLBI here in this country. We have 400 investigators. The movement is from basic science on the top to clinical application, but we have very sophisticated technologies that we use for health, and now they are applied, we use for disease, and now they are applied to health. Cellular models, animal models, imaging, multiomics, and machine learning. Now, we have 8 different topics that are being addressed by these 400 investigators, and each of these topics has a leader that is a clinician investigator and a leader that is a basic scientist. Here you have, I am involved in 3 of them, the mechanisms of atherosclerosis, the brain, and promotion of health. This is what happened 15 years ago, and this is why I moved from investigation of disease to investigation of health. This is actually has been published at this time, but I already was aware at that time, 15 years ago, that hypertension was increasing, obesity was increasing, diabetes was increasing, and 1, 2, or 3 of these risk factors had an implication in mortality. What is worse is the projection between 220 to 250. Here you have hypertension increasing, obesity, diabetes, and this is not only the incidence of cardiac disease in red or coronary disease in red and stroke in blue, but this is the cost of this treatment of these diseases in the future. So it didn't look good at all about 15 years ago, and we dedicated then to health. How do we address health? I say 3 different ages, and we began actually with age 20 to age 60. And you have to decide a priority. Our priority is, can you image coronary artery disease that can be affordable all over the world? You will say coronary angiography, forget it. It's not the way. So we were very much on technology of imaging, and this is the PESA study of 4,000 people, 4,200, that we have been followed for 20 years, every 3 years, with sophisticated imaging technologies, in this case, 2 and 3D ultrasound of the carotid and iliofemoral region, calcification of the coronary arteries, and then here you have positron emission tomography and magnetic resonance imaging of the external arteries. We look at the relationship these with more than 4,000 parameters, and here you have multiomics. This is addressed every 3 years, and we divide the body above the neck and below the neck. This is critical. Over the years, and we began this in New York, we developed a technology of detection of atherosclerotic disease by 3D ultrasound in the carotids and in the iliofemoral region. This is AI directed. You see, you put the device here, AI tells you where the lesion is, and it can quantify the lesion, AI, in cubic millimeters. This is all done in over 12,000 people thus far, and we will be available without technical expertise to everybody in the world probably within the next couple of years. We have published in the last 2 years all of the data of this longitudinal study, but I just want to emphasize 3 things. First, atherosclerotic disease is a systemic disease that begins at age 30. Now we know even can begin earlier in patients with familial hypercholesterolemia. Second, a risk factor at young age, like age 30, has a reactivity of the arterial system much more significant than at age 65. And that is a healthy artery actually reacts to a risk factor much more vigorously than the artery that is stiff and maybe later in life. And then most importantly, a risk factor at young age, and this is in the cardiac study, we found that between age 20 to 40, if you follow a risk factor and you trace an area of ups and downs of LDL or hypertension, that area predicts over age of 60 cardiovascular events. All of this is published and is in the bottom, and is published in the last couple of years. But here's the question. Can we identify coronary artery disease with these technologies that are in the neck and in the iliofemoral region? And this is going to be published very soon, but the data is quite fascinating. Here you have in the abscissa no carotid or peripheral disease or iliofemoral disease, and here is both. If both are present, here you see the ordinate, mild, moderate, or significant coronary artery disease. So if you identify disease with this technology, which is quite sophisticated in the carotid and iliofemoral region, if you detect disease in both, the chances of coronary artery disease are 75%. And you can go all over the world. This is very economic, it's going to be, and actually you don't need to be a technician even to do that, because the cell phone will tell you with AI what is the amount of disease that you have in the carotid or in the iliofemoral region. You say, what about calcification? We have done calcification in 12,000 people, and I actually am driving Medicare to really be generous with the people who ask calcification actually for diagnosis. And I have been the senior author of a paper just came out on calcification. Means I am not against calcification, but I am a little against it at this time by the data we have obtained in young people. This is the data I presented to you, iliofemoral and carotid disease, 75% coronary artery disease if both are present. But can you imagine? In 50%, the coronary calcium is less than 11 international units, close to zero. Why? If you do calcification in people under the age of 50, good luck, you are wrong. Because the chances of having a zero and the disease is developing is very high. And actually what's happening is calcification means healing, so happens later in life. So the use of calcium scoring under the age of 50, I don't think is appropriate based on the studies that we are doing. Having said that, thanks to the recent guidelines, now finally the guidelines on, in this case of lipid disorders, they goes to childhood or to young people. Well, so with all of our data and imaging technology, we decided to develop the first trial, the pre-cut trial of lipid lowering in people under, between age 30 and age 49. But let me tell you first the use of statins. You say, I'm going to put on a statin somebody who requires statins, for example, an LDL more than 100. 7% will use it, young people. And the data is already in the literature. So that is, young people don't like to use oral statins at all. This led us to go to the subcutaneous approach to PCSK9 inhibitor addressing the liver. And this is with the use of inclisiran. Well, this has been quite of a success. And now I am presenting to you the pre-cut trial. 1,600 people, 30 to 49, with an LDL more than 70. Why this is abnormal? Because we already see subclinical disease with an LDL more than 70. To prevent atherosclerotic disease in the young is the title. Here is the group with inclisiran, 5 years of follow-up of progression of disease that we know long-term is cardiovascular events, and here is the control group. Well, it's fascinating. We are entering patients every week, about 20. And this is the story. About 1/3 is between age 30 and 35. 38% are male, 62% female. And you see at this young age, look the disease, 53% we already see carotid, iliofemoral, or bilateral disease, or disease in both entities. And this is New York, this is all at Mount Sinai. That is, you have diversity, and I don't have to go into the details. Well, the excitement of this trial led to the trial that now we have between Denmark and Madrid, 16,000 people, the REACT trial, trying to really move forward, not with 2,000 people, but with 1,600. And we already enter 8,000 people that we are supposed to enter in Madrid. Well, let me tell you where we are going, and this is a prediction. The prediction is in the near future, we are going to look at risk factors, regardless the socioeconomic entity or country or community that you are. And then you will do very simple, iliofemoral and carotid, using the device I mentioned, and then, which can be done without technical expertise, and then those who have disease, at least we will be able to say you are at risk, and maybe we will be more successful when they see the disease in itself. That's where we are going, and this is what is going, in my view, is going to be. But there is something very interesting. In these young people, we found so much disease, it was silent, that we work at the microvascular dysfunction. I have to confess that the first 3 studies that I mentioned, Dr. Guiomar Mendieta, Dr. Ana Garcia, Ines Garcia, were critical in the studies. What I'm going to present is Ana de Besa, microvascular dysfunction. You will say, if you look at young people between age 30 and age 45, microvascular disease in the coronary arteries, you will not find anything. Well, this is wrong. In fact, we use magnetic resonance imaging as the guidance, and actually, we were very, very surprised. We look at 3 risk factors: hypercholesterolemia, diabetes, or hypertension. If you had 2, there were 30%, they already had microvascular disease at young age, completely asymptomatic. Is this surprising? Actually, it's not. Now we have data on the retinal arteries, data on the microvascular of the kidney, and I will tell you, this is a systemic disease that affects the large arteries and silently is affecting the microvasculature. So why this is not affecting the microvascular of the brain? And this actually led to the trial, to the studies that we are going on the brain that are certainly very motivating. This is age 60 to 100. What is, in this case, the priority? Cognitive dysfunction, Alzheimer's disease. You can have many other priorities, but this is the one we took. Well, the data was very interesting. We published this in The Lancet a couple of years ago, and this is in the PESA study that I just mentioned of young people. We look at the glucose uptake when there were 2 of the 3 risk factors we mentioned in the brain, and this is baseline. This is 6 years later. The significant decrease. What was most important is we measure flow in the brain with magnetic resonance imaging. And you can see as the MRI shows less flow, so it shows also less uptake of glucose in the brain. This is actually happened in the last 3 years. Now we develop at least the concept that the same risk factors that affect the heart and the systemic circulation affect the brain, and mainly in the microvasculature, because we didn't find large vessel disease in these young people, or at least was disease that was not obstructive. Well, let's go to Alzheimer. If you read Alzheimer 120 years ago, it's quite fascinating. You know what it says? This is a disease, my disease was a pathology of the small cerebral arteries. He was talking about the microcirculation. Alzheimer's disease is complex, but it's interesting that when we look at the uptake of glucose, the decrease in the uptake was in the same centers that Alzheimer's disease develops, pointing out that Alzheimer's is complex. I don't have the time to go into it today, but probably the risk factors that begin to affect young people are already affecting the microcirculation, and they may enhance or make the acceleration of a disease that is complex, which is Alzheimer's disease. Well, now there is a plethora of articles every month about pathology saying the whole problem in the brain is in the microvasculature and disease is cognitive. And this is what is weird. It's not atherosclerotic disease. It's intimal medial thickening, like when we talk about intimal medial thickening of the carotid arteries. This happened in the microvascular of the brain. And this is the studies that are really appearing one after the other. But I want to point out what was published about 3 weeks ago, a huge study of 2.8 million adults in South Korea, in which they had what the Europeans call not hypertension, but elevated blood pressure, 120 to 139. More is hypertension, less is normal blood pressure. They measured this and they followed these people for 8 years, and the question was, who develops cognitive dysfunction? And the study is fascinating. And here you have, this is actually, this line means dementia or cognitive dysfunction in the vertical axis. And here you have, in the horizontal axis, is the follow-up. And in terms of the dementia, you see high blood pressure or hypertension. This is high blood pressure, and this is normal blood pressure. This is cognitive dysfunction in general. This is vascular, when there is no other reason than just the risk factors I mentioned. But look, dementia for Alzheimer's disease, again, the same thing. So what we are really talking is the risk factors that I am mentioning are really affecting, it seems, the microvasculature of the systemic circulation, and the brain is also there. And Alzheimer's disease and cognitive dysfunction are really part of this problem. In fact, these are the two articles just written, and we are involved in some of them, one of them in the second one, which is, of all causes of cognitive impairment and dementia, cardiovascular risk factors contribute to the 20% that you say is vascular dementia, but probably play a part in all the cases of dementia, including Alzheimer's. Well, this is very interesting because we then, all what I presented, at least from our side, was retrospective, but then we developed in 2022 a prospective study of 1,000 people with an average age of 55 years, in which we use all the imaging technologies I mentioned in the brain and the systemic circulation. And then here on the right, 4 types of measurement of cognitive dysfunction. These people are followed every 3 years. And here we have something very interesting, which I don't have time to go into, is actually our biomarkers of cognitive dysfunction. Well, I just want to say that this is very fascinating to me because this is a disease that is systemic. It starts at young age. The risk factors affect also the microvasculature, and the brain begins to develop the symptomatology later in life in the way of cognitive dysfunction. This led us to say, can we abolish all of this? Can we prevent it? We have a lot of data in the adults, but this is not what we are doing at this moment, or at least our emphasis is in children. And the question is, why in children? This is between birth and age 20. We have data, and actually my brother, who is a neuroscientist at UCLA, has contributed to that, that whatever we teach a child under the age of 10 years comes out later in life. Just see how you are today, and you will know how important was your environment, family, socially, economically, school system, how you are today. Well, this was in the human studies, in the frontal lobe, but now you have in nature a fantastic study which goes to animals. You have the animals at early age. A lion, for example, is born. After 6 months, know exactly what the dangers are or what not the dangers are not, just in 6 months. And they live for about 10 years. So whatever is later in life that we see a lion is able to react to whatever is in the environment, they can already do this at 6 months. The same in humans, but it's later, it's in the first 10 years. So what I want to say is this is actually the reason why this is happening. At early age, the number of receptors in the brain, you can tell anything to the brain is stored because the receptors are not interacting with each other. Where later in life, as you see here, the number of receptors in the brain to what you tell anybody, they are linked with each other, and very easily you can tell something from one ear and it goes out on the other, because there's so much interaction that this is very diffuse, so it's not really fixed as it is at a young age. Well, we did 4 randomized projects in over 7,000 children in the school system in 3 socioeconomic areas. And we reached 3 conclusions. I don't have the time to get into this today, but this is actually has been published in the last few weeks, which is our experience in 15 years. The first issue is you act in the first 10 years of life, and adherence to the teaching is important. We teach 6 months for 60 hours. And what we teach actually is here, how the body works, healthy food habits, physical activity, and how to control the emotions. That is to prepare with self-esteem these children to react against drugs, alcohol, and so forth when they are older. It's a self-esteem issue. All of these, as mentioned, in 6 months and in 60 hours. Adherence is important. Who is teaching? The teachers. The environment is important. We found that in these randomized studies, all the studies we have done in children are randomized, and we are now dealing, by the way, with 50,000 children around the world. What is very interesting is the control groups do well because they are in an environment, in the school system or in the family and so forth, in an environment that is positive, is for health. You don't have to intervene, they already react. So this leads us to teach now not only in the school system, but also in the families and in the environment that one is there. And finally, sustainability. We have to reintervene every few years. And this happens in the adults too. On anything, can be health or something else. When you think you are on the top, you're already going to the bottom, unless there is something that makes you to go up. We found this in children, and it's very fascinating. We feel that the reintervention is exponential in terms of habits and knowledge and so forth. So this is interesting. This was taken by the American College of Cardiology as organization in saying, you know, let's go to the world and now get into prevention by addressing health in children. The first meeting was this last week, actually, Friday and Saturday. Very complex meeting because the teaching of what I'm telling you took 2 days to go step by step. But these are the first 50 cardiologists. We are going to train 250 who sign up, and they were quite happy after this. But I have to tell you what we are teaching, and here is imaging too. Everything we teach children is imaging. There are no words to start talking about. And here is just an example.
You're invited to a very special adventure.
Phonocardiograph screen activated!
We will discover emotions together. Food that helps us grow.
Boom, 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 boom.
Movements to feel strong and healthy. And how wonderful our body is. Activate the Super Health Protocol.
Dr.
Fuster and Friends.
There are 32 videos, by the way, but there are also actors. So every video has aside children that are acting. And here's another example.
Dr. Fuster and Friends. I know how to do flips, like either back handspring or like a back tuck. And I do that all on the gym floor. My name is Michelle, and I'm 9 years old. I do gymnastics and dance. And I love my sports. My name is Nia Malloy.
Very basically, I think that I was asked to talk about subclinical disease, and we feel imaging technology is critical. I didn't have the time to go into the brain. It's not that we are going to do imaging of the brain to know if you are developing chronic or some dysfunction, memory, or so forth, but we know that the risk factors at young age are critical to be addressed and has to be done very early in life. And we feel that all this research in between age 20 and 60 and 60 to 100 have to be integrated with an educational process. And we feel that the highest educational process comes in childhood, as I presented. And our involvement with children is very heavy at this time as our involvement in research with the brain. These are the 2 main areas that we are particularly interested. And I just wanted to present this to you today, although this is not the right meeting to talk about promoting health. But anyway, I was asked to talk, and this is what it is. Thank you.
Wow. Thank you, Dr. Fuster. What a fantastic, fantastic lecture. I love Fuster and Friends. I hope that I could be one of the friends. Last year, for the very first time, we had an inaugural award that that Dr. Sharma, in the name of his dad, has done, and this now becomes our memorial keynote lecture, the Anandi Lal Sharma, who's been so incredibly giving through the foundation of Dr. Sharma's family for these types of educational venues, whether it's to the fellows for all of the years of bringing our visiting professors to Mount Sinai, or here at CCC Live with Dr. Kinney supporting all of this. So it is really, truly my distinct honor and privilege to introduce our keynote speaker for this very important memorial lecture, Dr. Robert Califf. There are few individuals in modern medicine whose influence has been felt so broadly across clinical care, clinical research, regulation, and public health. Throughout a remarkable career, Dr. Califf has consistently championed the principle that better evidence leads to better care for patients. As a distinguished cardiologist, we know which institution, Duke basketball, everyone, huge basketball fan for Duke, but at Duke University from the beginning, but also Stanford and also many other honorary degrees, a clinical trialist and leader. He helped transform the way we design, conduct clinical research. For me personally, now as president of the American College of Cardiology, but as a fellow in cardiovascular disease, I was so very attracted to everything he had developed at Duke Clinical Research Institute. And he began the very, very first, most important clinical trials in cardiovascular disease that to this day remain how we treat patients in the cath lab. Beyond academia, he has served our nation with extraordinary distinction, where he, as commissioner of the U.S. Food and Drug Administration for 2 different administrations under Obama and Biden, he navigated some of the most complex challenges in modern healthcare while maintaining a steadfast commitment to science, integrity, and public health, and good and public, the good for the public. What I've always admired most about Rob is his ability to see beyond the boundaries, to see what through one single discipline, of any single discipline. He understands that improving health requires bringing together clinicians, scientists, regulators, industry, patients, and policymakers, often around the same table with good, healthy conflict and good discussion to solve problems that none of us can solve alone. And for this reason, as president of the American College of Cardiology, I will be tapping into that for what we want to accomplish this year. It is therefore especially fitting that he joins us today for his memorial lecture as his career embodies many of the values we seek to honor: intellectual curiosity, service, leadership, and an unwavering commitment to improving the lives of our patients. Please welcome me. Please join me in welcoming Dr. Robert Califf.
The honorarium, and this is the special Beatles.
Oh, the Beatles.
Yeah,
The Beatles,
ball
yeah.
tie, designer, and so glad that you are the recipient. Okay.
Fantastic.
Thank you very
Thanks
much.
so much.
We'll leave it, and I'll leave it on your,
I'll take
near
it.
your computer.
I'll take it.
Okay. Thank you.
Well, wow, after that introduction, I'm not sure there's anything I can say that would be fitting, but I'll do my best here. And hang on, I'm going to go through a lot of slides, but the slides will be available. There's nothing proprietary about them if anyone wants to look at the details that are on this slide. The title that I was assigned is an interesting one to think about, and I've had a lot of fun talking with friends and colleagues about these issues. This is my disclosure slide, and just to quickly go through it, Don't worry about criticizing me. I can take it. I've been through 2 Senate confirmation hearings and multiple other hearings with the likes of Bernie Sanders and Rand Paul and Marjorie Taylor Greene. I'm about to turn 75. I'm not looking for a job, and I'm not looking for an NIH grant, so I'm free to say what I want. And I feel at this point I've worked in every sector, and so I do feel like I carry a little bit of every sector with me. We had a spirited conversation at the faculty dinner last night. To me, the main takeaway is all these sectors are full of really good people operating under a set of incentives that we all wish were a little bit different. So I have opinions. Feel free to disagree. That's perfectly fine. So I'm going to just quickly go through the bottom line here. Here's a list of good things about AI in medicine and healthcare. And what I'm not going to talk about are the highly technical issues, which is what almost all your meeting is about. Like Valentine, I'm a bit of a fish out of water here in what I'm going to talk about. But I think you are really going to cover the details of the amazing possibilities for the implementation of AI in the context of the delivery of complex coronary and other types of interventions in surgery and interventional cardiology. I did have a lot of fun working at Google for 5 years in the midst of all this, where there was tremendous effort that went into developing platforms which are now beginning to take shape. I'm going to talk about the things that are highlighted in red. Here's what I consider the ugly, and we could spend the entire session on the bottom 4 topics here, each one alone, which you might say, what does drone warfare have to do about healthcare? I think right now, if you live in certain parts of the world, it is the main focus for what's creating the need for healthcare, and it's going to be even more so in the future. And if you want to have some hair-raising conversations, talk about the capabilities of AI related to bioweapons and what needs to be dealt with in society. And then this is what I consider the bad that could really be good. These are the issues that are modifiable depending on how we behave. And so I'm going to say it multiple times in different ways related to different topics. AI is a nuclear weapon. It is going to change everything that we do, and it can either do tremendous good or tremendous harm depending on who's in control of what AI is turned loose to solve, what the issues are that are attempted to be solved. And maybe I'm a little ahead of my time and overly optimistic, but I don't think so. This one caught my attention. It just came across my feed today, but Elon predicted in 2015 we'd have self-driving cars in 2017, and Gregory Hinton, who was really the godfather of artificial intelligence, said radiologists are going to be obsolete within 5 years. And the picture shows where we currently are, radiologists driving to work in regular cars. So the basis for all this, there are 2 key things that I think we need to keep in mind regardless of the application of AI that we're talking about. The first is that in this country, we now have far and away the worst health outcomes of any high-income country, and we're losing ground by the day, while at the same time we are leading the world in technological innovation. And I had a lot of fun over the last couple of days for other reasons to talk to people who know a lot about where we are in AI. And we are ahead of every other country, significantly ahead. But significantly ahead, and this is kind of an interesting factoid, according to 3 of the big companies working on this, is about 6 months. They're operating on horizons of 3 to 6 months in terms of staying ahead of the competition, particularly China. And this is not a uniform issue in the United States. Those of us in this room are doing pretty well, and all predictions are we'll continue to. But what we're getting in this country is a tremendous divide, the worst since the 1920s in terms of dispersion of wealth between those who are wealthy and those who are not. And there's a very direct relationship between wealth in the United States and health outcomes that's more than linear. It's more like an exponential function. This is just one of many depictions I could show of how the wealth gap is really widening significantly. And I probably don't need to tell you that historically, when this has happened to societies, it has ended in beheadings and hangings at some point. And so it's something that we really need to take seriously. And my main point about that is that AI could either make this a lot worse or it could make it a lot better, depending on what we decide to solve using the powerful tool of AI. This is particularly integrated not just with money, but also with where people live. And I'm from the Southeast. The Southeast doesn't look too good here. And this is very much associated with rurality as an issue, with not living in a city. There's so many resources and smart people living in cities who have access and knowledge about how to be healthy and stay healthy. And then there's the information side of it. And this is just a mental image I have. There's a lot in the news over the last couple of days about where MAHA is headed. And I think what MAHA has done is to do us a favor, because it has pointed out that in this country, we're on the wrong road when it comes to health and healthcare. And we're headed for a big ditch or a crash ahead if you look at where our statistics are relative to other countries. But unfortunately, a big part of MAHA is recommending a turn to the left-hand side into a different ditch, which is no better and probably worse. And my argument is we need to turn AI loose to make that right turn into the evidence-based policy segment, and should also give MAHA credit that they've called a lot of attention to the fact that we basically ignored the things that Valentin is talking about. If you look at our allocation of resources, they've all gone into what you're going to talk about most of today. Let me just give the caveat right here. I'm not opposed to what you're doing today. I hope when I have my event or I need my pacemaker or defibrillator that you're going to be there to take care of it, and I'm happy about the significant investment. But we can't underinvest, and so we need a lane on the new highway, which really is a MAHA lane of nutrition, exercise, education of young people, et cetera. Just to bring this home in terms of images, since we're all image-driven now, the MAHA exit sign, you'll recognize the things on it: raw milk, dead animals, swimming holes full of bacteria, beef tallow instead of vegetable oil. What we need to go take is the evidence-based policy exit that has all these things that we hold and have held in high esteem. And this meeting is already off to a good start. The first two speakers did a great job, I think, of showing how dramatically improved we are in terms of generating evidence, but also how far we have to go. The problem with the public is that the things on the EBM exit sign look really boring and not very exciting. And so I want to give Valentin credit. The sort of animated things that he showed is really the way we have to go. Press releases from the American College of Cardiology are important, but they are not going to carry the day with the public. All right, so now I'm going to go through these slides quickly. First point is, we've got a great thing about AI is we should be able to reach people now who have previously been left out. And I'll just give the one example of heart failure. This is from a few years back. It's gotten even worse since then. We're going from 6 to 9 million people with heart failure in this country. We've got 33,000 cardiologists and 1,200 heart failure specialists. You don't have to be a genius to know that these numbers don't work if our goal is to provide reasonably equitable care to everyone who lives in the U.S. And Harlan Krumholtz in Roxanne's journal of the American College of Cardiology, wrote a nice article about a program that I'm very enthusiastic about because it's going to push the frontiers, the Advocate program. And the point he makes here is that this is an urgent issue, because if you do the numbers and you look at our outcomes, you'll see that so many people who really need access to high quality care just don't get it in heart failure because they live too far away or they can't get an appointment. And so it's going to be important that we use AI to extend the reach of high quality care in a way that we could never do by taking 10 years to educate and train a bevy of physicians. So the Advocate program is one that you'll hear a lot more about over the next month, but it's reaching for the stars. It's going far beyond anything you could imagine right now. For those of you not familiar with it, ARPA-H is a new part of the government, by the way, that was completely written out of the budget and what the president submitted, but I think Congress is going to restore it. It works like DARPA, which has been the basis for things like the internet, the defense part of the agency that uses contracts to fund research critical to the country. But the idea of the Advocate program is to develop a fully autonomous agentic AI that interfaces directly with people in rural areas to provide evidence-based heart failure care. Now that sounds pretty wild, like how could you possibly do that? But I can tell you when they put a bunch of money up, probably no surprise to you, all the big guys are in the hunt now, Anthropic, OpenAI, Google, Microsoft, et cetera. But they also put up money for health systems, and so health systems are going to be directly involved. Now, they're going to announce who got the funding in about a month, and then the race is going to be on. But the thing to just have as a mental image is a fully agentic, without a physician in the loop, AI system that interfaces with people with heart failure. Will it work? I don't know, but we're definitely going to make a lot of progress. The second example is the FDA's effort that started when I was there and is now continuing under Michelle Tarver's leadership to try to lasso the industry, not to take away from what you're going to talk about here, but we got to get the industry that uses digital technologies to spend more time developing systems that work in people's homes, because that's what people want. It's where the biggest gain could be made. And then the third, just to give Mount Sinai some credit as one of the nation's centers in AI, for all of you, I think one of the biggest uses of AI fairly quickly is going to be the identification of people who used to have to hope that they would be in a situation in their nursing home or with their primary care doc where they would get referred to the right place at the right time. But now we're in an era where an ECG can be used to identify, for example, structural heart disease and really facilitate bypassing these sort of arcane, interconnected referral systems that we've had to try to get people to the right place at the right time. And Mount Sinai is very much involved in this. Second area is complete up-to-date information for patients and doctors. How many of you are not using open evidence? Okay. Well, some of you are like me, are old enough to remember when this is where you went. As an intern, the great interns were those who could find the reference, make a Xerox copy, and hand it out on rounds. This has obviously changed now, and this is what I'm now experiencing in my own healthcare. I personally use open evidence every day, even though I'm not seeing patients directly now. I get a lot of referrals for help, and I'm interested in my own healthcare. But the idea that you would have 24/7, up to the millisecond update on clinical practice guidelines and other evidence that's accruing is a phenomenal concept. It's now close to a reality. But in addition to that, I've been able to turn an AI agent loose on my own electronic health record. Now, I've been at Duke my whole life, so for a doctor to go through my entire record would take probably a day or 2 days to do the whole thing. But I turned an agent loose, and within about 5 minutes, the agent had found 3 things that needed attention in my electronic health record that a doctor would have never been able to pick up. And one interesting part of this is the development now is the integration of these factors, and so the agent looking at your health record can interact with the agent providing the evidence and identify not just what the problems are, but what the proposed interventions might be. And now there are companies being developed to take advantage of the compilation of this combination in large numbers of people, with the idea that real-world evidence can be just-in-time evidence developed as close to real-time as possible. The question for all of us is not whether this is going to happen. It's fully underway. It's happening. The question is who's going to oversee it, what are the values going to be that are embedded in the system, and how is it going to be regulated? I will note that a component of this is trying to figure out what's the best way to do it, and there was a really interesting article this week that did a comparison of open evidence with just a general large language model from the big vendors, the Geminis and Claudes of the world. And the answer, at least in this analysis, was that surprisingly to me, the wide open aggregators of information did better than open evidence, which the benefit of open evidence theoretically is it only uses curated information from reliable sources. So we're going to have to work out what the best approach is, but the race is on and it's happening. Third area is integrating research and practice. And, given what Roxana said about my career, it's been a lifelong pursuit. I started my career in a place where this happened. Practice and research were fully integrated when I was a youngster back at Duke. And then whatever happened, it sort of went away. And everywhere I go now, I see a lot of angst about the fact that these things are separated. I had a chance to talk to New York Times about this, and what I said was not important, but the picture that they came up with, I think, beautifully depicted what my hope is about all this, which is that we'll have a robot in the background basically taking care of all the things we have to do now, which we know are not important from the patient's perspective, but are checking all the boxes to get paid and meet the quality metrics, et cetera, bring us up to work with the patients. And we got a long way to go in this integration. It's still the case that about 15% of major clinical practice guideline recommendations are based on high quality evidence. And so we not only need to integrate research and practice, but what I showed you about ways to speed it up using AI really needs to be an emphasis. And the hope would be that we go from this disaggregated system of learning. You could call it research or you could just call it learning. Just to make sure you're awake and insulted enough, it's my contention that the average Walmart clerk does more research than the average doctor. Because the average Walmart clerk is barcoding everything. It goes into a data system immediately, is analyzed continuously and fed back with the goal of optimizing the satisfaction of the customer and also the revenue, obviously, of Walmart. And I hope we'll then go to a system where there is this sort of constant churning of information going on in the background, and then the insertion of randomized trials like Dr. Sharma showed so beautifully into practice using data that already exists because it's curated as a normal part of patient care. All right, then the ugly, using AI to extract money from the vulnerable. Based on what I've seen, it looks like right now the main use of AI in medicine is to figure out how to optimize the margin generation for health systems. And I would argue this is not good. It's not just the dispersion in wealth that's important, also the differences in education. Right now, an 8-year, a college education is worth 8 years in life expectancy in the United States. And over half of Americans couldn't raise $5,000 if they had a medical emergency. And 2/3 of Americans agree that I have to be responsible for my own health because no one else seems to care. Now, show me a health system in the United States that's not advertising that it's patient-centric. Show me a patient who really believes that their health system is patient-centric. Right now in the United States, almost no one can get a primary care appointment, which is the most basic fundamental need that people have. And so I asked Gemini to contrast these two things, the values of medicine as a profession and the values of medicine as a business. They're not unrelated, and I'm not arguing that we should not pay attention to medicine as a business, but everywhere I go, when people really talk honestly, what's happening in the U.S. today is that the medicine as a business values get about 10 points. Medicine as a profession values get about 1 point in the discussion. And the only way to balance that, this is my plea to you, is for people to speak up. You can't change the way our insurance system works, which is badly broken and provides bad incentives, but you can add an element of humanity to the system by speaking up. And then there's the general information context in which we operate. And I don't have time to go into any detail about anything today, but just to make sure that the impression is made that if we look at everything that's on the internet today, which is where people get their information, whether you call it, watching Fox News or Facebook scrolling or TikTok, depending on the age range and the preference, a vast proportion of it is either misinformation or disinformation. Misinformation, just not getting it right. Disinformation, purposely not getting it right. And then there's also a category of malinformation, which is in some part the work of state actors, particularly China and Russia, in order to sow distrust and contentiousness in our society. And I'm going to give you the best example. This is advertising, and I'll give you the best example according to my advertising friends. Remember, I worked 5 years at Google, and I went out of my way to try to learn how advertising really works. This is the Super Bowl commercial for Hims and Hers. And there's a theme here, which is really the dominant theme right now of people who are attempting to undermine your authority as experts and credentialed people who should be able to provide expertise for charging a fee. It starts out, rich people live longer. I've shown you that that's absolutely the case. But it doesn't pertain to most people watching the Super Bowl. They're not in the rich person category. A great slogan, the wealth gap is a health gap. Absolutely true. And the rich have health care that comes to them. I've got a concierge primary care doc for the reason I gave. You can't get an appointment if you don't do that. But the vast majority of people can't. And then, after sowing discontent and making the point that all of us sitting in this room are part of an industrial complex that makes a lot of money and doesn't provide the goods to most people that they need, it diverts into what's in the lower right-hand corner, custom formulated peptides, things that are completely unproven, may be dangerous, no one knows, but you can get them readily on the internet now. So this is the motif that's being used to undermine your authority. And if it's not bad enough that advertising is doing this ahead of the whole thing, RFK Jr., this is a direct quote, "Trusting the experts is not a feature of democracy and not a feature of science. It's a feature of religion and totalitarianism." I bet you didn't think that when you became a cardiologist you were becoming a religious priest or a totalitarian person, but this is the mentality that's being fed to the general public. So if we look at all the information on the internet, there's a small part of it that's definitely true. 2 + 2 is 4. HIV does cause AIDS, although RFK Jr. also said it doesn't. But the majority of what's on the internet is either somebody's opinion or completely untrue. And in the sort of middle of that is where most of our clinical practice guidelines are as an example. And there were good examples shown today already. Our guidelines, based on the evidence we have, are all probabilistic, and reversal is not uncommon when further trials are done and we learn more. And so we've got to learn how to deal in this environment where the few minutes they spend with you in a clinic cannot overcome the 24/7 assault on the way people think that's happening over social media and the internet. Now, I'd like to be able to just call bullshit when you see it. By the way, I think one of the greatest courses in universities today is the University of Washington course, which is now 10 years old. It's the title of it is Calling Bullshit, and it's actually an entire course about how to detect misinformation and deal with the quantitative issues that are there. So to that end, just to introduce it, we're forming a national organization called Coethia. Aletheia is the Greek goddess of truth, co meaning working together. Try to create a federated community of people who do have the facts and who do have the information to get on the battlefield. There's a battle going on for the minds of people around the world, including Americans, driven by the internet, and we're not even on the battlefield at this point, although Dr. Fuster is a lone person in some ways out there with the social media. And I won't go into detail here. This is sort of the story. And the point of AI in all of this is that AI can really, really accelerate this. In fact, when the lipid guidelines came out just over a month ago from the AHA-ACC, this overall sentiment on the internet was 80% negative about statins, mostly driven by armies of bots that were dispatched by people who were selling dietary supplements. And the idea here is to unite mostly students. Students are very interested in this, but also a number of faculty and others who want to pitch in. We actually have a chapter of retired doctors now. I've learned in medical grand rounds, the house staff don't typically come now. It's a whole different environment. A lot of retired doctors, though, come to grand rounds, and a number of them have come up to me, and they're thinking quite well and would like to participate in this. But the idea here is to get the most reliable information, including depiction of the uncertainty involved, and to use social media to put the messages out to a large extent. All right, so then finally, to get to the ugly, inaccurate models. Algorithms should not be taken for granted, but we tend to do that. Our whole clinical environment now is polluted with algorithms that are inaccurate. FDA was onto this a long time ago, and this is from early FDA guidance from about a decade ago. The most important thing about AI algorithms is not the work that's done before they go on the market. The most important work is continued validation of the models as they're put into the environment of clinical practice. There are many examples now where bad algorithms have been detected. As a retired regulator, I'll just say that some really bad things are going to happen, and then more regulation will be put in. We'll just have to let that happen. And the idea that doctors can figure out what's good or bad about algorithms is completely a non-starter. This is a great article by Bob Wachter and colleagues about the limits of vigilance. Easy way to think about this, you probably don't think about the algorithm that's telling you where to drive when you get in your car these days, but it's very much driven by AI that none of us completely understand. You'd have to understand foundation models, which even the people who have developed foundation models don't entirely understand how they work. And so the key is recurring local validation. Our health systems are going to have to be accountable for the things they put into practice and to make sure that they're validated. I love this term, by the way, recurring local validation. And it's going to eventually be required that people actually explicitly say what their AIs are doing and what they're intended to achieve. Now, some argue that we should license AIs just like we do doctors. And in fact, several institutions that I'm working with now are actually working on how you would credential an AI if it were autonomous and developing within a system with the same sorts of assessments and assessments of risks and benefits. So this is an article talking about that. I think the food safety system is a much better way to think about the regulation of AI. It's going to be integrated into everything that we do. It's ubiquitous, just like food is necessary and ubiquitous. We don't have an FDA inspector on every farm every day. What we have is a set of foundational principles that were agreed to and written into law that every farm, grocery store, distribution system, and restaurant has to abide by. And they have to agree to the principles and then have a plan that's their own local plan depending on where they are. The easy way to think about this is there's a water rule, and if you're in a farm that's level with a clear stream coming into it, you don't have to think about much. But if there's a farm uphill from you with cows on it, you'd better be thinking differently about your plan for what the water needs to be. And I think we're going to eventually evolve into a system that looks like the food safety system, where it's going to be up to the health systems and vendors to be accountable with oversight by an agency like the FDA. I asked, it was interesting, I asked Claude, OpenAI, and Gemini to give me the 10 foundational principles for healthcare and medical AI. And this is just an example from Gemini, but they looked almost identical. It was really interesting when you went across AI systems. And I would argue that most of the AIs we're currently seeing are missing the boat on a very large proportion of what should be the foundational principles at this time in this almost completely unregulated environment. Extracting money from people. Just quickly, I've already said finances are dominating, and it's worse than it initially looks, and because there's an issue called suboptimization, and I bet you all can relate to this. In the American system, we're all taught to optimize the finances of whatever it is we're accountable for, regardless of what it does to the system as a whole. Classic example would be a pharmacy budget where there may be a drug that offsets costs downstream. Still, the pharmacy is held as a tub on its own bottom, and that results in a system which is much less than the sum of its parts. And we have the middle person problem. These are four, I think, classic articles about the problem and the way it works. And I've been waiting for years for this slide to make it into the peer-reviewed literature. It finally made it into Lancet, but you'll notice that there's a slight disproportion in the accrual of administrators versus clinicians in our system. So much of the money now in the American system is going to middle people that in other industries no longer exist. So I think one of the greatest uses of AI, which I hope happens very quickly, is to take the middle people and assign them to new jobs in patient care. If you've been to a nursing home in the U.S. or been dealt with people over age 80 who are trying to live at home, we have a vast lack of people to do the work that's really needed, that's human work. And we have tons of people who are processing claims and prior authorizations, et cetera. So the last point is moral injury and jobs. And I think this, to me, is one of the most interesting that's really come into focus just recently. It really does look to me now that, if you look at the source of moral injury in American clinicians, and also in the UK where I'm spending a lot of time, a lot of it is because they're doing things they know they shouldn't be doing because that's what generates the revenue, that's where the incentives are. Now we're in an era where I think it's fair to assume that algorithms will take over everything that algorithms can do better. And then the question is what's left? And I would argue there are two things that are left, one of which you're talking about today, sophisticated procedures. That point's already been made. But the other is what we all know is the human part of health care. We know how to teach the sophisticated procedures. We haven't done a good job of defining what is the human part of health care or defining how to teach it and focus on it. I was asked to write an article about use of AI in clinical trials, and I got introduced to a really interesting character named Junaid Bajwa, who's sort of a polymath who has an MD and a number of other degrees. And we started writing this article, and he came up with the concept of a reinvestment test when you implement an AI in any kind of a system. And that is, you need to state what's the human burden that the tool is intended to reduce, how reducing that human burden can be measured prospectively, and how saved time and cost will be returned to the human needs. Now, the alternative to this is to employ an AI, fire the people who are no longer needed, and make the system more efficient to accrue to the financial benefit of the people who own the system. If we force this issue, I think it could do a tremendous amount of good and push AI into where I hope it will go. And then finally, the last point I want to make, this is a little bit technical, but I think it's an important part of this as we think it through. You're all familiar with equations, and algorithms have been part of medicine forever. And there's a left-hand and right-hand side of the equation. The left-hand side is what you're solving for. The right-hand side used to be a simple regression equation. Now the right-hand side is everything that's on the internet all at one time, which is, would be hard to have imagined, but it really is everything that's on the internet all at one time. But what is critical here is what is that we're solving for on the left-hand side of the equation. if we're solving for the financial benefit of people who own the systems, it will, in a very rapid pace, create more disparity in wealth and well-being than we already have. It will be very good at that. But there is a thing called a true multivariate equation where you solve for both at the same time. So I don't want to be mistaken as saying we don't care about the money. We have to have money to make the system work. But we need to solve for both at the same time. And unless clinicians especially speak up about this need, I'm very worried that the system is headed in the wrong direction. So I'll close with this slide from Steve Steinhubel. Some of you know Steve Steinhubel. He's an interventional cardiologist. He actually was a chemical engineer who was assigned at Kodak to save chemical photography from digital photography. You know how that story ended. And if you look at almost every other part of life, the digital revolution has already had its impact. We're just at the front edge of it now. And whether it turns out to the benefit of humanity or to the detriment of humanity broadly defined is going to be up to us. So we're at the fork in the road. I hope that in the midst of all this, people will have the courage to speak up and push the system in the right direction, because it's going to change, and change is underway. Thank you.
So this was incredible. Thank you very, very much. And the harsh reality, but also the excitement for the future and the fork in the road. We are going to, because of the fact that we're about 45 minutes late, we're going to go directly to the cath lab and curtail our discussion. If I can ask Dr. Gibson to come up here. He's the president CEO of BAME Institute, interventional cardiologist, professor at Harvard. Bill Nicholson is on a call. Arthur Reitman, please come on up here. Jas Sink from Wash U. Greg Stone from Mount Sinai. Paul Tiersten from the Scripps Clinic, some of the top-notch interventional cardiologists. And if I can ask Dr. Dangus if he's in the audience to be here. Oh, Bill's here. Hey, Bill. Great. Excellent. So we go live to Mount Sinai Cath Lab. Are we ready to go live, please? We have the very first live case, Dr. Kinney at the helm. Good morning, Dr. Kinney and Dr. Sweeney. I see you both. Can you guys hear me?
Yes.
We cannot hear Dr. Kinney. Please increase the volume.
Can you hear?
Now we can hear you. Just bring it down a little bit. Now you're overpowered. Somewhere in the middle.
Okay.
Hi, Dr.
Yeah,
Kinney,
good.
Dr. Sweeney. Good morning.
Yes.
Hi.
Good morning, everybody. If you can put the slides of live case number 1. I know we are 45 minutes delayed, but the way I think Mount Sinai does complex cases with the speed of light, we should be able to catch up with the time. So if you can show the slide of case 1, which is a 67-year-old
We have two
male.
cases. Is that right, Dr. Kinney? 2 cases. All right,
Yeah,
let's go.
first and
Case
second.
1.
So 67-year-old male who actually presented with chest pain, as well as he has rest pain also. So he has risk factors which included hypertension, hyperlipidemia, and on top of that metastatic renal cancer, for which they wanted to start therapy, because nowadays they start immunotherapy. And once he was having pain, that instead of doing stress test, he went directly for cardiac cath, and you'll see the reason why I think actually it was seen. So if you see that, MPI had shown inferior ischemia, but EF was near normal. So we always like to do these important parameters on this patient. So hemoglobin A1C was 7.4 with him, pre-diabetic, and on statin therapy, LDL is 64, CRP was 34, and serum creatinine, you can see that. Medication, he was on statin, metoprolol, amlodipine, that was for his anti-anginal and for hypertension, losartan. Cardiac cath had shown 3-vessel disease, and let me show you the angiogram right now. So
Great.
you can see you can show the angiogram?
Not yet? please show us the angio. Here we are.
Okay, so near normal LV function. Today EDP was 12. We have already given him platelets. His hemoglobin platelets are okay. Platelet of
So he's had a prior
342.
stent in the right coronary, from
Yes,
what we could
so
see,
you
yes.
that's where you are with the stent in the right coronary artery, and this is where we are going to show you the left system. Now you know why he was having rest angina.
Wow.
Okay, despite being on 2 therapy, 95% distal circ, because you can say there's an OM1. Ectatic vessel after the significant disease could be just because of atherosclerosis, but more important, moderate distal left main disease, about 30 to 50. And this is the kind of cases you need some kind of confirmation. You see that in the cranial, almost 50%, significant proximal to ostial LAD before the septal. D1 is okay. D2 is again 30 to 50, large size. Moderate disease, about 30, 50 with the bridge in the distal LAD. That's where we are. So, of course, we had a discussion with the referring cardiologist. Patient, since he was 3 vessel disease with active cancer, he needed to get his therapy ASAP. So after discussion, despite the syntax score, is more, borderline syntax score 26, not definitely above 32, 33. He had PCI of the right coronary artery, and today we are going to do PCI of the entire left system. So while we were waiting, we went ahead, did the circumflex. You can dry cine, you are able to see tram track calcium in the LAD, little bit of calcium on the one wall of the circumflex. We just did a balloon and a stent, and we have done imaging. So in this patient, the reason we need imaging and post optimization, meaning to make sure that you are able to stop DAPT. When they start their therapy, there is a chance, likelihood platelets may decrease, and you may want to shorten their DAPT therapy, though right now we can say 1 to 3 months is ideal, but somebody with 3 vessel disease, left main disease, you need to be sure that your post optimization with imaging is good. So what we used is a new Opus imaging catheter, which was first in human. We did the first case here. First in human, first in world, first case we did in Mount Sinai. On Monday, we have done several cases, so we can show the imaging post, okay? Kiski, show that.
This is post, this
Post-stem.
is the fine, what you just showed us angiographically is right after this angiogram is when you did the imaging, just to make sure that we're all clear.
Circumflex, yes.
Yeah.
Post PCI.
The circumflex,
Okay.
if you can show it.
Please, yeah.
Can you show? Yeah, okay, sure. So this is the Opus wave, Telumo, IVAS, and the OCT simultaneously. So I do the pullback. This is the proximal circ. Now you see the stent, get a good expansion. Now come to the ostial circ, then come to the bifurcation and left main. I agree. First, the today's stent well expanded.
We
then
only have
come to the
a screen that's just not moving at all. Are you showing us a moving screen?
Yeah.
It's not moving.
Can you? It's not moving.
No.
Huh?
1 second.
Okay. They're not able to see that down?
We just see the
I see
still.
that.
We see a still picture of both IVAS and OCT, and I kind of like it. I'm sure that this panel is going to have some enjoyment watching this. It's like a side-by-side IVAS versus OCT. What do you think, Greg?
Yes.
Well, so what is the new catheter? Is this an integrated IVAS OCT system?
Yes.
Yes.
Telumo
Okay.
Opus wave, IVAS and the OCT.
Yeah, I mean,
Still not
here,
moving?
the images look,
Oh, you
there
can
we go,
see.
just started to move.
Yeah.
Sure.
Now
So
we see it,
today's
yeah.
stent looks well expanded, and the proximal part.
Yeah, I'm interested
now
in the
we come-
proximal part because angiographically it looks like it needs work, but let's see what you show.
Yeah, actually the minimum stent area is a 7.0 based on the OCT and 7.2 based on the IVAS. So the stent expansion is good, and the proximal edge is very smooth transition. Distal edge is at the level of the ectatic, so that's why some malposition, but actually longitudinal length is less than 1 millimeter, so we call it a minor malposition. Then we also measure the ostial circ. Now this you see the LED from the 2 o'clock. So that's the after that. So this is the austere circ. The area is like 3.9 based on the OCT, 4.4 based on the IVIS. So like borderline, or it's okay to defer. Then come to the distal left main. Yeah, so this is the distal left main cross-section area, 5.4 based on the OCT, 5.4 based on the IVIS. So it's less than 6, so we can call it severe. Yeah, but today's stent is very well optimized.
Can I ask you, can you
Yeah,
co-register
so
these?
Paul, go ahead, maybe you can.
Can you co-register this with the angiogram on this device? This is, I think, the new.
So yeah, we have the angio registration, but today we cannot use that.
Okay.
It's an interesting, it's great to see both images at the same time, and
Yes.
it's exciting, no? Paul, do you like this? You're going to
Well,
use this?
I'll probably learn a lot from this.
Yeah.
So, because, you see
ready?
them in the exact same places.
But honestly,
unusual,
looking
yeah.
at this angiographically, and now seeing the IVIS and OCT with that distal left main into that ostial circ, you're probably going to end up treating the going into there and bringing that in,
So,
right?
I mean,
Actually, not that good clearance.
You
Not
got
good
under
clearance.
6, so that's sort of one of the criteria, but I don't see I mean, I would usually do an FFR also on something like
Yeah.
this.
Would you? I don't know. That's the question.
It's good?
Actually, not good. Maybe tight stenosis, or maybe you can prove a little bit.
Okay, now,
Yeah, we can check the puff.
It's also good to image the
Okay.
osteal LAD as well.
let me take it
Well,
out.
they're
This,
doing, I think they're
flow
going to
is
come
not
all the way
best.
back.
Yeah.
It seems to me like both are involved, yes.
Yeah, there's definitely some proximal
Show
LAD
the-
disease. So, we usually use 6 millimeters squared
Go.
in the left main proper as a cutoff, based on
What do you
Della
think?
Hernandez's older studies suggesting that if you leave that behind, the MACE rates are increased, and if you treat it, it seems like it decreases it.
Okay,
No
ready?
randomized data on that. FFR is also, very good for the left main, but you can get false positives or false negatives when there's other disease in the circ and/or the LAD,
Hold the
depending
wire,
on
hold
where
the
you
wire.
put the wire. So you have to be a little careful with that.
Dr. Gibson, what are your thoughts about this catheter? 2 images side by
Wire.
side?
Yeah, I got it.
You like it?
Amazing. This is absolutely beautiful. I think it's very informative and lets you see calcium and the wall and everything at once. It's beautiful.
Jazz, what do you think?
I like the images. The problem is you have too many things to see.
Right,
So
right.
what you want to do,
From the
you
wire
have
back.
one, and you use it well, and you make decisions and stuff like that. It's good for a life case, but, I think there's too much information here, really. I think it's.
You'd rather have an imaging with maybe physiology
Yes,
combined?
absolutely. I would rather have a, high definition thing, one thing, and gives us the stuff. 5.4 here, it may not be significant really, because of the size of the vessels that you have. So the key here is, Greg is right, FFR is not reliable because LAD is disease. You are assessing the left main trunk and not the LAD. So if you fix the LAD, the left main may become significant. And IFR, resting indices here are very, very
Get the run
helpful.
through ready.
It really
I have
tells you what the gradient and what the jump will be in that setting. So I would put a wire in the circ, pull back and see how much jump you have in the left main, and then make a decision. You could probably simplify this, fix the LAD, get out. If your physiology
But
is.
the circ was pretty, I mean, you
Where's
mean
the run-through?
what we just saw with the, with.
No. The circ is fixed.
Yeah.
The LAD proximal you could fix. Assess the left main with co-registration, and then figure out if it's really giving you ischemia or no.
So what's going on
So,
here is
Dr.
interesting
Kinney,
because
you want to tell us what it looks like
using a
you're moved
rotablator.
on to the LAD treatment, like you're done with the circ. What are your plans?
So, of course, what happened is we tried to do the imaging at the same time. We saw some flow disturbance in the vessel. That's the one thing about imaging. But as you know, we've been waiting so long also here. So I took out the imaging catheter of the LAD. So just based on angiography, we did the rotational atherectomy. That's where we are, pull back. And
So-
now we can assess.
So are you still doing a lot of rotational atherectomy, Dr. Kinney, with IVL's appearance?
Yeah, excellent question. So we can show we are able to get the IVUS alone. So if you need to decide the calcium, just based on angiography, I told you it was tram track, you could see it on our LV gram as well as before the angio. And when you see that kind of a tram track calcium, I mean, we definitely will start with the rotational atherectomy. Question is that do you want to, now you have to chain the wire and all these things, that would you just do the IVL? We could, but with what IVUS we have seen, the length was very long in this case. So you could go, you want to try IVL, yes. If it does not go, then you need to pre-dilate it and then try to go with the IVL. But the way we do it here is that rather than that, just go with the rotational atherectomy, use your post-dilatation balloon, and then if you think that still it's not modified, then you can consider IVL.
Okay. So I guess, Paul, it seems like you're more of an IVL guy. Is that what you're telling us?
Well, I
Or
mean,
how do you choose?
The data is pretty clear that the safety is IVL is much safer, less risk of dissection. I mean, the data is pretty clear on that. And, but I didn't even see a ton of calcium here, so on the imaging. But,
okay, let's go to LED IVUS.
Okay, sure.
Yeah.
Bill? Maybe you can expand on when you choose, because I've heard you with the best talks on when do you choose which device in calcium modification.
Yeah, we generally are going to go with rotablator when you can't pass the catheter. So if you can't pass the imaging catheter, it's a pretty good indication you're going to need a rot. Greg, can you answer a question for me? So this 5560 cutoff, when you came up, I mean, this person's got cancer and a bunch of other things and probably don't need to do much with the left main to get them by what they need to do with in the near future. Does that number 5560, does that come from averaging of people that had a 10 and a 1 and you came to 5? I mean, do these 5560s really have events? Like, do we need to fix these?
Yeah, well, it's older data, actually. It's probably
Really old
almost,
data.
15, 18 years old.
didn't take a
Again,
picture,
from several studies. There were actually 4 studies. And they looked at the outcomes of treated and
Looking good, right?
untreated patients. And there was a cutoff at 6 millimeters
Just
squared
go to
where
the
the
IVUS.
MACE rates were higher.
No
Did
OCT.
they arrive at 6 millimeters
Okay,
by
now some done.
averaging?
Some done.
No.
People
They
all over the
looked kind of
place,
just
or-
continuously, and they said
continuous,
which
okay.
patients had a higher rate of MACE. And it wasn't all angina. So in the left main, when you talk about physiology, it
They
may
do it.
not be specific to angina. It may be all the plaque and the amount of myocardium at risk. So, but that's older data. It's not contemporary guideline-directed medical therapy, et cetera. And not all of this, the 6 millimeters squared and less have a positive IFR, and not all those that have positive IFR actually have less than 6 millimeters
Are
squared.
you using IFR to make that distinction? For me, like, I would almost never treat this left main. So, like, I think it's not impressive to me.
Okay, done.
And you're going to extend across the ostium circumflex, as high as restenosis rate that we have. And it just doesn't make sense to me.
I think there are tools now that can simplify this case, and that's what we were talking about, and I agree with Bill. I think, doing physiology and resting indices in this area to see the contribution of the left main is really critical. If it's,
Let's take a picture.
If it's markedly ischemic, then you haven't done the justice to the patient, right? So then you have to be
Then it's
forced to do.
simple.
Absolutely.
Ready?
If it's
That makes it
ischemic, then it's
simple.
a simple
Absolutely.
decision. If it's not ischemic, then that's a more difficult decision. Now, if you've got a patient with cancer and a limited life expectancy, then you'd probably be a little more conservative.
Yeah, the initial 6 millimeter squared was done in 50 patients, by the way.
Yeah.
And then the Litro study,
Rosette?
they came with Hernandez and stuff, they did all the stuff. And then the Korean study was 4.5. So in general now, we're looking
image or
at
just take
physiology
care
and
of it?
IFR. If your area is 5 to 7, you really need to do some injective things. And we have co-registration and physiology now. Anything more than 7, data is, it's okay. Anything less than 5, people agree. Now, in that gray zone is a gray zone. And this is a gray zone. So I really think that doing co-registration here and determining ischemia to simplify your case is probably the way to go.
Dr. Kinney, what do you say to that, and when do you begin to evaluate for ischemia when you have such complex disease? And of course, especially in a cancer patient like this, the less you do, the better, right? You don't really want to be tracking it all with stents, and there are tapering vessels here as well. So do you want to just talk about your strategy? Is it often just intravascular imaging, or are you incorporating physiology as well?
Yeah, very excellent question. I think, yes, left main, I like the point, borderline they're saying, but usually even based on the guidelines and the current data that just came published, when we are talking borderline has to be 6 millimeters. So this here is less than 6 already. Now in that situation, you want to do an FFR of just analyzing the left main, we understand, but the patient has significant disease of the LAD. So you need to take care of the LAD first and then evaluate the left main. So you have borderline osteal circ, you have osteal LAD lesion, you have left main. So you're going to take care of the LAD, not take care of the left main. Rather than that, you have one imaging data here which is saying distal left main is, for us it's significant, but if they say it's borderline, that's fine. But then you cannot take care of osteal LAD and then leave the left main lesion, FFR, then decide. So rather than that, you put one stent across.
Okay,
That's probably
my other question here
only,
is,
only IVUS.
Okay, sure.
in the other view that you just showed us, I didn't really love that circumflex in the more, it looked like maybe there was some, maybe you can, as you're imaging, take a look at the last picture you took with the circ.
You're talking about the outflow of the
Yeah.
circ?
Yeah, no, it doesn't.
It looks a
I
little
picked up a
funky.
little,
There's something funny looking about it. and she
something
imaged
funny,
it.
FLK, funny looking thingy.
Yeah, I was worried about that. The outflow's not good, and it was a little dye swirling there.
Yeah, maybe you just, as you're doing the imaging, AK, maybe you can show that LAO caudal.
Can we show the hemodynamics?
The LAO caudal
in
that
the
you
side?
just showed us before. The
Now,
last,
what happened is, like I mentioned, as soon as we are entering with the imaging catheter, since we did the circumflex PCI and we are waiting to come to go live, we started having some EKG changes. That's why I'm moving fast.
Let's get the stent.
okay.
So let's
Just
go
show us
back to your question.
this one. You see that in the circ?
So there's a wire
Yeah,
crossing.
that's just ectatic
a vessel
circ.
crossing.
That's just ectatic circ.
Okay.
Yeah, I think that is probably the case. It's ectatic and there's a lot of blood
Yeah,
flow.
there's
'Cause they
post-stenotic
had a
dilatation, but in
post-
the other view
They had
it
a
looks-
post-stent, IVUS and OCT, and the outflow looked fine.
Yeah, the outflow had some
can-
malopposition, and that's flow
That's what I-
dynamics.
Yeah.
That's what
That's
it
what I'm
is. So
worried.
it's really nothing going on there. IVUS looked pretty decent, no dissections and stuff. The problem here also is your rotoblader started in the left main, and because of your wire bias, you cause injury in the left main. Now you're forced to fix the left main. And that's the issue, right? So, if you started in the left main, you cause injury in a lesion which is 5.4 millimeters squared, now you are forced to fix the left main. That's what Anu's rationale is, right? Anu, you're thinking about putting a stent from left main into LAD, and then I think you probably will be forced to open up the stent struts into the circumflex, either DCB or something needs to be done into the ostium.
Well, Dr. Kinney makes the point
We've had 38.
that, there's so much diffuse complex disease in the LAD that she wants, either way, she wants to have good outflow into the LAD, and I don't disagree with that. So the question then really becomes, the only problem with left main stenting is actually the osteal circ. That's where all the recurrences come from, is the osteal circ. So the question's really going to be, what do you do with this osteal circ? And if it looks really stable and it's a 30% angiographic stenosis and it's a 3.9 millimeters squared, then, I think you can leave it. I don't think you have to do a two-stent technique or even, do a DCB or a KISS.
Excellent point, Greg. And I'm wiring the circ. This is for the audience. If I'm doing this case by myself, I would not wire this circ, but that's okay. Let's move on. And there was a question about, you have to do it for the audience. Like if you see here, there was a question about calcium in the left LAD. So if you can see here, this is the balloon, and this is you see a still picture. You can see tram track.
Yeah,
that's still under
We see it,
expanded.
yes, still under expanded.
And what pressure were you at with that?
This was 3.5, then we went up to 22 atmosphere. We opened up. Now, since we have, you can see some EKG changes. It's probably from the diag, D1, D2s. There's so many branches. I don't think we want to image. Okay, again, but now at a high atmosphere, it opened up. But otherwise, I think it's ideal. You want to go re-image and make a decision.
Yeah, so
that
here
do
you
want
see
to
it's
use
over
IVL
300 degrees of calcium.
Are you going in with a stent now? Because I don't know, were you satisfied
Yep,
with your?
we're going in with a stent.
Oh, still?
You had a post, tell us, we did a quick IVUS when you guys
so-
were talking. Tell us quickly.
This is IVUS. Of course, the IVUS resolution, not clear calcium fracture or something, but the MLD, it was 2.0, and now after the loader 2.4, like slight increase of the MLD. Yeah, but
No,
still,
we did balloon.
Yeah, okay, but that's why the MLD 2.4. But with this resolution,
You see a
it
couple
might
fractures.
be calcium fracture.
Yeah.
Yeah.
2 fractures.
So I think we are good. Yeah, so I think we are good. We are just going with the 3.538. I know there's a lot of discussion what to do with the left main. We just put one stent and stent across. And I know Jazz is discussing about recross and KISS. And I think, Greg, you can discuss our combined paper from the very old Excel trial, right? Where we decided not to recross KISS. Go.
The problem is you put a stent that is malopose distally. If you, in the circ, in this 360 degrees of calcium, and you can shut the door to the circumflex. So wiring is critical here. You have to wire because this is definition criteria, very high risk bifurcation because of the calcium. So wiring is essential, which you did. The question is, you know, for you to leave a circ ostium like that, especially with a fresh stent, which is malopose, is probably not a good idea. So I would at least do physiology to make sure that there's nothing going on there.
Yeah, so the malapposition doesn't bother me at all.
Because it's
the
the
malapposition
distal, right?
in a huge vessel is
a huge
not a
vessel in the
predictor for
distal.
anything. So to me, it's really, you just want to know that that ostial circ is large enough, that it doesn't have a dissection, and it's not, not disrupted, et cetera. In fact, you probably have less of a chance of restenosis of the ostial circ if you don't dilate it or treat it.
Right, but the problem is, if you put a fresh stent and you are markedly ischemic at the ostium, then that's an issue. That's an issue because that's flow dynamics. So that's the only thing I'm thinking about, just to make sure that when we finish off, that there is good flow in
Give me
Give
a
us a twin pass.
Twin pass.
And nipride.
Nice. Yeah, looks.
Okay,
well,
so
what
there
about
is some
the
distal
proximal-
LAD flow issues. We are going to take care of that, and then you're going to
That
post.
proximal edge, Paul,
Yeah,
where
the
they
proximal
guide it.
edge.
Yeah, no,
the proximal
You might
edge.
want to look at that with the imaging again.
Twin pass.
Well, it's got to be.
Ostial LAD, no, ostial left main, you was okay, right? On
Well,
your
the proximal,
imaging?
yeah.
We're looking right at the edge,
Just at the
right at the
edge.
edge of the guide
Just at
where
the
there's like a
edge, where
little,
the guide is into the stent.
you want to make sure it's not stent deformation.
Yeah, I think it'll
I
be.
think you're going to want to put a little.
No,
stent
no, we did not come up to the ostium for the same reason. We can have another group of discussion here. Should we have come up to the ostium or should we have stayed away from the ostium? I stayed away from the ostium, and let's take a circumflex, this caudal picture, and then decide on the proximal optimization.
Looks okay.
To me, circ looks good. I'm going to take out the wire, get us a 4.0.
408 high pressure.
Good. See, also you have to see, you have some EKG changes, the flow is abnormal, you got to move with the speed of light here.
EKG is better now.
Yeah, getting better.
So what's next here? You're going in for
going
optimization
to-
of the stent?
We're going to pot the
Yeah.
pot the left main.
And we have some vasodilator therapy with the twin pass, so we can give it distally. And after this, we are going to image before we post-dilate.
Yeah,
Okay,
because
just
I
make sure
actually
we're okay
thought maybe the proximal, that ostial circ, looks a little bit more pinched than your last, and it's expected, and it might get even more pinched as you.
Do you do,
looks
Dr.
okay.
Kinney, do you use something like stent boost to get the balloon right up to the proximal margin of the stent?
there. Yes, good, down. No, there is a stent boost in this room, right?
Yes.
But I usually don't use it, but I would recommend if people, they want to use it, they can use it, yes. Show the picture of the
depends how big the
EVA
patient
I was
is.
there.
10.
Down, yeah, good.
Ready?
Okay, let's do a quick IVUS, then only we consider post. We're going to go with a quick IVUS run, then I give vasodilators
After.
to the distal LAD. Has Dr. Sharma come back?
Yeah, and what we
No?
could do is
Otherwise, I
go
have
to
go
Dr.
other side.
Sharma's lab and come
No,
back
no,
to you.
we are done, we are done. We are going to show you
We're gonna show
IVUS,
you
then we are
IVUS.
done. We are just going to give vasodilators in the distal.
So you're
vessels.
leaving the circ alone? I don't know,
Yes,
I'm not,
100%.
I'm not feeling that good about that, but I'm just telling you. But who am I?
I share your concern, Roxana. But who am I?
Check the final IVUS.
You guys are good with
Okay,
that,
it's
sir?
native.
Post-stent?
No.
Anybody good with that?
I
No
would-
one on the panel feels
stop,
good about the
Tuvok.
circ, it's not just me.
It's coming.
I'd want to
Yeah,
image
it's
it,
coming.
actually.
So distal, yeah.
So
and
if you're
we
not
do-
going to routinely treat it, I'd want to image it.
If you do image it, Greg,
I
the
can check
problem
area
I
here.
have, at least with the IVUS catheters, you can actually lose the tip of the
I'll come
IVUS
to left
catheter
main.
through a stent strut if you don't dial
Well,
it.
you don't go
Nice.
crazy pushing
Nice.
hard if it doesn't
I will
go
stop it.
easily, so you've got to take that into
That's when you pull
You
it
know, you
back.
could
I've
just
lost
do-
it.
Oh,
There are so many options now, because if you could
Well,
go into that circ,
that's why-
just do a physiology.
do
If it
OCT
looks good,
for-
you're done. If not, you can even go in with a drug-coated balloon for that osteal circ.
Right. And
I
then you
mean,
get-
those are the kinds of things
Yeah.
I'm thinking about, but let's see what Dr. Kinney is thinking.
Okay, show us the distal edge, proximal edge,
So-
and give us a stent
Yep.
personally, I
5.8,
wouldn't treat
anything
a
above
large
5.7.
osteal circ
Very
with a
smooth
drug-coated
transition.
balloon. If
Yes.
I'm going to do it, I'm
Section,
going to treat
normal
it.
position.
Let's
This
see
is
what
distal
it
edge.
is, what-
And come to the
Right.
proximal edge.
DCBs and the
This is
also
natives,
smooth
okay,
transition.
small vessels,
Just a
side
residual
branches,
plaque
et
at the
cetera, but
proximal circ.
Okay, what does proximal edge is good?
Good. I mean, the
No, every-
residual
Proximal,
plaque
it
at
shouldn't look
the
so bad, but
osteal
yeah.
main.
what is the stent area of the?
Yeah, so
of
this is the
in
mid-lady.
in the
No, no, he
left
wants a
main?
left main stent area.
Yeah, that-
Yeah,
Okay.
It looks like
Left
he
main
about-
stent area.
yes,
Now come to the
You're gonna
proximal
cut him
part.
balloon.
yeah, stay there, stay there.
Yeah,
Right
so
there.
this is the left
Yes.
main. One
MSN.
second, dot.
Yeah, your left main looks good.
This-
Your just primary
Yeah, like
calcium area is
Looks
not
good.
expanded.
10.1, yeah, I
Left
mean, it
main
could be
MSA
expanded
10,
further, but
LED
it's
MSA
large.
5.8. No edge dissection,
looks
no
good.
malposition. It's an optimal result.
Okay, good.
And
Final
how
picture.
was the edge of the left main stent? We were just worried about that
look so
proximal
bad.
There is a
edge.
It didn't look so bad.
residual
Yeah, that
plaque,
looks
but
pretty
I
good.
don't
Looks
think
pretty
there's any
good. That looks pretty
dissection
good.
at the osteal.
Looks
That
good.
shows you how the
Ready?
angiogram can fool you.
Okay.
And then the circumflex, what are we going to do with the circ?
Yep.
Yeah, the circ looks bad.
Yeah.
Put a higher
Okay, what do you think of the circ? Osteal circ.
I would leave it alone. Since everybody wants it, now you're telling me recross it, then you try to get imaging catheter, FFR, that's the time you'll start messing up with
No,
the
I
left
would,
main stent.
you would deform the
Yeah.
stent if you did imaging. I would just put a physiology wire in there, make sure it's not markedly skinny.
You won't deform the stent if you use
Okay.
OCT and you have a sheath.
That's true.
Then you don't deform the stent.
That's true.
Okay, so let us
Safer.
get, we go to Samin Sharma's room and then we will tell you
Okay,
what's the
thank
FFR of the
you,
circ.
thank you, Dr.
Yeah.
Kinney.
This
Let's
is-
go to
this is
Dr.
for the
Sharma's
audience.
room.
Let's get some flow.
Not yet.
Hello, Dr. Sharma.
Okay.
We see you with Dr.
All
Huda.
right. Good. Oh, all right. We have, of course, and then we have additional, our fellows, Swati and Bharat, and our RNs are Vicky and Aldina. Imaging Kiski will come if needed. CVT, Nino, and Hakim. So all we are ready for this case. Very interesting in the left main arena, which we wanted to, this is the session this morning, along with hemodynamic support device. So this is interesting. 85-year-old male was admitted outside hospital with a small non-Q wave, apparently has a known total occlusion of the right coronary for a long time, and was found to have shortness of breath, as well as, of course, continues to have some angina. They did the angiogram, risk factors on the left side, kind of well controlled, and they actually, after he stabilized with the diuretics and so and nitro, they actually did the stress test on him before sending him for angiogram. I mean, this kind of patient comes to the non-STEMI with heart failure, you probably take them to the cath lab by every I would say, recommendation. But anyway, they did the angiogram, which was a 3-vessel disease, and ejection fraction near normal. And that's where we are in this particular case because of the CAD. Now, if we can just go to our angiogram, please, so we can show what we have. Now, this is the case. Let's start with the groin shot. This is the patient we transferred. First time we have interaction yesterday. Good vessels. And we know the patient has mild aortic stenosis and ejection fractions of about 50+%. right coronary, CTO, which very calcific, you can see here. So a lot of bridge collaterals, some antegrade collaterals with the, which basically the, as you can see, the circular Vucens, QL's collateral, we crossed the ventricle, pullback gradient was 12 or 15?
Yeah, 15.
About 15 millimeter gradient. EF actually looks all right. But now we'll ask everybody first. RCA total, and this is the left main disease. You see the distal left main, disease of the circumflex, disease of the LAD. So what happened is outside hospital, they recommended patient bypass surgery.
We need
If
to
you are
see the
going to
distal
die-
left main a little bit better,
Yeah,
Dr.
we're
Sharma.
going to show, yep, right here. It's going to, this is a 7 French
Yeah.
catheter.
Okay.
And further
Severely
again, and look at the
calcified.
LAD.
This one I would rotablate.
And diffuse disease, yeah, very calcified.
You want to use
And, the
IVL
question
here,
is what to do.
Dr. Tierstein?
You know, you probably can, but
later. So
this
first thing
looks
first.
like a rotablator case.
No. First
Yeah,
things
this
first
case-
is the use of Impella. That's the question.
Yeah, now question is, you can ask people while we are starting, as Paul just said, we have put a wire and we are starting with the only 1.25. Tortuosity, a lot of people are concerned about 1.25. They think it's get stuck. But not the issue, in my opinion. 1.25 is quite safe. 1.5 can be used, but aggressive.
great.
Now, question only comes down to, of course, as Roxana said, we'll use IVL proximally, but after doing the rotational atherectomy with the 1.25, because IVL will not make a first turn out of the left main. So while you are having a discussion that should we use Impella in this case, it's not a BCIS 3 case.
Yeah.
It's not a Protect 4 case also, because EF is near normal. And patient
Yeah.
has a mild AS, that's okay. A 1.3 valve area. But
so
with
we-
the RCA is total, you are going to do a distal left main bifurcation. At that time, will be no cardiac output. That's why we felt Impella, and why that is. You are having discussion. We are starting with a 1.25 bar.
Okay, Dr. Sharma, great. I'm going to start with Dr. Reitman, who hasn't yet commented. What do you, first and foremost, is this a case that you feel compelled for an Impella device?
Well, I think the first thing is you cured his mild to moderate aortic stenosis with the Impella. So you remove that from the equation. You know, Dr. Sharma we always started with a 1.5 burr, and I do get a little bit concerned about a 1.25. It's a long segment of disease, and when you start sort of thinking about this, Dr. Sharma showed us the sub-study of the shortcut trial that talked about atherectomy IVL and whether we cause medial injury, which in somebody like this is probably really the long-term question, which is this individual going to come back with restenosis, neoatherosclerosis? And I think by doing it this way, plus IVL, you minimize the medial injury, and he'll end up with an excellent result. And I think you have
Okay,
to use Impella.
I want to just get a better idea about the rest of the panel in terms of the use of Impella device with Dr. Stone at last to tell us, since he's the PI of the Protect 4. Bill Nicholson, would you be using, just yes or no, would you be using an Impella device in this case?
No.
Jazz?
Go for it. Done.
2 no's so far. Dr. Tierstein?
You know, I would, because this is, the LAD, although it's well bypassed by himself, if you notice, it's
Yeah.
an amazing collateral. But the LAD, you know, this is the kind of lesion you can get in trouble with. And so because of the lesion complexity mostly, I feel that, and if you can do it safely, you got to have some skill set to make sure that you don't have a femoral complication. I would do it.
Dr. Gibson?
I think it's reasonable. You're going to send a lot of things downstream with the rotablator. This vessel's supplying a lot to the right. There's a little, you know, there's some AS there that's now been resolved with the Impella. So I do think it's a good choice here.
And then last, Dr. Stone.
Well, again, this is not a Protect 4 case, as was mentioned. I think you could probably do without Impella in this case because of that collateral. I mean,
Yeah.
that was like the biggest circle of Willis I've ever seen.
Right,
I mean,
exactly. And we saw he went with a 1.25 with very, very cautiously.
Yeah.
I think this is a really important teaching point also, Dr. Sharma. Maybe you want to talk about the burr size, because often we don't use that 1.25, worried about getting stuck and not being able to come back. But now you use that, and maybe you could give us a little bit of an understanding of why you chose that, and what are your techniques when you are using such a small size burr?
Yeah, so I mean, question is, as I said, a lot of people are worried, and I can tell you, in our case, the most of the burr struck happened with the 1.5, not 1.25, and go a little cautiously. Now, 1.5, in my opinion, what is going to do is create a lot of gutter, because 1.5 will have its own mind. 1.25 will go into the direction of your wire. So we prefer 1.25. I know of the 100, let's say, rotablation, our 60% are 1.5, 20 are 1.75, and about 15 are 1.25, like this case. And then rarely 2.0, and more than 2.0 should not be used anyway nowadays. So with that note, it's a reasonable. Now what it done is, you can see, despite that calcium, the whole vessel will open up. This is a 2.530 balloon. And
So you're not upgrading to the next level. You're not upgrading to the next level of, because I feel like you didn't really do enough, but let's see.
That's a very good point, 20. No, but I just want to say this on this issue. The second burr, in this day and age, unless a special circumstance, it should be IVL. Your second burr is IVL. So what you have done, 1.25, shaved the calcium. Now this balloon going to do a job, and proximally, we have 3.0 IVL for the distal left main and proximal LAD. You are right, Roxana, it may not have done much work, but we are not talking about the debulking. As long as you take that calcium out, so that now, and the balloon, of course, ruptured here, we can get
so
a 3.0 balloon.
you need more work. So here comes your IVL now for your second
No, not yet.
burr.
No, I think we have to go a little more balloon dilatation, and then we can stent the distal, and then we put a IVL in the proximal area. Because this is a good vessel. I mean, lot of diffuse disease, as you can see.
By the way, I didn't see any low blood pressure, by the way. I haven't seen your Impella device with good use so far, but you tell me.
So far, so good.
Well,
but remember, if you lose the pulsatility, it's a bad sign. At least that's what we learned from the BCIS3. Hopefully, it is not going to need. That basically maybe tell that maybe not every case you need go up here. There is a little, anytime you have a balloon rupture, it causes a little bit of active,
Is this a stronger balloon? Is it rated at higher pressure, what you're using now? Is this?
No, it's a regular, not the open NC. This is same non-compliant balloon, which is not uncommon in these cases. They rupture with that calcium around, but
so
now
why
what
not
is
use
going
a
to
cutting balloon as your second thing there, once you see that
Usually
you're...
the problem is a spicule of calcium. And I'd probably do some other atheroablative technique to try to eliminate that.
So let me ask, with this, you have a CTO of the right. These are the cases when you do atherectomy, they get very sick because you embolize to multiple territories when you do that.
It's gone.
And they get sick later. So like they get sick in the unit like 4 to 6 hours later and go south. And so how are you making a decision whether to leave that? The Impella, to my mind, in this case, is only useful to bridge this guy for the next 12, 24 hours in the unit. And making a decision in the lab as to whether you're going to leave that Impella in or not without a right heart cath. How do you make that decision without some hemodynamics to help steer you?
So very good point. So basically, we'll go with the angiogram. Yeah. So question was, in the part of a PROTECT trial, we have center who mandated that they will do the right heart cath. And we participated in that. We said no right heart, maybe some cases. Now, by and large, we do not do the right heart cath in these cases. But some cases, maybe in this case, could have not have been bad because of AS. The balloon rupture, we're worried about that area, but I think we are okay. So now question is that do you stand? That do you leave with the guideliner? So do you leave the Impella? Now I can tell you that about we are done close to 450 and 500 MCS trials, and guess how many patients we left the MCS device? N equal to 0. And none of them, because if you did a good PCI, good results, you don't have to worry about something will happen at 8-12 hours later. Yes, if you're suboptimal, then maybe you can downgrade to either balloon pump or continue that Impella. But so far, none of the cases, 88 cases within PROTECT 4, 0 Impella. In Magenta, we have done now 60 cases with 8 French device, Elevate 3, 0. And before that, other trials with the PROTECT 2 and so, we have not done any impella left so far.
Okay.
So that's where
But
we
it's-
are.
Let's see where we are now.
As you always talk about, though, with rotational atherectomy, you're almost always giving a little bit of neosynephrine, et cetera, concomitantly
if
with
blood goes to less than-
atherectomy.
yeah.
So, I mean, this may be a little spuriously high compared with, you know, I think it would be, without impella support, this just strikes me as a very challenging scenario.
Well, your blood pressure, your starting blood pressure was high, your EDP is low, your ejection fraction is normal, you are preconditioned. The reason why he's tolerating is for all those reasons. So you could go either way. With rotational atherectomy, the concern is when you have myocardial depression, it usually happens right after the procedure, and it lasts probably 2 hours before the retroendothelial system to absorb all the stuff. So ejection fraction, that wall is down for probably a couple hours. So when you are doing the procedure and the procedure is finished, if they're hemodynamically stable, I think leaving the impella over, in the ICU is associated with more bleeding and more complication than anything else. So I would favor just removing it.
Yeah, I would agree. I'm not perseverating on this case because there's a normal EF and it's very hard to kill somebody with a normal EF. But I'm talking about somebody with a bad ejection fraction that you're going to rotablade, you're going to embolize the two territories. That's the person that's going to get sick. This guy is not going to get sick either way.
No, but I think, let me come back to it, because as I mentioned, the 500 cases in the trial, many of them with a protect EF of 20%, 25%. The key is you're not going aggressive rotablation. You're not doing much of this side branch, or basically slow flow and so. And you have good flow after your rotablation, TIMI-3 flow, you are given vasodilator. That will not get into trouble. If trouble will be in the lab, that patient will have a ST elevation, then maybe you put a balloon pump in that particular case. But that's the way I would treat this case. Now we have the 3.0 IVL. Let's start now.
Yeah, so I
saw that area
like
which did
this.
not open. Yeah.
And
So
do
I would
I
have
see a
done
guide
IVL.
extender there? Is that what you have, Dr. Sharma? Or
Yes, I noticed.
I'll show you that.
you got to keep our audience up to date here.
Arrow.
I see a
Yeah.
guide extender.
So you
What was
put a-
going on there?
Yeah.
But if we, the
So
other
what we
thing
did
is,
in this
Jazz,
particular case, see this area had not opened up.
Yeah.
We advanced the guideliner.
That's right.
No, it's a Gargilla, and that area which did not open up, we are doing the IVL.
Okay.
And do it before you put a stent. So this is where we are 3.0, new IVL arrow, which is more flexible and goes to various areas, and you can just leave it at the 4 atmosphere. You don't even have to change it to 6 or so. Just do 10 seconds, and the pulses are a little faster, so you can finish your job in much quicker, like 3 or 4 seconds lower. And I know a few of the IVL devices delivering all the energy within 5 seconds, because that may become important. Patient with a left main disease. Go on.
Yeah, and
So
your
how
guide
much-
extension is in there. Is that blocking the left main? Do you have good flow around it? Because you could pull that
Yeah,
back
well,
now.
blood pressure is a little down, as you can see there, hemodynamic. Yeah, but
His blood pressure is
I will
very
pull it
stable,
out.
so that tells you
Yeah.
it's so preconditioned with a guideline of being occlusive in the left main, right?
Yeah.
So the hemodynamics are great.
And maybe
But
the
Jazz, by
collateral
your
is-
earlier comment, if you're probably gonna do rotational atherectomy of the circumflex too, right? Because that whole segment was diseased too. So now it's 3 walls that are ischemic, because the right's completely infarcted. And so, again, just thinking about the need for support, does that
I'm not-
persist beyond?
I have not yet been convinced that we needed support so far, but let's keep going.
Well, multiple areas, atherectomy, those are all theoretical things, and they matter, to Bill's point, when your ejection fraction is low, because you really don't get the microvessels to really
Okay.
adapt to what you need. When you have normal ejection fraction like this, I usually don't worry about that.
Okay, so Dr. Sharma, the big question is, when are you going to do some imaging here, or are you planning or not?
Yeah, we'll see. So right now we are far away from imaging because there's no surprise yet. So this is what we expect, right? Calcium angiographically required both rota and IVL. And remember, I would say that impella has been placed for one purpose, not for this rotablation of the LAD. No, impella has been placed for the purpose of the left main bifurcation PCI. That time, RCA total, even your 30 seconds or 20 seconds of inflation, I can tell you, will make it a blood pressure of 0 to 10, and that 10-second, 20-second inflation then will create the cycle, which we said earlier, going down, 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 and that is where the trouble will happen. So that is what we want to avoid, and this is the one which, despite this, we need a balloon
the great
again.
work
a
of
2.5
IVL,
balloon.
you still can't pass it. Oh, there it goes.
No,
There we
it goes.
go.
No, of course it'll go.
There
Of
you
course
go.
it'll go. No question there.
Good guideliner.
The other thing you could have used is a wiggle wire here. It's really helpful.
Go. Yeah, so this is looking very good. It's a 2.548. Giant.
Okay, let's go.
Yeah. Samin, I want you to take a lithotripsy balloon and leave it up in the left main, and I want to see the hemodynamics. Nothing will happen.
One will come.
Well, right now also with this blood pressure, remember the Impella,
Yes,
high
it's helping.
afterload works
Yes.
against the Impella.
We get that.
So right now, it's not augmenting that much flow. Where it becomes useful is if you end up with no flow in the
Exactly.
LAD or the left main, then it becomes essential.
So what I'm going to do, that once we do a balloon or any stent of the left main, for a few minutes, we'll stop the Impella. And that will be the I would say the indicator. You can go 20 atmosphere. 20. That will be the 24. That will be the indicator that we needed in this patient Impella, yes or no.
So,
we know that many
Dr.
times we don't.
Sharma,
Yeah.
we have 12 minutes left. I'm thinking that we can go to Dr. Kinney, if you don't mind, and then finish that and then come back to you for the duration because we
Okay.
and
Yeah, show it,
have
show
you
it, show
work
it, yeah.
in peace a little bit and
Yeah.
then show us, okay?
Yeah.
Let's go. Dr.
Okay,
Kinney,
good.
are you
Go.
ready for
20.
us? Hi, Dr. Kinney. I knew
Are they
you'd be
showing?
ready.
We are not ready. We finished the case.
I know. That's what I'm saying.
Yeah, please. This is the next patient on the line. Do you see that?
Yeah.
So that's the final picture. No, let me go back.
Wait, but what did
Where's
the
the
physiology
show?
show in there? That we were
Okay, take
also
a guess.
concerned.
Take a guess.
It
What do you
looked
think the
perfect.
physiology
It
showed?
was normal. That's why you finished.
Remember, we wanted to finish the case, but everybody wanted physiology. We can show the physiology. We did the IFR.
0.98. Excellent.
Pretty good.
Feeling good about that. Excellent.
Yeah.
I just wanted to make
So,
sure.
So not only eyes for imaging, we are going to start using eyes for physiology also now.
All right, good. Well, thank you so much. Excellent. We'll go back to Dr. Sharma. Beautiful work. Okay, Dr. Sharma, we're back to you. You still haven't used the Impella. I want to make sure we're getting our money's worth. Let's go. Next. What are you doing next now?
We had placed the stent, and now we are doing the left main proximal LAD IVL, which we did not do earlier. Huh?
You give the IVL.
Or IVL for what?
IVL.
IVL. Yeah.
Okay. IVL going?
Yeah. So we are. Yeah. IVL is going.
I'm just saying, Dr. Kinney's all done.
Yeah. Okay. Good. Go negative?
I mean, the key with that physiology case is amazing because you really simplified your case, right?
Exactly.
You don't go by eye and say, listen, it looks bad, I'm going to put stents, I'm going to DCB, which
It
is
really
the fed
helps.
everybody wants to do.
Yeah,
You just
gives
put a
you-
wire in and physiology and you're done.
Right.
And the fact that they didn't have to intervene on the osteal
It's
circ
wonderful.
is most likely not
Most
going to
best
restenosis
thing.
and get worse.
Okay.
Okay. Let's
What-
see. And you got a stent
You
there?
got the IVL
So
now?
we
You're
are
going to
going,
go in the
yeah, IVL. Yeah.
IVL in.
Okay, just 1 second. IVL. We still have a lot of. Go.
Well, that's still in the proximal LAD, correct?
Yeah.
Okay.
Proximal LAD. Yeah.
3.5 IVL?
Yes. Trio. This was same trio. The
Oh, the
cycles are
same
left,
one.
you're right. It should be 3.5. Yeah. Same
You still
one.
have energy left there?
and- Oh, yeah, quite a bit. Still
Okay.
7 more cycles. Go.
Okay. I guess the other thing is
And
the
the second
cost
I-
analysis of combining ROTA with IVL versus two burrs versus just IVL alone
I know.
with other things. That's the cost analysis that I know you're often very worried about. What do you think, Dr. Sharma?
No, I mean, same thing that IVL actually, it's a good thing now We have the reimbursement of combined technique in appropriate cases. That's a good thing. Since of January, January, a lot of CPT and new DRG codes have come for these kind of combined procedure, which is good. And that's why we are more liberal in using both cutting balloon, DCB, as well as the IVL. So this is where we are. Now let's see the picture. Let's see our guide, some idea where we are. Ready? All right.
Let's see. You're right, the costs are higher. We get reimbursed, but we still have a responsibility to the health system to keep the costs down. But in this case, I think you have to take care of the patient. I mean, the patient, we're not usually thinking about cost with a patient like this. I mean, think about the Impella. That's a $100,000 reimbursement.
Yeah, the problem
so
here is
I can tell you,
with 1.2
in all our interventional device, listen to this now. This is the called the fact or the highest contribution margin procedure done in interventional cardiology is Impella, because and not even your tower, mitral clip, and this many of them actually lose money in the tricuspid side because of the cost. But highest is Impella, because the DRG has said, Paul, that it's about 100, anywhere from 98 to 120. Based on the DRG 1 and 2, and it's a cost is, of course, the 28,000 of the Impella, but still, it's a 50,000 plus ACM for all Impella cases, but has to be appropriate, and this is where the whole field will go or not go after we get the trial data of the Protect 4. Now, see, so far, so good. Agree?
Yeah.
Yeah. Okay, now question is what we do to the circumflex. Let me just see. Yeah, filter wire. Okay.
Are you going to do SKSSS or what are you doing? What's your plan?
No, this
for
was
that?
vinicrus. No, we don't do SKS now. Long time. No provisional. No.
Did I miss it fast? Or
Minicrush.
Is the collateral gone now? I think you.
No, the collateral is beautiful.
No, it's still
and
there.
I just saw it.
Yeah, big collaterals. Collaterals are big. It's still there. All of them. So now the question is the circ and the left main.
Well,
anybody give any opinion?
This circ, so, I mean, this view, I can't tell. You would have to image it.
Yeah, I'd really
My
like to
eye
image.
isn't that good, but
I'd
as
really
good
like
as
to
you
image
guys.
this whole vessel.
I'd like to see it imaged
Okay,
before
let's
I
see
could
the LED.
tell you.
Okay, we are going to image the LED.
Left
See
main
the
and
circ on the
LED
side.
are tight. The circ looks moderate. The ostium doesn't look involved. I just make it simple. Just 85-year-old, fix his left main LED, leave everything else alone.
Yeah, that's the point.
That's what I would do.
But before you say you're not going to do anything.
Yeah. Okay, the
85.
imaging finally coming in.
Impella and an 85-year-old. I'm impressed,
I'm almost
Dr. Sharma.
85.
I want to see you use it and need it.
And patient is going to need a tower in about 2 years because valve area 1.3.
Good.
And patient apparently has no other comorbid conditions. I mean, he's good. He has a little bit of MI, inferior wall long time ago. Otherwise, he have been fine. And okay, now this is we have the IVUS. Okay, let's see.
Okay, check the image.
Can we show it? Yeah.
Yeah, it's today's stent, okay?
Yeah, that's okay within stent. Just we want to more proximal and look at the ostium of the circumflex.
It's coming. Today's stent, yeah, looks fine. Some carton behind stent. Now it's native.
3.5.
Looks pretty good.
Lot of disruption.
From my little naked eye.
I see some fracture and nodule in the left.
Yeah, I think at least 20.
I will stop it. You can take it out.
Looks good, right?
Yeah. Today's stent
3.5,
today's stent is
very
like
fast.
5.6, will expanded.
No, stop at that level. Yeah. Show the ostial circ, my friend, again.
So, sir.
But stent has nicely expanded that area?
Yes, 5.6.
Okay. So, we are not post-dilated yet, which we'll do. Okay. So based on that, ostial circ seems to be with the eyes, not with the, we can say EB-IVUS, eyeball IVUS or IVUS. There are many terminology. Looks okay. So what we are going to do, what Jess said, that avoid the stent because ostial doesn't look bad. Then let's leave it. Moderate disease of the circ, this guy, and we did a left main to LAD. So that is where now 3.5. 33 is going in. If looks good, then you can go start your sessions. How do you like that, Lil Dai?
We like it because we have 4 minutes to go.
Yeah. and get a 4O balloon. Yeah, little dive first. We have to pull back a little bit.
Yeah, there was an eccentric nodule in the where your balloon was not expanding, and the rotor, probably the 1.25 bias, was away from that nodule, and that's why you probably needed lithotripsy. And that's probably where the combination is going to work, is nodules. Otherwise, I think rotational or orbital followed by a specialty balloon with a shortcut trial and stuff like that is probably the way to go.
And Dr. Kinney is doing a study on calcific nodules and the use of IVL, and maybe hopefully she'll talk about it a little bit later. Okay, let's see this, because we're going to have to go to our lectures.
Just 1 second. We're not in little dive. We are there. Yeah. Ready? Yeah.
Beautiful.
All right.
It looks amazing.
Looking good. Gorgeous. We'll just complete the job with the high pressure balloon and pot.
All right, but I didn't see any use of impella. Thank you all. Thank you very, very much. Wow, what a wonderful, fantastic, two incredible cases. And we begin the lectures by our luminaries. This next session is really, literally what I've been looking forward to. And our first speaker, for the last 2 decades, I've been watching the work of Dr. Paul Ritker. He's a cardiologist, obviously, at the Brigham. He's the Brunwald Professor of Medicine at Harvard. But more importantly is the work that he's done over the last two and a half decades on lipid lowering, but most importantly on inflammation. And this next, in the breakthroughs in cardiovascular medicine in the last 5 years, I think he's the one who's truly deserves to begin this talk with us on prevention with lipids and inflammation. Paul, we're so grateful to have you here. So honored to have you here. Thank you for being here. Dr. Paul Ritker, everybody, get ready.
Wow, so thank you, Rox. I got to say, as someone who hasn't really spent much time in a cath lab in the last 30 plus years, it's kind of mind-blowing to see the incredible technology that you all are employing, and it's kind of absolutely amazing. And I want to repeat something that Rob said earlier. It's like, I'm incredibly glad you're there if I ever need you, but I really hope I don't need you. And I think that's what this talk's going to be about how do we do preventive cardiology in a modern era. And I'm smiling that at an interventional cardiology meeting, we've got 12 minutes to go through all of preventive cardiology. But I'm going to do this in a way that reminds us that this is to prevent you from also needing your colleagues to intervene on you. So we'll see how this goes. Okay. We have 2 things to cover very quickly. One is residual cholesterol risk, and one is residual inflammation risk or residual inflammatory risk. Your patients have both. Some have extremes of one, some have extremes of other. Almost all have both. We will get to universal screening for high sensitivity CRP, just like we have universal screening for LDL, because it's a biologic reason to do this. And I think a good case can be made already that we know that lower is better on both of these directions. And I'll come back to that in a little bit. I wanted to start on the lipid side first, because Roxana said, what can we tell an audience of interventional cardiologists about what's new? So 3 important papers, all in the last 3 months. The first is the Vesalius trial. This was using a PCSK9 inhibitor, evolocumab, in patients without a prior myocardial infarction or a prior stroke. So this is sort of high-risk, technically primary prevention, but they're known atherosclerotic disease, and they all had to have an LDL above 90. Now, I would hope that everybody here is on a statin and that your LDL is well below 90 on a statin, but for those folks who are not,
I'm just going to fix your mic because I'm shorter than you, so now this is much better.
I'm barely taller. But thank you, Rox. Oh, I can hear myself. Great. And the bottom line here is not surprising, but it's good to have the evidence. If you gave a PCSK9 inhibitor on top of good lipid-lowering therapy, yes, you're going to get a bigger reduction in LDL and all the things we care about, 3-point MACE, 4-point MACE, cardiovascular death, and more importantly, all-cause mortality were reduced. So another piece of evidence. And to me, this is interesting because our Jupiter trial was published almost 20 years ago now, which showed effectively the same thing. Lower is better, so that's all good. That's number 1. Number 2 is more modern science. This is the first publication of an oral PCSK9 inhibitor. This is enlicitide. This paper also came out just a month or two ago. This is sort of a tour de force of pharmaceutical development. This is the ability to get around the needs for subcutaneous injections. There's a lot of really cool biochemistry that's been done to make this drug get through the GI system and get into your circulation. Bottom line, they've done a very nice paper here. Large reductions in LDL, large reductions in non-HDL, large reductions in ApoB, concomitant reductions in Lp(a). So again, consistent with what we'd think would happen if you gave this kind of agent. And the last is just really cool stuff. In vivo-based editing of PCSK9. This is the one and done thing you've read a little bit about, probably the New York Times. Single injection of a drug called VERVE-102. The biology of this, again, is extraordinarily interesting in what's happening in terms of blocking the liver from actually doing its job on a one-time basis and without going through the biomedical details. Again, big clinical effects. These data were presented at the EAS meetings that we were at in Greece a couple of weeks ago. Large reductions in circulating PCSK9, large, depending on dose, reductions in LDL, and quite durable out to a year. We have to figure out, is this going to be a therapeutic option or not, but certainly biologically it works. So lots of stuff in that arena. What I want to do is, though, is cover the part of this that I'm personally more interested in. The ACC put out a 2025 scientific statement. This was written predominantly by George Mensa from NHLBI. It's a really interesting thing to have ACC scientific statements, and I got to thank Rox for these that are sort of state-of-the-art as compared to our guidelines, which are maybe state-of-the-art. Scientific American also ran this cover, Your Heart in Flames, a radical new take on cardiovascular disease could save lives, in May, and it's largely an interview of our research group, which is very flattering for us. Couple take-home issues. CRP, high-sensitivity CRP, this marker that we use for silent vascular inflammation, it turns out to be at least as strong a predictor of future cardiovascular events as what we universally screen for LDL cholesterol. But the fundamental problem we have is doctors will not treat what they don't measure. We need to get to universal guidelines if we're going to introduce inflammation inhibition into clinical practice. Very quickly, let me show you the secondary prevention data that we published now a couple of years ago from across the room. This is everybody on a statin. The black bars are the predictive utility of high-sensitivity CRP on recurrent cardiovascular events after they've been out of your cath lab and everything you've done wonderfully for them. Their biggest risk is the inflammation. Now, we all lower LDL cholesterol. That's very important. All the trials show us beautifully to do that. But notice that the LDL in white is a much less issue. So again, we have this unmet clinical need. That's the secondary prevention. When we published this paper, we did something that at the time was very provocative. In fact, the editors of Lancet said, Paul, are you sure you got this right? And we said, okay, we have these 4 groups on a statin based on the LDL above or below 70, the CRP above or below 2. Start in the far right-hand side. If you're in that situation, the CRP is high and the LDL is high, that makes sense, the risk is high. But right next to that, the second bar in from the right is a very interesting one. LDL is below 70. We've done our job. But the CRP is above 2, and the risk is just as high. And if you go one step over, where the guidelines are now telling us drop that LDL to 40, 45, well, okay, absolute risk reduction is very small, relative risk reductions are there, but the risk isn't there. And the question is, was this replicable? When we published this is what the data we had. Roxanne has stepped in. They published very similar data in a secondary prevention cohort, all post-PCI, exactly the same phenomena. That the high risk is sitting on the right-hand side when the inflammation is there, irrespective of what we've done with the LDL. So again, the kind of data we need to move this field forward. Primary prevention. We published these data in the New England Journal on purpose. I will admit it was a bit of a political paper to try to get people to recognize that this whole phenomenon in secondary prevention also matters in primary prevention. So this is our women's health study cohort, nearly 28,000 initially healthy American women funded by the NIH for the last 32 years. A random blood sample for CRP on the right outperforms LDL cholesterol on the left. Now, obviously, we're going to screen for LDL cholesterol, but the guidelines have to get there. And we have to get past the inertia of saying we don't really want to take inflammation into practice. A very recent paper from UK Biobank is just sort of the grandfather now of this whole thing. 448,000 patients followed for 14 years. The far left recapitulates the whole story. MACE, HSCRP levels less than 1, 1 to 3, greater than 3, clearly predicts risk. The middle is a variable importance plot. CRP is actually outperforming obesity, kidney function, LDL, diabetes, and blood pressure in terms of predicting mortality for our patients. And the right-hand side is probably the most important thing for those of you who don't measure CRP because you're concerned about variability. Turns out the variability is actually no worse than blood pressure. It's no worse than our cholesterol levels. This is an alluvial plot showing some people do go up, some go down, but the vast majority, 2 decades apart, are in the same setting. I also want to repeat something that we did. I admit this was a little bit cute. We were trying to transmit this knowledge to our primary care colleagues. SMRFs, besides being these 1970s little blue guys, are standard modifiable risk factors. If you're SMRF-less, by definition, you have none of these. If you're SMRF-less but inflamed, you're way outside prevent guidelines. You're way outside what the ACC and the AHA are doing because your risk is anticipated by the guidelines to be very low. We know it's not low if you have this process. So we did a number of epidemiologic studies. This is the first one we published. It's been replicated again and again. If you have no major risk factor, but you do have this chronic inflammatory process, your risk over your lifetime is actually quite high. And so we went back to our Jupiter trial, again, published in 2008. But it turned out we had 8,278 individuals in that trial who had no major risk factor at all. Never would have qualified for a statin, but they had an elevated CRP, and we had a 38% reduction in hard events, 69% reduction in MI, 47% reduction in stroke, and a 40% reduction in revascularization. So again, the point of this talk is, I love the fact that you're there when I need you, but I'd frankly rather not be there. Last, what's going on in the inflammation biology arena? It's pretty incredible. It's going to be a very big year. This is just the overview of this notion of what we're trying to hit here. Is this segment between IL-1, IL-6, the drivers of this inflammatory process. Because it's a short talk, just focus on the black and white micrograph in the upper right-hand corner. That's a cholesterol crystal. Everything you've talked about today shatters that crystal. That's great to reestablish blood flow. It's terrible from an inflammation biologist perspective because crystalline structures are activating this entire NLRP3 inflammasome, which is driving this inflammatory process. You're doing to save that patient's life, so thank you. But it is activating all that we're talking about here. The cover of Science, that yellow blob is, again, a cholesterol crystal activating this. So what are we doing? We're trying to target this. CANTOS was the proof of principle that lowering inflammation with a targeted drug, IL-1 beta inhibitor, could block that very process. We got the same 15 to 70% reduction in major adverse cardiovascular events that we saw with PCSK9 inhibitors given on top of a statin. So we know that inflammation inhibition works. You heard earlier today that colchicine may not work in acute coronary ischemia. That's probably true. It does work in chronic stable atherosclerosis. So after someone leaves your cath lab and you're trying to figure out what can I do to lower their inflammatory burden, you might want to think a little about low-dose colchicine. And then last, we are now embarking on a very new set of studies. So later this year, probably at the AHA, the very first of the big IL-6 trials that we've been designing will be laid out, and it's either going to work or it's not going to work. We're going to find out. But the idea that IL-6 inhibition will be the next step in this was driven by our work published in The Lancet talking about what can we do to get larger directed targeted therapy. This has been replicated now by a number of different drugs. Every major pharma in the world is developing something in this IL-1, IL-6, NLRP3 pathway. And this is just the overview of what you're going to get over the next year or two. The first of these trials, which I am the PI of, is called ZEUS. It's chronic kidney disease, it's atherosclerosis, an elevated CRP, very high-risk patients, aggressive care across the board. It's fully enrolled. This one will read out sometime later this year. And again, it's going to be the second major test of this idea, can we target cytokines directly on top of lipid lowering to lower vascular event rates. The Hermes trial is also just now fully enrolled as of like 2 days ago. That's a very interesting experiment. That's in the setting of HFpEF and HF mid-range, and that's a very different kind of hypothesis. And Roxanne is working with her colleagues here as well as down at DCI to run a clinical trial called Artemis, which is the acute coronary ischemia version of all this. CSL Behring has another IL-6 ligand inhibitor called clazakizumab, which they're looking at specifically in patients with dialysis, residual inflammatory risk, elevated CRP, and atherosclerosis. And Tourmaline Bio and Novartis just picked up another drug, which is another IL-6 ligand inhibitor. So you can hear a lot about this in the near future. Move one step upstream, you're at the NLRP3 inflammasome itself. Just accept the fact there's many different ways to alter this inflammasome. This has the possibility of being a terrific therapy because it's oral. It has the possibility of being a problematic therapy because it's upstream. We have to figure out risks and benefits of this approach. But I wanted to leave you with a clinical pearl or two, thinking in the cath lab as you're opening those arteries. Your history and physical still matters. If the patient has any autoimmune or autoinflammatory disease, it should trigger in your head something else is wrong here. This is a big study, 22 million folks in the UK, with all sorts of autoinflammatory disorders, ankylosing spondylitis, polymyalgia rheumatica, rheumatoid arthritis, Crohn's disease, inflammatory bowel disease, pernicious anemia. Every single one has accelerated atherosclerosis. So you're going to see a lot of these patients in your clinic. You're going to see a lot of them in the cath lab. It should ring a bell. It should say, this is not silent vascular inflammation, which is what we've been talking about. This is clinically apparent inflammation. The point here being inflammation from any cause is a problem. Last, to tie these two pieces together, lipid lowering and inflammation, there's no competition here. Lipid lowering and inflammation inhibition are synergistic therapies. In my vascular biology world, most of us are convinced we're going to have combined, very aggressive lipid lowering with very combined aggressive inflammation inhibiting therapies, and that's the future of this. And the last thing I want to leave you with is just good old prevention. Diet, weight loss, exercise, smoking cessation, all the things that all of us would do, all lower inflammation, they all lower risk, and they might just keep all of us out of your hands. Thank you, Rox.
Well, Paul, I can't wait for Zeus, and I can't wait to see what's coming next on inflammation. Since we're on Harvard, we'll keep going to our next Harvard associate professor. I think he's an associate or maybe even full professor by now, on heart failure and drug therapies in heart failure. So excited to have Muthu here with us, Dr. Vaduganathan, who is at Harvard Medical School. He works very, very closely with our dear, dear and close friend, Scott Solomon. And over the years, he's just done some of the most beautiful manuscripts in the New England Journal, several of them. We're so, so thrilled to have you here, Muthu. Welcome, welcome to us. And here you are from Mass General Brigham.
So thank you very much. And continuing on the theme of drug therapies, I realize I'm an imposter here as a heart failure clinician in a coronary care symposium. That said, I would argue that you meet more patients today with heart failure than a heart failure clinician meets because of the burden of heart failure, especially heart failure with preserved ejection fraction alongside coronary disease. I only have 5 minutes, and I want to take you through one of the most remarkable transformations in the last 5 years in heart failure, and that's in heart failure with preserved ejection fraction, previously called diastolic dysfunction, heart failure with normal ejection fraction, but HFpEF is the current terminology. 5 years ago, we used to treat this condition empirically with blood pressure control, risk factor modification, and decongestion with diuretics. And today, we have 3 separate drug therapies approved for the management of HFpEF. And this has actually changed the face of HFpEF from a disease that the late Professor Braunwald called the stepchild of heart failure to today a treatable disease that you can actually modify disease course with. So I'll quickly take you through these individual therapies. SGLT2 inhibitors or flozins, of course, are very familiar to you and have a home in diabetes and kidney disease, but quickly found a place in heart failure care. And there are 3 approved therapies for heart failure management across the ejection fraction spectrum. That's dapagliflozin, empagliflozin, and sotagliflozin. Sotagliflozin is a unique compound in that it's a SGLT1/2 inhibitor. Importantly, these are drugs that have benefits across the full spectrum of ejection fraction. Protect against hospitalizations and mortality, even in those individuals with completely normal ejection fractions. So these were the first truly disease-modifying therapies in HFpEF. The second class of therapies in general are the mineralocorticoid receptor antagonists. And of course, MRAs are perhaps household names for cardiologists like spironolactone and eplerenone, which we've used for almost 2 centuries. And they are strongly recommended in heart failure with reduced ejection fraction, but the data in HFpEF were a bit less settled. And the first trial was the TopCat trial. This was an NIH-funded trial of about 3,400 individuals, and unfortunately the overall global trial was neutral for its primary endpoint, but there was marked regional heterogeneity such that some countries seemed to benefit and some countries did not. And so there was overall complexity after this trial reported. A second trial just reported this year at the American College of Cardiology meeting called SPIRIT-HF. This is now a German trial, and again, unfortunately, did not leave us with definitive answers, was an underpowered second trial of spironolactone in HFpEF, lost funding midway through the trial, and unfortunately didn't recruit its target number of patients or events. So the only definitive evidence with this entire class is with a newer generation MRA called finerenone, which is a more selective, specific inhibitor of the mineralocorticoid receptor and has a safer profile in terms of less hyperkalemia risk. And the Fine Arts HF trial showed a 16% reduction in the primary composite endpoint and thus lended to a second pillar of care for HFpEF. So today, we have these 2 definitive therapies, SGLT2 inhibitors and MRAs, specifically these more selective MRAs that might have a more safer profile. Head-to-head against spironolactone, these drugs cause less hyperkalemia, less worsening kidney function in head-to-head comparisons in early phase trials. The third drug that I'll mention and the third approval was with the angiotensin receptor neprilysin inhibitor, sacubitril valsartan or Entresto. This is a drug, again, strongly recommended with mortality benefits in HFrEF. But as you can see, as you move up and march up the ejection fraction spectrum, some of those benefits become attenuated. The FDA took in the totality of evidence and issued an FDA label for all of heart failure with the sublabel that the benefits are most seen in patients with an ejection fraction below normal. So many of those patients where the ejection fraction might just be abnormal, EFs between 40 and 50%, say, ARNI might be a consideration in those patients. So today we have the wealth of now 3 new drug classes to treat patients with HFpEF. These are each targeting different mechanisms of action, and just like Professor Ridker shared, combination drug therapy, just like in HFrEF for GDMT, is going to be the mainstay for HFpEF. And these combination drugs are anticipated to provide profound protection against cardiovascular events. Here, we estimate about a 40% reduction in cardiovascular events with these 3 drugs. And when you forecast that over a lifetime of therapy, you actually anticipate about 3 to 5 years of event-free survival gained with combination drug therapy. So today, this is the sort of new paradigm of HFpEF care. We've moved from a condition that was previously considered a stepchild of heart failure that was untreatable to a condition now with an evidence-based platform in which we have these 2 therapies, SGLT2 inhibitors and MRAs, that really should be used in all patients with heart failure, and selectively the addition of additional compounds, including ARNI or sacubitril valsartan, when the ejection fraction is slightly reduced. So thank you very much.
So incredible. You just showed us in 5 minutes what's been going on, 5 and 5 in the last 5 years, you being responsible for a lot of this work. And what a great speaker you are. We are so thrilled to have you here with us. Round of applause, please. But don't go.
Yes.
We also heard from Rob Califf, one of the biggest issues is we're not bringing your evidence and the evidence collected over the last 5 years to the bedside. Too few heart failure physicians, too expensive of drugs, and these combinations are expensive, and underdiagnosis or really not a good diagnosis for HFpEF. What are we going to do in the next 5 years?
So thankfully today, heart failure has moved a long, long way from over the last 10 years, and we finally have an all generic set of guideline-directed medical therapies. SGLT2 inhibitors have now generic therapies. Sacubitril valsartan is now a generic therapy that can be that you can obtain in unbranded fashion. And then we have MRAs and we have beta blockers that have long-standing been generic. So these are now, there's really a potential for about $100 to provide a month's worth of guideline-directed medical therapy, and that is a marked reduction from before. So I do think we can provide widespread, equitable access to medical therapy. And many of these therapies are joining the WHO essential medicines list. So from a global health perspective as well, we're able to reach large populations of previously untreated patients and undiagnosed heart failure. But I think the key message for you is that you meet many, many patients where filling pressures are elevated, where HFpEF is actually newly diagnosed in your cath labs. And that is a patient that should be plugged in to general cardiology and to heart failure care, because there are now, today, new opportunities that we never had before.
Well, thank you so very, very much. And stay tuned, I'm going to bring you to the Heart House to help us out. Thank you very much. Okay, great to have you. Now moving on to a close friend, a colleague, a tremendous teacher, and an incredibly well-published heart failure leader of the world, Dr. Sean Penny from Mount Sinai.
Thanks very much, Roxana. My thanks to you and to Dr. Sharma, Dr. Kinney, to be here today. Much like Muthu, I feel a little bit like a fish out of water being a heart failure specialist talking to a group of interventionalists. However, when I told my friends in the cath lab I'd be speaking at Dr. Sharma's conference, they all kind of walked away from me. And I said, but I'm going to be talking about devices, and then they all came back. So I'm going to run through the top 5 devices in the last 5 years. And so the criteria to make this list is that the device had to be FDA approved. Lots of investigational devices right now which are excited, but we're only going to talk today about the FDA approved ones. These devices have to lead to some improvement in either left ventricular structure or left ventricular function. More than that, though, they have to have proven clinical benefit, and they had to have been released either in the last 5 years or have a significant update within the last 5 years. So let's go. Number 5, cardiac contractility modulation. This was originally developed by Dan Burkhoff when he was at Columbia, and he had the idea that if you could deliver an electrical impulse to the right ventricular septum during the absolute refractory period, you could increase the amount of intracellular calcium. In response to that, you augment systolic function, and that augmentation in systolic function should translate into clinical benefit. The device was actually approved just prior to COVID on the basis of the fact that it improved peak VO2 as well as quality of life. However, more recently, what we see from real-world evidence is that the use of the device is associated with additional clinical benefits, with the suggestion that there's a reduction in heart failure hospitalization and perhaps even an improvement in survival. One of the things that has limited the expansion of this therapy is the fact that it has its own separate generator. So in those individuals who I take care of who have one generator for an ICD and they need a separate generator for CCM, that becomes cumbersome. So ongoing clinical trials right now are being conducted to look at an integrated device that can deliver CCM as well as ICD therapy. Number 4, baroreflex activation therapy, or Barostim. So Barostim is a device that delivers electrical impulses to the carotid body. It consists of the pulse generator, the lead, as well as a wireless programmer that allows one to program the time of day that you want to deliver the therapy. Now, pulsing the carotid sinus leads to increased baroreceptor signaling, which is usually downregulated in heart failure. And in response to that, we see autonomic modulation. There's a decrease in sympathetic activity and augmentation of parasympathetic activity. And the combination of this leads to an improvement in heart failure symptoms. Now, in clinical trials, there has been proven benefit in terms of achieving exercise capacity, quality of life, and reductions in NT-proBNP. And a pivotal phase 3 study is going on right now to determine whether or not baroreflex activation therapy can reduce heart failure hospitalizations as well as improve survival. Number 3, mitral valve transcatheter edge-to-edge repair, something that is very familiar to this audience. Following the successful publication of the COAPT trial, we have seen the introduction of mitral valve TEER and its place in the guidelines, both in the valve guidelines as well as in the heart failure guidelines. And subsequent to that publication, we've seen expansion of this therapy into populations that were excluded from COAPT. First, we see the introduction of the use of mitral valve TEER in those individuals with moderate degree of mitral regurgitation in the ReShape Heart Failure 2 study, showing reductions in both heart failure hospitalization and the combined endpoint with cardiovascular mortality. We've also seen improvements in device therapy and in the expanded registry, as this device has been brought to patients who did not fulfill COAPT criteria. We still see benefit in the non-COAPT criteria compared to those who are COAPT-like. Number 2, Impella 5.5, the Impella microaxial flow pump. Now, this particular flow pump we saw demonstrated earlier today, but the 5.5 is different in that the flow is higher and is much more durable. And what this is translating to in the world of advanced heart failure is that we can now keep candidates supported on this microaxial flow pump for not only days, but weeks and in some cases months. And as a result of that, we are beginning to create more candidates for advanced therapies with a greater proportion being able to receive heart replacement therapy with either a durable left ventricular assist device or a heart transplant. And then number 1, the granddaddy of them all, is the HeartMate 3 left ventricular assist system. This centrifugal flow pump was engineered to be fully magnetically elevated and to be more biocompatible and hemocompatible, and has been shown to be right now the device that is used in clinical use throughout the world. What has been published more recently, however, is 5-year outcomes showing that patients who are supported with this particular durable left ventricular assist device can expect to have a 5-year survival of around 60%. This was originally shown in the Momentum 3 study. However, more recently, when we look at real-world evidence captured by the INTERMACS database, the 5-year survival for those individuals receiving it for commercial use is close to 64%. So in summary, the Fab 5 devices are cardiac contractility modulation, baroreflex activation therapy, mitral valve TEER, the Impella 5.5, and then the HeartMate 3 LVAS. Lastly, my apologies to the Knicks. I should have put up a slide of the Knicks, who right now in New York are being celebrated with a parade. Thanks very much for your attention.
Thank you so much. Thank you, Sean. As always, beautiful. 5 and 5. This is great. But it is truly my pleasure to introduce one of my dearest and closest friends, Dr. Victoria Delgado, Madam President of the European Association of Cardiovascular Imaging, a world-renowned imaging expert of the world, who is just absolutely brilliant and wonderful to listen to. Imaging in the last 5 years, what have we done? Dr. Victoria Delgado, head of imaging at her hospital in Barcelona, Spain. Welcome.
Thank you very much, Roxana, for the kind introduction and for the invitation to participate in this meeting. And I think that following what has been said this morning, particularly in this field, the topic that is going to come is going to be mainly artificial intelligence. Because it's for imaging, we need to make it more efficient, we need to get more data, and we are seeing in all the labs the blooming of imaging for almost everything. So I will try to provide you what are the technical aspects of this artificial intelligence and to make it more attractive for understanding how we are using it. Because as this editorial from Professor Lushar said 2 years ago, imaging is one of the main ones that form part of this artificial intelligence in order to get perhaps more personalized medicine. And I like this review, for example, because it makes a little bit of an analysis of
what are the 4 domains of artificial intelligence and how we can use it and for what. So we can have image analysis and interpretation, particularly to identify subtle patterns of anomalies in medical images and reducing the human error, operational efficiency in order to speed up the process of reading and interpreting medical images and to make them more cost-effective, predictive and personalized healthcare, where we have here more machine learning algorithms that try to identify those patients that are at risk for diseases or where specific therapies can have a beneficial impact. And then the clinical decision support, where we have the assistant for complex procedures and also the integration with other technologies. So starting with the first one, for example, in image analysis and interpretation, I could have like this registry coming from the United States and South America for the detection of cardiac amyloidosis from a single apical 4-chamber view. This is very useful because if you are all probably in BC Echo Labs, you acquire right now maybe 50 images. When I was trained, maybe we were acquiring 10 in a videotape. So the amount of data that we are accumulating is increasing, but there are many areas where access to echocardiography is very low, and therefore having the possibility to have an apical 4-chamber view and detect based on the pattern recognition if the patient may have cardiac amyloidosis increases the awareness of the disease and detection earlier of the patients. So for example, one of these systems could be this artificial intelligence-assisted echocardiogram, where we have these 2 patients. So if I show you this patient on the left, who many of you would consider that this patient could have a cardiac amyloidosis? Anyone there's 2? And the patient on the right, both have left ventricular hypertrophy, both have characteristics that could lead more towards cardiac amyloidosis, but I'm going to show you how one of these systems works, and this is real life. I mean, this is just applying the echocardiographic study, and you have the complete report in 2 minutes, basically, with all the measurements done that you can always evaluate. And then you have this area where, based on the apical 4-chamber view, this is pattern recognition, can indicate whether the patient may have cardiac amyloidosis or not. And you can have here the checking of all the measurements in order to correct it if you are not happy with it. But that helps very much into the efficiency of our echo labs in order to get faster the measurements and the reporting. So not to lose time, I'm going to go to the next slide, if I can pass. So for example, another example of operational efficiency, and this is one of my other fantastic 5 that I would take, is the group of Rohan Kera, who published this PAN-ECHO with a complete artificial intelligence-enabled echocardiography interpretation with a multitask deep learning, with validation and derivation and validation in several cohorts, not only in United States, but also in European countries. And what they can show is that 18 diagnostic classification tasks had a very good area under the curve, and also 21 echocardiographic parameter estimation tasks with a median normalized mean absolute error of 0.14, which means that is very accurate in terms of reporting the echocardiography. Now, perhaps more in your area, the guidelines, the European guidelines, for example, recommend the use of CT coronary angiography for patients with low or moderate pretest likelihood of obstructive coronary artery disease. And in terms of the use of the hemodynamic significance of those stenosis, they recommend much more invasive algorithms. But we have now also non-invasive algorithms using the CT computed tomography. And in this case, for example, this study, the fish and chips performed in UK, try to demonstrate that actually this has an impact on how we manage patients with coronary artery disease and also on cost saving. So this was kind of the background for this study. We know the diagnostic accuracy of FFRCT in reducing mainly unnecessary invasive coronary angiography, and the NICE guidelines consider that FFRCT had a high accuracy and could reduce those unnecessary invasive tests and save millions
in health expenditures. So the fish and chips tried to answer that question, and for that they evaluated retrospectively almost 100,000 patients before being available the FFRCT and after being available the FFRCT. And what you can see is that after having available the FFRCT, the all-cause death, cardiovascular death, and invasive coronary angiography without revascularization was reduced. There were no differences in myocardial infarction, and the downstream test after CT was also reduced after having the FFRCT, so reducing also the cost derived from those downstream. And here is the study of cost effectiveness demonstrating that this technology could be cost effective. Now, in terms of predictive and personalized healthcare, this is one of the areas where we have machine learning, and this is one of the studies published in JACC Imaging, where they try to identify the patients with mitral valve prolapse that could benefit from an earlier intervention. The only problem of these studies is that are not validated in external populations, and therefore we don't know how it will be performing this model in other areas outside France. But it's an interesting concept in order to identify the patients that can be benefited from early intervention. And then in terms of clinical decision support, there are many innovations in terms of integration of different imaging modalities, even for training, like for example here, the use of CT to develop images that look like transesophageal echocardiography to guide a transcatheter edge-to-edge repair of the tricuspid valve. In addition, we can include other data that lead to mechanistic models that help us to understand how the therapy may impact on the disease of the patient, so creating these twin models and making a much more precise evaluation of the patients and management of the patients as in this study. So taking all together, if I take, for example, this slide from Professor O'Gara, and I like very much where does it fit all in the stages of the patient journey. So we have the screening detection, the referral assessment in the intervention, and then the follow-up. And if we go into screening detection, for example, how many of you would say which is the one that has severe mitral regurgitation? This is something that we have several people, experts in the lab, and we may not coincide. So here, the study from David Oyuang, for example, and there are others now published, but this one was one of the first, trying to identify from videotapes from echocardiographic images which are the patients who have severe mitral regurgitation with a very high area under the curve, very precise, and with a derivation and validation study. If we go to referral assessment and we take the example of coronary artery disease, so one of the exams that we may use in patients with a high or moderate risk are functional testing. And in my area in Europe, still dobutamine stress echocardiography is very much used, but it's difficult to interpret. And this is where the Proteus trial, using an artificial intelligence augmentation or assisted system for reading the wall motion abnormalities, tried to see whether it had an impact on the patients referred for invasive coronary angiography. The trial was underpowered in that sense, but if we go to the subgroups, one of the interesting data that we could see is that in those centers where the volume is low or they are starting, actually the system had a beneficial impact in selecting those patients that really are going to benefit from invasive coronary angiography. And then for intervention, again, we have these models of machine learning, and in this case, this study coming from Houston on the evaluation of patients with severe aortic regurgitation who may benefit from earlier surgery, and in this case, applying not only imaging data, but also clinical data, they could identify those patients that are higher risk of events if they are not operated on. And this comes to this final slide from Parthos and Gupta, where we try to move away from just cutoff values and trying to implement those into the patients and trying to have much more endotypes or phenotypes that could be identified and could be treated differently. And just to finalize future developments, I think that this publication was interesting, having this kind of patch echo. where you have continuous monitoring of the cardiac function and where you could even get data on stress and continuous monitoring of the heart function with echocardiography. So with this, I would like just to finalize that artificial intelligence applied to imaging techniques is here to stay. I think we have seen faster workflows and analysis, more reproducible measurements, integration of various imaging modalities, information for interchangeability, and creation of models to predict disease. And handheld ultrasound systems are going to go into the patch as wearables that are key. So with this, I would like to thank you for your attention, and thank you for the invitation.
I can't help but to ask you, are imagers going to be obsolete given that AI is doing such a good job? Is your job at stake?
I don't think so, but I think that we need to learn how to be better on what it was said this morning, having more time with the patient. And if there are activities that can be done by artificial intelligence and you just need to supervise them, it can help you very much in order to make your life your life work more efficient and spending more time on what really matters.
But clarify this. Each time you're reading an image, are you helping the machine to get better than you over time? Because it's not just you, but millions of imagers who are looking at multitudes of imaging. And is there going to be a time where truly what we heard from Caliph, Dr. Caliph, where he said, you know, the radiologists are still in traffic, but are these imaging work going to be relegated to machines?
I would be more worried if the systems can replace us to indicate when to use an imaging modality. Mm-hmm. And that is what we see right now. Many times we ask for imaging modalities without having a clear question on what we are searching for. And it doesn't matter if an artificial intelligence reads it or you read it. Mm-hmm. You know, if you don't know what you are searching for, you don't know what you are going to do with it. So for me, I think that we are focusing too much into that, and we are not seeing what we need to do, that is spending more time with the patient listening before we ask an echo.
Thank you so much, Dr. Delgado, for coming. She had to divert from Stockholm to come here and is leaving us very soon for her next journey. Well, fantastic. Paul, I've been waiting for this for so long. Dr. Paul Tierstein is going to take us through intervention, the incredible breakthroughs in the last 5 years. I'm sure he will keep us very, very much entertained. Don't miss this. Put your seatbelts on. My dear close friend, unbelievable man, incredible operator. We have scrubbed together, saved lives together, and have done a lot of work together, and I'm just so happy to have you. Paul Tierstein from the Scripps Clinic.
Thank you. Thank you, Roxana. Roxana is sort of like family to me. So we've been working together for a long, long time. I'm going to get to this and try to do it quickly. I'm going to start with lithotripsy. It's kind of the obvious one, right? That's hopefully you're all using it. It's really democratized calcium modification. My favorite quote about this comes from David Auth, who invented the rotablator. He said, "I'm not a plumber. Plumbers take soft material out of hard pipes. I take hard material out of soft pipes." And so that is the challenge. That was in 1987, he said that. And this picture is, and I was Marty Leon's fellow. We got to go to Bellevue, Washington, because we were doing bench work. I was measuring particle size from the rotablator and got to meet David Auth. And look how much hair I had in 87. This really annoys me. So when you go to Bellevue in 1987, Auth takes the rotablator and he wants to show you the principle of differential cutting, how it's safe for soft material, but not good for hard material. And he takes it and he puts it on his tongue. It was really quite incredible, and just to show you how safe it is, it's rotating at 180,000 RPM. It sounds like a dental drill. And he just stands there with it on his tongue, and this is what he looks like today. But lithotripsy has a whole different mechanism of action. It's a high-speed sonic wave. It creates basically a bubble that expands and then contracts, and it's like a hammer on calcium, cracking it. It's about 50 atmospheres of balloon pressure if you try to equate it. It's safer, it's got a very easy learning curve, you don't have to be proctored, better stent expansion, and fewer complications. And I think it's really made a big difference in our field. And, you know, we didn't even need a randomized trial for this. That's what's surprising. I mean, this would be a difficult concept to sell here, but you don't need to randomize parachutes, you don't need to randomize everything. And with this device, compared to we just used performance goals. And the safety of it was what got it approved by the FDA very quickly. And it is, in my opinion, I mean, I think it's been clearly shown it's safer than using rotational atherectomy. And I think we saw the roller coaster slide in Dr. Sharma's initial talk, which I took out of this talk because I didn't think I'd have enough time. Now, this field is expanding dramatically, so hold on to your seat for this. So, for example, this is a case I did last week. It was referred to me for rotablator. The doctor couldn't get a balloon across, even a 1.5 balloon. I couldn't get a 1.5 balloon across, but I didn't use a rotablator. So I took out instead the Javelin. This is the new front-emitting lithotripsy catheter from Shockwave. And the way this works is it's got, instead of having two emitters in the body, it's got one emitter at its nose. And it basically ablates looking forward. And it doesn't work all the time, but I mean, in this case, I mean, it was beautiful. It went pretty much 80 pulses right through. It cracked the plaque. You see the nice cracks in the calcium. And, before a stent, this is what it looked like. I was shocked by this Shockwave case. And what you're going to start seeing probably later this year, we'll have FDA approval of the Boston Scientific device. This is Bolt Medical's device. Instead of two emitters, it has two arrays of 4 emitters emitting at 90 degrees from each other. So you're going to get more and many more pulses, and you can turn on one emitter and turn off other emitters. This is really taking the technology a step further. This is going to be approved also, I'm sure, without a randomized trial. Again, this is just a performance goal, and it met its success goal and its adverse effect goal. So you're going to see a tsunami of IVL catheters coming to you. Now, what do you think, Greg? What do you think of this image? Pretty cool, right? So how did I draw this? This was Claude. This took about 5 minutes, about 4 or 5 prompts on my part, and I get this beautiful image of lithotripsy catheters waving, crashing down. So then I asked it to animate. So can you animate that and make the waves really come down on top of the cath lab? And this is all it could do. It's not perfect, but AI is not perfect yet, but it's really helpful. The fact that I can make this image in 5 minutes is pretty cool. So there are 10 IVL products that are in various stages of clinical trials. So this is going to be a very competitive field. I think the price of these devices is going to plummet as we get a few of them on our shelves. Okay, let's move on. De-escalation of antiplatelet therapy. I think this is a breakthrough, and this is tailored therapy. The idea, we've spent 20 years worrying about thrombus. Maybe we need to worry more about bleeding, and the idea of tailoring the therapy to the risk of a patient's bleeding. This was illustrated best, I think, with Roxana's trial, Twilight, which is now kind of old, but it was really the original thing that taught us that maybe de-escalation. So what she did here is Roxana took away the aspirin 3 months after PCI, and the data showed that the bleeding rate went way down and the efficacy rate stayed the same. So this really kind of put this on the map. And what's happened now, this is a really good paper. This is a complicated subject now. It's very hard for us interventional cardiologists to kind of grasp it all, actually. There's just so much going on with it. So you can do early discontinuation like Roxana did. You can also switch to a less potent agent, go from prasugrel down to clopidogrel, or you can just reduce the dose. And so there's a lot of things, moving parts to put together here and to sort out exactly what we should do. But this should be on your mind and when you see patients in follow-up after intervention. All right. Next, unprotected left main goes mainstream. All right. So this is something, this is sort of funny. So Greg Stone calls me, this is about 10 years ago, Greg, and you want me to be a site for the Excel randomized trial. And I said, Greg, I can't do that. I don't have equipoise. I mean, I've been doing left main stenting for at least a decade. This thing works great. How could I possibly randomize patients to open chest surgery? And Greg was insistent. He said, Paul, we need to do this trial to get this therapy on the map because it's not gone mainstream, it's not in the guidelines, and the only way we're going to get it is if we do a large randomized trial. And I mean, he was totally right about that. And he just published, this is a couple of months ago now, 10-year data. This is a meta-analysis from 4 unprotected left main trials showing no difference in mortality, 10 years, that's pretty good after the intervention. And even if you just look at the worst outcome was actually Excel. Excel was only followed for 5 years, and there was actually, the mortality benefited bypass surgery. Okay, but just even look at where bypass surgery won, it didn't win. So if you look at the data, mortality 13% with PCI, 10% with bypass. That's a 38% increase in death. Now, how could that possibly be a good thing? How could I be standing here promoting left main stents? Because I don't look at death. I look at life. Okay, I look at the freedom from death. And that's 87%. And you tell a patient, look, your chance of dying being alive is 87% if I put stents in your left main. And I can move that all the way up to 90% by opening your chest up. Like, what patient in the right mind would choose that? The number needed to treat here is 32. One of the problems with the trials is they don't really capture all the important endpoints. So here's a patient 1 day after bypass surgery for unprotected left main. I can't show you her face, but if you look carefully, you'll see her right hand there. It's reaching out for help. And then the next room is a guy whose right hand is waving goodbye 3 hours after a left main PCI. And these are endpoints that aren't captured in the trials. Or what about this? I found this on the internet. All right, should this image be part of our informed consent? This is what goes on during bypass surgery? Obviously not. But you know, these are endpoints that are not captured in the clinical trial. So why this is important, why I'm saying this is a breakthrough, is, you know, a couple of weeks ago, I have a 90-year-old, she's very symptomatic, obviously, unprotected left main. I didn't have a CT scan. I didn't know I was going to bump into this. She's got an intermediate syntax score. Her right coronary is open. So what do? Am I going to take her off the table and have a heart team discussion? That, to me, with the data that we have, is kind of ridiculous. I'm not going to do that. I'd spend 20 minutes. You could argue maybe I should have put Impella in. I did not. I felt the right coronary was open. I thought this was nothing like Samin's case that where he did rotoblator. It was a much more complicated case. This, to me, is not a big deal now, and we have the data supported. I think ad hoc left main stenting is now a real thing. I don't think you have to have a heart team discussion about everything. Yes, some of the patients, but not all the patients. So that's, I think, a big, important breakthrough. All right. This one you're going to be surprised about. Ultra-low contrast angiography. All right. So this is really something interesting. IVUS-guided minimal contrast PCI reduces kidney injury, expands the treatable population, and it's growing really quickly now. Now, this started, believe it or not, with Roxana and myself and Jeff Moses, and the patient was my father. My father had a creatinine of 2.5. He was a big shot pulmonologist right at Mount Sinai. And the night before, I had dinner with him, and he said, Paul, tomorrow your team is going to kill me. And I said, Dad, we're not going to kill you. He said, well, I'm going to be on dialysis. The average lifespan is 4.4 years after you're on dialysis. And I said, Dad, okay, I'll go in the room and I'll push the die. So we did his PCI. First we had to do a diagnostic angiogram, and we put a stent in his right coronary, image guided, and we used 7 cc's of contrast. And we put this together with some other patients and put this paper comes from like 2010. So we did this around 2008, 2009. And by the way, what do you think about the image on the right? That's kind of cool too, right? That was also Claude. It takes a few prompts, make the kidney look like a kidney bean, and make him cry. I thought that was pretty good. So the only thing, the way minimal ultra low contrast works is it's just a structured approach to doing the case, and the big item is no puffing. All right, you think of each molecule of dye is really important, and so you want to limit it, and it's very thoughtful, and it's all written, written in our paper, but the reason that I think it's now been a breakthrough is because of Ziad Ali here in New York. He's kind of taken hold of this now, and he's doing teaching conferences, and he's really promoting it. He wrote a beautiful paper, where he goes over all the details of it, and I really highly, if you're not doing this, I think you should. This costs you nothing.
There's no expense. You don't have to go to a hospital committee to get a device approved. It adds very little time to the case, and it's mentally stimulating. You're going to be very thoughtful about your contrast administration. So I highly recommend you do this. All right, we're almost done. An aspirational one. This one's aspirational, but I can't do breakthroughs in PCI without talking about it. PCI for vulnerable plaque. So this is another one of Greg Stone's projects. So the idea is that we can now identify vulnerable plaque. And Greg has done his second randomized trial. This is not a tiny trial. This is a 1,600 patient trial randomized to preventative PCI versus medical therapy with only. And kind of to our surprise, it really worked. I mean, there were better outcomes when you use preventative PCI. And so Greg has done 2 randomized trials now, but there's actually 4 more coming on the way. And, as I say in this trial, this is aspirational. It may change everything or not. I mean, we need a lot more data. I mean, it's a little scary to be putting stents into patients who have FFR negative lesions, but maybe with drug-coated balloons, that might change things. And so the last breakthrough, the Leave Nothing Behind movement. This is almost like a political movement, actually, and people get very, very emotional about it. But this brings me back to, again, working as Marty Leon's fellow in 1987. I actually took this picture. I can't even believe I did this. This was we were doing a study on the healing response in vein grafts in sheep, and so I use this picture when I talk to patients about restenosis. I tell them, look, when we put a stent in, we want a carpet of cells to go and exclude the stent and protect it from the circulating blood. But, we want a Berber carpet, and you've got a shag carpet from the 1980s. And so that helps the patient understand what I'm trying to deal with here. So we now have the agent, the paclitaxel-coated balloon. These balloons either are coated or elute cell cycle inhibitors and transfer them to the vessel wall. And as you know, this was a very, very positive trial, reducing target lesion revascularization by 50%, reducing MIs. And this, I'm sure you're all using this device now. Easy to use, not a big deal. Expensive, but that's going to change too. And there's more to it than restenosis, a lot more to it. So if you don't put a stent in, what happens with a drug-coated or eluting balloon is you get vessel expansion. You get positive remodeling. So this is going to be used for de novo lesions. So, the stent in 1990s was the great liberator, right? And now, in the 2020s, the stent's now the evil coronary cager or side branch jailer. By the way, this was also done by Claude, by the way. It's like, it's Claude or ChatGPT, I mean, and it's better than OpenAI. Open Evidence is not going to give you these pictures, but this is not very hard. And I was coming to New York. I figured a Statue of Liberty. It's pretty good. I thought it was pretty good. All right. So for the de novo, what's happening, and it's going to happen before the end of this. It might even happen in the next couple of months. But the FDA will have this approved by the end of the year. And this is eluting sirolimus. This trial, the Solution trial, randomized a lot of patients. I mean, it's 3,500 patients, and this is a non-inferiority trial, but it did exclude some patients, but this is a mostly all-comer de novo lesion trial, and what you see here is they did pretty much the same. And so there is this whole movement now, which is really very hard for some of us to feel comfortable with, but there's a movement to not use stents, but to use drug-eluting balloons. So there are 6 products in the pipeline now, so in various stages of clinical trials. It's actually 12 worldwide, but in this country there are 6. 3 of them are sirolimus, and 3 of them are paclitaxel. And there's even more because the Absorb stent, you remember the bioabsorbable stent, that's been renamed the Eversorb, and it has even thinner scaffolding diameters, so should give us better outcomes. That's now in clinical trials. And then we have the magnesium resorbable stent that is in a clinical trial in the United States. So these are really, I think, important breakthroughs, the idea that we're going to not be putting so many stents in the future. So there's a tsunami of nothing left behind devices coming to your cath lab, and there's the animation. And so my advice about these is that, if you're older, if you're a certain generation, you lived through the pre-stent 1990s where you had disrupted dinners, middle of the night acute closures, and it worries you. But now we have dual antiplatelet therapy, we have imaging, and we have these coatings might passivate the vessel. So my advice is to give it a try. Apparently the Europeans tell us we get very, very comfortable with this. And I'm going to leave you with my first poem. I wrote this poem last week, and I'm very proud of it. It's called Limitless. Okay, and here's how it goes. Your patient's needs are endless. Your capacity to help them is limitless. And this is why your house has a very unhappy spouse. Thank you very much.
Poetry in motion. That's fantastic. Well, fantastic. We're running very, very late, but we have saved the best for last. This is Dr. Michael Gibson from Harvard, CEO and head of BAME Institute, one of the finest organizations. But most importantly, if you all know that Timmy Flow, that's him. He is the inventor of that absolutely most important endpoint that we all use every single day in our cath labs. And he's got an eye for everything, especially his artwork, which is tremendous. The top 5 recent advances in antithrombotic therapy, no one better than Mike Gibson.
Well, Paul, I remember when that picture of the stent first appeared, it was liberty and justice for all, but it really said liberty and just stents for all. So if you live long enough, you'll see things taken away. You'll see stents taken away. That's the theme here. For 30 years, we added drugs. Now we're going to start taking them away. The key is going to be giving the right drug to the right patient at the right time, at the right duration, in the right place as well. I have research grant support through our institution with a lot of the agents I'll discuss. There are 2.8 million ways we can give these drugs. Sadly, we have tried all of them. But the goal of research is to try and bring a little order to all of this. We have 3 competing goals: reduce stent thrombosis, reduce stroke in the setting of AF and a PCI, and reduce major bleeding. These are all incompatible with each other, so we had to kind of smoke the peace pipe. There were many trials. The first one was the Pioneer trial that I led, where we showed that dual therapy, dropping one of the antiplatelets and substituting a NOAC, was better. There have now been meta-analyses involving about 12,000 patients. The bottom line here is, as you see, the combination of a NOAC plus a single antiplatelet therapy, in this case, a P2Y12 was superior, obviously, in bleeding, but no trade-off in terms of MI or stent thrombosis. So less is more. Now, what's fascinating to me, we did a lot of research over the years where we said, oh, clopidogrel is better than aspirin. But what did we do? We didn't replace aspirin. We added the 2 together, and that was called dual antiplatelet therapy. Now we know, though, that subtracting aspirin may be better. So we never tested whether aspirin added anything to ethionopyridine. We only tested if ethionopyridine added anything to aspirin. Turns out that aspirin doesn't add much to thienopyridines, and now we are taking them away. And as many of us have shown, it depends upon the bleeding risk. Now, you heard from Dr. Califf about the use of AI. I do think there are some good uses, as he said, of AI. The way we have used it, and this is a publication from a week or 2 ago, this is probably one of Dr. Braunwald's last publications, we used AI in the following way. We do trials in populations, but we treat patients. And a patient doesn't care what happened in the population. They care about what's going to happen to them. The problem is that patients come with Avogadro's number of subgroups embedded within them. AI has the potential to look at all those multiple interactions among all of those different subgroups. Another thing is, as doctors, we don't just say, here at this moment in time, we're going to predict your outcome all these years later. We iteratively assess risk over time. We see someone at 3 months, we see someone at 6 months. If they haven't bled, then we know they passed their bleeding stress test, and we readjust. And finally, what's not happening to date is we are not taking into account the patient's preference. How much do I value a GI bleed or an intracranial bleed versus an ischemic event? So what we did is take into account all of those. The patient can express their preference by using a little slider. How much do I want to avoid disability? How much do I want to avoid bleeding? How much do I want to avoid ICH or an ischemic stroke? And you get different answers depending upon the patient. So if you are an elderly, small body weight female, well, the lowest dose might be the best dose if you want to avoid bleeding, obviously. If you are an older or younger male who's heavier and you want to avoid ischemic stroke, then the high dose is going to be better. Now, if you want to avoid death, well, for the elderly female, the low dose may be better, but the high dose may be better for the bigger, less frail, younger patient. So we integrate all of this information into shared decision-making. I do want to add upon what Dr. Caleb said earlier. It's not enough to show that your AI tool is accurate. That's actually pretty easy. The next job is to say, is the AI tool able to improve clinical outcomes? And right now, I'm running a trial of about 175,000 patients, more of a direct-to-participant approach, where we're looking to see, does AI interpretation of an EKG actually speed time to diagnosis and speed time to initiation of evidence-based therapies? So the goal will be not just, is it accurate, can it replace doctors, can it really actually improve outcomes? That is the ultimate goal. This is a useful tool. The next step will be, can we improve outcomes? There's been a lot of discussion about factor 11 inhibition. All of you have been involved in a trial you didn't consent to, you didn't even know about. You were randomized to either normal factor 11 levels or low factor 11 levels. The people who are randomized to low factor 11 levels have a much lower rate of venous and arterial events. So it seems like a legitimate tool or goal for us to attack. There's been some failures, but there's also been a recent success. Again, getting to the right dose in the right patient, in the right syndrome here. After a stroke, factor 11 inhibition with one drug, asundexian, did improve outcomes fairly dramatically. So there's still some trials out there that are ongoing, one in atrial fibrillation with milvexian, another with stroke with milvexian. So we'll see what those show. It did not work in acute coronary syndromes, as I showed, and Roxana and others have shown. The efficacy in this trial was pretty good. I mean, 2.2 absolute % reduction. You'd have to treat under 50 people and reduced a variety of syndromes, particularly ischemic stroke. And it was safe. There was really no increase in major bleeding. We always talk about NNT, number needed to treat. We talk about NNH, number needed to harm. I think practice is dictated by NNB, number needed to blame. You know, no one ever walks into your office and says, thank you for preventing that heart attack. They just walk into your office and say, I've got a nosebleed. So there's this asymmetric battle between safety and efficacy, and NNB predominates. This is a winner in terms of NNB. Finally, moving care into the home. Dr. Caleb talked about this earlier. That is what we need to do. We got to bring the care to the patient rather than bringing the patient to the care. Right now, I'm working with Dr. Kumo as the Chief Medical Advisor. We have a $1 billion contract with the VA where we are bringing care into the home. By doing remote patient monitoring, they get a device in the home that guides them with respect to continuous glucose monitoring, heart failure management, all the things we talked about earlier. And on the back end, there are humans helping navigate this care. So that's bringing care into the home for chronic conditions, but we also need to do it for acute conditions. So STEMI care, time is muscle. We've done all that we can, and we've been successful at limiting door-to-balloon times, but it's the time for someone to get care initiated. So there are several trials now of starting therapy in the home. This is a trial of giving a 2B3A inhibitor in the home subcutaneously. It did improve patency, did improve this kind of clinical composite endpoint. So less is going to be more. I think we are, in the past 5 years, taking drugs away. We are taking aspirin away earlier, depending upon the patient's risk. We are de-escalating. We are now using AI to guide us in that process, in iterative assessment of risk, and then de-escalation. Factor 11 inhibition may achieve the NNB, number needed to blame, but it must preserve efficacy, which we'll see. And in STEMI and in other syndromes, I hope we can bring care into the home. Thank you.
Thank you, Dr. Gibson. Hey, guys, how about a break? 10 minutes, no more than that. Be back in this room no later than 12:20. We're going live with 2 live cases and then lunch. Well, some lectures, couple of lectures, and then lunch. Come back, 12:20. the podium? Okay, go ahead. Second session, if we could call Dr. Ankur Karla, Dr. Nitin Barman, Dr. Upendra Kaul, Dr. Parasuram, Dr. Lasala, Dr. Stone, Dr. Tierstein. Please come on up. Very soon we're going live.
I now invite Dr. George Dangus, Professor of Medicine and Surgery at Icahn School of Medicine, Director of Cardiovascular Innovation, Chief of Cardiology at Mount Sinai Queens, and Associate Director of Mount Sinai Heart. Please welcome Dr. George Dangus.
All right, well, excellent. We're ready to go to the cath lab and save some time. We have expert panelists joining with us. Dr. Stone, Dr. Parasuram, Mela Korde, Krista Murthy. Dr. Kaul is joining us in a moment. Dr. Nitin Barman, Dr. Lasala join in a moment. Dr. Paul Tierstein joining in a moment. And Dr. Ankur Karla already with us. Going right now to the cath lab. Room 2, Dr. Kinney and co-workers, Dr. Kinney and Dr. Sweeney working together, Dr. Kinney and Dr. Sweeney. Let's be able to hear Dr. Kinney though. She's talking to us. Okay, AV control, let's hear Dr. Kinney from the cath lab now. Or maybe we can hear Dr. Sweeney instead, or we can hear nobody. Well, we hear only Sophia. We hear. Should we have Sophia run the live case as well?
Okay, give me the mic. Can we hear?
Very good.
If people on. Oh, yes.
Very
okay.
good. So
Can you see us?
AI has already outperformed live presentations. We were ahead of time and they hadn't even put their headphones on. Let's go for the live case, Anu. Great job.
Okay, good. So if you can see, if you can show the live case slide, case number 3. And welcome George Dangus.
Case
So
number
it is
3. Let's please play. You see, Sophia would have played that already. We would have been looping that, but human factor still is in the frame mode, not in the cine mode.
Good, 71-year-old male who actually presented with symptoms, anginal symptoms. So worsening fatigue, dyspnea on exertion. You'll know the reason why dyspnea on exertion, because many of that's angina equivalent. MPI had mostly inferior infroseptal infralateral, which is probably RCA territory, prior smoker, and hyperlipidemia. And we also have seen prior smoker often have calcific disease. EF was near normal, so he did have a cath way back in April because of all this. And what happened is 3-vessel disease. He actually is on anti-anginal now. So had 3-vessel disease, which is a proximal LAD and mid LAD, RCA circumflex. So with the syntax have a heart team discussion, patient refused and subsequently had PCI of the RCA circumflex. Today he is for the PCI of the LAD. So we're going to show you, this is the EF, near normal, little bit high inferior hypo, RCA, the stents are patent, but if you can see that. Can you see it now?
Please try to keep up with the speed of Dr. Kinney. This is the RCA we see now.
Okay, good. And then we have circumflex. The stent looks okay. So this is where we are. We are stopping it here, and then you can, okay, let me go to the LAD. This is the LAD disease.
LAD,
So rightly so,
is
the
that cranial?
syntax score was high. Yeah, that's a cranial. Okay, good. Clicker, okay.
All right.
So if you go with our criteria, 3 vessel disease, high syntax, though syntax not in the equation of the current, and then after heart team discussion becomes appropriate. And then we have this dry cine to show that is tramp track calcium in both areas. So let's go have a discussion how to handle this case.
All right, I guess Dr. Thiersten is ready right away to give his opinion about the situations. I heard him commenting already to Dr. Barman. So go ahead, say out loud, Paul.
I think this LAD, I'm going to demand that Dr. Kinney use a rotablator on this LAD. It really looks like a good rotablator case to me, long diffuse lesion. It's probably calcium. She's used her IVUS eyes to determine that it does not, that it needs a calcium modification. It's long. You could do other things. You could use IVL for this. I think it would probably get through, or you can use a high pressure balloon. The 24 atmosphere balloon that Abbott sells is actually, you can take that up to 30 atmospheres and doesn't cost the same as the OPN balloon, which is a bit, it's more expensive. But I think this is I might use IVL here, even though, I think there's more than one way to do this.
Greg, what do you think? Would you try an imaging first and see if that decipher any options?
Well, I would definitely always image a case like this. I mean, the osteal LAD is obviously very concerning. I'm not even sure about the osteal circ. But, I will tell you, I don't disagree with Paul. I mean, this looks like a great rotational atherectomy case given the diffuseness of the disease. But I'll also tell you that this is the kind of case that we enrolled in the ECLIPSE trial, and that we randomized to orbital atherectomy versus balloon angioplasty lesion preparation, and there were no difference in the outcomes. And so it'd be very interesting to image this and see really if you have 360-degree long calcification, et cetera, before you 100% decide you have to go that route.
And then if you did balloon, first, if you really gave it a good try with an undersized balloon that you took up to 28 atmospheres, you might find that it expands well, but you also might find that there's a nodule of calcium that causes all kinds of problems.
Dr.
That's why the
Lasala?
imaging helps.
Dr. Lasala, your opinion and any need for a hemodynamic support perhaps, or no?
Yeah, I don't think I need support for this, but I'm going to give away the conclusions of my lecture, which is next. And that is, if you can cross it with a balloon, you probably could just go with IVL. Otherwise, atherectomy is reserved for the other entities that are much more severe.
Will the imaging cross, Dr. Barman? What do you think? If we try to do imaging, IVUS will even cross here or not really?
I think it probably would. I would agree, obviously, calcium modification is necessary. In terms of ROTA, which is probably what I would do as well, there'd be some concerns, the length of the lesion and embolization risk, although, again, the EDP and EF are normal. There's also seems to maybe be a bridge segment just beyond the calcified segment, so the technique would be really important, not to allow the bird jump.
Yeah, we used to say if the IVUS didn't cross, then we got to do something more aggressive to modify. But the new Aero balloon does a nice job of crossing where the other old IVL did not.
Dr. Carla, any opinion?
I don't think your phase direct catheter will cross here. The phase direct IVUS will not cross.
So IVUS might not cross. That's a good impression. I probably would say the same. I think Dr. Kinney agrees with us.
Okay. So nobody is worried about this osteal circ?
Yeah, I am worried about the osteal circ.
Greg was concerned about the osteal circ. Maybe we have to do an physiological assessment.
Right? A new term has coined with the symposium. Now we are going to use the word IFR. And we did not believe that osteal circ is significant. So we did do IFR because we did not want to do it later on.
Yeah.
0.99. Okay, right there.
Excellent.
Okay, but when you
negative.
Bye-bye.
But when you stent the ostium of the LAD, it may be problematic. The circumflex may get squeezed a bit.
Agree.
All right.
Okay,
so what's
the
treatment plan now? In the imaging or not?
Yeah, imaging, yes. So we did. We do have a rotafloppia wire, and guess what? The Ultreon Trio that has been just released was being used here. And OCT did cross on the rota wire, Kiski, quickly show us. So Ultron 3O can show
Perfect.
not only calcium, can show lipid. So when it's blue, it is lipid. So important with the OC, you see that that's lipid. And then calcium, total length we are getting it's 40. Many places it is 360, 260, 270 degree. Thickness is 0.8. So length is about more than 20, thickness is about 0.8. I think every way we are saying some kind of atherectomy has to be used until we have head-to-head comparison between atherectomy device versus IVL. What we are doing head-to-head comparison is in the cases with nodule. When we see a nodule, then we are having the trial right here. We are randomizing them to rotational atherectomy versus IVL.
Yeah, but we don't see calcium nodule for this product. Mostly
So,
calcium sheet and.
One thing that's interesting, what are you going to do about the diagonal? Or are you going to take advantage of the 90-degree takeoff and do nothing on the diagonal right now?
Originally, we had planned maybe if something needs to be done, D2, not like a D1. D2, questionable lesion, should we
D2,
consider
yes.
DCB there and stent across? You see that D2?
Can you,
D1, 90-degree takeoff, I think we'll leave it alone.
Does anybody know the Ultron 3, because that's relatively new, what's the blue? The orange, I assume, is calcium, and what's the blue?
Yeah, blue is lipid.
Lipid. Yeah.
All
But
right.
just a visualization, not quantification.
So Ultron 3O has one other, you can use, they call it a QFR, you can use but that is not FDA approved yet.
Yep.
But the great thing about this is that one, you have co-registration, which you guys wanted, number one. Number two, AI is included. So interventional cardiologists don't need to think what to do. It quickly gives you where is calcium, the length, and the thickness. Yeah, keep going.
We
And I think this also had the first product, the 1 second product.
Oh,
So, also, I just.
slow packing motion.
This was a great demonstration. I'm not surprised at all that the Ultron crossed here. I think everybody is surprised on the panel, but I wasn't. I just want to remind everyone of Kiko Mahara's work. Severe calcium is greater than 270 degrees calcium for at least 5 millimeters long and 3 millimeters deep. And so this really doesn't look that severe by this OCT.
Because it's not
this
that-
would have expanded fine.
Because it's not 270. And,
Right, exactly. There were a few areas that were about 270 degrees, but not greater and very little circumferential.
So the AI doesn't tell us the depth of the calcium, does it?
The OCT.
It has told us the depth, it's
But
about
does the AI,
0.8.
I mean, the AI, as Dr. Kinney said, we don't want to think, or interventional cardiologists. So the AI gives us colors, but it doesn't give us the depth of the calcium.
I'm going to use the poor man's assessment of
No,
this,
no,
is
no,
that
let me do one
rotablator
more.
went through very easily.
Yeah, yeah.
Yeah, right, exactly.
Don't
Now,
hear any decelerations and no obstruction.
This is a 1 fiber.
That seems,
It's a one fiber. At the tightest area, can you give me the lumen diameter?
Yeah, 1 second.
I think it stops there, right?
Yeah.
Run through wire.
There's the one part.
Yeah, 1.27.
Okay, so at the tightest area, go back. Can we show the imaging by the side, not the hemodynamics? Continuously keep showing the imaging because, okay, so at the tightest area is 1.2.
Yeah.
So we did
MLD,
select
minimum
1.5
lumen
bar.
diameter.
Now, if someone said we should have gone 175, is okay, but with a long lesion like this, there's a risk of slow flow.
Yeah, that's 1.5, the maximum birth size I would use as well for this is the longer lesion, you have to go a little conservative with the birth size. Because otherwise you plug the macrovasculature way too much. But that's great.
So Dr. Kinney, how do you decide if you've done enough atheroablation? Are you going to image and look for fractures? Are you going to, is it how easy it went through? Are you going to just routinely go up to a 175? How do you decide?
So definitely no second burr. I think Dr. Sharma did mention second burr would be IVL. So there's two ways. One, image, see what has happened. Or two, if you don't want to image, you go with one-to-one burr. This LED is probably about 3.5, but we have a 3.5. You can go up with the balloon and see how it behaves. The good old way. In the past, we used to say if it did not expand, try cutting balloon, but here you can image, because there's one area about more than 270 degree with the very thick calcium, you may need IVL at that level.
Yeah.
But if
Gotta
everybody
stay away
agrees
from
you
the
want to do
circle begin
a
with.
quick, you want to do a quick OCT, we can do that too.
So you don't like to exchange the wire with a microcatheter?
No, just like George Dangus said, go with
No,
the
when,
speed
when
of
it's
image,
easy to
that's it.
wire, we try to avoid that. Dr. Cowell, any ideas about the next step after this? Regular balloon, maybe 2530, and go from there, or?
Yeah, so I would just get
No, I think having done a rotablation quite, effectively, I would actually go with the balloon and see how the balloon expands, and if it expands very well, without very high pressure, and then look at the angiogram, and if there is any doubt, then do, intravascular imaging and then go ahead.
So nobody wants imaging? What's the balloon?
Not really.
3-0.
Okay.
Not really,
I
I
also
think.
think you can go right to a balloon. here.
Everybody wants to a 2530 high pressure balloon and image afterwards.
Okay, everybody wants to start using the eyes. We like it.
This is a 3-0-20.
That's right.
Yes. We like it. Okay, we're going with the balloon. And let's see how it behaves and we can decide.
Great. So far behaves well. Patient is very stable hemodynamically. That's already a big accomplishment. Rotablated is very long, highly calcific, highly stenotic LED with a rotabur.
Okay.
And
Now,
patient doesn't blink an
nobody's,
eye.
talking
That's an
about that,
achievement.
right? Yeah, right there. Okay. No, okay, we didn't wire D2.
This is a 20 balloon.
Yeah, we went up to 16 down. Nice expansion there. There was no calcium. This is where majority of the calcium is.
Yeah.
We'll go to 20
Well,
atmospheres here.
some people say to do the scene at the calcium level in two orthogonal views. To maybe you can go another view and show us that again. To make sure the balloon doesn't expand uneccentrically. Maybe you angulate a little bit the camera.
Okay, I will.
3-0-20.
See, those are great
He
OCT
went to
images.
20
That's all
atmosphere.
180
You want to
degree
go
calcium.
Go up here. He
Even
wants to
better.
go another view.
Very good. I think full expansion of the balloon.
Yeah, see
Dr. Melacorde, what do you think?
Yeah, as we expected, the balloon actually expanded fully because, like Dr. Stone said, there is no severe, 360-degree calcium or a calcified nodule on the screening OCT, so.
Terrific.
Time to stand.
So let's see how
what
the
are we
circle
going to
looks
do
now.
now?
after
Let's
all
do
that.
the, no, not circle. First, let's do D2, how it is behaving. Okay,
That's
ready?
right.
Picture.
Let's look at D2 first.
Oh, boy, get that
D2
diagonal now.
Okay.
looks like
Remember, that's what we had planned.
needs a wire.
Yeah, okay, get us the field.
And the circ has a tremendous flow. It's great.
Do you
Okay, how
want
do-
to
how
put
do
a
people
wire
wanna
down
treat
and
that?
dilate the diagonal a little bit?
Yeah.
Right.
How do people want to treat that?
Yeah, we are going to wire that.
We don't need any IVUS or flow wire to understand that there is a situation happening in D2. We don't need to randomize the parachutes.
D1 is also not so happy.
But D1, look at the takeoff. I think that one you can leave it. But depending on the size, try to at least work on one vessel, which will be D2. So we'll wire that. What do you want to do?
So this wiring is very difficult into D2 because
so
the
what
lesion
wire-
is
what wire are you using,
a little
Dr. Kenny?
subtotal and all that.
This is a fielder wire.
And yeah,
Is it a Fielder XT or a Fielder FC?
Regular fielder.
is a
Neither of the
filter, whatever you like.
Fielder XT is tapered, 0.009 tip.
Yeah.
Fielder FC is more floppy, tip load is lower. The regular fielder has a tip load of around 1.
So this is not so easy to cross.
Yeah, well, there's a lot of calcium with a lot of friction up there. There's always think about the calcium situation. It's not only the angulation of vessel and all that, but it's also the friction that gives to the wire length So that's another factor.
Yes.
Yeah, so you might want to, this is the kind of place you might want a microcatheter so you can change the tip of the wire easily and all that, but.
Right. It's not only about the tip. The tip may actually favorably go. I'm just a little concerned because it's such a long calcific lesion and hugs the entire wire. And that may pose a significant situation there.
Yeah, I would agree with Paul that you're going to need more of
Sometimes
an, you may need more of an angle there. Unless you got it right there.
Yeah.
You go iliocrani.
No. That's the, whether you
You can
get
also use a dual lumen
line.
catheter.
Someone, I was going to say, someone always recommends the Suzuki catheter at this
So
point.
Suzuki, you think Suzuki
I
catheter?
don't, people always
Which
recommend it
catheter?
now.
Which microcatheter would be the choice here?
I
Let's
would use
go
a
down the
Supercross.
panel
Just
and
use a
let the
Supercross
Anu work
90.
a little bit.
Get a
So,
Supercross
Dr.
90.
Melacorde, what's your choice of microcatheter?
Reshape and try again before a microcatheter.
Reshape and try again. No microcatheter. Dr. La Sala.
No, other thing is you can take the run through. I don't know how the tip is behaving. I
Not
want
really.
to remove the rotor wire. Run through could go there because way distal, right?
The run through, I don't think run through
This
is
is the
gonna cross
case
this lesion.
we should avoid before ballooning. Remember
That's a
we
good
were-
point.
I mean, the microcatheter used for this work would be a Caravel as opposed to a CTO where you want something that you can really spin. Like a Corsair
Yeah,
Pro.
at this point, I think you got to do something
I
different.
was
at this
thinking more
point.
of the Supercross 90, but I don't know.
Supercross 90 is a good idea.
Supercross 90
Yeah.
Or even a 120. I sort
But
of got used
but
to
you're talking about
using the
shaping the
120s.
tip, that's what you would do with the
Over
microcatheter.
120, yeah.
But Supercross is
Supercross
great.
120, good.
What?
Dr. Barman?
Yeah, I mean, I think with a good curve it could go, but I might have used the microcatheter on the rotowire just to, because it seems like we're getting
Of which
caught in.
microcatheter? Turnpike?
I mean, if I was going to open one, I would probably take a Supercross at this point, just in case it was necessary, but I think the bigger.
Supercross 120 seems to be the winner here, or Turnpike, or whichever you like, and shape the
Just getting caught in a lot
microcatheter.
of
Paul,
subintimal
Paul,
space,
which microcatheter would you use? Or you said Suzuki?
Yeah. I mean, the Supercross used to be a little careful that you could dissect the main vessel, but you got to wire down it, so I think
Yeah, the
that's-
vessel is already dissected for the rotablator. You have not to worry about. You
All
can't
right,
go
now,
crazy.
look, no, you got my hopes up there for a second.
Yeah.
It
All
is
right.
going there, it could be,
Okay, yeah, and that's
about
what
right
I
there.
do, yeah.
Yeah, this is a run-through wire. It's a little
This is
difficult
run-through.
there.
run through wire, yeah. I
Yeah.
was trying to do that, otherwise
Not
we'll
really.
have to.
It's not
Let
happening.
me,
Yeah, generally I would
let's
use a
see if
microcatheter or the board.
It's not
How-
happening.
How's the
Can we
bend
change the
tip on the wire that's in the
Let's
LED?
try,
Maybe you
let's
could
try to get the run-through
change them.
down in the LED, and then just, we just put like a little microcatheter up there.
Get a 2012 balloon. If we, once I'm at the,
Yeah, I'm not sure the run-through has the characteristics you need to get through this.
Yeah, no, run-through is not gonna take a turn.
I'm shocked.
I'm afraid you may need to use a microcatheter 120 and a Miracle
okay.
3 here.
No,
to go
we're
through
not
the
going to use
calcium of the
super
ostium.
cross here. We can go with fine cross on the wire and change the shape.
Well, let's say that. But first we got to get the run-through back in position. Distal LED,
212 balloon.
No, it may not work,
not gonna happen.
Drop it.
No, there. So what has happened, it is, the calcium might have,
It's close.
It's close, but there's so much friction, it cannot go through.
Yeah.
I think it's banging
So
on the
there's-
door, but the door is not opening up.
exactly.
You don't want to bang on that door too much because it might close.
You need the right key. The key to the door is a different shape or something like that.
I don't know.
All right.
So you can try ringing the doorbell or take the door down. I don't know.
Okay, you want 2012 balloon, micro catheter, give us the micro catheter they want. Fine cross is there and we'll
Yeah.
change the shape.
Yeah, that's what I would use, and then
balloon
use a
trapper?
specialty wire.
Specialty wire. I would go with the whisper extra support here.
That, I would consider that a specialty wire.
Actually, you may need a Miracle 3.
Yes,
Hold it, yeah.
ultimately, I
Miracle-3.
think you need a shaped microcatheter, Miracle 3, to go through the ostium of this thing.
I think a
Because there's some
Miracle 3 is a
displaced
good
calcium.
choice here. I think the calcium is inhibiting you.
Yeah, there's a little displaced
Yeah,
calcium
yeah.
right there.
I think
So
Miracle 3 is a good
Exactly.
choice.
You need to push through it, yeah.
Get a Miracle 3, open it.
So looking at that level, not much calcium based on the OCT, mostly lipid
No, it
plaque.
could be lipid also.
Yeah.
Because at that level, there was no calcium,
No.
it could be lipid also, which we have also published that when there is a lot of lipid proximal, it does move.
Yeah, this
That
could
was
be
one
extend the
which,
wire? Was that a
Barman.
long
No,
wire?
we did not. No, the one thing we did is I took the rotor wire out, and the Barman did mention, should have gone on the rotor wire because it was a
Right.
long wire. We are just trying to go with the, but could be, yeah, no, I don't want to do that. Take it out.
How are you going to handle the other case of Dr. Sharma? You want us to go there for a few minutes and come back?
Okay.
Why
Go
don't we
back,
try,
go
why don't we
there.
try to see what's
Give
happening,
me
set up
the
the case
balloon
anyhow,
valve, 202.
and you let us know what worked over there. Let's go to lab 3, AV control.
I think this case underscores that. The other thing is that in
All
complex
right.
coronaries, you
Dr.
get
Sharma
snagged by
anxiously
something going
waiting
on.
there.
You
Dr.
didn't
Sharma and
expect.
Dr. Huda, is that right? Yes,
We
go
are the
ahead.
same, so remember on the plane, the pilot and all the crew changes. So now we have the crew change with the fellow, Sabina Kumar and Pratish George. So they can fly 12 hours. So same way, tough case, they can be 90 minutes. After that, we have to change them. So this is the new batch now. So let's go through. Okay, let's go our slide presentation, please. This is a case number 4, which is right here. Patient is 64-year-old female, has a 3-vessel disease. Now question is with a high syntax score, usually you try to get these patients to surgery, and particularly patients who are diabetic, which she is. But she declined after the heart team discussion, and then of course presented initially as a class 3 angina, and the CTA and all those tests showed good medical therapy, nice values, and that's where we are. So after the discussion, it was decided, now we can go to the actual next slide. So we have appropriate use criteria, OC, which is next slide. So basically it's a 3-vessel, so otherwise it is just maybe necessary, next slide. But it is after heart team discussion, it becomes plus. Next slide, press again, just press again. This will come.
This is again the limitations
That's
of
it. Yeah.
Sophia
Yeah.
versus
Yeah,
the
good.
human factor.
Yeah,
You can see
I know.
that.
Believe me, we start using Sophia a little more. So
Yes.
it is appropriate after heart team discussion. Let's go back to the angiogram now. Let's go back to the angiogram. So this is a case which we had done the LV function is good. That's a good on our side. And remember the 3-vessel disease in the latest guideline. If you have ejection fraction less than 35, then cabbage is class 1. Ejection fraction 35 to 50, both are 2B, PCI and cabbage. So cabbage is no longer class 1 in the mild LV dysfunction and normal LV dysfunction. So both of them can be taken care by
Dr. Waxman,
intervention
join us.
or by cabbage. Yeah, good. Okay, now let's keep going here. Now this is the right coronary, which we did a few weeks ago. That time we used a very calcific vessel, did a rotablation, put 2 stents, which looks very good. And the left system is this. We're
Dr.
going to show you
Ron
another
Waxman,
view. You
join
said-
us to the dice, please.
Okay, so you see the subtotal circumflex and very complex LAD. Ready to see it? Here it is.
I can't see it. It's so complex.
Yeah. Yeah.
It's aneurysmal. Very good. Very complex.
Aneurysmal, angulated, severely calcified. So this took a little time, but Huda, our expert, my associate, before I could come, he said, well, while we are waiting, let's open the circumflex, although that was never the plan. At least got a little extra blood flow in the circ, which was subtotal, reasonable vessel, but more importantly, he already wired the entire, the LED and changed it to the rotor wire. That's where we are now.
So,
And
Samin,
just-
was it
yeah.
hard to me, the challenge of this case is going to be getting the wire through the aneurysm. Sometimes you have to do a backflip around the whole aneurysm.
Yeah,
Did this just
that's
go
right.
down, or
Yeah.
was this easy, or?
Let's Amit will answer it. How was it? How was it?
No, it was not very tough. Like we just have to make a good curve.
Okay.
And initially it was going to the septal, and then with the help of microcatheter, we were able to reshape, and then it went in easily.
Yeah, so you fielder wire, right?
Yes.
Okay, fielder. The change to the rota floppy, again, 1.25 bar. We are ready to rock and roll.
I mean, one of the complex things about the aneurysms is that there's often an inflow and an outflow narrowing, right? And that's what really hurts you.
Yeah.
If you come in
and
on
not
an
only
angle,
that,
then the wire's going to go around in a
that is
circle.
correct.
And it can be challenging to get out
but
of it.
once you, absolutely, as you said, many times you make a reverse curve. To go through it very difficult. But in this case, kind of we are beyond that now. Our rota wire has been there, and clearly there is a more chance of perforation. So what I do is, in these cases, don't open your covered stent, but be ready in the room. That when perforation occurs, they are not looking for the covered stent. So we have 2.5, 20 papyrus ready, and we have the 1.25 bar ready to go in. Same with 3 steps, back and forth at this level, and then at the Y connector, and then third.
Why is it 1.25?
With that aneurysm.
Why not 1.5?
Yeah. Well, I mean, again, our goal is that to try to cause that angle. That 1.5 has his mind of his own. 1.25 has a mind of the wire. That's what I say. So that's the region. In this case, we are using it. And let's see, this is okay. And same. If you need to go to second bar, we can always use the, Just because of that angulation, I think Paul asked that question. Look at the severely calcified, because bigger one will go to the mind of its own, I say all the time. 1.25 bar has the mind of our hand and the wire. So all goes to 150,000 RPM, just flow, advancement, packing. Yeah, that's okay. Yeah, go to 150. Yeah, good. And see, there is a second negative bands.
What are the hemodynamics doing?
So there's one helpful thing about the aneurysm is that the side branch that comes out of it is unlikely to be affected by any atherosclerosis.
21, 22, 23, 24.
You see that? If go more than second. Yeah. Give atropine, please. Oh, come on. Yeah. Hopefully no perf.
Do you give
blood pressure?
Yeah.
Do you give any atropine there?
Yeah, just given now. It just happened.
No. Stand still.
I hope there is no perforation here. Okay. Get a run through wire quickly.
Run through. It's coming back.
Yeah.
Yeah, a little atropine, a little neo is going to do the trick here. Let's take a look.
Don't see anything yet. Yeah.
Very
In 1
good,
second, we
very
set
good.
Fine cross also handy.
Yeah, we would not expect going so bradycardic in this particular case because LED is LED we are working, not a left main, and your RCA is completely fine. So you worry about the could be perf, but you know that device will not go on the your rota wire. You have to put your use the over the wire system what you had before.
The fine cross and field.
Yeah, we don't need that. Yeah. So what I did is we always go parallel. This is the run through wire. This wire came up. Yeah. So let's 1 second. Let's give a little dye. Balloon is ready. The other balloon is ready.
Please move the hemodynamics to top right, please.
Yeah. Good. Okay. Which we call it SFSG. So far, so good. Balloon. So we don't have to use so far, we don't have to use the papyrus, we don't have to open it. Although bradycardia sometimes is the sign.
Very good. So I'm going to use now same discussion as the previous case. I'm going to use a long high pressure balloon, or you want to use IVL or some, what do you want to use now?
No. So very simple. As I said, 1.25 bar. Do not be intimidated by size of the bar. Even in a large vessel, because you just have to take that calcium out. We did 1.25, it's a 2.5 now?
Yeah, we have 2.
It's a 2.5 30 balloon, and let's see it opens up, and the proximal way require rotatripsy that do the IVL proximally, but let's go one by one. First, this is the 30, going very good. Start from here, go up.
Samin, question for you. Is your plan spot stent, the distal segment, and not cover the aneurysm and then do this a separate stent
No,
proximal?
I would say, no, I would just
Or
go
do the whole
complete.
thing?
Because remember, because remember that aneurysm, there is a little disease proximally, distally will give more trouble. Aneurysm, and we know, prediction, see the size of the aneurysm? Right now it is about 4 millimeter, 4.5. This will become 2 millimeter by the time we'll be done. Because stent will prevent the flow subsequently, and so the stent will decrease in size. We actually have published 3 papers now, that even large aneurysm, once you put a stent, not the covered, regular stent, once you put it, it falls underneath there. So we had 2.5 synergy,
The
38 or
so-called
48.
end-to-end technique,
48,
normal to normal.
Yeah, 48. Normal to normal, yeah. Okay, so anybody want to do, so question comes here, the balloon inflation was reasonable, although it's at 2.5. Go.
Well, let's
and
give
so question.
let's give a little nitro and take a picture now.
Yes.
To see where we are, what we gain from this balloon, particularly proximally, because that's where you think the vessel is bigger, and you may want to do a lithotripsy or not. Let's see.
Lithotripsy. No, don't.
Let's see.
Yeah.
Pressure is good now. It's 140.
Just a question.
The pressure source.
The CTO, the circumflex, did you just balloon that or did you stent it?
No, it was just a balloon, and that was not even intended. This we used, patient got extra 2% of the myocardial blood flow because of waiting for the live case. How do you like that? Extra bonus. And question is, what I would have done, not the stent. Question is, should we have done the drug-coated balloon in that? We'll decide. In the end, if we need to do, we'll do that. And now we're getting the stent now, 48, good. Little die. Beautiful.
I think it's exactly. Come a little back, no? You need to cover so much.
Remember, there is a disease distally.
Oh, yeah, that's good.
Let's see. Little
Come
die.
back a little bit, yeah.
Yeah. Good.
Perfect, right there.
Go. Yeah. Yeah. And the question is usually, I protect the side branches, get a 3 or 12 high pressure. But in this particular case, see the diagonal is so angulated. If I don't have to protect, we'll be okay. And as said earlier, many times these are not involved. And if they remain good, TIMI 3 flow, even have 70-80% lesion, we just take the last picture where you don't see the ostium, so everybody will be happy. Yeah. Beautiful.
Great.
Beautiful.
So we're going to do a little high pressure, and then pump, and we're going to be done here.
And you can go to Dr. Keeney now, right? They're ready there?
I think so. We're going to go back to Dr. Keeney and come back to you for final results. This is great.
Final results, yeah.
Terrific. And the aneurysm is already gone. There's only one way now.
I said, yep, offside only. Yep, beautiful.
Yeah, and as we said before, that ostium looks fine. You don't have to
Let's go back to lab 2, which already across a diagonal, and trying to do a little cutting balloon.
This is a cutting balloon. I'll show you how we crossed. You can ask the panel. I know they gave all their opinions, and now we can say
how did you cross?
How did I cross? The KTT has a way. So let me tell you. Go up here. 1 second again. This is a cutter, and then we plan to stent across. Okay, down.
So we missed it. How did you cross? What wire?
Okay, I'm going to show you right now.
Choose the fine cross.
So fine cross, we use the fine cross, okay, with a regular wire, and then this is the wire. So I think all the discussion, whether it was calcium, but then Kiski just mentioned there was no calcium. It was likely probably some kind of a lipid plaque, went into that. So like George was mentioning, the door is locked. We had to find the right key. And guess what? The right key was Miracle 3.
Miracle 3, yes.
Just look at that, how it crossed. You need
by turning the key left, right.
The wires.
If you turn the key left, right, then it opens the door.
Yes. The right key. Look at
wire, it's just got better integrity and it gives you a little bit more control.
Now you see that, how tight
it's
it
really
was?
nice.
That is why you needed the stiffer wire. So we did a cutting balloon, and I think we will stent across, image, and be done. Right? You want to take a picture? Okay.
I think it's great.
So a leave-alone cutting balloon, you wouldn't do a DCB there?
Okay. You want a DCB?
Not really.
No, I'm just asking.
Not really.
I would never
I mean, we
pretend to
did.
tell you anything.
Let's see what.
Paul, you a DCB, Paul?
A lot of people would like to do a DCB.
No, Dr. Tisted is laughing at the suggestion of no DCB, but when I asked him, he also said no DCB.
No, I would do.
Oh,
I think it's
beautiful,
reasonable, but-
beautiful. Let's go. Move it. Time for lunch there, yeah. Let us just put a stand
Yes.
across,
Then
image, and be done.
we are one stand and two short lectures before the lunch.
And let's have a short lunch or a working lunch. Bring the lunch, come inside.
And let's give a thing. Oh, we already have Dr. La Sala, first speaker coming up. He's ready right here, very close to the podium. Excellent. We'll be ready to cue in Dr.
I think
La Sala's,
once we stand,
slides.
now there was a discussion about DCB. Is there any opinion? Do we do DCB first or stand first, then recross and then kiss and then DCB?
Yeah,
Anything?
the last one if we need to, yeah. Everybody's agreeing with that. What you just said.
Okay.
Stand first, get a good result, then you do
Right.
some kiss if need be, and then we decide about DCB. But are you talking about the diagonal too, or are you talking about the circumflex now? That's a question.
No, we are talking, hold on, we are talking diagonal. We are talking diagonal. We are not talking circumflex. Remember,
I'm really worried I'm trying to say that I'm really worried about the circumflex. I'm not really care too much about diagonal.
okay.
All right?
Okay,
So
here,
here's
see, we
my
are,
answer.
okay, it goes in, so we are far away.
Far away.
See that? I think we'll be okay.
Great.
We will be okay. Okay, good.
Maybe we do nothing at the OCLAD and nothing at the CERC. We'll see.
Yes.
The circle looks better in this picture.
I know.
Yes.
Keeps looking better. The more nitro you give, some of the lesions go away.
Well, this is, a lot of lesions that you're almost convinced need to be done.
Okay,
When
go
you IFR them, they sometimes come up as negative, and you leave them alone.
Get us a 3-5 proximally to post dilate.
Circles I'm talking
and
But
then
they
final
did show the IFR was
if
negative
the diag
anyhow.
looks
We
okay.
gave a lot of rotaglide inside that vessel. The lesion, the spasm possibility went away. Let's see how it goes now after
take a
the
picture.
stent.
Okay, ready?
We have jailed that diagonal wire for a long time.
Beautiful.
That one looks
It's
amazing.
called work of art.
I would say KIO technique. Keep it open technique.
Yeah. So
It's
we are going to
beautiful.
post dilate and image. If you want to continue with the lectures, you should start.
I think we're going to do
Right?
image and pot before the diagonal, and this is an amazing case. Let's go. Thank you, Dr. Kinney. Very, very good. Let's go back to Dr.
I now
Sharma.
invite Dr. John LaSala, Professor of Medicine
After the
at
talk.
Washington University School of Medicine. Please welcome Dr. John LaSala.
All right. Well, it's Dr. La Sala here, and thanks to Dr. Kinney and Dr. Sharma, who made 20 minutes off the scheduled time. So we're going to be going.
Thank you. It's been a pleasure to be invited again to this symposium. It's always interesting. It's the best live case symposium that you'll ever see. And first time I've been introduced by AI. To talk about atherectomy, and my task is to talk about rotoblator particularly. It's also to remind you about how prevalent calcium is in most of our lesions, particularly as we've gotten older and more diabetic. There's a lot more calcium. There's twofold increase, as you can see over this. Unfortunately, the amount of atherectomy that's used, even in severe calcium, is relatively low. It's less than 40%. It's not like going to this course. The outcomes, of course, are much worse. You can see these two curves dramatically diverge right from the very beginning. Looking at moderately severe calcium at 14.8 versus 10.4 in target lesion failure, and even a mortality difference numerically can be seen in these lesions. So if you come out of any of this debate is to make sure you treat calcium, because 50% of the time it's not being done at least. Rotoblator, you just can't get away from the physical dynamics of it. You saw a picture of David Auth earlier on, who decided, he was actually a laser physicist and decided that laser was going to be inadequate to take care of calcium. So he said, we're going to go to the high pressure, the high drill, going at 180, 200,000 RPMs. There's not a piece of calcium that can stand up to that. Gives you a nice smooth lumen. And it's a front cutter. Let's make no mistake about that. So the more severe the calcium is, the longer the lesion, the better job that rotoblator is going to do. Clearly, it's different than orbital, right? They both have their role. I'm not here to say use exclusively one over the other, but it's not the front cutter that rotablator is. You may have difficult getting through some of these, and we'll see that in some of the trial data. Some interesting data, though not a plethora of patients. 100 patients in rotablator receiving versus modified balloons, which could be angiosculpt, Scoreflex, Flextome, et cetera, compared 1-to-1 in patients with calcium. What you can see in the outcome in the bottom right is that the target lesion revascularization was statistically significant. So as opposed to some trials that we'll see with orbital, at least you have something, even though it's a small trial, suggesting this is a benefit compared to even modified balloons. How about if we look at the next trial here, looking at rotablator versus orbital atherectomy? This is really the only head-to-head we've seen. Again, 50 patients. It's hard to draw a lot of conclusions there. I have to wince here when I look over at Greg, because I'm sure he's saying this is clearly not something you can draw many conclusions from. But it was statistically significant in terms of the stent expansion, rotablator versus orbital atherectomy, and there's a significantly greater maximal tissue modification as a result of that. The clinical event rates, though, are not going to be significant because of the small number of patients used. If you go to a combo thing, which is what you've seen here in a number of cases already, taking rotablator and then try to use a rotacut on top of that, you can see that there are significant differences in terms of the luminal gain that's obtained, though the stent expansion was relatively comparable. There's a greater MSA for these combination types of therapies. So we've got at least some reasonable data. The rotablator functions well in these heavily calcified lesions and provides a better type of result, at least in terms of the expansion. Greg is already famous for presenting this type of data. Just to remind you, as we'll hear more about it in the next lecture, study design, orbital versus conventional angioplasty, second generation stents that were utilized. You could dilate before you went if you couldn't get through. Pre-dilatation may be necessary for orbital atherectomy, was allowed if necessary. The crossover was supposed to be discouraged, although there was still some of it going on. The results are you're well aware with. The target vessel failure did not achieve any statistical significance, so that if you can get a balloon across, the balloon does just as well as doing orbital atherectomy. So in contradistinction to rotational atherectomy, we do not have a statistically significant difference in the outcome. Just a couple of things that sort of pop up, and they may or may not be relevant, but we do see stent thrombosis in more than twice those in the orbital arm versus balloon. Very low, of course, so it's not a statistically significant number. And one of the interesting things, if you look at the patients that actually crossed over, the use of rotablator or laser or IVL or any combination was about 28%. So even in those people using orbital atherectomy, when it doesn't cross, they go to rotablator many times. Same thing in the balloon angioplasty arm. That's mostly using the same sort of atherectomy. So conclusions, of course, routine use of orbital atherectomy did not reduce TVF in 2 years. These are calcified lesions that the operators felt that they could cross with a balloon. So therefore, it's a different group. It's not like the high-grade lesions that you might see in some of these rotablator arms here. Intravascular ultrasound, we didn't show this, but clearly shows a better result comparing those. So adequate stent expansion, low rates of adverse outcomes are achieved with conventional balloon. We don't see a significant benefit. I will say that the concept of precessing around a central area, like orbital does, has been actually adapted in some respect to high-speed rotational atherectomy. And you can not only just go through, but you can dial down the RPMs so that it does precess a little bit and allow it to increase the lumen. So we're not going to throw out the baby with the bathwater and say that maybe we want to still use this concept even for rotational atherectomy. This is an interesting early trial of shockwave versus rotational atherectomy. It shows that there's really no difference in those outcomes. So this is, it's just not, in other words, you don't have carte blanche to use these atherectomy tools. If you can get through with IVL to begin with, there may not be much of a benefit in adding atherectomy on top of that. So as I looked for some of the algorithms that would be appropriate for looking at calcified lesions, clearly imaging is very helpful, but many times you can't cross. In those situations, you have to use laser. If you can exchange out for a rotablator wire, use rotablator, and then image. The only one I could see in terms of using orbital atherectomy in one of these algorithms was in the realm of nodular calcification. I think Art's going to show us a little bit of that later. Nodular calcification continues to be vexing because it may require a combination of therapies. But for the most part, when we're looking at these difficult lesions, it's going to be rotational atherectomy. Quick case here, somebody who had a CTO with a right coronary, could not get through with much, eventually got a rotoblade, a judo wire through, nothing else would cross, no microcatheter, no small balloons, used a laser, 50-50 contrast, took over 38 laser trains to get through, but eventually was able to then pass a microcatheter and go through. But still a balloon wouldn't cross, despite the fact that we had a microcatheter, and therefore it was time for rotational atherectomy, and coupled with a guide extender, gets a nice lumen in the situation. So this is a classic example where you can't cross or anything, that a laser helped you out, but rotablator does the facilitation of delivering things. So in conclusion, rotablator is the most powerful tool for dealing with calcium. It's just basically because of the power that's generated at these high RPMs, far exceeding orbital atherectomy. It is a front cutter, therefore it lends itself to penetrating non-crossable, non-dilatable plaques of any type. I don't think it's like the parachute analogy. I don't think you need a trial to prove that. This is the one that does it the best. Good techniques, complication rates are acceptable low, and a crossing time faster than orbital atherectomy. Randomized data suggests the road is both superior to standard balloons, non-atherectomy techniques. Unlike orbital atherectomy, we don't have that data. Small head-to-head trials, very small. Rotablator was superior to orbital. Combination therapies may be helpful, as we've seen, in expanding the lumen. And if you don't believe me, we'll see that the panel suggests that this may have a higher level of guideline approval than orbital atherectomy. But the one caveat, as I alluded to, is that crossing with IVL may minimize atherectomy of any type. And this is what I was referring to if you look at the 2021 guidelines. First of all, in 2011, we did not have any evidence for rotational atherectomy, but by 2021, we see it has a 2A classification as opposed to a 2B for orbital atherectomy and the others. Thank you very much.
All right, let's go to Cath Lab 3 for a minute to see the final result of this rotational atherectomy case.
And I also want to request that all our organizers here, audiovisual, any...
Can we hear Cath Lab 3, please? AV control.
What is basically said by the speakers.
AV control.
Just when the GD said, just to say, this is what we started with. Remember, this is a very tortuous aneurysmal. We wired 1.25 bar, and I just want to make it very short. And this is the artery.
Very good. Excellent.
Transplantation of the LAD done in this case. That is it. Thank you very much.
Excellent.
No IVL, rota high pressure balloon, and two stents. Thank you very much.
Very good. All right, excellent. That was an excellent end of a tortuous calcific case. We can move on in the second talk. Cue in, please. Dr. Jasvinder Singh.
I now invite Dr. Jasvinder Singh, Professor of Medicine at Washington University and Chairman of ARCH. Please welcome Dr. Jasvinder Singh.
Jas, thanks so much for coming once again. Great.
George, you need some, your AI needs DEI.
Boy, I like this AI thing. I'm going to try to use that at ARCH. Anyway, thank you very much, George. So, I'm going to talk about orbital atherectomy and why that should be your first choice. It's just as good and easier to use. It's hard because I have disclosure. I was trained by Dr. Lasala in rotablator, and I trained him in orbital atherectomy. So we are a good team. So, Samir asked us to debate each other. So it's hard, but I'm going to try to make an argument here. All right, let's see. These are my disclosures. So we'll talk about mechanism, ease of use, some data. We don't have too much time, but we'll talk about slow flow, no reflow, plaque modification, costs. So how would you treat this lesion? So John showed his cases. You can see all these lesions that are there. These are not lithotripsy cases. These are the kind of cases that John showed. The area in green, mild calcification and moderate calcification. Listen, I think all the data shows that, you may not need atherectomy in this. You may not need lithotripsy in some of these scenarios, depending on if you image and understand what kind of calcium you have. What we are talking about is this moderate to severe range. And those are the scenarios where balloon, lithotripsy may not cross, and all those kind of things fail. So what do? You either use rotational or orbital, and if you can't really cross with one of the wires, then you'll have to do laser modification with contrast and try to get in there like John showed in his case. So that's what we are talking about, really. We need to understand what kind of calcium it is. The old days of looking at angiogram and saying, well, we had train track calcium, so we're going to try to figure this out here. Now, everything, all the guessing game is gone. We need to understand superficial. If it's superficial, we need to understand whether it's what degree, what length, what depth. Is it deep calcium? Is it nodule? Like Samin's case, this morning he did. There was a nodule there. Rotablator didn't do much because of wire bias. He had to do lithotripsy. You have to understand, is it eruptive or is it healed? Those are the things that really determine what kind of modality you're going to use. And Greg, published this from the Eclipse trial. Really, imaging is critical. Whether you use balloon, lithotripsy, orbital, or rotational, imaging makes a huge difference because you understand what kind of calcium you're dealing with and how you treat. It's very, very important, really. So orbital, obviously, for severe calcium, it's very easy to set up. It has glide assist. You can take it. It goes to the lesion very nicely. You don't have to really struggle with it. It cuts backwards and forwards, so the chance of rotor bird trapping is gone. Low speed, really, because of the unique way it sort of centrifugal motion that it has, it really sort of grinds and debulks the lesion in addition to causing fractures. So it's very, very important to understand that because, and also what it does is, really in the next slide, I will show you the next slide after this, but think about it. There was in the Europe PCR just presented the French registry on orbital. The primary wire that they have, the flex tip now, you can actually cross the lesion primarily with it. It's much better than the rotor wire, and you can deliver stents over it also. So here you can see bidirectional sanding, fractures, and also what it does, it changes the compliance of the artery. So it tells you that it actually minimizes recoil and also has some deep fractures, and it also affects deep calcium like lithotripsy. So it's very unique. Rotablator does not do that. So here you can see, sort of animation of how it orbits, causing deep and superficial fractures. Very easy to use. We talked about very easy to set up. You don't need gas. You don't need any of this stuff. Very, very easy to do. Learning curve is not much. And you can get to the lesion very, very easily. The data, everybody knows. I'm not going to go over the data. Extensively studied. The orbit to TLR rate was much lower. So the reason why we don't have randomized trials and most of the atherectomy devices really don't pan out to be better than balloon angioplasty is because the kind of patients we really need this are not really enrolled in these trials, and there was significant crossover really in rotablator trials. So you can see Prepare Calc and Rotexis were the two trials that really showed, that the strategy was successful, but then it was no different. But those cases really had moderate calcification. The ones we really target, that algorithm I showed you, are the ones really not. And then use of imaging is important. Yes, we know that, but they were not really mandated in these trials. So that's why I think Eclipse trial was the same kind of thing. Same things happen. You can see there was no difference, orbital versus balloon angioplasty. But you can see there was moderate lesion severity, 67%. Are you kidding me? The kind of cases that I showed you, those are the kind of cases that we need orbital in this. So those patients were not really studied, and there was limited imaging, and also the low use of cutting angioscalp balloons also. And you can see the area that you achieved was 7.4 millimeters squared in Eclipse. Listen, those calcium is very hard to achieve that area, right? And the crossover rate was much lower in also. So those are the limitations of this Eclipse trial. There was a meta-analysis just in EuroPCR this year. rotational, the largest meta-analysis, lithotripsy and orbital. And as I said, it really there was no real difference between them. Procedural success was slightly higher, yes, because they crossed the lesion better than lithotripsy. But you can see slow reflow was lower with IVL. Yes, it's a balloon technology. And you can see there was this little signal that IVL and orbital were across from 1, which means we're slightly better than rotablator in terms of mortality. So it's a signal, but it's obviously a meta-analysis. Plaque modification. Pretty impressive study in 2017 showed that orbital actually causes more calcium modification in larger vessels, and also the way it orbits in non-calcified plaque, because most of them are either fibrotic or mixed, it actually causes more plaque modification than rotational, obviously because of the mechanism. This is important. Particle size with orbital slow, 80,000 RPMs is much less. There is less injury, less platelet activation, and also less no reflow. And you'll see here, I'm not going to go over this, but with rotablator, everybody knows there is slightly higher risk. That's why the speed and the injury, the thermal injury and platelet aggregation and all those things is lower with lower speeds, but there is an incidence of raw reflow. CFR actually remains low in these things after the rotablator. But when I look at it here, Zia just presented at the Europe PCR 2026, orbital versus rotational in coronary microcirculation. And you'll see here, they analyzed, they did FFR, they did CFR, and IMR, and actually showed you that you can see that orbital had a much, much better profile, significantly lower IMR with OA than rotational atherectomy. So it tells you that actually there may be something about the mechanism that is a better atherectomy tool than rotational. So temporary pacing, yes, rota is more used because of the mechanism. Also, in people with LV dysfunction, because the way it orbits allows blood circulation, there is tolerated better in people who have low EF also. So, and nodules are one thing. Rotablator actually is not very, very efficient because of the wire bias. Because the way it orbits, this orbital actually has some mechanism to cause fractures in these nodules, especially the healed nodules. So there rota fails. Lithotripsy has some data on it, but I think orbital is also complementary in those scenarios. And you'll see it here that nodules treated with rotational atherectomy had worse outcomes because it really didn't do much. So orbital probably has some use in this scenario. So safety profile is very similar, but across the board, I'm trying to just win against John, so I'm just trying to put all these things in green. But safety profile is pretty similar. Orbital, obviously, slightly better in those scenarios. So cost is important, right? Cost is important. Rotational is pretty much similar, but this is where IVL actually fails a little bit because even though it's lumped now in the TPT code, expired, even though it's lumped now, the margin is much, much lower if you combine and do lithotripsy than orbital. So that's why I think orbital should be your first line calcium strategy, provided, you learn and your team is ready to roll. So thank you very much.
Good job. Good points, man.
All right, and after such a heated debate between orbital and rotablator, let's try to make things simpler and present an even simpler than either one of these complicated things as a possible game changer here. IVL, as we all see, and my previous two debaters indicated that they often use it in combination with orbital or rotational atherectomy, can actually allow you to have a peace of mind, keeping your wires in the side branches and perhaps doing all sorts of things we need to do without bothering too much. To begin with, balloons in a calcific lesion, let's just have some pictures first to understand better what we're talking about, and it's not really about the data. Not a single clinical trial is positive in the atherectomy space, in rotablator or in orbital, as evidenced by Dr. Sharma's, Dr. Tierson's talks earlier in the day, the Eclipses trial, the bigger one, negative. They didn't overcome the balloon. So the balloons themselves, they're pushed away from the rock-hard calcium. So in a calcific vessel, you're either going to crack it in some ways, or if you don't crack it, you're just dilating the normal wall. Sort of, and if it's thin, you may actually ultimately perforate with very high pressure balloon. So you need to understand this concept and limitation that we have. And the atherectomy therapies, talking about dedicated wire, special, which is not easy to manipulate. You see Dr. Kinney, she did the longer changes in all the cases with another wire and a macro catheter. You don't have a wire on the side branch. You saw at a hard time she had crossing, perhaps other people or other lesions you cannot even cross, you lose the side branch. And you have a lot of distal embolization for which we worry about, and we go slower, burying, flush with a rotaglide, and all these things. Why? Because of a continuous plugging of the macrovasculature, and we have to allow them time to recover. That's great. That's why you saw Dr. Sharma's case go Brady right after the initial rod ablation, because there was a significant amount of micro debris that it causes spasm as well and all that. So that's a situation, let alone the possibilities if things go really sour that you can create a device perforation which is really massive. So here comes a simpler device that looks and is a balloon and a specialty balloon. So no particular training except for how to fit it in the monorail catheter. You have to have a little patience. I guess that is a training, because in interventional cardiology, everybody wants to do things super fast. And over here, you have to go through the cycles of lithotripsy at low atmosphere. So we're not going to bank high atmosphere. You're not going to inflate only 20 seconds and then be done. You have to do serial dilation and lithotripsy at 2, maybe 4 atmospheres, and take your time. Personally, since we pay for the device, I always exhaust the maximum number of pulses. So I give all these 120 seconds that are allowable in spaces. So 12 times 10 seconds each is 120 seconds of lithotripsy. I choose all. I know some operators only use 6 or 5 or 7 of all those. I like to get what I pay for all the way. And most importantly, this low pressure inflation due to the lithotripsy allows to the plaque modification. And at the same time, if you're concerned about the side branch, no sweat, you're able to protect it with your second wire while doing the lithotripsy, so you don't have the conundrum of what happens to the side branch after you do the lithotripsy, and then after the ablation, you have to wire it or perhaps not be so successful in wiring, let alone that you don't deal with shoveling down the vessel debris all the time. All right, so the calcium, you can see it can be concentric, eccentric, or nodular, and I think we all understood it very well from multiple presentations today and multiple case examples with the intravascular imaging. You know what you're up against, and you're trying to really either burr through it with the limitations, though. You saw what sizes burr we're using, 125, 1.5. We no longer go to the 2.0 burrs and all these things. Now, the vessels usually are 275, 25, 275, 3, 35, 40 sometimes. So it goes without saying that whatever you're doing with any ablation device is probably not as big, or most likely not as big as you'd like to in the vast majority of the vessels. So the IVL differs mechanistically, and by the way, and I underline that, has a device that is up to 4.0 in diameter. So if you're going to deal with a 3.0, a 3.25, 3.5, 4.0 vessel or bigger, then you have appropriate sizing that's going to get you there before you're starting with your stent or any other device. And you can see how it works by multiple cracking, create some cracking, that it can be further expand this vessel wall very well. And you can see the examples of that. I thought always I like the graphics because you get better the idea, but this is the actual pictures of the cracks after the IVL. You see how it is cracked in different locations and how ultimately in these areas you're able to widen the vessel with a stent and the different techniques. This is the situation that I explained. Once again, the summary of how it might look with a balloon. You get a good result, but primarily, or a decent result, primarily from the non-affected calcific part of the vessel. So you're overstretching the other wall. In the atherectomy, you cut some, but you don't really crack all of it. So if it's very deep calcium, that's another situation. You're really not doing much. You're not affecting much of the deep calcium. You're cracking the superficial. Is that enough to help you? Sometimes it is, but some other times not. And is that worth the special training many people don't have? And is it worth the side branch threatening? And is it worth the distal embolization? Perhaps not. This is the example of the eccentric calcium with the deep calcium and the fracture, and ultimately you can see the expansion between 6 and 9 o'clock very nicely all the way. This is a mechanistic studies. I'll show just a couple of slides on mechanistic studies because I think in this type of example and discussions we're having, it's all about how things work inside the vessel. You can see the similar stent expansion along all the different calcium arcs from less than 180 to 360 calcium in a very good minimal stub area and stent expansion by the imaging techniques following this activity. And there's a specific study I want to highlight. I know this and a few others were presented by Dr. Sharma and Dr. Tierstein. Gives me the chance to save a little time. But in this particular one, there was a 200-patient randomization study of with the outcome of no or failed stent delivery, and most importantly, the OCT assessed residual stenosis over 20%, which means that the stent wasn't really expanded as much. It was a randomized study between the IVL and other specialty balloons. If it was highly stenotic and nothing could go through, could use a little rotablator if need be, and nobody is really talking about these exceptional, very rare cases and nothing crosses. But the vast majority of the cases you're able to cross rather easily with this device. So ultimately, it was a wildly positive by specifically the fact that the residual stenosis over 20% was in the 30% versus nearly 45% with the rest of the devices, and a highly significant primary endpoint, which obviously an imaging endpoint. As I said, it's all about imaging and understanding the mechanistics of the study. In the Society of Cardiac Geography and Intervention, the expert consensus algorithm, you can see that is intravascular imaging is very important into deciding what's happening in order to understand superficial versus deep calcium versus calcium nodule. And you can also have upfront the decision to utilize a lithotripsy of the specialty balloon and then go ahead and check for calcium fractures and finish up a good job. Goes without saying that, as I said, something is very user-friendly and very easy to apply, easy to learn. How do we know that? Well, you can see the tremendous growth. Everybody likes and enrolls into that, even obviously people who are not trained in the specialty centers that otherwise rotablator and other atherectomy are in 2%. Why? Most people don't know how to do it. And of course, we're not talking about the experts that we have here, but we're talking about all over the country now by the NCDR ACC database. So in brief, I have to say that the use of coronary IVL has rapidly increased after its introduction tremendously. And a standalone modification is associated with a simpler procedure, shorter procedure, less temporary pacemaker use. I will never use it really. And obviously, all this can be accommodated in a very easy procedure, radial access and outpatient settings, whereas all the resource utilization with admissions and other complications related with active atheroablation and aggressive atheroablation. Due to a relatively rare inability to cross a target lesion, it is safe and easy to apply option for the vast majority of the calcific lesions. Nobody's debating about the less than 1% or 1% of cases that nothing really goes through. Due to the unique ability to target the deep calcium, particularly in good-sized vessels where you mostly need the expansion and you have the biggest risk of thrombosis if you don't expand, it is a common adjunct to the classic atherectomies. Anyhow, we heard that before in the previous two lectures. So IVL, in my opinion, is not only good enough, but much better than anyone expected. It's been a real game changer in this field, and we continue to look forward to further improvements. Thank you so much for your attention. And let's go to lunch until exactly 10 minutes to 2, okay? Then you come back here, please. 10 minutes to 2, 22 minutes for lunch. You can bring your lunch here. You can finish your lunch here if you bring a plate in here. Thank you.
Well, thank you for the warm welcoming. This is going to be a wonderful afternoon. I want to call my moderators today. The faculty is Dr. Duvuri, John Fox, Dr. Kaul, Kalra, Samir Mehta, Bill Nicholson, Dr. Javindra Singh, and Ron Waxman. Please come to the podium. Okay, I think we have few of our panelists already here. In order to keep the time on time, we're going to try to connect to the cath lab now. Fantastic, Dr. Kinney, I can see you. Do you hear me, Anu?
Very, very, very complex RC, if you can see that. So if you can start with the slide of case number 5.
Dr. Kinney.
64-year-old male who has had dyspnea, and when he saw his physician, now this is the first thing everybody orders, is a calcium CCTA. On CCTA, he had a calcium score of 4,937. A lot of it was in the LED circumflex as well as in the RCA, and you can see his parameters, which is written there. He was started on, based on the high CT score, he was started on anti-anginal therapy and was referred to the cath lab, which showed significant two-vessel disease.
So, Anu, I'm sorry to interrupt. We still don't have the slide of the patient here. But summarizing, it's a complex RCA, you have two-vessel disease. Now we have it. Oh, no, we're still waiting. Yeah, we have it now. Go ahead, I'm sorry, go ahead.
Yeah, PCI of the LED was done, and then he's here for the PCI of the RCA. So before we say that, if they can go to the angiogram. Before showing that, you can show the faculty here who's helping me.
Okay, we can see the faculty.
Right here. Yeah, you can see. Isha, who was my fellow, she's here as an attending and helping me. Then I have Sabina, who is our interventional fellow, and this is Sophia Tan, not the Sophia that is helping you down there. This is my fellow, Sophia Tan. So we are all these people trying to help. So make sure the Sophia there does not get jealous. Let's go show the angiogram. This is the left side. LED looks okay, circ was non-obstructive, and this is the RCA. So anterior takeoff, almost anomalous, you see that? It is from the right sinus, but slightly higher. So the question is, what's the guide? So we have a long sheet, and then we have a 6 French. We took a AL1. This is the case where you need a very good guide support, but often you don't get guide support. So we are AL1, we are able to engage. If someone says they want to try multi-purpose, probably okay too. And what we try to do is wire it. So this will be a fielder fine cross. If someone want to use a different micro catheter, Corsair, that's okay too. And with a fielder, we are able to wire. So you see that it's engaged, but still not stable. So get into the right coronary artery. We have a pacing wire just because there's so much ectasia. Even if we do balloon stent and if we develop slow flow, there's a risk of developing complete heart block. So that's why we have a pacemaker ready. So now we are able to enter into the right coronary artery. You see that? So after this, there's not enough support. So you can bring your microcatheter. So we use the word, you see that this is like a zip line or cliff angioplasty, where you see guide we have no support. You cannot advance anything. You cannot bring a balloon. You cannot bring your guide extension right now. So just with the microcatheter at the tip, we are able to wire. Okay, we have the wire across. And this is where we are now. So the fine cross is across the significant disease. So I'm trying to see, now be prepared also, we already have the guide extension in the guide, but we cannot advance the guide extension unless there is a balloon. So let's do. We are going to use a 300 run through, open the 300 run through. Are you able to see that? We are just getting the fine cross all the way down.
And tell us the rationale for the run-through. Won't you prefer a stronger wire for support here?
No, I was just thinking about it. I don't even know. Do we carry Grand Slam or any of those? So the issue with the Grand Slam and all that,
I know.
you know, they get us a good support, but then they also do not, they don't behave when you're too distal. It starts spring coil, it comes back as you're trying to do the procedure signal. So let's see if run through does its job.
Speaking on support, did you consider to go 7 French here because you would need a lot of support in this case? Why 6 French and not 7?
I mean, it's a misnomer that 7 French you get better support. The question is larger guide. We did contemplate that in the beginning. That is also because if we think, I don't think there's a lot of calcium. You see that?
Mm-hmm. There was more than 2,000 calcium on the CCT.
That's, no, what I meant is, but it is not at the level of the lesion. So we are able to do that, right?
Mm-hmm.
Let me get...
So you have a wire and you have a fine cross in?
Yeah.
And you're going to try to pre-dilate this?
We'll try to dilate. We have to take this out, get a balloon. At that time, advance the Godzilla or whatever the car.
Sometimes now you can bring the guide in and turn it up and give it a little bit better support.
2512?
Yeah, get the balloon. 25. 2530. You have a 30. Okay, 25. Okay, take it slowly.
With all the lectures we've been having earlier today, I think this is a perfect case. Perfect.
Very nice.
And I think imaging will probably show us you also have every type of a calcification there. There may be a nodule there.
I'm thinking about between the coaxiality that is not there and the resistance of the vessel. I think the issue here is more the coaxiality that we might be able to correct with the Godzilla.
Yeah,
but using imaging here,
also
it will be a different ballgame.
Exactly what Dr. Fox mentioned. I think you'll be able to bring in the guiding catheter a little better now with the wire out so distally.
Yeah, and if you just
Any questions there, Anu? Do you think I will feel comfortable to do this case without imaging because it's a large vessel? But of course, this is a good question for the audience.
Now, this is the kind of case, use your eyes.
Exactly.
Not a case of imaging. Don't even think about it.
Yeah, because you lose the wire and that's the worst that can happen.
That's it, end of the game. We don't know whether, see, it's a short monorail. Imaging catheter is a short monorail, may not make the turn, and then we may lose everything.
I think it's when you do the imaging, though. You still can do it, but maybe doing ballooning first.
Yeah, with all these controversies with the imaging, now that we have Greg here in the front line, I think, as Sharma presented it this morning, we have to trust what we have learned in so many years, that imaging has basically supported and reaffirmed the confidence that our eyes bring in complex cases in which you lose time, and it's even actually complex to do.
Hold it there.
I could probably argue that you don't need your eyes. It'll all be told to you by AI. Nothing, no human interaction needed. I mean, look at the Terumo catheter out there combining IVUS and OCT and back it up with the AI. Eyes are not needed.
I totally agree. Also,
Okay,
your eyes are really good, Pedro, because you've had years, and as you're coming out into this, you're now.
It's beautiful. So, two extremes here in the moderator. One say no eyes, only AI, and John Fox saying trust your eyes. But the most important thing here is how she's going to advance. She's inflating.
Do we need do we need fingers or no?
Yeah.
Go.
Not for too long.
So she inflates during the deflation. She advances the Godzilla over, and now
And
that
we
will
need
allow the balloon to go further.
Okay.
And
Okay, good.
yeah,
Go.
very
Yep.
good, very good.
Okay, good.
Now, yeah, the
Now,
catheter.
Get your guide. Okay, down. I think the 2.5 balloon is not crossing the distal part of the.
3-0.
Right?
Interesting.
I know this is a AL1 or AL.75?
AL1. The guide is an AL1.
Go.
The question, why not to start
really
with
high.
rotationalatectomy here?
Exactly.
It's
Very
a
good
very,
point.
he's 64, so he must have calcium. I don't know how much because we don't have imaging, but looking at this artery, if you run or do a pass with rotational atherectomy, it's going to be much easier to deliver all the balloon after that.
This is a good retrospective view of the case that Ron Waxman brought out. If your fine cross is there, distally, you can always put your rota wire and then the rota will always go, specifically in a lesion like this. But now we are committed to Godzilla-supported balloon angioplasty and then stenting. Although never too late to change the problem.
I don't think you're committed. It's just hard for us to change the course, but I think if you'll change it, probably you'll save time.
I'm not sure. You will probably do cliff rotational atherectomy with the rota hanging outside. Go. You can change to 2 balloon. Okay, good.
You're making progress, Anu. You feel...
Yeah, I know.
Yeah,
We'll do it.
You are.
I think if I get a 2 balloon, then, okay,
Well,
go.
in the hands of Kinney, you can do almost everything, but I think that for the ordinary interventionalist, it's going to be easier to do rotational at first.
Look at this.
Yep.
Wow.
It's the same as the eyes.
Very nice. I think the 2 may go now.
Let me try.
So, Kinney, I know you're concentrated, but tell us about this technique that you use to balloon, come back, advance, balloon, come back.
Yeah, you see that?
Yeah.
Let me
See your guiding.
Guide.
Sneak and attack.
And maybe now you can get coaxial, right, Anu? Guide.
Doesn't matter. I think then every time something happens, everything comes back. Yeah, good. Down.
It's coming
You want to give some dye and see?
See, the whole process...
So now you...
Yeah, go ahead.
Okay, ready? Let's see. Make a decision. Do you think? Okay.
That's the part, the complex part.
Very tight there.
You had a 2.015, that's what you had?
2.5.
Yeah.
Or
give a
2.5?
2.5, not 2.0.
Okay.
We'll change to 2.0 now.
So the whole process here has been done through the balloon and the Godzilla interaction. The wire distally giving you support, the guiding doing anything. So this is how sometimes the pivotal components of the PCI are changed to allow you to go further.
You're doing it this way, you just have to be a little bit careful injecting through the Godzilla if you're right up against the plaque.
Yeah. Let's see, the new 2.0 should go.
Yeah, the 2.0 went
This is a new
beautifully.
2.0.
Yep.
Yeah, good.
Excellent work.
Stop. I think the decision to do rotational atherectomy, no rotational atherectomy was all the way the guide. We never got a good guide engagement into the vessel.
Yeah.
Yeah, down.
Pull
And
back
the
a
question
teeny.
is, pull back a
Maybe
little bit.
this
Go
is
up here.
semi-compliant, correct?
Yeah. Yes, yes. I think it's okay.
It's
there.
getting better. How much atmosphere is there, Isha?
12.
12,
5?
she's saying. Go up, go up, go up.
Yeah, you can go
16,
higher.
18.
16, 18.
Yeah,
Oh,
good.
beautiful.
Now I'm going to advance. Go down. Okay. Go up here again. Do you want that other balloon? What is the balloon we have? 3O? We can try that.
You
have
think
3O15, right?
You think the lesion expanded to 2 millimeters? We can't tell
Yes.
here.
It has expanded. And let me try the distal lesion, right?
Okay.
If it goes, yeah.
The balloon is going freely?
Yes.
Okay.
I'm not going there.
Yeah.
You want to do it with the 2O? Okay, let's finish with the 2O.
Yeah, let's do
You know, it is interesting
and then
that...
go with the 3-5.
Yeah. Interesting that in the Sunday meeting where we prepare all the cases, we didn't think about rotational atherectomy is because of that anomalous origin.
Actually, I know we did think if we need, then we'll need extra support rota wire and probably a 1.25 bar. But then you saw the way the guide is barely there. And that's the time down. If you want to do rotational atherectomy with the guide extension, then we needed a 7 French.
What size is the balloon?
2.5. Yeah. Okay.
Well, you have to be able to
2O.
get it in. I still like rotational atherectomy in this case.
No, 6 French.
Making a lot of progress.
And remember, you have
My
to take
concern
one more
is,
turn, which is going to be also hard to get pushability.
I love to see that Godzilla distal. Guyliner, whatever is the name.
Okay, go up there again. No, they're saying 1.25 bar is not going to go through the guide liner. Okay, down.
Yeah.
Let's go with the...
We historically always paid a lot of attention.
Okay, that's go.
To choosing the right guide, especially when we used 8 French and things. We didn't have guide extenders. So for people just coming into training with graduation here, it's important to just, at the beginning of your case, be comfortable that you have guide support because we get away from that thinking because the equipment's gotten so much better.
John, you have to speak higher.
Sorry. I think the guide selection's extremely important, especially for people coming out of training. We used to spend a lot of time with 8 French equipment and stuff. We didn't have guide extensions. I think we've all gotten used to the really good equipment, especially coming from radial. And we depend on these things a little bit too much, but if you just focus a little bit on having a good guide at the beginning, all the rest of the support hinges still off your guide.
Yeah, maybe we should do it.
No, we can't.
Take the
We'll have to
guideline
remove the
out.
Godzilla.
Yeah. So John Fox is basically quoting your paper, Dr. Kinney, on guide selection for this anomalous right. We call it unusual origin.
It's a little anterior.
It's a very good paper in JAC that Dr. Kinney published to give guidance to
There's a
people.
mock guide called an ART, which is kind of a little bit of a reverse Samplats. I use the ART4 or ART45.
Get me the fine cross. Let's change to 1.5. But the rotational atherectomy has to be done cliff hanging. Get us extra support wire.
So we're
Just
gonna
extra support.
switch.
Clean the wire. Yeah, we're going to just change to rotational. So there are 2 things. If you want to do it through this guide extension, then you can go orbital, right? Orbital will go through this. Or you have to remove the Godzilla because 6 French and do a 1.5 bar extra support wire.
I think
What do you want me to do?
Yeah, I wouldn't do it through the Godzilla. Anybody?
No,
against that?
Godzilla Rota 1.25 is not going to go, but orbital will go.
No, why don't you use 1.5? It's a very large vessel.
Yeah. So remove the audience believe, the
And then you don't
moderators-
need to use the guide extension for now.
Flush. Now we are going to, change to 1.5 bar. Okay, go.
So I wonder how many radialists will do it radially. I guess probably all of them will say they will do it radially. John, would you use radial for this?
Yes, sure.
Yeah.
Yeah, absolutely. You get the support in a different way. You still have to get the right catheter to be able to turn it in without getting into the plaque. Again, the mock make a nice guide for this. It's an ART series, and it's very nice for superior anterior takeoff of RCAs.
Again, I don't know what others think, but, left radial here may give you a better entrance into the
But
vessel.
your left radial, it's like you're coming from femoral, though.
Yep.
It's this backward turn of the aorta. It depends on the tortuosity in the subclavian. It's usually the age of the patient. The older women give you a
I
lot of
think
tortuosity.
the question here about radial and femoral, if you have coaxiality that you usually have with these anomalous, unless it's very short, very up there with the left main, those are very difficult. You usually have coaxiality with your guides, independent if it's radial or femoral. But in the absence of coaxiality, things are a little bit more difficult.
Do you see it?
Well, the question
Okay,
will be
that
the
is coming.
Amplats 2, no? The Amplats 2 from
Yeah,
the
we
beginning.
either Amplats 2 or Amplats 1.
Yeah.
Yes.
I think it was a
Amplats
bigger
2 sometimes
Amplats.
is the guide.
Ready? There.
Look like a bigger
It's a
Amplats.
dinosaur guide.
Hold the wire. Now,
The
the fine
interaction
cross is
changed.
not making a turn.
Where is your fine cross?
That's it.
Oh,
No,
over
it's
there
not
in the
making
middle,
a
yeah.
turn down there.
In the middle of
Yeah,
the
yeah.
lesion. It will go.
The wire is back a bit.
And then for people doing cases, you have to keep an eye on your ACT whenever you start to have this much equipment and the thing starts to be a little longer than you thought.
What's the ACT? People are asking for the nurse.
What's the ACT? 300.
300, okay. You're using Angiomax, no?
And Angiomax.
Yeah,
So
you
that
don't
takes
need
that
more
out of the
ACTs.
equation
yeah.
then.
Okay, tell us what you're doing. You're clockwise-ing?
No, I'm trying to get the fine cross all
Yeah.
the way down. It's not making there, right there.
And if you remember the anatomy, would you be able to negotiate from there with
We
the
did
rotor
now.
wire?
Earlier we did. Leave it. I'm trying to see. Otherwise, we can't free wire because the extra support wire is not as good as the rota floppy.
Just to go back to the guide discussion, that Amplats is really designed as a cusp catheter. So when it's like this, it's just not catching the back wall of the aorta. So
Exactly.
it just pushes in free air for people who don't use a lot of Amplats.
Yeah, you don't have coaxiality for sure.
Yeah.
Yeah, if somebody said radial, yes, maybe the orientation could have been different.
So which catheter you were turning clockwise?
Fine cross.
Fine cross.
You want
Yeah,
to
it's interesting.
try the
Free wire.
yeah.
Yeah.
Right?
Yeah. At this point, you've maneuvered.
We are going to free wire that. Pedro?
Yes.
No, Dr. Sharma is calling you guys to room 3.
Okay. Let's move
Go
to
there,
room
we are going
3.
to
Well,
change and then, yeah.
okay, Dr. Sharma. You are on the screen.
Good afternoon, Samin.
We don't hear you.
And of course, everyone. Can you hear me now?
Yes, perfect.
please. Okay, beautiful. And of course, the team, the pilot and co-pilot remains the same. Myself with Huda, and we have change of crew. Fellows are Marilina and Akash Patel. One is our structural and interventional fellow. the CBT, Habib and Hakim, and our nurses, same, Eldina and Vicky, and of course, Kiski may come imaging if we need. All right, so let's go to the case number 6 slide. This is the patient, as you can see here, a 75-year-old the male had a aortic stenosis and then found to have a triple vessel disease. So we did the valve replacement, put a sapien valve in April, and now continue to have shortness of breath. So many times you leave those cases with a moderate disease. And as you know that we are ongoing complete tower trial where patient, unless it's a left main, medical therapy versus PCI. So this case, actually we offered the patient get into the trial, but patient refused because said if you have such a high blockage, we want to get a PCI. So let's go back to it. Echo height, 1 month echo, 30 days, completely fine, almost no gradient. We wrote down there and good LV. So this is the right coronary. Look, go to the angiogram, please. This is the right coronary. You see very tortuous, but moderate disease, about 50-60% at the bifurcation, with no issue in terms of engaging because the valve, the coronary risk plane, we call it, after the valve, it's completely above. Then this is the case in discussion. Look at the calcific artery, jumbled up quadrifurcation, but no matter what we did back then and now, there seems to be disease only of the ostial LAD. There could be some disease, a little bit of the ramus maybe, and so, but tough to say, but about 50-60%, but it's a very calcific distal left main and kind of mainly a little bit, but clear-cut 90% angulated LAD. And this is where another view, it doesn't tell us anything about the circumflex. It still has some moderate disease in the distal, circumflex after that bifurcation. You see that 70 at about 10, 11 o'clock position, and this is the LAD now. You can see here, very calcific, dips down, goes up, 90% lesion, in there 95, 90%, and moderate distal left main. So this is the case. Actually, we can have a IVUS ready for the future, later on in this. So what we felt, because of so much calcium, this is the case we are going to go with the rotational atherectomy. Of course, can you do just IVL? Maybe, but this is our lab. We do the highest number of atherectomies in the world, about 70 per month, and I personally do about 50 of them. And this is the case, okay to use 1.5 bar. Some tortuosity, but not that bad compared to other 2 cases where we use 1.25. Though this will be our 6th case of the symposium, all 6 cases have been done with a rotational atherectomy. So clearly there is a concern, but we are starting with a 1.5 and go back to the slide presentation so I complete my slide. So what happened is, this patient also has the peripheral vascular disease, a little bit of PVD. Go to next slide, next. This is our plan, post our next, an appropriateness point of view. This patient is a high risk, otherwise next. Clear discussion, surgical, every tower patient have a heart team discussion, felt that appropriate now for the intervention next, and also as a carotid. So surgeons, carotid guy said that we cannot do it. This needs end arterectomy. This is a not case for carotid stenting. So we needed to do some intervention before. So we felt just do the LAD plus minus left main. Unless there is some disease in the circumflex or ramus, we take care of that maybe as a single stent strategy and maybe do a balloon of that. With that note, the Pedro, you can have a discussion with the panelists and we are ready with the 1.5 bar and you will be able to see that.
Yeah, excellent presentation. Definitely the surgeons dash peripherals interventionalists that are going to take care of the carotid says, no, you need to fix this LAD. Do you envision doing rotatripsy here?
I think so. I think it's a good case, but I just say, what I learned from the shortcut trial, one very clear message, that once you do a rota, try the balloon first. Because we know cutting balloon is good enough, it's economical. If you think that still there is a chunk or calcific nodule is there, then you definitely go with the IVL. So in this particular case, I think I'll be reasonable that we'll do the IVUS after the rotablation and the balloon, and then we decide what we need to do. Okay, this is the same, 3 steps our back and forth.
Was it hard to get the wire in the LAD, the angulation off?
Amit?
No, it was pretty straightforward. With the help of fine cross, we were able to navigate.
The fine cross and fielder wire, they went very easy.
A big bend.
Okay.
We don't hear the
And
rota.
the real
so
lesion was further. Yeah.
we don't hear the sound of the rota, but that's okay, I guess.
Yeah, but
Without that,
Pedro,
doesn't
you see the
sound-
difference
doesn't seem
between
like it.
rota
It's just
and
pushing.
working hard with balloon and guide
Yeah.
extension. I mean, this is a very
It's a very
apparent.
good take-home message.
When you think about rota, you should use it.
Yeah, that's our teaching. It's in the Bible of Mount Sinai. If you think rota, do it.
Yeah.
I'm sorry, the Quran.
It looked a little,
Now, do you have this angulation? You got a 1.5 burr. Tell us your technique here. What is the speed?
The same, very slow, 150,000 RPM. And if once you have a drop of 5,000, there will be an open triangle. And if more than 5,000 is a full triangle, orange, and you go more than 10, 15,000, it's a stall, red light. So clearly you can look at the console. We design the console that you start with a 150. All cases, you want to go above, you have to set it up, but it comes from the factory set at 150,000. And this particular case, you don't go to higher, just a slow. This is the area where it could have perforated.
Correct.
Or
That was my
dissection
question.
shot.
There's a little angulation there.
Big angulation there.
Yeah.
that's where it's dipping down in the myocardium.
Yeah.
I don't recall cutting
And coming out.
cutting the rota wire.
There
Yeah,
you go.
beautiful.
Wow.
You recall any cutting of the rota wire, SS, with the rota?
No, that
No,
will be okay. No, in what way? Tell me again.
No, the question is,
we
you know,
have seen in angulated vessels,
Exactly.
rota wire can be cut. Oh, yeah, we have
Exactly.
seen at least three rota cut in our last 10 years, but very
look,
rare.
Look at the nice polishing of the lesion.
Yeah,
I mean,
yeah,
that's
it's a
really-
beauty.
That's the way to do it.
This device is incredible. Probably.
Dr. Sharma, I
Well,
have a question.
I can-
If you still cannot deliver a balloon, would you upgrade the bear, or you would? What do you do if it's going to be hard to deliver a balloon in that?
Yeah, very
bent
good point.
area?
So I can tell you that just by experience, I know you have done quite a bit. Also, once you put this 1.5 bar, I don't think there will be any trouble with delivering the balloon. If your balloon delivery, this is the case you put the guideliner or Godzilla. The first thing first, we put a side-by-side wire with the run-through. And then we are going to, question here is there a left main disease?
Yes.
Let's vote from our the panelists that whether there is a left main disease, although we don't see it here, the left main, yes or no. And I'm going to show with IVUS, we want a 5.5 MLA, less than that or more than that. Ask the panelists.
What is the panelist judge? Raise your hand who thinks there's less than 5.5. We have Duvuri committed, and another, so 2 votes here. So
Moderate,
many of the people think there is no significant left main. I actually joined Duvuri, I think.
Why do you need to think? You can IVUS it and find out.
Yeah.
That's it. No, we are doing it. No, that's what I'm saying. Before the IVUS, we are taking the
This is
vote.
before the IVUS, yeah.
Oh, the eyes before the
I
IVUS.
don't like the
Yeah,
tubular
yeah,
aspect. The tubular aspect of the left main before the bifurcation suggests disease, yeah.
Moderate calcification, 6.5.
The question is, would you do it? Because
The price is right.
you know, remember this case is for the carotid, you know.
Yeah.
Sometimes a 5.5 will be okay, depending on the age and all that.
Yeah.
You will have to stent to the osteum, though, right where the,
How diseased was the ostium of the LAD?
Yeah,
That was,
exactly.
to me, the impressive part of that.
You saw that?
Caudal shot.
Yeah,
Very
look at that.
impressed.
How
Very
bad it
diseased.
was. Look at this. Very much disease. This is the way you
the
have.
osteum is bad.
Yeah.
And angulated. Look at the angulated and
Well,
osteum.
that's, to me, when your burr crossed there, it didn't really come up and down like it did in the
Yeah.
mid portion. It really cut it and
The
took
mid.
out that angle.
But look at the mid. No, but look at the mid. Angulated. Look at the angle of the mid lesion, like horizontal. See that?
Yeah.
That's why so careful advancement. That's what we did.
It's
And
amazing
of course, a lot of questions. Yep. And
You
a lot
have
of
a
people worry about
trifurcation there,
1.25.
Quadrification, yeah.
The quadrification. Now, other point I want to say, very simple. I know there have been maybe a lot of discussion did happen. We use a 1.25 bar, but believe me, no need to worry about that. You are timid in the rotational atherectomy. smaller the burr will create less trouble. Very simple. We did the status trial. We went a rota artery ratio of 0.8. More trouble, more restenosis, and more deacceleration. So that bigger burr, as long as it can do, we can start the pulling back, please.
Can you show the IVUS on the screen?
It's not coming back.
So what Dr. Sharma tells us
coming
that we
back.
don't need to keep all the burr sizes, we can return them to Boston, just keep 1.5.
Yeah, I see the
1.5 and maybe some case 1.25. I think.
Beyond 2.
Yeah.
Three eccentric.
Yeah. No, forget 2 even. You don't need 2.
I remember when we
It
used
won't
to
go.
burr and then just balloon alone, and you wonder if you did that with the bigger burrs, with the drug-coated
Yeah, you
balloon,
can take it out.
what your results would be.
Yeah. Okay. All right. Kiski, tell us left main size.
Sure. It's a calcified nodule and the surface is shaped with the loader. It's very interesting. It's shaped.
Okay. What is the human area of that left main?
Okay, sure. Coming back to
Left main. Left main. No, we know everything else. Get the balloon.
Sure.
And flush it for later. The
Right
left
here,
main is
right
the
here, you
question.
just passed it.
Stop.
No.
Yeah.
Left main is
I'm
fine.
very
it's just the
eccentric.
ostial.
So at this level, 6.8.
What is this?
This is
Okay,
the
right
level
here
of
you
the
have
bifurcation.
220.
This is osteal LAD.
That's
Coming
osteal
back to the
LAD,
left
yeah.
main. Okay, this is a distal end of the left main.
Aha. Give it back.
Yeah,
Interesting.
that's a beauty.
Yeah.
5.35.
Okay, those significant.
Yeah.
It looks significant there. Yeah.
But-
All right, let's go for. Yeah, very eccentric. Okay, now we are dilating with a 2 pi, the 3 or what? It's a 3020 non-compliant balloon. And as said, Pedro, that we'll decide now after this whether we need to go with the IVL. And I would basically just decide whether the balloon is fully inflated or not. Okay, good. This is a 3030.
Yeah.
Yep. Go to 1216 atmosphere.
12,
This is that angulated lesion.
Yeah.
It still has not opened up. Go to 20, 24. Good. I think it is okay. Negative. Let's pull back. And what company stands
You know,
supposed to?
Signs will
Yeah.
be using.
Yeah, and we'll use a 3.25, 33 Zions. Go up. Or maybe 38 even. Go up. No, 33 will be okay. Go. No, but there is a left main, so 38. Negative.
Question for Kiski, how much
Yeah.
would you tolerate
Yeah.
incomplete expansion? Let's say between 80 to 90 will be okay in this case? When you compare to reference diameter, when the IVUS at the end?
You want 40.
Because it's an angulated,
This is 30.
as much as you can will
40,
do, you
48
might
stuff.
have incomplete expansion of the
30.
stand there.
Yeah, I would be careful
No,
with that.
38 will be okay. Yeah,
Yeah,
give
because
38.
eccentric calcium and the other half is non-calcified plaque, so it's a risk of the population with you do the aggressive balloon dilatation.
So you don't
Okay,
expect,
so we're ready to take the stent?
very good.
Most
So what's the
eccentric
stand? It
and the
says three-
surface is shaped.
Yeah, we are using a 3.538, 325, so 32538 Zions. So we actually have, we are like 50-50 share. We carry only 2 stents, 2 type, Abbott and Boston Scientific. And of course, we divide about 50-50. And that is why you are able to get very good financial deal. All these things have become cheap except your drug-coated balloon or IVL. IVL 4,500 and drug-coated balloon is 5,500. As you know, by year end, we'll have 2 things actually, both new IVL and as well as the new drug-coated balloon. So the competition may decrease the price a little bit.
Samin, what about open and C? It's only 800.
No, open NC is 1,200. I mean, they came down to 1,000 so far. But the cutting balloons are about 800, 750. But open NC, once it becomes, I would say 800, believe me, we'll start taking it also. Yeah, that's something which we can use.
Yeah, it's
So
a
it is-
matter of negotiation.
Yeah.
The knuckle there.
We did. So they went down to 1,000 and they didn't go less than that. I said, the guys that day, you come back at the price of our the cutting balloon, we'll talk. So they need to come back. If they are listening they may be there. Yeah, go up. This is okay. Go.
Pedro, a somewhat unrelated teaching point here. I think I didn't pick up from the presentation where the TAVR device was placed. But profound wisdom in not using a supraannular here. Imagine struggling with the access to the coronaries with that.
Correct.
Thank God. Thank God. That is, and now with overall the data coming, so actually now we are also, we should know, the 80% are now the sapien, even in our lab. Go to atmosphere.
So it says you're
So
covering
yeah, clearly,
the distal left main
Yeah,
there,
that
no?
angle, no, disease, yeah.
Distal left main
Moderate distal
covered.
left main, whether,
And the
we
angulation
see
is there.
if there is a proximal area, angle is covered.
Question is, how does the distal part of the stent expands?
Yeah, and then rest is we can post dilate now, that's
Yeah,
not an
of
issue.
course.
Yeah,
Very good.
ready? Okay, and just 1 second, yeah, go. All right, so you see that because of the intramyocardial, everything else is looking good. We just have to decide about the left main. We might have to bring another stent from the mid left main to the ostium, putting up maybe 3.5, and we take care of it as not an issue. And now you can go back to Dr. Keeney. This is another very
Beautiful
angulated lesion, which
this
people
is-
are worried about doing the rotational atherectomy, and we will not have any trouble. Thank you, guys.
Beautiful
And
case,
girls.
Dr. Sharma. Bravo.
Thank you. You know, it's interesting to see this post-TAVR, because I assume when the TAVR was done, it was not that calcified, otherwise someone would have fixed it, right? I mean, you won't live like that when you go to TAVR.
That's a good question, it says. Do you think that angiography was evaluated properly before TAVR?
Some people don't do any more angiography,
Let's
but
go
that's a
back to
mistake.
Kenny. Let's leave that question for
Okay,
later.
okay. Guys.
Okay, something to think about.
All right, Anu.
Go ahead, Anu, go.
Are you here? Okay, good. So you see that this is where I think we left. The fine cross was not making a turn, at that mid RCA, because we dilated the proximal part of the RCA. We thought let's free wire because it has crossed at least the significant proximal area. So when we try to free wire, of course, the Godzilla, the guide, everything comes out, which is very common because you see that it is hanging there. So we change to now a different guide. This is the multipurpose. So with the multipurpose guide, see what's happening, right? It's in the inferior portion of the vessel, into the lesion. No, and also facing down. Was not easy to wire. It is either going to that conus sinoatrial branch. So we had to advance it so that it goes coaxial into the RCA, and then able to wire. You see that? We have to go down, coaxial. Now we change to the rota extra support. Now you see that the rota extra support is giving a lot of support. That's how we are. We have one fiber ready to burn. Now same, when I'm trying to advance the rota burr, that part of the guide is trying to come out. So in this situation, what you'll do is stay there, the way where we are, and we will go with Dinah. So go on Dinah, she's going to go break release and hold the wire, and I'm going to advance, and let's see if it behaves. Okay, ready? Go. Okay, good. I think we are okay there. So off Dinah, and let's go. We had already done a balloon here.
Yep, it's going.
This is the area, it was not allowing us to go further, right?
Yep.
Yes, so, okay, he's saying 20 seconds, I pull back and wait. Okay, good. So now I need to go to the second lesion. So this is what we called as a rota 2, where we have to train how to go advance. So go with the Dinah. She's going to break release and hold the wire like that.
We need the
And
camera on top of the machine. The camera has to be on top of the machine.
No.
Yeah,
Ceiling
now
camera,
we're good.
please.
Now we're good.
Okay, good. Okay. You're good? You see what she's doing? Good. So now, good. Leave it. So what is happening is, you see this is 9 centimeter. So it has given me extra room to move the rota into the distal RCA. So often distal RCA, when you're doing a distal anastomosis of the lima, distal circumflex dominant, when you need to do that, if you have proximal lesion going distal, this is the technique you need to use. So we are off Dinah, and let's go there. This is where that tight lesion is.
Perfect.
Good?
Yep.
This is 1.25,
Okay, so-
is it?
1.5.
No,
1.5.
1.5. In fact, yeah, we were thinking we should have used 1.75, but look at the EKG. You look at the lead one, you see some ST depressions there, which we had predicted, yeah. So good. So we'll come out now, and then, now in this case, normally you see our previous case, LED, we went side by side wiring. We may use, the microcatheter and exchange. Don't go too far. Stay here, stay here, stay here. Don't go too far.
You placed the temporary wire when you decided to go with Rota, or that was before?
No, it was before.
No, it was there before. We expected slow flow because of the ectatic RCA. Large ectatic RCA can give rise to slow flow. We all know SA nodal branch, AV nodal branch, everything comes from the right coronary artery. They do become, pacer, it's a bradycardic, hypotensive. I know we believe in aminophylline, but since
You're having a lot of EKGs.
it's a
changing.
symposium live case, we thought let's yes.
I actually like to commend you on doing it because many people will say I can put the electrode on the wire, or I can give aminophylline, or I can give what. But this has give you assurance. You have a lot of things to deal in this lesion. So one thing you don't want to start to work is on pacing.
Look at the flow. Look at the flow.
Yeah.
Yeah. So we're going to go, I think we will do, right?
you did
Everybody
good
agrees?
stuff.
We'll use a long wire and we're going to give a lot of vasodilators. Look at the EKG changes. This is a case where if there's persistent hypotension and EKG changes, we may have to leave a balloon pump at the end. So be ready for that kind of.
Love to see the pressure.
Yeah, the guide may also be sitting into that, right?
Yes,
I would
that's true
pull your
also.
guide
Guide may
back
be
and make
sitting
sure
there.
that statement is okay.
Pressure is good.
But look at the mid to distal lesion, right? It was ectatic, and right now, whether it was calcium or just a lot of atheroma, you see a nice dissection that you have created. And that, if you see a wire bias,
Yep.
not that, okay. You see that. But that is how the rote extra support wire does. It cuts the vessel. Let me go there back. Do you see?
Yeah.
The inner part of the vessel.
Yep.
Yeah, that's why I know even if we thought we can go 175 bar with this kind of ectatical vessel.
You want to disengage the guide and see if it gets a little better? The STs?
No, I'm not disengaging the guide.
A little bit.
No, everything will come out.
Now that you're putting
Have
the exchange catheter, would you consider giving some nitride through it distally?
Nothing yet. Let's
No, I'm
change
talking when you
the
put
wire.
when you took the
Blood
wire
pressure is
out,
okay.
before you put the next one, yeah.
You're saying distally, can you give vasodilator?
Through the
Right
But,
now, get
the SC depression
wire
is on
there.
the yellow, which is lead 1, right? It's not lead 2 and 3. So why do you have SC depression on lead 1?
Question for an
I think
echocardiographer.
large RPL.
Because the RPL.
wraparound.
Yeah, large RPL. Maybe ask that question to Sophia. Maybe she'll be able to answer it.
I would check the ACT for sure.
No, ACT is very good right now. Remember, we're giving Angiomax. We do only 2 ACTs. Yeah.
Oh, you have Angiomax, so I still check
300.
because, Angiomax...
300. What's the ACT?
Yeah, for sure ACT would be
300
good
they're
with
saying.
Angiomax.
Yeah, STs are coming back.
Pedro, I want to actually see what
3520
you
balloon,
and
right?
other panelists
We only
feel
have a
about
12.
it. I think for large
Open,
vessels
20.
with the moderate to severe calcification, there is an almost perfect synergistic mechanistic basis for rotatripsy. To the extent that it probably could even be considered as almost as a default, you
Give me a...
particularly also in addition if there is a calcific nodule as well, just makes complete sense, that the maximal power of two ablative strategies.
Good comment.
Yeah, I think that's totally correct, though.
Yeah. Love to see the OCT after the
Or just
shock
go
wave.
with IDL.
Yeah, first we have to get the flow back.
Here you go.
That's what she's doing.
Godzilla.
No, yeah, exactly. If there is this kind of situation, EKG changes, flow is not normal, do not think of imaging at this time.
Yeah.
Let's get the flow back. I'm getting the Godzilla and a balloon ready, and then we can consider giving some vasodilators. I'm going to give some vasodilators. I know you wanted it distally. We're giving some nipride, not need to give and nitro. Hemodynamics are there, yes.
Yeah, we're good.
Yeah, pressure is good.
Yeah. And no
Okay, good.
bradycardia,
Ready? Hold
STs are better. Little bit V1 giving us hard time. So you put the fine cross, I'm sorry, which wire you put in, Anu?
No, we put a fine cross, exchange it to rota, not rota, I mean run through. 300 run through.
Okay.
And now we'll take a regular balloon. Give us the wire you have.
Now you put your Godzilla back.
Godzilla is there.
Beautiful.
I think what we'll do is we'll take a balloon, dilate it distally. At that time we'll advance a Godzilla, stent it distally, and then come proximally.
Now, do you want to complete this online and with the time
No,
issues?
it's up to the panelists if they think they want to move on. But from here, I think we should be okay. We should be good, right?
That's what I think. But you're the boss. You want to move with the talks or you want to finish here?
I'd like just to make one
Let
comment.
Srinivas Duveri decide.
Yeah, Ron wants to talk. Go ahead.
No, the slow flow is going to take time to recover, but I think meanwhile you really have to open the vessel, so you're going to have a better flow on the inlet and in the mid, because the larger the vessel, this will help to recover some of the slow flow. So I wouldn't fight too much the slow flow as long as you have good hemodynamics and try to stent what needs to be stented.
This is a crucial comment. When you're dealing with severe lesions, multiple, very obstructive, you may encounter ST elevations, slow flow. You have to relieve the lesion. You have to keep going until there's good lumen, and then you do the rest. That's
Yeah,
a
because
very
if
good
you continue to give all those vasodilator, the blood pressure will fall, and then it's going to be another trouble. So
You just have to be careful not to keep doing no reflows. They get repetitive and it makes it worse and worse because you keep putting debris down. So it's a real balance. But
4045, what do you think?
Well, we don't have flow in the PDA now.
No, it may not. No. We injected very slowly. Godzilla is there. We have damped pressure. Look at the pressure there. So we're quickly going to stent it. Okay, it could be 28, 32. We are going to take a long stent. And
you have
now
that
the pressure
shadow.
is down, so you have to give some pressors.
Go.
Can you guys?
Yeah, we need the neo now.
Yeah, either leave
I
or
think the
Doppler.
PDA has this staining distally.
No. It's all, once I get the Godzilla back, there will be antigrade flow. Everything will get better. I need to stent the distal.
Pedro, I suggest you let her work in peace. We'll go to the talks, and she'll come back to us because this is going to take some time.
Okay. The panel suggests to listen to Dr. Stone now.
Yes, agreed.
And we'll let Dr. Kinney work a little bit, and then we'll come back. Doctors, now.
Greg Stone.
I now invite Dr. Greg Stone, Director of Academic Affairs and Professor at the Icahn School of Medicine at Mount Sinai. Please welcome Dr. Greg Stone.
All right, well, exciting case. We've had a lot of discussion today about the appropriate use of microaxial flow pumps, particularly Impella. So I've modified my talk title a little bit, and I'm going to talk about these devices for high-risk PCI and cardiogenic shock. So those are really the two situations in which we consider Impella use: primary PCI for AMI cardiogenic shock and elective high-risk PCI. So let's start with shock. This is clearly the unmet clinical need, number one in the cath lab, where we've got the highest mortality, most complex patients. And when we consider mechanical circulatory support devices, we've got to consider the fact that each device is, its own, specific scenario. They've got different risks, different benefits, different degrees of hemodynamic support, whether it supports the left ventricle, the right ventricle, whether it gives you oxygenation or not. And again, depending on the bore of device and its mechanism, there are different complications such as hemolysis, vascular bleeding, et cetera. So if we look in cardiogenic shock, we've got several randomized trials. We have the IABB Shock 2 trial, in which there was absolutely no benefit of using an intra-aortic balloon compared to control for reducing mortality in shock, 40% 30-day mortality in both groups. We have several randomized trials of VA ECMO in cardiogenic shock, the most significant of which was the ECLS shock trial, 420 randomized patients, and once again, absolutely no benefit in terms of reducing mortality with routine VA ECMO use, and there were major increase in peripheral vascular complications and bleeding and trends towards increased stroke and systemic embolization. So we do have one positive trial, and as you know, it's the danger shock trial. This was a trial that was done in Europe that took more than 10 years to enroll, a total of 350 patients. And overall, the primary endpoint of all-cause death at 6 months was reduced with Impella CP use compared to control, from 58.5% to 45.8%. So a number needed to treat of 8 patients to save 1 life. This was somewhat of a fragile result. The p-value was only 0.04, but again, all-cause mortality is the most important endpoint, and it seems fairly robust. When the patients were followed for up to 10 years, the curves, if anything, continued to diverge, and the number needed to treat is reduced to 4 patients to save 1 patient, keep 1 patient additionally alive at 10 years. But there were many adverse events with the Impella in this trial. There was a number needed to harm of 6 patients because of an increased risk of moderate and severe bleeding, limb ischemia, renal replacement therapy, sepsis, a trend towards increased stroke, and a substantial incidence of hemolysis as well. There are several other things to note about this trial. Probably one of the reasons it was positive is that they were very selective as to who they enrolled. They were very careful to enroll patients, 1, only with STEMI and AMI cardiogenic shock, and 2, in particular, patients who did not have evidence of advanced hypoxic brain injury. So patients who came in comatose or intubated after a prolonged CPR, et cetera, were excluded from the trial. So they only randomized about 30% of patients. And I think that's very important to apply in your own practices. It's one thing to support the heart and get the patient through the cath lab procedure, but if the patient's not going to wake up, you haven't done them a favor. So what do the guidelines say after all of this data? Well, they recognize, because of the one trial of danger shock with somewhat tenuous results, with a class 2A level of recommendation to use the Impella CP device in STEMI with severe refractory cardiogenic shock to reduce death. There's a class 3 indication for absolutely no benefit for the routine use of intra-aortic balloon pumps and VA ECMO, but it doesn't mean that the selective use of those devices may not occasionally be warranted, depending on the hemodynamics and the specific scenario. So there are several unanswered questions about mechanical circulatory support for AMI cardiogenic shock. One, is it possible people have wanted a second randomized trial of Impella and AMI cardiogenic shock? And the answer is, unfortunately, probably not. Okay, I was the study chair of the Recover 4 trial, which we spent more than 2 years in planning and had just started enrolling it when danger shock came out, and the DSMB stated that there was no longer equipoise and that we likely would not be able to enroll the trial. Can Impella use in AMI shock be made safer? That's really important, and perhaps even more effective. And I think it can be. And we're actually doing a single-arm trial called the OASIS AMI cardiogenic shock trial to look at best practices for insertion and withdrawal that are being tested. In fact, we've got 12 different best practices, and in this large-scale US-based registry, we're looking to see if ultrasound-guided puncture, single access for Impella and PCI, use of pre-close, right heart cath-guided weaning, Impella removal in the cath lab, and other approaches will reduce that complication rate. And then we've got smaller pumps coming out, such as the Impella ECP device, Magenta, and others, which will certainly reduce vascular and bleeding complications, if nothing else. And some of them have even higher cardiac output support. So there are other questions, though. Should we do in AMI cardiogenic shock multi-vessel intervention versus the infarct artery only? The trial that Holger Thiel came out with, culprit shock, suggested that we do harm by doing more than the infarct artery only in patients with AMI shock, but they may have gone too far in doing chronic total occlusions and a lot of other scenarios, and that's a very important question. What about early escalation? When is the Impella CP not enough and you need to escalate, for example, to the Impella 5.5, a surgically implanted device that can support the entire left-sided circulation? What's the timing and effectiveness of right heart support, such as with the Impella RP device or the Protect Duo? When should VA ECMO be used, for example, in combination with Impella, so-called ECPella? What about the adjunctive use of other approaches, for example, supersaturated oxygen, which reduces infarct size in non-shock patients, hasn't really been tested in shock, and is it synergistic with Impella? We actually had started the IsoShock small randomized trial, but it was stopped because of lack of enrollment. What types of studies are required for regulatory approval or indication and guideline expansion for smaller and are more effective microaxial flow pump devices for left heart circulatory support, such as the ECP device? Do you just need, with that device, a smaller type of Impella, a safety and hemodynamic efficacy registry? What about the Impella 5.5, a surgical device for early escalation? Do you need a randomized trial for that? What about other non-Impella microaxial flow pumps? Do you need registries or randomized trials versus the Impella CP? And what about other novel mechanical circulatory support devices, non-axial flow pumps? Do you need randomized trials versus Impella CP? And what about right heart circulatory support? And what about cardiogenic shock not due to acute MI, chronic heart failure? So there's a lot of unknown questions. And probably for us in the United States, one of the biggest questions is how can trials of mechanical circulatory support in AMA shock be made easier? Right now, we have to enroll patients under EFIC because these patients cannot give consent and they often don't come in with a legally authorized representative. We have to go through tremendous hoops to be able to consent patients who cannot give consent. You have to have public hearings, you have to do radio ads, post billboards, etc. It's very, very difficult. That's what we were doing in Recover 4. And this is what it feels like trying to use EFIC in the United States. That's why almost all those shock trials are done in Europe, because they've got a much better regulatory path to enroll patients that can't give consent. Can nothing be done short of passing a new federal law to overcome this? Well, you know, that's what this would look like. All right, now let's shift for the second part to complex and high-risk PCI, or the so-called CHIP case of using mechanical circulatory support. This exists, the CHIP patient, you've seen a bunch of them today, when you've got the overlapping domains of complex patient comorbidities, complex coronary anatomy, and then hemodynamic compromised, either a low LVEF, low blood pressure, high LVDP, etc. And when you have that overlap, then you've got the complex high-risk patient. Should we be using a routine mechanical circulatory support for those patients, or should you have it on standby if the patient develops hemodynamic instability during the procedure? Well, why might hemodynamic support be useful? Well, for elective cases, hemodynamic support may certainly reduce procedural complications and therefore improve early outcomes such as hypotension, ventricular arrhythmias, cardiac arrest during the procedure, etc. But perhaps more subtly, but perhaps more meaningfully, not having to do the case under fire drill situation can enable optimal lesion selection and stent implantation, facilitating, for example, the use of physiologic lesion assessment to know which lesions to go after, intravascular imaging to get optimal stent implants, etc. And that would improve not only early but late outcomes, not only reducing restenosis and stent thrombosis, but also leading to greater improved LV function recovery, which could reduce MACE, heart failure, arrhythmias, hospitalizations, and improve quality of life. And then there are some studies suggesting that increased renal blood flow from these devices may lead to reduced acute kidney injury and long-term renal preservation. So what data do we have to support any of this? Well, we have limited randomized trials for elective MCS use First is the BESIS-1 trial of 301 patients with ejection fractions less than 30% and extensive coronary disease, randomized to a balloon pump versus control, with the goal of just trying to improve procedural outcomes. And overall, the primary endpoint of in-hospital MACE was not significantly improved with balloon pump. If you looked, bleeding tended to be increased, although procedural complications, in particular prolonged hypotension, was decreased with the routine use of a balloon pump. So this was a negative trial. But interestingly, when they followed the patients out to 5 years, the survival curves actually spread. And there was actually a significant reduction in mortality in the patients who got balloon pump support compared to control. Now, this wasn't powered for this endpoint, and there's not really a mechanism as to this, why this might have been, but it is interesting that you note the curve spreading over time and becoming significant. The PROTECT-2 trial took similar type patients and randomized them now to the Impella 2.5 device versus an intra-aortic balloon pump control. And this primary endpoint was at 30 days, and there was no overall difference in a very complex 10-component MACE endpoint between Impella and balloon pump. But they followed the patients only out to 90 days, and interestingly, after 30 days, the curve started to spread, favoring the more potent Impella device. And here you can see intention to treat. The per protocol population actually was significantly different at 90 days. George Dangus readjudicated that complex endpoint to a more contemporary MACE endpoint of death, stroke, MI with a CK, MB, or troponin of greater than 8 times normal, or revascularization. And now you can see that the curves were starting to spread even very early and continue to spread over time. So interestingly, in both studies, as you followed patients longer, the curves favored the more potent hemodynamic support device. So what do the guidelines say? Well, the 2021 guidelines from the ACC, AHA, and SCI basically give a Class 2B, level of evidence B, recommendation to use elective hemodynamic support in some selected cases. So it's not a glowing recommendation, but at least it doesn't contraindicate it. But there's no positive randomized trial yet. And it doesn't make any distinction between balloon pumps or Impella, saying only that Impella leads to more potent hemodynamic support, but there's not enough data to really choose between the two yet. What about the European guidelines, which are usually more up to date? The European guidelines have never mentioned the even concept of using mechanical circulatory support for high-risk non-shock PCI. And it's just not done in Europe. They just don't use elective support. So we now have one trial which has looked at this, which was the CHIP BESIS-3 trial, in which they randomized 300 patients with either unprotected left main intervention, needing severe calcium modification, CTOs with a retrograde approach, and other indices of complex coronary disease with left ventricular ejection fraction less than or equal to 35%, to either the Impella CP device or to standard of care, which in Europe was basically nothing. And they followed the patients up for 12 months. The primary outcome was a hierarchical outcome of death, disabling stroke, spontaneous MI, cardiovascular rehospitalization, or procedural myocardial injury, defined as a relatively very low threshold of a troponin, high sensitivity troponin elevation of only 5 times the upper limits of normal. And there was no significant difference between the two groups. If you take out that last endpoint, which is really a meaningless endpoint, and just look at the first 4, once again, absolutely no difference between the two groups. You can see in the Kaplan-Meier curves, they're overlapping. If you look at secondary outcomes, there was actually some evidence of concern. You could see there was a trend towards an increase in all-cause death, and there was a significant increase in cardiovascular death. Although those deaths did not occur early, they actually occurred late. There was no significant differences in disabling stroke or spontaneous MI. In fact, both of those tended to be reduced. And there was no differences in hospitalization for cardiovascular cause. And you can see most of these events were these meaningless increases in high-sensitivity troponins. So we clearly need a larger trial to give us an answer for this. This was really an underpowered trial. I will say the one good thing about this trial was that there weren't major complications that were seen. There was not a significant increase in bleeding or vascular complications, although there tended to be somewhat increased, but not significantly so. And procedural complications did tend to be reduced by doing complex PCI with Impella, but again, not significantly so. We just really need a bigger trial. So for many years now, we've been running the PROTECT 4 trial. This is over 4 times larger at 1,252 randomized patients, ejection fraction less than 40% with truly complex PCI in patients with really refractory symptoms or heart failure, randomized to the Impella CP device or control either a balloon pump or mechanical circulatory support. We have a long-term, in addition to short-term endpoints, a long-term 3-year outcome, and I'm pleased to say that we randomized all 1,252 patients, and these results will be presented at ACC next year. So I can see Pedro wants me to move on. There are a bunch of unanswered questions for elective high-risk PCI, and hopefully PROTECT 4 is going to answer many of them. Thank you very much.
Okay, we're going to invite now for the controversies, starting with Ron, who is going to tell us that DCB is the way to go. And then we'll have Bill Nicholson to say the opposite.
No.
Okay, Anu,
Tell them to show the live. Huh? No, I know. Can you see me?
Yeah, okay, Sharma said you want to speak after, but you want to do it ahead.
No. I'm showing the final result.
Okay, go ahead.
Can you see me?
Yeah, we see you. Yeah, good point.
No, we showed all this. That we did. Rota we did, right? We did the rota. And I left at the right point. Okay, good. So we had mentioned, so we take the Godzilla to the distal stand. When we did the distal stand, there was, everybody concerned about the flow. But we said, when a situation like this, go back, take care of the distal lesion. Then we took care of the proximal lesion. This is how it looks now. Lot of vasodilators, and look at the final result now.
Excellent. Bravo, Dr. Kinney.
Yeah, but just to say, all women case. All women case trained by me.
Nice.
Women power.
Yeah.
Okay. Now coming to male power here, Dr. Ron Waxman.
I now invite Dr. Ron Waxman, Associate Director of Cardiology at MedStar Washington Hospital and Director of Cardiovascular Research and Advanced Education. Please welcome Dr. Ron Waxman.
Thank you. That all-women case really close to my heart. Kinney was doing the first, I think, in the world, all-women case at CRT in 2018, and it was really remarkable. So I'm glad that today it's not like unusual, but at that time it was really a pioneering. Anyway, let's switch gears. DCB is really something that is coming, and this is a very provocative title. I'll try to defend it. And I must say that first and foremost, these are my disclosures, you need to understand and agree that there are some limitations to drug-eluting stents. We've seen here stenosis, we still see some thrombosis, and we have been seeing that DCB is emerging as potentially alternative for not having another layer of stent when it's come in stent restenosis, or not to have at all a stent when you're treating coronary artery disease. So I think it is something that is coming. You have to accept it because it's changing the entire culture of treating. But I'll try to bring you some data why we can conceive that DCB will replace DES in most of the cases. So first and foremost, DCB is approved now in the US for over 2 years for the treatment of in-stent restenosis, and it's used pretty heavily. And we do have also data on 3 years that does show that it's maintained the efficacy against POBA, not against DES, but against POBA. DCB, as you can see, is disseminating in many, many countries. Now we have it also in North America. And if you look in Europe, what are the indications to DCB? It's almost everything: small vessels, long lesions, bifurcation, CTO. We can go on and on and on. But DCB, from indication perspective in Europe, this technology has been there for over 2 decades, has been disseminating to almost all the indications. So in-stent restenosis, we talked about it. We have agent 3 years data. Solution ISR probably will get approval within few weeks, if not few days, in the US with sirolimus eluting balloon. Medic Touch and Prevail are on the way. So we would have, within a year or 2 years, almost 4 systems just in the US for in-stent restenosis. And I think people are going to use more and more of this device for the treatment of ISR. This is the Asian trial, the original study design. Again, I criticized why it was against balloon angioplasty and not against DCB. The reason was that DES was not approved at that time also for in-stent restenosis, although it was used. And this is a 3 years data. We're showing that over 3 years, you still see events, but agent DCB is better than balloon angioplasty. So balloon angioplasty is not the way to treat it. Solution ISR was a similar study, but this time it was not the control group of balloon, it was the standard of care. What was the standard of care? DES in 80% and 20% POBA. That standard of care through the duration of the study has been changed. It was set as a non-inferiority study. There was a large delta. But overall, it met the non-inferiority. And based on that, it will get approved in the US. There is no doubt in my mind. And as I said, it's a matter of few days. And one of the questions that asks everybody is there is a difference between paclitaxel to solution, which is sirolimus. We actually looked at 2 treatment groups from agent and from solution. And when we tried to plot one versus the other, we saw almost similarity. So at this point, I cannot say that there is an advantage of one drug versus the other for in-stent restenosis. But the biggest issue is the de novo lesions, because many of you would argue, stents are doing so great, why should we de novo lesions? So we do have some data, the solution de novo 3,323 patients. We have also data on complex lesions, 421 patients. We have cage-free, 2,272, and all these are randomized studies. We have small vessels with over 758 patients, bifurcation, 825 patients, CTO, multiple studies, and we have expansion of labeling also to ACS and STEMI and SVG and calcified lesions. So let's talk about the solution de novo. This was basically a strategy trial to look on a patient whether he should get a DEB or DES. And it was a very large study. It was conducted in Europe. It was investigator-sponsored study. And the primary core endpoint was non-inferiority for TVF at 1 year. There were also secondary co-primary endpoint. But when you look at the overall cumulative incidence of TVF, it seems to be within the ballpark. Look at the numbers, 4.4% DES strategy, and the solution DEB 5.3%. So again, the numbers are very low event rate, but what is the advantage? The advantage is that you don't end with a stent with solution de novo. Is that gonna hold over years? We'll have to wait 4 or 5 years to see if you have a flat line or you continue to see events like DES. But if you won't see events like DES coming in a rate of 1% per year, over time, DEB would be probably surpass in terms of efficacy of the DES. So that's something that we are definitely paying attention. But people says, well, this was, although all comers, these are simple lesions, well, they're not so simple. This is a sub-study that was presented at EuroPCR with Dr. Simon Eckshell, who was one of the principals of the study. And he was actually looked just on the complex lesions, which mean 3-vessel disease, lesions. There were more than 1 or 2 drug-eluting stents, bifurcation, chronic total occlusion, all those, and long lesions, more than 60. So that's basically what seems to be a complex lesion cohort. He found out 421 in the solution and 414 in the DES. And if you look overall, these were from the lesions that were treated per patient, there were about 2. Patient had multi-vessel disease. Bifurcation was nearly 40%, and moderate or severe calcified lesions was over 27%. So you cannot argue that this is by the angiographic characteristic complex lesions. And when you look at the overall balloons that were used, you can see in multiple balloons. Imaging was used only in 20 to 26% of the lesions. But here's the result. If you look at the complexity criteria, for longer lesions, the solution was 71.7% versus 60.4%. And when you have at least 3 devices, and this is just for the complexity 64 versus 50, bifurcation 35 versus 44. So clearly you do have testing of the solution in complex lesion. If you look at all of them together, and you're looking solution DEB strategy versus DES strategy, for this complex lesion at 1 year, the TEF is lower in the DEB versus the DES. So that makes you an argument. You may have to work more in terms of vessel preparation. It may not fit all of them, maybe only 80%, but at the end of the day, this is fitting a very well complex lesions. And this is some other results. Cardiac death is lower, target vessel myocardial infarction is 2.6 versus 7.5%, which probably drove the results. And clinical driven TLR is almost the same. So you get the same, less complication, and without a stent. So why not? And this is some secondary endpoints that go on the same trending, late lesion occlusion 0 versus 0.7 in the stent, which is not high. But if you can save that 0.7, that's a good thing. Now, cage-free was looking also in China on DCB versus DES. And what they found out that if you look at small vessel, it does work. If you look at large vessel, it doesn't work. And the question is, why is that? We don't know yet. There are more studies that are coming on large vessels. And you can see here the difference between the small vessel, 3.0, there's no difference. Large vessels, DES was still better. So that's an open question that needs still to be investigated. Small vessel, we have ample data to show that DCB is the way to go from the Bello and from Piccoletto and from other studies that were done in Switzerland. This seems to be pretty convincing. And there are a few studies that are going on right now in the US, and I will submit to you that they will be non-inferior to stents. So who wants to put stents in small vessel? No one. And that's why in Europe it's becoming more and more the practice of the interventionalist. And you can see, and even in the US, 30% of the agent is using an off-label, and the majority of them are in small vessels and in bifurcation. This is all the study that in small vessels, in bifurcation, you see the same thing. Even in the cage-free, there is an advantage or non-inferiority. And CTO, I know Dr. Nicholson is going to debate with me, but this is all the DCB in CTO also looks pretty good. So it's being used. It's being used in calcified lesions. There is data to support it. Not all of this is randomized trial, but it will come. So at the end of the day, I think you have to be open-minded and you have to look in the future. Patient doesn't want stents. Physicians, it's easier for them, but I submit to you that over time there will be a shift to leave nothing behind, which would be including DCB versus DES. Stay tuned.
Excellent. That was an amazing talk, and we're going to hear Bill now, who's going to discuss, Dr. Nicholson, that this is hype.
I now invite Dr. William Nicholson, Professor of Medicine at Emory University School of Medicine and Director of Interventional Cardiology at Emory Healthcare. Please welcome Dr. William Nicholson.
Thank you. Appreciate you having me. This is near and dear to my heart. So we just ran a big conference, and Dr. Weissman was kind enough to come. And I'm actually a huge proponent of this. We've done 300 de novo DCB cases in the last 8 months, so we're really into this. But I'm here to bash it now, so we'll walk through this. So, really want to talk about why are we doing this. You know, if you really look at the data, you know, we've got 20 plus years of DES data out there. Annual event rates are extremely slow. All this are extremely small. All this theoretical, unproven. No inflammation, return your vascular motor tone to normal. It's all nice to talk about, but it's all theoretical. None of it's been shown. And if you look at what DES has had trouble with through the years, we've solved that on our own over the years. So the first generation, second generation, and the modern DESs, I mean, the strut thicknesses have gone way down. The biodegradable polymers have taken away the long-term inflammatory issues. DAPT is not an issue. People talk about high bleeding risk and shorter DAPT. I mean, we've got tons of data out there that says 1 month of DAPT, and that's all we do at Emory routinely on all DESs that aren't ACS. Late thrombosis is almost non-existent anymore. You're down to about 0.5%, and that's 5 years that you have a 5 to 8% restenosis rate. So it's really making an argument, is there really a point to doing this? What's wrong with the stents? They're awfully darn good right now. Dr. Waxman talked a little bit about REC cage-free, but this is a large randomized trial. You're talking about close to 2,300 patients. that were randomized. They're simple lesions, so not complex cases. Randomized, you got hard data outcomes that shows that clearly the DCB loses to DES. It did not meet non-inferiority, even the lowest bar you could set, 2-time relative risk. If you looked at shorter lesions in that, even when you get over 20 millimeters, you almost, again, had a 2.5-time higher rate of issues with DCBs than you had with DES. So DES works. Short lesions, big vessels, de novo vessels, it's very, very good. Solution de novo, as Dr. Weissman alluded to, is probably the best case argument for this, but it's still non-inferiority. It's numerically, it was worse. They did do the subgroup analysis that he talked about, but that was not what the trial was designed to look at, so it's interesting as far as hypothesis generating, but that was not the point of the trial. And 1-year follow-up, there's no longer what we're seeing with DES competing with DCB. And interestingly, 20% of these cases, they crossed over to stenting in the case anyway if they were randomized to DCB because they didn't get optimal outcomes. So you're already putting stents in 20% of them regardless. So you got to talk about what's really happening here. This is, if you follow the money, there's been a 67% drop in DES reimbursements over the last 15 years. That means that you had a market that was at its peak around $6 to $8 billion. Now you have a DCB coming in. The best we're showing is non-inferior. We're going to charge 22 times the price for it, charge you $6,000 for it. We've got a $1 to $2 billion market share from doing that. That's supposed to grow every 4 years to double. So in 8 years, they'll be back up to their $8 billion market that they lost. And so I think you always have to wonder about whenever something loses its revenue value and something new shows up on the market, I think you have to be wary of what the etiology and the motivation is behind that. So, like I said, for short-term DAP, that is over in my mind. 1 month of DAP for standard PCI with DES is pretty much standard for us. I'm not sure there's any role for arguing with that. The small vessel argument, Dr. Waxman said that's kind of over and done with right now, but each of these trials, you have to realize, are very fraught with some real questions. Basket small, that was done up against the DES, but it was using a taxis for 30% of those cases. I mean, that's a stent that nobody's implanted in decades, and it explains the higher rates with the DES group. And then Picoletto was, again, the same type of thing, but that was looking at late lumen loss, which you're already biased to win with in a DCB strategy versus DES. And the outcomes were worse for the DCB crowd as well. And then if you look at the Andromeda trial, which was basically a combination of all those trials, it's again driven by the use of taxis as the DES that they were going up against. And so small vessels there, but it's questionable. And it's interesting too with DCBs, we kind of get trapped into going into places we shouldn't be going. So we're going downstream and we're doing a lot of small vessel downstream disease. We're doing side branch bifurcations that we would have left alone the vast majority of the time. I find when I'm doing CTOs that you're tempted to go work on the distal RCA or maybe balloon the PDA with a DCB. You don't feel like you're getting the same penalty of putting a DES in. So we do a lot of work in areas that we shouldn't be doing. And so it brings back the overall riding message is when you're going to talk about a $6,000 device that's non-inferior to a territory that we probably shouldn't be working in the first place. And it's very hard for us to show that we do anything really productive as far as survival or other outcomes from all the trials that we've been bashed with through the years from an interventional versus a conservative therapy standpoint. And so I really would argue that the comparator, if you're going to talk about DCBs in these territories, ought to be against medical therapy. And it shouldn't be against DES, where you have another inferior treatment that you're comparing yourself to, saying, am I as bad as the bad treatment that's out there? And, this was talked about earlier with Repatha and all the data that we're seeing with this. I mean, you have incredibly good results and incredibly impressive numbers as far as what the reductions that you have in these situations with optimal medical therapy. And I think it allows us to tread into territories that we shouldn't be going into and that we're tempted to go into. And we've had this discussion back at Emory a number of times that we do find ourselves working into vessels and small vessels that we normally would have left alone. The last thing I'd leave you with is, this is not real world data. This is clinical data that you're looking at, and these are all in trials. These are thoughtful operators that put together the trial design that they were going to use. We in the U.S., this does not translate to the American cath lab. And so when I think you look at and I know we're talking about imaging, apparently doesn't matter anymore, but all day today, but imaging still does drive a lot of this. And the fact that imaging and physiology are not going to routinely be used, you're going to get the same thing that happened with Absorb. You're going to have shoddy work being done where vessel sizing is not going to be appropriate, preparation is not going to be appropriate, and you're not going to do the appropriate things at the end to analyze the result. And I challenge you to say that this is what you're going to end up with. I mean, this is a patient that's 45 years old, comes in with chest pain. The operator at the hospital balloons this with a 2.0 balloon, then a 2.5 balloon, says it looks good, no physiology, no imaging, sends them to the floor. 6 hours later, this is your LAD, occluded, gets 80 millimeters of a 2.25 stent, if you can believe that. And this guy is now 45 years old, doomed to this, basically metal jacket of his LAD because somebody did a shoddy job up front. You've got the same thing here where you have an osteal ramus branch, not an issue to treat. They balloon it with a 3.0 balloon. They look at it in this, not 2 views, no physiology, no imaging, looks great. If you talk about, does he have TIMI 3 flow, less than 30% residual stenosis, no type 3 dissection or type C dissection, all the criteria that are in all those trials, looks great, goes to the floor, comes back, there you go, having a heart attack again, ends up getting a stent put in again. So this is the kind of real world work that I think you're going to see. I mean, the numbers are incredibly impressive of how small of a rate of acute thrombosis there is in all the trials and Dr. Waxman, to his expertise and credit, has been the main person involved with all those trials. The numbers are low, but this is reality, and this is what you're going to see. And I think there's a lot of question that comes with this. I'm not sure why DESs are so bad with the data that we have out there. The data that favors small vessel and large vessel for DCB right now is very weak, and it's all non-inferior. And so you're paying $6,000 to have a device that's non-inferior to a device that's borderline usable as it is. And this is the real question. The TPT for this goes away in December 31st, 2027. So every time we use one of these DCBs and we submit it to CMS and they send us a check for $6,000, and I don't have to hear my administrator yell at me for using expensive equipment, this goes away in about 1.5 years. And so then you're going to be stuck with the bill for the $6,000, and you're going to have to answer that. Are we really going to use a non-inferior device to treat something when we're going to pay $6,000 for it? So, thank you.
Okay, thank you so much. That's excellent. We're not gonna have any questions now, no controversies, and we're gonna let AI now, Sophia, introduce.
I now invite Dr. Annapurna Kini, also known as AK, Director of the Mount Sinai Cardiac Catheterization Lab, Zena and Michael A. Weiner Professor of Medicine, Program Director of the Interventional Cardiology Fellowship, Director of Structural Heart Intervention, and a global leader in interventional cardiology and technology as the founder of Kini Think Tank. Please welcome Dr. Annapurna Kini.
Can you see me?
Yes, we do.
Can you hear me?
Very good.
Okay. Time starts now. So my talk is novelties in artificial intelligence in interventional cardiology, especially in the cath lab. So I know there have been a lot of talks and also discussion, and you have seen Sophia all through today. So let's go. What we have done is a yellow trial, which actually started way back in 2000, about 15 years ago. What we have made, and our goal is to get personalized medicine. So in yellow one, we used high-dose statin and randomized low-dose statin, high-dose statin, and what we found was within 6 to 8 weeks, though IVUS did not show any changes, there was a change in the in the lipid arc, a change in the LCBI of this patient. Now the question is, yes, you see a change in the plaque. How does this change happen? How exactly plaque changes? We know body is very complex. Understanding plaque morphology is also very complex. So before that, we need to do some more digging into understand the biochemistry. And that is how cholesterol exactly works. It's very complex. This is from our first year medical school biochemistry, how the fat gets into the body, extrahepatic tissue into the liver, and there's this kind of a homeostasis that's maintained to maintain cholesterol in the body. The most important thing is extrahepatic tissue. We are concentrating in the vessel wall. What happens to the extra lipid that's there. That's what is called as the reverse cholesterol transfer happens and the lipid goes back into the liver. So that is the key. So that's what we wanted to study. So this is exactly what the vessel wall looks like. You have intima, and this is a smooth muscle cell. This is the normal vessel wall in the corner. If everything is great, that's how the vessel wall should look. But everything is not great because of the kind of food that we eat. So when you have extra fat, LDL gets in, macrophage, which is M1, gets activated, takes the lipid, and we know all of this. So what happens? The extra fat has to go out. The HDL and the good APO, which is the ApoA1, takes it back to the liver. So cholesterol efflux is the one that removes the cholesterol from the plaque, and that is what we wanted to study in yellow too. How does that happen? It all depends because you have a particular gene expression. So we also did what is called as blood mononuclear cell gene expression. So we took only rosuvastatin, followed this patient between 8 to 12 weeks. At this time, we used OCT to understand how this fibrous cap changes, and we did a cholesterol efflux and PBMC microarray. As we see, fibrous cap increased with the improvement in your cholesterol efflux and decrease in CRP. We know they both go hand in hand, and important genes associated is the genes associated with cholesterol metabolism and the receptors that were required to transport the cholesterol using HDL. So this is exactly what the liver is. This is how the statin works here. And these are all the enzymes that we found. They were upregulated, and ABCA1, that was also helpful. So going back, now we understood this is how it works, but we still found there were patients who were non-responders on statin. They still had some yellow plaque. So question comes by then, we had PCSK9, do we have to decrease the lipid further down? And we did yellow 3 on patients with statin who had lipid. We wanted to make sure the fibrous cap was thin. Evolocumab was given for 26 weeks. When they came back, we did all the imaging. But right now, we did a change. We used the bulk RNA sequencing to understand exactly what happens in these patients. As you see, with evolocumab, the LDL definitely significantly reduced from baseline to follow-up, and no change in CRP in these patients. And the primary endpoint was change in fibrous cap thickness, significant change in the fibrous cap thickness from 60 micron to 90 micron, and this is what happens. The lipid at the baseline decreased when they came back. Then we saw who are the patient who responded based on the imaging. At least 20% or 80% of the patient responded, where we saw there was a change in their fibrous cap, and about, 76% a change in their lipid. So what we call, and this is a melting butter sign, the butter that's in the body changes, means it disappears. There's a melting butter sign. And there's a group, they were non-responders. So if you see here, this is what we do when the patients come to the office. We check their cholesterol. So 78, if the baseline was 78 LDL, they come to see us. What do we say? Hey, you're doing great, no worries. But look what happens in their body. No change in their fibrous cap, no change in their LCBI. There are non-responders. Who are these non-responders? Only the gene expression could tell us that these are who are the non-responders. So we found multiple genes, but then when you introduce into the so-called ingenuity pathway, then we came across which are the pathway that worked in the patients who had changes. So there was upregulation of what is called as a mitochondrial translation and protein synthesis. Essentially, you need a healthy mitochondria to make these changes, to decrease the inflammation and make changes with your plaque. And there was down regulation of so-called immune regulatory interaction, which is down regulation of your inflammation. So this is responders, improved mitochondrial function, improved cell response, and for non-responders there was inflammation continued. The bottom line is very simple. The core is mitochondria. Mitochondria, 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 responsible for cholesterol efflux, anti-inflammation, and for the apoptosis. So what we are promoting is for your butter to melt, you need a healthy mitochondria. The question is, how can you have a healthy mitochondria? There's no drug at this time. Can we do something? Exercise. And This came out in 2024. When you do exercise, your mitochondria definitely increases, so start exercising. Then diet. And this has been repeatedly shown. There are various diets, but of course the top of the line is so-called vegetarian or Mediterranean diet that helps. So even in the guidelines right now, both in European guidelines and American guidelines, it says that you need from 150 to 300 minutes of so-called moderate exercises. And what we are planning to do is that you could, in the past, to do a drug discovery used to take 15-20 years. We are using our AI tools. We're likely to see if we can have a drug discovery towards mitochondria. This is the JAK imaging paper that just came out with the central figure. So going from yellow 3, what we learned, that we did a bulk RNA. Now we want to understand, can we do a single cell RNA sequencing and have a multi-omic approach, which is to understand proteomics and metabolomics, so that we can come up with a biomarker who are responders and who are not responders. When they come to see us in the office, we can say so. So yellow 4 will include a randomization of standard of care, PCSK9, but more important is understanding transcriptomic, metabolomic, proteomics, and mitochondrial function. Healthy mitochondria, that's the goal. Yellow 1 also used the so-called AI understanding is, can we use AI from all the imaging that we did? So radial wall strain, we all know what is radial wall strain. That radial wall strain has an association. Higher the radial wall strain, there is better FFR, then plaque burden changes and risk of the target vessel failure. So we used this so-called AI to understand, and angio-based FFR and radial wall strength before and after maximum lipid lowering therapy at 6 months. Definitely we see a change. It is accepted for publication in atherosclerosis. So we can do the so-called very granular measurements using AI right now in using this software. So how we plan? We plan to change atherosclerosis regression is imaging. I know intravascular, we will be adding CT scan, do your blood test, you have your AI model to understand where this person belongs, and you will have biomarker. The goal is personalized treatment for CAD. Use your AI. So multiple publications of the JAK, of the yellow in various articles that you have seen. Also we have a website that you can go there. Going to the next step is education. You have seen the education that we do. We started our CCC live cases way back July 21st, 2009. Since then, we have done 204 complex coronary cases, and you can see we have moved on to every other part of the cath lab, structural, peripheral, imaging, coronary physiology. And this is what we are doing, is that using AI in this live cases that we are doing. AI generated case summary, there is a chatbot interaction between the so-called AI agent who will try to explain what is happening at a given moment. And if you are watching an archived case, you can go to that video, press there, and they will take you back to what the description was. And you can have a personalized conversation with this AI agent, and we are going to show you in our next 2 live cases, which has been incorporated and done by MedInbox. So AI is entering the cath lab real time. So exactly what did MedInbox do? They have introduced what is called as an AI agent. And this AI agent is with us, watching the person who's doing the procedure and listening to the commentary. And what has been happened, this AI agent has been trained in all the literature. I don't know if they have listened to Dr. Samin Sharma's top 10 for the last 20 years. So Sophia may actually collapse listening to the top 10, but either way, the goal is we have to make sure they understand, they have some literature knowledge and keep asking the questions. So we are going to test this AI agent in our next 2 live cases. So this is the QR code. Please go ahead, download the QR code and have a discussion with this AI agent, and please give us your opinion. Did you like it or no? These are all our apps. And this should be downloaded. Everything that we do for education is free right now. So the newest app that came out this year is a hemodynamic app. So if you see here, all the live cases, all the apps, all the lectures that we have given, If you take a full-time employee, it will take more than 3 months. So the AI agent is going to understand very easy for you to ask questions, especially if you need to understand there's a complex calcified lesion, how would Mount Sinai approach it? Ask the question to that AI agent and it will give you an answer. Procedural guidance is the next, and we have done this using some of the engineers that once you're doing image acquisition, this is quantitative analysis immediately done. We are the first one to report the quantitative analysis for bifurcation, and that automatic report is happening, and we are using this right now in the cath lab. So the goal is we already know there are algorithms for bifurcation, so step by step PCI guidance can be used, and that is the next step we are going to work on. Care coordination, which I have already presented multiple times, that we have our mobile communication system that is using our various sister hospitals called the STEMI app, multiple publication. What we are proud to say is May 26, 2026, this particular communication app got a patent, and thanks to our dear friend Samir Mehta who helped us to get this patent. So we are very proud, and now what are we going to do? Use AI into this app. AI summaries, AI chart review, AI agent Sophia will be the one that is monitoring everything in the case, escalate it to whoever is necessary. If the patient goes into cardiac shock, connect various people, and that's the future. Patient engagement, everyone has met Sophia.
I'm Sophia, a virtual assistant specifically designed to assist patients like you with their cardiac care at Mount Sinai Hospital.
She's so beautiful. When the patients are coming to the cath lab, they are looking for Sophia. So I have to, watch her, Sophia. So that's what's happening. More than 5,000 unique daily. What she's been calling patients. If you see the number of minutes she's spoken, and hundreds and hours of nurses' time. The reason why we created is we want the nurses come back to us and do bedside clinical work, not do these mundane phone calls and do this kind of logistical work. Look at Sophia, how fast she is, running all over the place, presenting all our abstracts, and also we presented during the VF 2025, and guess what? That was the highest viewed lecture. The lecture that I gave on Sophia. So she has been to CRT, ACC, and she's ready to go to Australia this year. And that's where we are. So what we also did was, we did not stop there. We wanted to understand how can we improve her. So if you see how patients are responding to her, majority of them are neutral and positive. This is called sentiment when the patient is talking to the AI. Negative is only 3.6%. Essentially, even the patients are ready to adopt AI. So AI we are right there. And future of Sophia will be that Epic integration and subsequently used in every area of the cath lab and every other cath lab of Mount Sinai system. So this is the future. What is the vision and how AI can help us in the cath lab? So patient could be stable, AI guided FFR because of the CT scan, or unstable, we have the AI STEMI app bringing the patient. If it is stable, pre-procedure Sophia is going to make the phone call. Or if you're in the office, you have AI scribe that is helping the patients. And then when they're in the lab, we already have AI-assisted imaging, AI-assisted angiogram, reports can be done. What we are working on is when they come, there will be Sophia avatar in the hospital who can help us so that the nurse practitioner can do other work, we use them. Within the lab, there are procedure guided by the apps. And like I mentioned, based on the yellow trial, we are going to use AI to find some kind of a biomarker that will tell us who are responders, who are not responders, so we can take care of our patient. And post-discharge, you know what we are going to do? There will be a personalized agent. Sophia will be making phone call to say, hey, how are you doing and what you're doing. What we are trying to say is AI is here, let us embrace in every form and help them to assist us so that we are able to do our work faster and give best care to our patients. Thank you for your attention. And this is the kidney think tank, who is our new person that joined the kidney think tank. That is Samin Sharma right there. We inducted him this morning. So, you know, what is the thing about this group is that we meet every weekend, 2 to 3 hours. You know, the think tank is thinking, what are we going to do for the future? So we hope Samin Sharma will join our think tank meeting.
Fantastic, Dr. Kinney. Couldn't be better. Beautiful presentation. We're going to stimulate everybody to go for this break and visit the exhibits. This couldn't be happening without them. See you all at 4:05. Dr. Devuri, Jason Freeman, Parasuram Krishnamurti, Samir Mehta, Bill Nicholson, and Ron Waxman. And let's go ahead.
After the live cases.
You're staying till the end, I will.
I'm not staying till 6 o'clock.
So, can we transfer to the cath lab now?
Exactly at 5.
Very good. Okay, Dr. Sharma, we see you.
And the new inductee for the KTT, and I saw that pin, which I got this morning, and if they can focus it, KTT pin, right there. Now it's on my cap.
Wow, it says that
Can you
looks
see it?
fantastic. Yeah.
Shining.
Shining, good. Okay, let's go back to our presentation, put the lights down. And this is a case number 8. So 7 will be a little later. The case number 8, we are ready now to show that, if we can show the slide, please. Yeah, this is the patient. You see a 64-year-old. Patient has chest pain, dyspnea, and has positive ETT, and has an old PCI. Risk factors are shown there. All looks good, good medical therapy, and patient has a cath done on May 12. I had a left main and 3 vessel. Basically, again, we go through the regular process, high syntax score. Our patient again declined after the discussion. So we did the RCA PCI, and that time we did the orbital atherectomy and 4 DES, and the patient did good. Now it's here for the left main evaluation, along with additional disease of the LAD, proximal and distal. We thought this is the type of case which we are waiting in terms of the trial, that you have an entire diffuse disease vessel and calcific, many of them, that you put a stent proximally after atherectomy, orbital or rotational, and distal vessel. After atherectomy, you just do a PTCA, looks good, then just do the DCB. And let's see how far we can get into this particular case with that concept. Now, go the next slide. We want to make sure that this, again, next, the appropriate discussion after the heart team. And this is where we are now. And let's show the angiogram to show basically, this is a patient actually first had the right coronary, and you see good LV function, and the stents are all throughout, from proximal RCA to mid RCA, distal going into the PDA. That looks good. So then we went to the left side, and we'll take the vote again. Is there an ostial left main disease? We know distal left main is not there. There is a distal circumflex disease. This is the 3 vessel. You see the LPL, and more importantly, very calcific. You see the calcium proximally in the LAD. And the second view is all the way. Look at the calcium goes all the way down into the diffusely diseased LAD. So
Okay,
this is where the case here, which we are trying. Yeah.
Very important.
Okay, before we
have
start,
now the
no,
QR.
Pedro, 1 minute.
Yeah, I was going to
Yeah,
announce.
you have a QR code.
Yeah.
Please download the QR code, and that is that you will have to just, I think, put your name, email address, something, and the AI agent will come. Means it is personal. So everybody download and start asking questions regarding this case and the next case that I'm going to do.
Good, beautiful.
Okay, 2 cases only that we are testing with the AI agent.
Okay.
So feel free, enjoy with Sophia.
And now this is you see the orbital atherectomy wire has been sent, and now we have the 1.25 bar, because we had done 6 rota, 7th we thought is a good case for orbital, straightforward. We try to avoid in an angulated vessel, orbital. In ostial lesion, we try to avoid and use 80,000 RPM. Very rarely we'll go to the 120,000 RPM, which a lot of people do. Now wire has gone very further down. Right? Oh, that's good. Okay. So we are gradually, these are all over the wire system. So it's not a monorail, and we are up there. You see that? You can't even see. Look at the calcium in the whole vessel. So this is where we are. And of course, you can see on the top that we put it down. And this is 80,000 light, and this is a 120. And there is another system of the glide assist, which help you just like the Dynaglide, going forward or backward, which will help it, and we'll show you that function. So this is the same 1.25, only one, they call it a crown. And we are ready to start. And this basically, the advantage of this is that it does ablation both because of the crown is eccentric and of the top going forward and going backward. So it is a 25-second run. So this one you can go continuous compared to packing motion we do with a rotational atherectomy. Here you go continuous and it makes the noise at 25 seconds. So make sure you have done enough. You have the time that you are going backward and it's a, yeah, see that noise? So 1 millimeter per second. Slowly movement, go forward and backward, and we'll try to go as much as possible, as down as possible in this particular case, because there is a lot of disease downstream. Now, even if you cross, what you do is you go at least 3 or 5 times, because you will be ablating or sending the plaque into different direction because of the orbital mechanism, which not only horizontal, it's also vertical.
The slower you go, the better you are. I mean, that's a very nice demonstration.
Yes. Yeah. Now, orbital numbers, as you know, after the IVL, both techniques have gone down. Rota used to be about 4%, has become 2.1%. Orbital used to be 2.5%, became 1% now, as the latest data from the NCDR. And IVL now is used in 8% of our coronary intervention. Many of them native vessel, combination with atherectomy, and with the ISR cases. So this is where we are now. I'm going to go because you cannot see in this, and you see here. And you worry about this band. See that? I can tell you I'm a little concerned with this orbital, but I think it's going straight. I will be very much worried about rota will not be any concern. And we know that Eclipse trial, compared to any of the rota trial, Prepare Calcium, Rotexus, there was no higher perforation, but there was a higher perforation in the Eclipse trial against balloon angioplasty using IVL. And here we want to do some plaque because you don't want to put up more stent as possible. Distal we want to do it definitely. There's a DCB.
In the polishing, you're doing a little bit faster movements, huh, it says?
Yeah, yeah, just putting back and so, yes. So whole idea is I think we do one more. We are not completely covered it, but right, that area, if you see, the real where the wire is, of course the burr should not come into, or they call it crown, should not come into touch of that area, but see at that level, further down, there is no calcium. See, calcium stops around 3 o'clock position. So that's where we are done. I'll do one more. This is about 2 or 3. We are done. Them, even if you cross. Get ready to run through wire. 25 seconds. Now, Amit will show that the glide assist function, which helps just like we take in the Dynaglide for the rotational atherectomy. Tell us what you need to do.
Yeah, so you just press this one a little longer and you'll notice it will start blinking. That's the one, glide assist is activated.
But no, it's not there. You have to press more.
No, it's activated. Now, this is the glide assist is active.
Okay.
And then we can defeat the brake and take out the device.
Dr. Sharma, are you giving any cocktail with this, or like with the rota? Or
yeah,
no
so
cocktail?
actually this is, compared to the rotational atherectomy where we have the nitroglycerin, verapamil and heparin and put a rotaglide. In this one, actually we nothing. We did try putting in the past verapamil and so, but it really caused a lot of bradycardia and hypotension. So we no cocktail in the orbital atherectomy cases. Now, because of that, you say, you're not using, why are we using in the rota? Believe me, about 3-4 years ago, actually 5-6 years ago, we did the first case, of course, in 2014. Then we stopped giving the cocktail in the rotational atherectomy also, but it was a trouble. You need the cocktail in the rotational atherectomy, definitely not here. But slow flow, as per trial in the Eclipse, they were higher. We always taught everybody, you don't worry about slow flow with the orbital, but the randomized trial showed no. slow flow is also higher in the orbital atherectomy group compared to balloon angioplasty. But I think overall, my feeling is both devices are good. Somehow, maybe our lab, that we do about 10 orbital and 70 rotational atherectomy every month. Maybe because of that, although we have good experience, I mean, it's overall we still have done over about the 1500 orbital atherectomy compared to rotational, which we have done like 20 plus thousand. The results, lot of my colleagues, and of course we had to teach the fellow, which is the biggest interventional fellowship program. Many of my colleagues who help me otherwise, when I say I'm doing the orbital, they run away. We have to pace them. We have to send them the bottle of champagne to call, where everybody is a little concerned, the lab-wise, but we still do because we have to teach our fellows. But this is kind of a straight case where I'll not have any agitation of using the orbital atherectomy. Yes, angulated one will create more trouble, more perforation. We actually found the same what they had in the Eclipse trial, that more perforation and dissection, except that we had no slow flow increase while they had a more slow flow in the Eclipse trial. Okay, so this is where we are doing now. And our game ultimately would be maybe 3/30 agent distally.
Now it says, if you don't see that the balloon is perfectly expanded, would you consider IVL?
Cutting balloon. No, I'll go the cutting balloon first. Since we have done the atherectomy, so I think let's save some money. And because you are going to use a DCB also, and that is what learned from the shortcut trial, that once you did atherectomy, that your balloon, cutting balloon will be good enough if that's the area negative. But yes, so the key is you can use a 2 DCB, but only will be paid for 1. So with the new code started this January, you have a DCB in 2 vessels, then you'll be reimbursed. But if we do 2 DCB in the same vessel, you will be reimbursed only for 1. So that's a little caveat which we need to be careful using more than 1 DCB in cases. Go up here. And what I'm going to do, that this case we are going to do let's say angiogram, and then question is, should we do the imaging to see that have we attained enough lumen? Secondly, is anything in the ostial left main? So this is one. Now, if you do not attain the left lumen, you go with the 120,000 RPM compared to 80. I would say my goal will be the same, that second increase speed. And so what you have to say that this is same, the IVL will do a better job with the lower perforation than anything else which you want to do in this particular case. You will nitro, and we are going with the imaging, and then we'll do the angiogram. Let's remain little secret that what we have. Okay, now we are going to do IVUS. The left main I think will be okay because we have 6 French. We are engaged the catheter. There is no dampening. You see the hemodynamics. And Kiski, you have the microphone, right?
Yes, I have it. Thank you.
You have it. Good. Okay. So we now going with our Boston Scientific. That is what we have been using. I know they want to do some OCTs. I don't know whether they did any OCT case. If not, we'll do some OCT. Otherwise, OCT team will get angry. We start doing a strike outside. We don't want that. Okay, let's go. Okay.
Yeah, so
All right, let's start.
Please make sure the guide is engaged, disengaged to see the osteo left main.
That's later, but I see. Okay. Yeah, guide is out.
Okay, check the image.
Yeah.
Yeah, okay, start fullback. Here is some fibrous plug. Yeah, some calcium here.
Yeah, it's not such a small vessel anymore.
Yeah, I know.
Yeah,
wow.
Some accent here, but
the point of DCB here is important because you don't want to put 48 millimeter stent if you don't need to.
And not only that, in this particular case, there are surgical options. If patient restenosis can go for Lima. I mean, there is no contraindication. But if we stent it all the way, then Lima choice will be jeopardized.
Yeah, you can take
okay,
it out.
tell us, Kiski, what we are seeing now.
So this is the level of the aorta. Now I can go a little inside.
Ostial looks good, right?
Yeah, this is the ostial left main.
Okay, beautiful.
Yeah, and the
what about the
like
distal left main and rest of the LAD?
Sure.
Get a 3
yeah, ostial left main 9.5 with block volume 56%. We can do for here. This is the mid of the left main. Now I see the initial bifurcation. So through the left main, its area is like 110.
Beautiful.
Yeah.
So we don't have to touch the left main.
I don't think so.
So in the current report, which we called 50, 60 left main last time, we are going to make it less than 30.
Yeah.
Acute regression happened.
Dr. Sharma, so this is a flux to mid LED, still like 360 calcium.
Yep.
But area is already 4.8, but I don't see major calcium fractures.
There is no calcium fracture, huh?
Yeah, I don't see major fracture.
And this is what, ostial LED or proximal LED?
This is flux to mid LED. The length of the ostium is like 20 millimeter from the ostial LED.
Oh, sure.
360 calcium, but no major fracture here.
No.
Yeah, here, this is tighter.
That's tight.
Like 28 millimeter. Okay, Dr. Sharma, still this is tight, 2.9.
Okay, the 3 or 30 high pressure. This one was 3 earlier?
Yeah.
Was 2.5?
That was 2.5.
Yeah, get a 3 or 30.
But mid to distal, no, the severe calcium.
A lot of
And actually,
disease,
start of the
right?
pullback is 3.5 vessel. It's interesting.
So there's like an 18 millimeter of calcific, more than 270, correct, Kiski?
Yeah.
Almost 360.
Yes.
Yeah,
Yeah,
this area
360
may
there.
need some
360.
help
Look,
with balloon.
Pedro,
Yeah.
not
And area is still
surprisingly,
tight.
imaging has picked up much more calcification than what it looked by angiography. Samin, if you had this IVUS results before, would your choice have been rotational?
Start timer.
Yeah, I mean, again, but I think we had not done the balloon yet. We did a 2.5 only. Now we have the DCB, 30, 30 there, and going to go same, 1 to 1, 6 or 8 atmosphere, do it for 60 seconds. And no touch technique, you basically don't touch the DCB portion. And there's some EKG changes, little T-wave elevation, but small. And then proximal area, we are going to now dilate with the 3O. And clearly, angiographically, if we feel it is not opening, then in that particular case, we are going to go with the high IVL. I will say probably now, not necessarily cutting balloon, I'll just go with the high IVL.
Can you show us on
and let's see
fluoro?
here.
Can show us on fluoro how
Yeah.
the balloon looked?
This balloon looks okay here.
Yes.
Question is the proximal the area. The tightest lesion, as you can see in the original one, will be at level of the 3 o'clock. That's where Kiski
That's where
showed.
the trouble is.
Yeah.
He said 28 millimeters from the ostium. All
Yeah.
that
Yes.
mid
That's
segment
what-
before the diagonal and immediately after.
Yeah. So this is done. Now, what I do, you can call it may not be a real science, but in the cases like there is a 40 millimeter lesion, there is some drug is still left. So I'll try to do maybe just go with the drug for 30 seconds. Because some people say, well, yeah, I mean, whether you need to, that truly some drug will still remain on this case or so, I do not know. But let me just do this. And I know Dr. Keeney will be ready in a few minutes. We are going to go there, go negative here. I know.
Would you consider to do IVL? I know you're doing the DCB, but IVL before the DCB?
No, but that area, no, you're right. If I had to put a DCB in the middle, absolutely. I'll do IVL. Because we all learn that if you could not open nicely with your primary technology and you had to put now, you have done DCB and now you had not a good area, not expanded, now you have to do it again, or put a DES there, is more trouble. So idea is that you put after DCB should be nothing else. So this is the one we did distal. It's a 3O actually. But the same area, question is there still remain a slight area distally, but proximal we'll try to figure out with a high pressure balloon. And now you can go to room 2. I think they're ready with the case number 7. We'll complete this and we'll try to show it later. Yes.
So, Samin, just one question. For the Prox LED with 360 calcium, why not just do the IVL?
Okay, that is completely fine. Only question was that I wish I would have done the rota. If in that case, I think you would have caused at least 1 or 2 cracks. And easy here, 2.5 didn't do anything, but that could be because of the small vessel. But yes, adding now, only question is, now you added double technique on this case. For reimbursement point of view, with the both IVL and DCB, we actually got few cases which have been sorry. Yeah, go up here. They have combined reimbursement, added reimbursement, I would say. But this is some cases we did not get. I follow them very sincerely. Yeah, I know there is a calcium behind it. So I would just say that angiographically, how does it look at 3 o'clock position? Go up here. 24 atmosphere does not look good angiographically. Guys get a 3.5. Actually, 3 should be IVL, right?
Yeah.
3 IVL. Yeah.
What will be your maximum acceptance for residual, post-PCI?
No, residual should be less than 20. No, residual should be less than 20. Every trial has counted now that after in the calcific lesion, your residual has to be less than 20%. All right, although it's looking good.
I agree.
Yeah.
Dr.
Yeah.
Waxman.
Good. Now yeah.
I would do IVL.
What do you think? Should it still be?
If you ask
Huh? Do the IVL or no IVL?
I would be for IVL because I think
Okay,
there's
let's do the
still
IVL.
like a ring
Good.
of calcium there. So.
Let's move to Dr. Kinney now, and we'll come back to
You know, the
SS.
key with
going to do a
DCB
trio,
is
yeah.
you need to get a good result. The DCB will prevent tissue growth, recurrences, but it's not going to enlarge a lot the lumen. Although it will look better, I can tell you. But if it's calcified and like a ring, you probably like to have IVL.
And there is a small randomized trial from Japan. They did a rotablation followed by DCB or DEB. They're actually the DES1 over DCB after rotablation, but those were the large vessels. Just a small randomized trial. Okay, we'll come back in a few minutes and you go other side. Thank you.
No, you're done. Room 3 show is done. Do not go back to room 3 anymore. Come back. Come here. We
Come
we
on,
almost
Dr.
finished the
Kinney.
case.
You have the big Dr. Sweeney there.
No, I think there was a discussion going on about why not IVL, when to IVL, and when the decision. I'm telling you, we are not ready yet for that. We have been doing our own randomized trial. It is for nodule shock, but we are learning when to do rotational atherectomy and when you think you should do IVL. The question is the same, 360-degree arc of calcium. You need OCT to really understand the thickness. What we are learning more and more is the so-called severe calcium. The definitions they have, definition keeps changing, but if it's more than 0.5 millimeters in depth and you have 360-degree arc of calcium, if it is tight, do rotational atherectomy. After that, if you do not see any calcium modification, that's the time you think you have to do IVL, and we also find that IVL works. Now the severe calcium, yes. So if you are doing moderate to severe calcium, when your arc of calcium is less than half, the arc, less than 180, that is a time what we are seeing is that the IVL does cause deep medial injury, deep medial cuts. So you just have to be careful in those kind of cases. But stay tuned, you will have an AI algorithm. Like we said, interventional cardiologists don't need to think. There will be algorithm to tell you do this, do that.
Before you go into, I have to tell you that my assistant AI here answered very good questions about orbital versus rota. So I encourage everybody to ask them. It's very good.
Yeah, keep asking. Keep asking, please ask questions on the trials. Like I said, the top 10 were presented this morning. I want to know if they understood everything, digested all the trials of 2026, 2025 to early part of 2026. So let us see how smart this agent is, okay? So let's go to live case number 7, 57-year-old male who has exertional angina with dyspnea. So if you see the risk factors with hypertension, diabetes, smoker, and BMI is high there. So echo is near normal. MPI had moderate to severe reversible defect in inferior and mid-inferior segment, had a CTA. Calcium score was about 1,000. So in 2017, he did have RCS STEMI and now has a bare metal stent, and we can see that. Good medical therapy, had a cardiac cath 526. This was actually done outside, and they felt that it was total to subtotal occlusion of the ISR of that bare metal stent. They could not, they referred for procedure here because you'll see why. And LCX OM2 has some disease, which if you see here, the moderately disease in the proximal part of that large OM. LED is okay, non-obstructive. So now you know why they sent it. This is exactly deja vu, the same RCA that we saw earlier.
So you got a
So the bare metal stent, so we also learned During our case discussion, we had AL1, and the fellows and Dr. Sweeney, Joe said, told me, no, go with AL1. So we went with AL1, and guess what? 7 French. So we went with 7 French.
I like it,
Though
yeah.
there is a nice antigrade flow, when you have this kind of antigrade flow, you're not sure, is it truly antigrade? Could it be that a little bit of bridge collaterals? And in this kind of difficult situation, nothing wrong in having dual axis. That's why we had dual axis. The whole case was crossing. So multipurpose, we took, even then, we can see we were struggling a lot. The guide was not engaged all the time. So the mid RCA, up to mid RCA, this is exactly what was going on. So up to mid RCA, we were okay, but when we reached the so-called subtotal total occlusion, we were not able to navigate afterwards, but actually Fielder crossed it. Otherwise, we had all the CTO wires ready to cross this lesion. So once we crossed, then look at that. Again, you see that how the guide is, we say misbehaving, keeps coming out. Got the wire further down. Then we changed to rota extra support wire. As soon as we did the rota extra support wire, now we have a nice engagement of the guide. This is where we are. The question may come, again same, it's ISR, why don't you just balloon it? We also have laser. So one of the indication for laser is total occlusion, especially of the ISR. So we have the new laser ready, but I think since we were able to cross the lesion, extra support wire, we are going with the 1.5 rotabur. Yeah.
So this is almost like total occlusion, and you decide to go first with the rota?
Yeah, I mean, let me go back here. See what happens is, see as long
I know
as
the
you
wire is
know-
in the main vessel. It looks like that, but maybe, you know, with
you see
ISR,
that?
sometimes you don't know if there is a component of thrombus there, if there is a component of under expansion. I like the idea of laser first, but if it passes.
Your concern is that the wire may have gone through a small branch?
I don't know because you don't see it. You don't see a distal vessel. It was like almost total occlusion, which we see a lot with the ISR. And I think that
Diameter
rota
stents,
would
yes.
be, I mean, it will give you a nice channel at least to see.
It's an
Same,
ISR.
you see that the
so-
guide is coming out as we are going in. So what I'll do, leave it there and we'll do dyna, okay? The same technique that we taught. Do your 3 things on dyna. Okay, go, good, go.
1.5 there, correct?
Yes, 1.5 bar.
Just to investigate a little bit more on Dr. Waxman's comment, did you have any issues wiring at the beginning or no?
No, oh no, of course, no, guide was not, see, guide is now well engaged. I showed you earlier, guide was not
Yeah.
fully engaged and I was having issues with wiring.
Okay.
What we do it what is called as a zip line. Zip line means your guide is somewhere else and you're trying to wire with the guide floating. So this has crossed, you see that?
Yep.
Yeah, so let me tell you, Pedro, this is my point. If you pass the wire through a strut or underneath, then the rota could
Let it come
cause
out.
problems there. If you try first with the balloon and you know the balloon goes all the way, you know you're good.
Yep.
Or imaging. But you're not 100% sure that you're not going under a strut.
Yeah,
with a
that
rota.
was my concern also for the wiring at the beginning. If it goes straight, you have less risk, but
It
I
looks like
agree.
the wire is free, but I'm just saying that without
microcatheter will get that
guaranteeing 100% that you're not under a strut.
Dr. Waxman, correct me if I'm wrong, but the microcatheter can also give you the feedback if you're underneath a stent shroud. Not as much as a balloon, but you might get a feedback because a microcatheter passed through that stent.
Microcatheter passed all the way. It's helpful to know that you are-
Differentiate,
yeah.
I think you're a microcatheter.
Although I can tell you,
Yeah,
it
yeah,
could be
that-
microcatheter. If the stent was not expanded
That's true.
and you're under the strut, that the microcatheter can also pass.
Yeah.
And very important is the tactile sensation, you know, you know the way the wire has crossed, how you traverse there. If you see here, look at that. So here, I actually need a lot of guide support so that I can advance the microcatheter and then advance the wire. But I do not have any of that. Every time we try to do something, guide is coming out. But you see, I was able to still
go through that lesion. Yeah. So in this kind of a situation, always be ready and have a dual injection, so you know you truly are in the distal vessel.
And especially worried if you cannot pass the microcatheter, because that could be that you're under a strap. So I often not sure. I put another wire and make sure that I'm not going to be under that. But
oh, let's take a picture. Yeah. Let's see if there's an anti-grade flow.
Yay.
Looking good.
Oh. But you see, I think it feels like it's a dual RCA. You see that?
Yeah.
This is a large PDA.
Yep.
Pull this back.
There's a AV continuation still there somewhere. Okay, now some dye there. So we're going to
Ron,
balloon
from
here.
your point of view, the last two cases have probably done justice to the DCB move here.
I just, you know, I gave my talk very positive and optimistic, but if you look at those results 6 months later, which I've seen a lot of those DCB in the Nova, and you'll see vessel widely open without a stent, you'll become a believer. You have to look at this not immediately after the result.
The reason I made that point was that many people at the moment are still not convinced about various other indications, but instant restenosis and long diffuse disease is a...
Why to put another layer of stent here? Even though if it's slightly inferior, I wouldn't do it, because I can always come and put a stent.
Even though the original was a bare metal, you still wouldn't put in DES this time? Good point.
No. Even though what?
The original stent was bare metal. It was not a
What is it?
DES. So
Look,
would you
a bare metal stent, the DCB works even better. There was a study, the first study that Scheller did 20 years ago was BMS. I think that the DCB works. Maybe DS is slightly better, but there is a trade-off. The trade-off is that it's another layer of stent.
Yeah.
And then what do you do if the second one is going to restore? You put a third layer and a fourth layer and a fifth layer?
Well, using imaging, you should, you know.
Well, I think
with
the
optimal
DCB
stent.
discussion is good, but let's come back to the case. Now, Dr. Kitty was able to
PDA
wire
and PLB.
the PDA.
So we actually went into the PDA.
Yeah, it was difficult.
And this was in a small branch, not easy. And we are going to dilate it. I don't know, you have imaging ready?
Yes, sir.
They're saying that it's ready. So let's dilate it, understand all the questions. So ISR is one case, if you can image. The biggest question is, you know, various things that you will learn. Is it neointimal hyperplasia? Is there calcium with neointimal hyperplasia, or is it calcium behind the stent in front or within the neointimal Why?
And the under
Because
expansion.
our group, under expansion is one, but more important with the neointimal hyperplasia, if there is calcified neointimal hyperplasia, rotational atherectomy works better. If there is calcium behind the stent strut, which has led to so-called little bit of under expansion, in that situation, IVL works better. We have published this from our own group. If you can show that slide in the side. Yeah, go up. And also, you can download the calcific app. All about atherectomy that we have discussed so far is there. We have upgraded that recently, last year, with including IVL and management of calcific nodule. Yeah. Because nodule is a hot topic. Today, we didn't see any nodules. But it's a very hot topic, how to take care of these nodules.
I think the panelists will love one of your apps for DCB.
Well, I can tell you brachytherapy, I still use it. You have the system, I don't know if you use it since you have DCB, but I still use brachytherapy because I still, for a very long diffuse, it's still the best.
Yeah.
Two people are the major believers of brachytherapy. Samin Sharma in room 3 and Ron Waxman in the panel.
I appreciate it.
But we still have it, or those oncologists don't want to come anymore, no? That's our problem now? Okay.
Yes. No, they're there, but we'll take a picture and then do a quick IVUS run. Okay, then we make a decision what you want to do. Now, this is a bare metal stent of many years ago. I think it is good to do a DES here.
Unless somebody is saying do a DCB because he's young.
That's what Ron is saying.
Beautiful,
Yeah.
beautiful.
And you're
What-
going to leave that RPL, AV continuation, bye-bye, no?
Yeah.
I agree.
Yeah, no, it'll wake up. Remember last time
Yeah,
also, you
forget
give some
about it.
vasodilator, it'll wake up.
Okay.
Okay, let's do the quick IVUS run.
How are we doing on
Right?
time? We are 4:36 p.m.
Okay, what do you want to do? We'll do IVUS run and then you can.
Yeah, we have
move
time.
on.
We have time. Unless Dr. Sharma want to show us what he did there?
No, we are done with it. Come.
You know
Stay
what
here.
is helpful
Stay here.
if you had the angiogram of that vessel when it was open.
Well, he's showing his KTT indulgement today in his hat. The emeralds and the diamonds were brilliant. Okay, so why don't you image? That's what you're going to do?
No, that's what we are going with IVUS. IVUS now.
IVUS, okay.
That will give us, and then you can go to your, I don't know, is there another case? What's the plan?
Case in room 1.
He's ready in room 1. Okay, we have another case in room 1. Let's image here, then you go there, and after that, I think we should be done.
Yeah.
He's in room 1 next? Okay.
Now, the question here will
I
be...
should go there?
Actually,
Can you show
because
the IVUS on the screen?
the day has been a
Okay.
DCB day.
Okay, start feedback.
Yeah.
Coming.
This will
Here's
be a
both
nice
stands.
case for DCB's
Yeah,
ISR,
this is the
no?
previous
Small
stand.
vessel.
Yeah, some neo-intima here, but Luma is good. Now this is native. Some dissection, eccentric, okay, flash bit, flash please. Okay.
Mm.
Or calcium here. Okay, got it.
Calcium.
Lot of
Let's
calcium.
Stop it.
Mm.
Actually, stented part is not that long.
So stented part is what?
Not that long.
Not that long.
Say that again?
Mid-to-proxy is mostly, mid-to-proxy RCA is non-stented, native plaque.
Mhm.
Actually, IVL.
Yeah, now, this is the edge of the previous stand.
We don't want to make it longer, so we will do DCB.
Yeah, it fails metal. This vessel fails metal. No under expansion, Kiski?
Yeah, so.
It
now
looks
I
like
show you,
it's
so,
well
yeah.
expanded and well
yeah,
opposed.
well expanded.
It's
yeah.
mainly tissue, so it's
And,
mainly
what?
biological
Yes.
impact.
Correct. Yeah.
I can't
a
hear
lot
that.
of neo-intimal hyperplasia. And actually, previous stent is just 15 millimeter. And now from the guide to the proximal edge of the stent is 34 millimeter.
Okay,
And
but more important, there is calcium and a native lesion. We need to take care of that, right?
Yes.
1.5 bar was too small for that area.
So actually, severe calcium is mostly proximal part.
Okay, so that's fine. But look at that MLA. MLA is 7.1, so we don't
Yes.
need to touch it.
Leave it.
So,
What do you think?
Yeah, at this point, there are a lot of calcified lesion. AI doesn't work. That's why I need to do manual collection.
At some
Yeah,
point,
that's a big
AI is
lumen.
not working.
That's a big lumen.
Yeah.
Yeah, but anyway, yeah, this is a
Don't
proximal
touch it.
RCA 5.0
Yeah.
after low term.
I think Kiski, we will put a 48, okay? Okay, from that acute margin, acute angle all the way backwards.
What's
Okay?
the reference
Actually,
vessel, Kiske?
Yeah, the start of the PUVAC vessel size is 3.6 millimeter.
So 3.5.
3.5.
Yeah, and here to the osteo RCA is like 60 millimeter.
No, we're not
No, we're not
talking
gonna go there.
osteal RCA. So just where there's no so-called, you see where the mid RCA, there's no RV branch. You see that?
Yeah.
Come back,
Yeah, I
back,
think
back.
this is the one within the stand.
No.
Okay, I know. Come proximal.
Yeah.
Come
Or
proximal.
prox.
Come
Yep.
proximal.
Now come to the
prox.
native lesion.
Yeah, come to
Yeah.
the native lesion.
Keep
Back,
going.
back, 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 back.
Keep
A lot of
going.
eccentric, but here
Yeah,
is
right
not
there.
much calcium. Mostly attenuated lipid
We are
plaque.
not talking calcium. We are talking lesion. Come back, all the way back, back,
Yep.
back to the
Keep
normal,
going.
normal lesser looking vessel.
Some
Oh.
part is AR bubble artifact. Now come to the restricted calcium.
Yeah,
That's the
what's
big
that length
vessel
right
there.
there?
Sure. So
This is why we should do
From that-
OCT.
48.
from that
Okay.
top-
Okay, I was saying 48. What did the EYE predict?
We
48.
I have one
45,
question.
48.
Why did you give up on the distal RCA?
Yeah. Question about the osteal PDA, distal RCA.
Because it looks like if you will be able to balloon it and put DCB, you may gain some vessel there.
It will be too much now to stand from there back.
No, we are not stenting that one. Okay, we can do that. Okay.
If we
We'll
can
take
wire it.
we'll take a picture. So with the bare metal stent, we'll cover with a long stent, and distal will do a DCB, distal RCA to the PDA. It's almost a 3-0 vessel. 2.5.
See, there is a flow there in the distal right, the beginning of the right. And I think that if you do a
No, we're
2
not doing
millimeter
anything. Let
balloon
us
followed with
dilate and
DCB, you
do a
may
DCB here.
recover the vessel.
To the PDA.
Yeah, PDA.
Leave the RPL.
Right
Yeah,
after
get us
the
at,
origin
20.
of the AV
We
continuation.
have a 2.5 balloon,
Yeah, beautiful.
2520 SC.
2.520 NC, and get us a 20 or what is a 28 DCB, and we'll put a 3.548
Stent.
in the stent.
Okay. Should we look at room 1 now, or
No, you go to room 3.
room 3?
No need to come back here unless you want to see the final result.
Of course we want.
And then
to
give
see
us,
the final result.
give us
Okay,
a,
okay.
you want a 2.5 DCB?
Pedro, if you would come 2 years ago to this meeting, no one would discuss even DCB. And look how much things are
What is
changing.
this now?
It's a change in culture.
NC.
That's what I'm saying.
2520.
I'm actually very excited about DCB.
Yeah, is that 275?
2.5. Oh,
Makes life easier.
27520.
20.
Although those DCB acute thrombosis previously shown were very interesting, no? Very good.
Okay,
Dr.
can we
Sharma.
show quickly? Yeah. Okay, you see there, that's where you left us. This was at 20 DCB, which we did. And then the clearly was lesion proximally with the high 30 balloon did not open. As we took the advice from Ron Waxman, up and down, total 12 cycles of the 30 IVL done. And you can see how it looks at the end. It's needed. And then we put a long stent, and this is the 3.5. Looks very good, but now there was still a trouble. And you see the distal after the first DCB, the distal lesion still remained trouble. We went to other view, so we needed to put another DCB. I think Mount Sinai will lose money in this case, but we'll tell them to reimburse one because of the symposium. Ask Boston Scientific, charge only for one. So this is where we are, and then we did the imaging. Yeah, yeah.
Looks good.
Although they had to give it. Now, we can see IVUS, the stent segment of the IVUS. Show the IVUS, please. And now we are doing the CERC PCI. Okay, IVUS. We did not go to the DCB area with the IVUS. We remained within the stent and make it on the main screen, please. Yeah. Yeah.
Looks good. No complaints, huh?
No issue.
Yeah. Yeah.
Very nice result.
Good.
I think Dr. Wasman will
Okay,
be happy.
so, yeah, exactly. So what, as you say, that lot of DCB discussion now, we are appropriate. Now what will happen is maybe you can have some presentation because we'll be ready with another case. Actually now, Dr. Upendra Kaul can give the lecture of top 5 lessons from the tuxedo trials.
Okay, tuxedo trial.
Yeah.
We need AI Sophia to tell us about it.
I now invite Dr. Upendra Kaul, Chairman and Dean of Academics and Clinical Research at Buttra Hospital in New Delhi. Please welcome Dr. Upendra Kaul.
Well, it's a great pleasure to be here and sharing the experience of Indian investigators during the last, several years. The beginning of the tuxedo trials started when there was a raging controversy that although everolimus limus stents were better for everything except diabetics, because it was felt that diabetics may have a specific role for paclitaxel. And this kept on going in meta-analysis till the time it was thought that a dedicated study in diabetic patients comparing paclitaxel-eluting stents with everolimus or any limus stent was needed. And that's one, at that time, Tuxedo 1 stepped in. This was a 1,830 diabetic patients from 46 centers of India with 1 year follow-up. And this was a non-inferiority design trial. And the primary outcome was that everolimus eluting stent was better in all the respects: target vessel failure, spontaneous myocardial infarction, target vessel revascularization, and above all, the stent thrombosis rates were unacceptably high in the paclitaxel-eluting stents. So this trial did not meet non-inferiority. And insulin requirement did not change the benefit. Everolimus-eluting stent was the preferred stent, and stent thrombosis was 5 times higher with paclitaxel-eluting stents, and that was the demise of the Texas stents. Then we planned the Tuxedo 2, and this was the time when there was a freedom trial legacy that coronary artery bypass grafting has traditionally remained the gold standard for multivessel disease in diabetics for long-term survival. But we felt that newer generation ultra-thin drug-eluting stents with the newer techniques of deployment, when combined with aggressive guideline-directed medical therapy, should offer a viable alternative for angioplasty, and we should not go on with the legacy of 2012 Freedom study. And then we planned this Tuxedo 2 multivessel disease trial, in which there were 1,800 patients were randomized. There were 3 answers which we wanted. One was comparison of supraflex screws, which is a ultra-low thickness stent, with Xience. Number 2, the combined PCI arm compared with the performance goal of the Freedom trial every year for 5 years. And the tertiary outcome, whether prasugrel and ticagrelor are equivalent in these diabetic multivessel disease patients. So it was a 1,800 patient study, mean age 60 years, 72% males, 85% patients had triple vessel disease like in the Freedom study. 1/4 of them were insulin requiring, and about 28% had high bleeding risk criteria. About 60% presented with a recent myocardial infarction with a mean syntax score of 75, and a mean number of 2.9 stents were used with a stent length of 80.5 millimeters. What was seen in the stent-to-stent comparison, that the ultra-thin stent, which reduces vascular injury, accelerates new endothelialization, and lower thrombotic risks, was equivalent. And the primary endpoint of target lesion failure at 1 year was 8.75 for the everolimus-eluting stent, and it was 10% lower with the supraflex screws. It met the non-inferiority. And if you look at the various endpoints, the cardiac death, target vessel MI, infarct-related target lesion revascularization, non-fatal MI, and stent thrombosis, they were all equivalent, and they were very consistent with all the subgroups, ACS versus stable, insulin versus non-insulin diabetics, 2-vessel disease or 3-vessel disease, small vessels, bifurcation lesions. As you can see, the risk difference was 0.83, and it met the non-inferiority. So at 1 year, the non-inferiority was confirmed in the ITT population, also consistent across all the subgroups. The lesson 3, can PCI beat CABG these days? We know that the Freedom trial had the first generation stents, Texas and Cypher, but Tuxedo 2 had supraflex screws or Xience. Intravascular ultrasound or OCT was encouraged in Tuxedo 2, but there was no such intravascular imaging done in Freedom. FFR and IFR was done in 18% of our cases, and we maintained the LDL cholesterol at less than 50. SGLT2 inhibitors and GLP agonists were used in about 30% of cases, and the syntax scores were 80% were less than 22. It was a non-inferiority trial with a performance goal of 10.58% with a power of 95%. The primary endpoint at 1 year for the CABG was 8.78%, and for PCI was about 3% lower at 5.79. And if you look at the MACE, the MACI was 5.77% for Tuxedo 2 versus 11.96, very significant. All-cause death was not different, but myocardial infarction, stroke, and repeat revascularizations were significantly lower for the Tuxedo 2 trial. So contemporary PCI is now a viable and often superior alternative to bypass surgery for appropriately selected patients with diabetes and multivessel disease, and it calls for a freedom 2 when you should be having a head-to-head comparison between the two. Then coming to this controversy of whether it should be prasugrel or ticagrelor, we know that Plato showed that ticagrelor was better than clopidogrel. The Timmy Triton had shown that in diabetic subsets, prasugrel was better than clopidogrel, but there was no head-to-head comparison between ticagrelor and prasugrel. ESAR React 5 from German friends had shown that prasugrel was superior to ticagrelor in acute coronary syndrome, but in the diabetic subgroup, which was only 20% of the patients of ESAR React, it was not different. It was only hypothesis generating. So what we thought, let us do a trial in diabetics, prasugrel versus ticagrelor, continued in the full dose of 10 milligrams versus 90 milligrams twice a day of ticagrelor, and 14.23 was the primary endpoint of death, non-fatal MI, infarct, stroke or major bleeding with prasugrel, and it was 16.57% with ticagrelor, indicating that there was a superiority of prasugrel. It did not meet, once again, non-inferiority. You can see 16.7% for ticagrelor versus 14.23% for prasugrel. And in all the parameters, whether it is primary endpoint, death, MI, stroke, the major bleeding, or all-cause death, prasugrel had better numbers and prasugrel was preferred. Now coming to the high-risk subgroups where the gap widens. If you look at the non-high bleeding risk patients, which was about 73%, there was no significant difference between ticagrelor and prasugrel for the primary composite endpoint or major bleeding. But when we look at the high bleeding risk patients, which is about more than 25%, ticagrelor was associated with significantly higher primary composite endpoint, and which was statistically significant. So prasugrel is strongly preferred to high-risk bleeding patients who are diabetics undergoing PCI. Ticagrelor carries meaningful excess risk. So in the most fragile, high bleeding risk patients, ticagrelor still yields the excess primary outcome compared to prasugrel. So risk stratify all the diabetic multivessel disease patients for prasugrel as compared to ticagrelor. So the primary endpoint, as you can see, for high bleeding risk, ticagrelor 22.76% and prasugrel 13.11%, indicating a very significant difference in the black line and the purple line, whereas in the non-high bleeding risk, there was not much of a difference. Then we come to the duration of diabetes. If the duration of diabetes is less than 5 years as compared to more than 5 years, in less than 5 years, that is recent onset diabetics, ticagrelor was inferior to prasugrel. Prasugrel was clearly superior in this. So prescribed prasugrel, it is a strong signal favoring in newly diagnosed diabetics. But if the diabetes is more than 5 years, there was not much of a difference. So what are the take-home messages from the 5 lessons from Tuxedo trials? Number 1, paclitaxel-eluting stents failed against everolimus-eluting stent, and that led to the demise of paclitaxel-eluting stents. Ultra-thin stent is non-inferior in diabetics with multivessel disease, and this is the largest trial of diabetics with multivessel disease, where supraflex screws was equivalent to Xience. Number 3, PCI can beat bypass surgery in diabetics with multivessel disease in the modern era, and contemporary PCI meets CABG benchmark and even surpassed it. Finally, prasugrel wins the antiplatelet battle. Ticagrelor failed non-inferiority versus prasugrel in multivessel disease. And high-risk subgroups where the gap widens, prasugrel favors. If the diabetes duration is less than 5 years, prasugrel is clearly superior. Thank you very much. And this is the team which has been doing this work for the last 10 years. Thank you.
All right, so we're going back to room 2. Room 2, Dr. Kinney.
Yeah. You can see that?
Yeah.
So can you see us?
Yeah, balloon angioplasty on the ostial PDA. Distal RCA, no?
No. This is the DCB.
DCB, okay.
This was the stent. This was the stent. And this is the final. Where is the IVUS? IVUS is a full, yeah. Can you show the IVUS? That was the final result there.
You did the IVUS after the DCB?
Not to that area.
After the stent.
We didn't touch just the
Okay,
distal edge of the stent.
You didn't touch the
Go
area.
to the, yeah, go to the,
Very important what Kenny did. Don't go after DCB with IVUS or OCT.
can you show the IVUS? Yeah, this is the distal edge, 97.6. Look at, you see that on the top 7.9, 6.7, anything above 5.5, we are very good.
Yep.
And proximal, you see that? Nice transition. So proximal edge, distal edge looks good. And that's where we are. I just want to finish by introducing our two fellows. I know earlier were all female fellows and all that thing. Now the boys also want to be part of it. So they need to be introduced. I have Kushal Chowdhury, fully trained here in USA, and now finishing his fellowship, and he'll be going to South Carolina, taking the flag of Mount Sinai there. And we have Bharat. He actually came from a different country, which is Middle East. From there he has come, complete training done, and he'll be going back. So essentially, we believe that one day, every hospital in USA for definite, maybe all around the world, there'll be one fellow trained from Mount Sinai.
Wonderful. Dr. Sharma, any issues up there, or should we move forward?
Yeah. Okay, let me present this case quickly. And 1 second while we are ready. Okay, so very quickly, this is the case number 9. As you can see, our patient is a 69-year-old male, has a severe AS. At that time, we found out also has a very significant CAD of LED diagonal bifurcation. We are detecting those things now at the time. So this is why I would say this was a very good case. This is the right coronary. The had a stent in the past or so, but this is the left main is good.
We don't see the
sapien
angio.
valve. Oh, you sure? Okay.
We see the slide of the
let's show the
case.
angio.
Case
Yeah,
presentation.
case, okay. Yeah, let's go to the case. Yeah, slide,
Now we
the
see it, yeah.
angiogram first. Yeah, yeah. So let me just show the right coronary. Very easy to, engage with the balloon expandable valve, which is the sapien. Now this is the VL 3.5. VL 3.5, and you can see here the LED diagonal. This is kind of, we thought, in the end, while we have shown the 8 crazy cases, calcific, diffuse disease, this and that, let's show the run-of-the-mill bread and butter case of LED diagonal bifurcation being done with a mini crush. And it's not even a calcified. So what we did in this particular case, we did a cutting balloon multiple times with the cutting balloon techniques that you have to do to go to 14 to 16 atmosphere. Don't go beyond 20. You'll rupture and perforation. So see that what we do, you pull back and go again 3 times, back and forth. Then same cutting balloon of the 3O, we went to the side branch, same way. You pull back and go back again. It will go into the different direction and cut the plaque. Some people rotate, but I think it's basically, the key is advancing 3 times. And those were then we did the imaging to see both LED and diagonal. So Kiski can show the LED image.
Yep.
IVUS.
Yeah, absolutely. Can we? Okay.
Show the IVUS, please, on the main screen.
We see it.
Yeah. So this is the start of the pullback lumen 3.1. Vessel is like follow vessel, eccentric plaque. Now coming to the LED bifurcation. Now we see the diagonal wire from the 3 o'clock. Just before that, already we see some calcium fracture at 6 o'clock. Then it's very short region, like 15 millimeter. The proximal vessel is like huge vessel, like 5 vessel. Lumen is follow vessel. So this is the pullback from the LED. Now come to the next pullback. This is the pullback from the diag.
Then with the diag also?
Yeah. Yes, this is like 3O vessel, and this is also well modified. Very short focal osteal lesion, but looks well modified.
Yeah, very good, because the cutting, it was not that much calcium.
Yes, no.
So cutting balloon, they are a good job of causing fracture. But you remember, many trials have shown, Kopp's trial and so, the cutting balloon do give the better MSA at the area of maximum calcification. But those are not the severe calcium. So severe calcium, I would say, it should not be, the cutting balloon could be contraindicated because sometimes it can rupture and can create a trouble. So now we are ready with the 2 stents, 3O12, Zions in the diagonal, and 3.518 stent in the LED. And they're ready for the mini crush technique. We are going to give a little dye to make sure everything is in good position. Let's see now. LED will move a little bit more. Yeah, little dye again. Good. I think we are okay.
The ostium,
So
ostium
now,
of the diagonal.
yeah, we'll be okay. We'll come up, go up. Yeah, so we pulled it out. Remember, you don't want too much inside. So 12, 14.
Beauty.
Negative. Go up again. Negative. And just pull back. You can go a little higher pressure here. Go 20 atmosphere. Ostium, you want to open a little bit more. Good. Negative. And actually, they can play the mini crush technique of our bifurcate. You know, many of the cases we do accordingly. So we bring it out, give a little dye. Yeah, that's fine. So once it is done, and then you remove the wire as well as the balloon. So wire comes out, balloon is already there, and LED, I think a little bit, again, slightly go up. No, I'm sorry, dye. Yeah, little dye. Good. Go up. -16, negative. Now, proximally, we were told it was 4.0, but that's okay. Once we do a kissing balloon, it will become 4.0 because 3.0, 3.5 will become 2/3 of that. This is where now a lot of people say, well, we are going to use a DK crush. Nothing wrong in the DK crush. But my only question is multiple steps, which actually are not needed in majority of our cases. And only the trials of the DK crush have been good from China. So people say that part of that is by doing a DK crush, you are dilating the ostium or the side branch better, and you'll be able to advance the wire and balloon. So I mean, that's probably a soft indication, because most of the time what we have done, we have never had a trouble, and we'll try to demonstrate that today in this particular case. So we have same wire which we had earlier. We have pulled it out, and now, although it probably has not seen the good days, wouldn't you feel the wire? Yeah, you ready? New filter wire? Yeah. Yeah, the wire has just seen its good days or bad days. Yeah. No, I don't think we should go with those kind. But let's see, this is what we have. Make the curve. But see, clearly, I want to just point out that at the ostium, everybody can see?
Yes, perfect.
It's a clear cut. And then more importantly, now once you open the side branch, the stent 1 will become little like main artery. Once you go to the side branch, it will become little bit, further expand, and it will become fully opposed. And that's actually what you need to see. Clearly, the wire has to go from the main lumen, because we have done October trial and showed that many times, 15, 16%, the wire goes underneath, and you call it stent deformation and many technique. The question many times we do, if there is a question, then you go in the LED first and then pull back. Now this is a very tortuous LED, so I would try to do the same thing. Or if there is a question, you can put this wire into the LED and bring the LED wire, which you know. It's a clear-cut interlumen into the diagonal. So that probably will be the better, but even for this wire to go into the side branch, distally, it's very tricky. It goes there, and because there is additional tortuosity, so you don't want to push it. Otherwise, it will cause more dissection. Little dye, let's see why it is not going. And otherwise, in these cases, your next good wire is your, let's get our whisper access support, right? Yeah. Yeah, so what happened is, coming out multiple times into the side branch, but it's not going into the main vessel, and it looks like having some resistance. Is there a distal edge dissection? I know the vessel looks a little small. Distally now? No, okay, good. It did it now. Okay, now we need to go. The question is, whether can you put a non-compliant balloon? Answer is no. Left main, yes. So give us a 2O, 12 compliant balloon first. So because most important is you have to open the side branch and then use same 3.5 and 3O, do a kissing balloon dilatation. As far as the pot, in the non-left main, we do not do the pot because we actually wrote the paper also. And in the left main, yes, because otherwise you'll see the kissing balloon and we'll do the imaging after to see, to show that how good, and we have published that paper, the good apposition happens with your kissing balloon, and pot actually sometimes even cause little overexpansion and distortion because, pot, unless you use the pot balloon, with a distal end, there is no overhanging. And this is now, will be few techniques. If you cannot get this one down in, then you put see this now?
Beauty.
Clearly went in. So no question that mini crush, you'll have any trouble, go up 20. You'll have any trouble with putting the balloons in the side, but I would still say the first one should be a little slow. Go to the compliant balloon because non-compliant, except in the left main, may give the trouble, negative. Now we are going to do, and I know we are reaching our time. So far, we're just few minutes late, but let me just do the clear-cut kiss. And if you want to go with your presentation, learn from all the senior, our esteemed faculty, they will teach us, each of them, 6 of them will teach us various aspects of the educational case, whether it's a complication, side branch balloon first.
Okay, we'll do that, Dr.
Let's see
Sharma. First, before...
Okay, let's see this now.
Okay.
First, we do a kissing balloon. And then, angiographically, if any question, then only we do the imaging. If you want to do imaging, we can be done also. Even in these current trials, which were negative, there were a few of them were bifurcation cases even. And still, the imaging did not come superior compared to angiography in both those trials. I was CHIP and in the optimal trial. Yeah. So now, this is a non-compliant balloon, which I'm not surprised it doesn't give. The pull back and go with the speed. So that is what you do. Good. Other balloon. This is what length? 12. Both are 12. Good. And you can take the vote there that for bifurcation, non-bifurcation, not left main. Left main, I'm sure many people, majority will say that go the DK crush. Non-left main bifurcation. Our panelists, what is their preferred approach? DK crush, mini crush, reverse crush, or just simple culotte. So what is the overall feeling of the group? Good.
Yeah, the panelists decided to leave the panel table a little earlier.
Why?
But we have Dr. Nitin Barman here. But tell us, you tell us.
Wow.
Okay.
That's a good one.
Well, the thing is that we went to the tuxedo, which is after the...
I see, okay.
The issue was. We're coming back to the cath lab later,
okay.
After the tuxedos.
Go.
Fantastic talk, by the way.
Yeah, super. And that's what I thought, that call the master of these these trials, that we learned the lesson, what we learned from these, and he made those 5 points fantastic.
Yeah,
you know what, only thing I could not get, how did they say that current stent is okay, go up again, okay with the cabbage? There was no arm of the cabbage in the trials, right? In the tuxedo trials?
No,
okay.
He's saying no.
Yeah.
Performance goal of the freedom study.
Oh, the performance.
Oh, yeah.
Performance goal.
Yeah, good.
Yeah.
Good. Understood.
But,
that makes sense.
But it's only 1 year.
Okay,
events.
guys.
We wait for 5 years.
So we are done. You see the last picture?
Yay.
We just do a little medication. So all done, and you can start your presentation, my friend.
Yeah. Before we go there, I just want to say that we witnessed a big RCA intervention by Dr. Kinney, who has the nickname of the GOAT, GOAT, great of all times. Congratulations, Dr. Kinney. All right, so let's move on. The last but not least, and the most exciting part is these complications that we have, complex cases, and we have Sophia introducing the speakers.
I now invite Dr. Ankur Kalra, Division Chief of Cardiology at SUNY Upstate, Associate Professor at Norton College of Medicine. Please welcome Dr. Ankur Kalra.
Well, AI actually pronounced my name just perfectly, so congratulations there. I wanted to sincerely want to thank the organizers of this incredible conference for giving me an opportunity to come here as faculty and present. These are my disclosures. So the topic that I was given was getting out of trouble with a focus on dedicated stents for either bifurcation or left main. I did not have a case for that, but I do have a case which illustrates getting out of trouble. So this gentleman is 79 years of age. He presented to our emergency room with worsening non-radiating substernal chest pain. As I went down to see him in the ER, he said that he had recent heart attack, quote unquote, and the fellow was pulling the record, telling me that he had a recent anterior STEMI, was diagnosed with 3-vessel disease, was a surgical turndown. As I was eliciting more history, the fellow tells me that the hospital put an intra-aortic balloon counterpulsation in and performed a percutaneous intervention in the culprit vessel, which was the left anterior descending, with a 2.5 by 15 millimeter drug-eluting stent. And then during that index hospitalization, he had a stage PCI of the non-culprit vessel, which I think is standard of care, is completeness of revascularization in patients with ST elevation. And so with that history, this was the presenting EKG. I'll go back to show you the EKG. That's the EKG at presentation. So you see there's ST elevation in the anteroseptal leads, even in the lateral precordial leads. And with that, we took him to the cath lab. So I always start by looking at the non-culprit based on what I think is the culprit on the EKG. So that's the right coronary. You see that the proximal to mid-segment is stented, and there's something going on at the distal edge of the RCA stent. Pedro, I don't know if you would agree with me. I think there's something happening there at the distal edge in the RCA. And then this was the angiogram on the left. As you can see, the LAD is totally out. So I called for my workhorse wire, which is, I like to use cyan blue. I know having sat through the cases, run through is a favorite wire at the Sinai lab, which, again, is a great wire. Both are really good wires. Mm-hmm. I was not able to get through the stent with my regular workhorse wire, either run through or cyan blue. So I asked for a polymer jacketed wire. This is, my wire of choice, a polymer jacketed wire of choice. The first one I use is a Choice PT Extra Support. You can pick your polymer jacketed wires. I got lucky with that loop that I created because, you go in and you do not know what the anatomy is, you can easily dissect the vessel. So I took that loop, I went in, and then I started dilating with the balloon. And this is what I got after my first balloon dilation. There wasn't much flow, and I thought if it was either I had dissected the vessel or the thrombotic burden was high. So between what you see on the left and what you see on the right, some of the steps that I took were essentially manual aspiration with an aspiration thrombectomy catheter, which I know is not routinely used in STEMI cases. Because of the total and TASTE trials that showed that there was an increase in the incidence of stroke. So routine aspiration thrombectomy is not indicated, but in cases like these, I use not infrequently aspiration thrombectomy. And then I exchanged the polymer jacketed wire with my workhorse wire by putting a fine cross and exchanging it. And then this is what I got after I had done the initial aspiration. So the long mid-segment, again, a question of whether it truly is a thrombus or if I dissected it and then somehow, found myself way back into the true lumen was a question that I asked myself. So then I start with balloon, with just, transluminal coronary angioplasty, so just with non-compliant balloons trying to dilate the calcified segment, because it looked that the stent, the initial stent, the 2.5/15 stent, the distal edge was in a diseased segment of the vessel. And after we do that, this is how the LAD looks like now. So now I'm really questioning if I'm truly in the true lumen or whether I've dissected the LAD all the way through to the distal segment. So I go in with a fine cross and I take a distal vessel injection with contrast and confirm that I'm truly in the true lumen. And at that point, and this was also after plaque modification. So at the distal edge of the prior stent, we did intravascular lithotripsy just for plaque modification because we thought that that segment of the vessel was heavily calcified and diseased. So then we start stenting, knowing that we were in the true lumen and that we need to stent the thrombotic burden because now we had done manual aspiration and we'd also done intracoronary lithotripsy. So then, we had good inflation with non-compliant balloons, so good expansion. So we thought that the vessel was adequately prepped, the lesion was adequately prepped, and that point started stenting. And the angiogram on the right is you see after we stented it with 3.0 48 millimeter stent, and then or a 3.5 48 millimeter stent actually. So the previous stent was clearly undersized. We did do IVUS. I don't have IVUS images to show to the audience, but the stent was undersized and malapposed, the first one from the week prior. And then this is just making sure that the prior stent is also adequately post-dilated. Some no reflow, acute no reflow, which we treated with vasodilators. Again, microcatheter facilitated distal coronary bed injection of adenosine. I also tend to use epinephrine over adenosine. There was a randomized clinical trial which compared both drugs head-to-head and showed that epinephrine does wonders in these cases. It has never failed me in person, so epinephrine is the drug of choice for me when I'm dealing with acute no reflow. And then this is how we ended the case. The one component here was you see that the diagonal has TIMI2 flow. You do see the contrast going all the way to the distal end of the vessel. So I rewired it. Again, the rewiring of choice in these cases is I use a Fielder FC. It finds the channels, and then I just, like Dr. Sharma very eloquently demonstrated in the case, was just using a 2.0 compliant just to reestablish flow. Interestingly, despite the echocardiogram showing that the anterior wall was, hypokinetic/akinetic in the echocardiogram from the previous admission for this patient, the patient reported, complete absence of chest pain when he rolled into the cath lab with a 10-on-10 chest pain. So we thought that was a salvage, and we sort of got out of trouble from an undersized stent from the previous intervention. So just a quick one-slide summary of how to deal with cases of stent thrombosis. The definition is hyperacute, subacute, and late stent thrombosis. So by definition, this was a case of subacute stent thrombosis. Always do intravascular imaging. It will explain to you how the mechanism of failure for stents, whether it was under expansion or malapposition or a deformed stent. Clearly, if it's subacute stent thrombosis, it rarely is new atherosclerosis or new intimal hyperplasia. You can have intramural hematoma or edge dissection. And then just go over the steps, like I mentioned, we did lithotripsy in this case, we did thrombectomy in this case, we also did pharmacotherapy because we infused the distal, coronary bed with vasodilators and with epinephrine, and then had to stent the long mid-segment to mitigate the thrombotic burden. Once again, thank you for allowing me the opportunity to present. I'm within time. We have 55 seconds left.
Thank
And
you
I'll
so
take
much.
comments or questions.
That was a beautiful case. Congratulations. I think
Yeah.
we're going to proceed with the next presenters.
I now invite Dr. Nitin Barman, Cath Lab Director at Mount Sinai Morningside and leader of its Interventional Cardiology Fellowship Program. Please welcome Dr. Nitin Barman.
Thank you. I got to say that she did mispronounce my name, which is some kind. It's Nithin with the TH. But I'd want to echo what Ankur said, and very grateful to be participating here. I was in the lab for the better part of 10 years on the other side of the camera and miss it a little bit, but it's always nicer to be able to just critique things. So the title of my talk, CTO Imaging Makes a Difference. No financial disclosures. I do have some talk disclosures, which is to say that this talk may not exactly be true to the spirit of the title, although there is no questioning the importance of IVI and CTO. It's definitely a CTO case with interesting imaging, but just not the IVI part. And I still don't know exactly what happened or why in this case, so I thought to present it, there's a lot of smart people in the room, could crowdsource this and maybe get an answer. So a quick outline there. So obviously, IVI and CTO imaging, proximal cap ambiguity clarification, antegrade dissection, reverse cart, assisting with these techniques. Of course, as we've seen, decisions on plaque modification and stent optimization. I'm going to get to the case pretty quickly here. The data, there's not a ton for CTO-specific data in terms of IVI. There was a randomized trial from Korea, 400 patients, IVIS-guided versus angio-guided treatment of CTO, and you can see the primary outcome was MACE was substantially reduced. So there's likely value in this subset. Of course, Renovate Complex PCI, the audience is probably more familiar. The subgroup analysis, there were about 300 CTO patients here, and you can see in the whole trial was positive. The CTO subgroup was especially positive, hazard ratio of 0.3. Just to be complete, Optimal and IVIS IVIS CHIP recent negative trials. Optimal didn't have CTO patients, and IVIS CHIP was negative, including in the CTO subgroup. Improve is pending, so we'll see. So let's jump to the case here. This is a 65-year-old male Jehovah's Witness patient with risk factors on dialysis for 10 years who presented with ADHF in the setting of missing dialysis. He had a mildly reduced EF with regional wall motion. In-house, he got a CCTA, which I'm not sure was necessary, but was done a marked calcium score, 9,800, 2 CTOs, and kind of a moderate LAD stenosis. He came for a left heart cath. So this is the initial angiogram. You can see not a huge RCA, severe diffuse calcified mid-distal. This is the LAD, about 50 to 60 procs, but not a terrible burden in the left main or LAD. And then there was a large branching CTO. We knew from the right that the left side supplied the posterolateral wall. Let that play again. So we took him off briefly for heart team discussion, although it's always challenging when the left main LAD is not substantial. He was turned down due to his Jehovah's Witness status and kidney dysfunction. And he presented for the CTO PCI. In fact, some of those pictures you saw were from the PCI, or just better images. So this isn't a huge part of the case. I'll go through it quickly. A right radial access, a VL4 guide, microcatheter. We crossed with a Gaia X3. It was uncrossable, as you might expect with that degree of calcium. Exchanged for a 1.0 balloon, which ruptured. But that did allow then our microcatheter to pass. We deposited a rotofloppy wire, confirmed the luminal position, and did a 125 burr pretty seamlessly. Subsequent NC dilation showed some kind of malexpansion of the balloon, had not yet dropped the IVIS. Did a cutting balloon, again with the Guidezilla support at high pressure. This is our post-modification angiogram. You can see kind of a moderate-sized subtotal side branch, which we then addressed with the 2.0 compliant before delivering a 275/48 synergy stent. Stent was deployed at 16 atmospheres, and then we did a post-dilation with a short balloon so that we could kind of adjust the pressure across the length of the stent, 3.0 and 8 NC. Had a little disruption. We saw in the IVIS, we put a short stent proximally as well. Finally did our IVIS here. This is the Philips IVIS. We, at that time, did not have access to maybe one of the better imaging products at the hospital that we're at. This is the best we had. Reasonable looking IVIS. let that run all the way through and then show a couple of still images. You can see a little bit of malexpansion there, but pretty decent. So there's some still frames. We had an MSA of 5.7, partially unexpanded, as I mentioned, but it was bigger proximally. It was a very kind of short area. This is our final angiogram, and we were pretty happy with this and thought that we'd have a reasonable outcome. So he actually did pretty well clinically. The right was not, was left for medical therapy. Presented 10 months later and developed significantly increased shortness of breath and reduced exercise capacity despite adhering to his HD sessions, and he presented for a repeat left heart cath. Sort of gets interesting. So first of all, his EDP with this catheter was 34. We engaged his right, and he had significant progression now with I guess I would call it subtotally occluded, kind of mid-distal RCA, again, severely calcified. This is a cranial shot showing some progression now. You can see in the mid-LAD just short of that second diagonal, and then the proximal diffuse disease. And obviously you can see in the background the LPL being occluded. Initially thought it was just CTO-RSR, but upon closer inspection, I don't know if that projects well to the audience or not, but the stent is definitely not where we left it 10 months earlier. So it really was hard to explain what we were seeing. It looks like the stent has been completely transected in two positions, and then migrated, and then beyond that rotated into kind of a perpendicular axis to the vessel. So kind of didn't really understand it, knew that we were not going to touch it. Took him off the table again for a repeat CTS consultation now with this kind of failed initial PCI and a progression in the LAD and the RCA. Also, he was not compensated at this point. Actually, the patient and surgeon agreed to an outpatient CABG, but after a planned course of erythropoietin and hemoglobin at this point of 8.2, and he was prescribed additional hemodialysis. So he actually had gotten his hemoglobin up to 11.9 in the subsequent months, but then was kind of lost to follow-up. He was a little bit of a patient with maybe less insight into everything that was going on. Represented then 5 months later, which is now 15 months from the original PCI. With, again, repeat non-STEMI, but newly depressed EF now. This is the first time his EF dropped down to 20%. He was treated with BiPAP and increased HD in the hospital, and then underwent yet another left heart cath, which showed much more substantial progression of that mid-LAD disease, so kind of a very aggressive CAD course. And he was on good GDMT otherwise. Whether he was taking it or not is not clear. We again re-imaged the migrated stent, and it's even changed since before. So these are kind of near identical gantry angles. And you can see on the left of the panel, which was the current angio, that first piece had now rotated, and we use the verb, I don't know if there's any sailors, but that's called yaw in this direction. There's pitch and yaw, and we had to relook this up, but there's other ways you could describe it. But this piece is kind of further rotated, so I think the stent exists in all three planes, an X, Y, and Z plane right now, three pieces of it. But beyond that, you could tell, and again, I don't know if it shows through, there's a little bit of di-extrav on the left, which was not present on the right, so there's some kind of connection between the coronary and the space there. So again, very bothersome. This is a 5 months interval between these two angiograms. So he was taken off the table for a third time. We plan to get additional imaging to try to describe this, and then really a courtesy CTS reconsultation. I think they had a very strong appetite the first time, and I don't think they were going to do it again. So here's the CTA. Dr. LaSala and Dr. Singh are gone, but it kind of looks like the St. Louis Blues hockey symbol there. There's the first part you can see as a on end, and then two perpendicular segments. So it wasn't indeed fractured in two places. And then there was an intramyocardial kind of fluid collection originating from the vessel, as per our CT colleagues. So CTS was, they probably did use the word that Ted would have used, if anyone knows that reference. It would not be, there would be a bunch of four-letter words. So he got additional inpatient hemodialysis, more detailed informed consent, and represented for them for protected PCI, which is mid-LAD and Zilla. So actually with the first angiogram, I took a picture expecting him to need an Impella-supported case, and his iliofemorals were acceptable. There's his LED, we already saw that. Now this is with the guide and the device for the PCI. We did a 175 burr, 3.5 NC, and then open the side branch with a 225. Not the kind of guy we wanted to put bifurcation stents in, stented across 3.5 Zions this time at 18 atmospheres. Oops, I don't know if we saw the final there. Okay, there we go. So a reasonable final result, the side branch head flow. Then went to the RCO CTO, and with the Impella, we try to get everything done at the same time. Couldn't advance initially, had to burr just to deliver a microcatheter. Did a little dilation with we don't have the best guide here, obviously. But still unable to pass the microcatheter distally. Then made an effort to exchange for a rotowire, which was unsuccessful. So put the other, it was actually a fielder wire that did go back there. And we called for the ELCA, but at this patient, I'm gonna put it mildly, strongly requested that the procedure be terminated. So we left the RC there and that's it. So that was the case, also on time, impressed by that. Thanks and congrats to Dr. Sharma, Kinney, and Moran and everyone who participated. Unbelievable speakers, unbelievable cases, unbelievable discussion. Hope to see you all on the boat, and if you have an idea what happened, please find me. Tell me what you think, so thanks.
Great talk, Nitin. You're the best. Thank you so much. Okay, Sophia, who's next? The volume of Sophia is out. Let's start again.
Good. I'm Arthur Reitman. Thanks so much for having me. Sophia, I wish she could have done sort of a better job with that picture of me, but that's okay. We're going to take it. I'm an interventional guy in Atlanta, and again, as always, I'm thrilled to be here. So nodular calcium was referenced several times over the course of the day today, and I'm thrilled to hear that angiography is back, because it's obviously the way that many of us were trained. Intracoronary imaging, obviously critically important, but understanding the angiogram, as we've heard time and time again today, is paramount. So we're going to take a look at coronary at nodular calcium to get a better understanding as to whether we can move through this in an algorithmic way. So just briefly, first case, 61-year-old hypertensive diabetic and dyslipidemic who had an EGD back in April. He has known coronary artery disease and had PCI of the LAD as well as a posterolateral branch in 2019. He has a recent diagnosis of adenocarcinoma, and his medications include Jardiance, metformin, lisinopril, and a beta blocker. Thoracic surgery had requested risk stratification for his therapeutic procedure for a thoracotomy. So, of course, a CT scan was obtained by one of my partners, and on the left-hand side, what you can see is the coronary CTA that demonstrates a stent in the distal portion of the LAD as well as the more proximal portion of the LAD, but dense calcium throughout the proximal and mid portion. The right coronary artery, you can see, has a stent all the way, as we talked about, in the posterolateral portion, but in the mid portion, we just see calcium. So the total calcium score, about 2,000, 2,200, led to a diagnostic procedure, diagnostic catheterization. And as you can tell, the mid and distal portions of the right coronary artery have these dense calcific nodules in the mid portion, which are going to be a barrier in all likelihood to general anesthesia. So at this time, originally the patient was taken off the table and we brought him back electively as he was relatively asymptomatic. You can see this in two different views, and you can see in the posterolateral branch a widely patent distal stent, which is amazing because neither of these nodules were present back in 2019 at the time of original PCI, and yet enough flow getting into the distal portion to maintain distal stent patency. So what did we do? Well, I don't need to take you through the whole thing, but what we did was we took a 1.5 millimeter burr, which is on the left. We then subsequently used a semi-compliant balloon to ensure adequate expansion of that balloon, and then using OCT, which I'll show you in just a second, we were able to take these nodules, these densely calcific nodules, and expand them. We expanded them and placed 2 drug-eluting stents in an overlapping fashion and got what we thought was a very reasonable result. So what was the key to getting this result angiographically? How did we look at this? And the way that we looked at it, as you just saw, you really can't see these nodules by CT scan, not present. Even by the photon counting CT, it will be a real challenge to accrue that kind of data. So you really need to move to OCT. And by OCT, what you can tell is that after, on the left-hand side, you can see that we this was right after rotational atherectomy. You can see the lesion is still tight, that there are some gutters. This is a 1.5 burr. And then on the right-hand side, this is our OCT image subsequent to intracoronary IVL therapy with shockwave, very successfully creating these gutters, these very deep cracks in the calcium that allowed us to then, sorry, it went forward. Let me see if I can go back one. That allowed us to place our stents. So, again, here, this third OCT demonstrates excellent stent juxtaposition, all the consequence of adequate intravascular lithotripsy up and down the mid portion of that vessel. So we can safely say in a situation like this that these were non-erupted nodules, and that the great likelihood is that this was not a lipid core that was below the dense calcific roof of the nodule, okay? Which is really what you need for a vessel like this. I just got these angiograms yesterday from one of my other partners. This is a very different type of calcific nodule that we can study here as well. And I didn't have a chance to put this second case together as a presentation, but I did want you to see that this patient presented with an acute coronary syndrome. So very different erupted nodules, which are infinitely different in terms of revascularization, in terms of rotational atherectomy. In this case, you can see that the nodule at the ostium of the RCA, as well as in the distal portion, in the distal third, is where the opportunity was. And this procedure took some time in order to accomplish the same sort of excellent stent juxtaposition. So the question is, the difference between the types of calcium nodules that we see, what is the etiology, and this was very well outlined several years ago by Alok and Renu Vermani in a 2019 state-of-the-art paper that described the progression of coronary calcium and how we can follow it across histologic examination at autopsy, CT, OCT, and IVUS, Agatston scores, and then clinical outcomes. And it's actually very useful to understand pathophysiologically or pathobiologically where this is emanating from in order to make decisions about the way that we are going to treat these type of nodules. So the erosive calcific disease with speckled calcium in a rare, fairly rare fashion, TICFA, ruptured vessels, the healed rupture that we often see, and then dense fibrocalcific plaque. And you can see the great difference amongst these types of pathobiology, which really leads to great differences in the way that we are treating vessels such as this. Sheet calcium, nodular calcium, all of these things, all of these different subtypes make a great difference in terms of the way that we achieve maximal stent diameter. So, procedural outcomes with lithotripsy in nodular lesions, excellent stent expansion that we're able to accomplish post-lithotripsy. This just presented, this was some of Ziad's data, which is previously known, but adding to the literature over the course of the last few months was the shortcut IVUS sub-trial, which allowed us, as Dr. Sharma alluded to a number of times today, when we do atherectomy, cutting balloon may be adequate. When we do not do atherectomy, then shockwave lithotripsy may be the best way of accomplishing the greatest lumen that we can to avoid neoatherosclerosis and restenosis. So the point being that calcium fracture and injury of the media are two sort of very nuanced and close lines along the spectrum of our revascularization. And our goal to accomplish calcium fracture in order to accomplish stent juxtaposition and the MSA that we're looking for, the downside of that is medial vessel injury, which leads to an aggressive inflammatory response, which Dr. Moreno can tell us about, and eventually neoatherosclerosis and restenosis. So eruptive nodules, as we described, eruptive nodules, very profound and can, with thrombus associated with these over-layering our nodules, can result in an ACS, can result in sudden cardiac death, whereas more stable nodules tend to be angiographically easily identified and treated more slowly, deliberately, and in a more controlled fashion. Coronary CTA in the future, obviously a prerequisite with the Navigate PCI trial and a lot of the work that we're doing, as was alluded to earlier this morning, just like with the structural heart team, planning complex CTO and nodular interventions can really be aided by coronary CTA, but we're not there yet in terms of understanding how to identify nodules. This is an old slide that dates back not quite to when I was a fellow, but Dr. Sharma's sort of his ability to be prescient and show us the real issues with calcification dates back many decades and has made many of us who spent time here better interventionalists when we left Mount Sinai. So again, thank you, Pedro, for having me, and it's always a pleasure.
Well, this is an amazing presentation, so elegant. Dr. Reitman, thank you. Beautiful case. Now, Sophia is going to wake up again. Oh, apparently she went to sleep. Sophia is tired now. We come back to human.
I now invite Dr. Amit Huda, Assistant Professor of Medicine and Cardiology at Mount Sinai and Assistant Program Director for the Interventional Cardiology Fellowship Program. Please welcome Dr. Amit Huda.
Hello, Dr. Moreno. Are you able to hear me clearly?
I couldn't hear you better. You are looking
Okay,
great.
great. And looks like Sophia is fully awake. Yeah, so I'm gonna share a complex atherectomy case, which I did like few weeks back. So regarding the patient, she was 84-year-old female with moderate AS, and she presented with generalized fatigue and dizziness. And when the ampere was performed on her, it demonstrated a moderate to large ischemia in LAD territory. And we did a cath and we found calcific left main, ostial LAD, and ostial circ disease. Her echo was normal LV function and moderate AS, like I mentioned, and valve area is 1.5. So we had a extensive discussion along with our surgeon, including the patient, if she wants to go for a CABG plus AVR or like maybe just a PCI now and followed by a tower in few years. So that was the plan, and the patient inclined towards going for a PCI. As you can see in this cath pictures, on the right side there's a minimal disease, and on the left side cath you can really appreciate the kind of calcium she's having at the ostial LAD as well as the ostial circ. So we went ahead a femoral access 7 French, and the plan was to treat it with rotablation to begin with both the vessels, and then plan a bifurcation stenting using a mini crush technique. So 1.5 rotabur was chosen because I thought like we can use the 1 burr in both the vessels, and circ I didn't want to use a very large size burr in this case. So 1.5 rotabur went fairly well in the LAD, and there was no dissection. So then I just used the same rota wire and wired the circumflex and used the same burr. In case if there was any major compromise in the LAD, then I may have left a wire along with a guide extension and then may have changed to a 125, but that was like our backup plan. And then the circ rotablation went really well, and I used a 3.5-15 high pressure balloon around 18 atmosphere to dilate that ostial circumflex lesion. And as you'll appreciate in these pictures, so we dilated the LAD as well as the circumflex, but with this 3.5 high pressure balloon, you can notice a little perf, which is you can see in the cranial picture, but it's hard to see whether it's coming from left vein or circumflex. And when we took a caudal picture, we can clearly see it's coming from the proximal circ. So at that moment, we thought it's a small perf, maybe it will seal off with a DES also. Sometimes it happens instead of putting a covered stent at that area because it entails higher risk of thrombus and restenosis. So I deployed a 3.5-23 DES, and still we can see a little extravasation, and so we did a prolonged balloon occlusion around 15 to 20 minutes, but still it was the leak was still there. So finally we had to deploy a covered stent. We used a papyrus, and then after deploying the papyrus, we post dilated it at high pressure 1:1 so that it really opposed to the vessel wall. And then I deployed the stent in the LAD. We performed the final KBI, and as you can see in these final pictures, it's almost gone. Though you can see in the caudal picture, there may be a very minimal leak. So just to make sure that nothing is going on, we got an echo done in the room, and there was minimal effusion. Patient was hemodynamically stable. So we planned to just observe the patient closely in the CCU instead of placing any other covered stent. And she did really good and remains stable with no symptoms and got discharged after 24 hours. And she came recently for a follow-up, and she did really well. So the key takeaways, yes, appropriate rotabur selection is really important, especially in this very angulated and calcific circ. And this vessel was huge, so 1.5 was a reasonable choice. The coronary perforation can be catastrophic, especially in the eccentric calcific lesions, and you have to really identify it in time, otherwise it can be too late sometime. And covered stent should always be immediately available when you perform all these high-risk procedures. And always tend to avoid aggressive balloon or stent oversizing, particularly in lesions with severe eccentric calcium or nodules. Like in this case, the circumflex was having a very calcific lesion, and with high pressure balloon also, that calcium nodule just perforated the vessel. And that's all. Thank you, Dr. Moreno. And
You're very welcome. Fantastic presentation, beautiful case. Okay, Sophia.
I now invite Dr. Samir Mehta, chairman of the Lumen Foundation and a global leader in STEMI and AMI systems of care. Please welcome Dr. Samir Mehta.
Thank you, Sophia. So sometimes clinical trials don't really help us. This is one such example. A single trial has given us some very confusing messages, and I hope that before it reaches anywhere near the guidelines, it would be investigated much further. I'm talking to you about the Proctor trial, and here it is. And I've many problems, many issues with it. I don't even know if these would be exactly the practices in the United States. Totally European trial, 14 centers there, 220 patients, comparing patients with the PCI of native SVG versus native coronary artery versus SVG. And on the right hand in the result, very strange, disturbing statistics, but you know, it's a well done trial. A MACE rate of 34% with native PCI, 6% all-cause mortality, 13% PCI-related MI, 18% revascus, I guess okay. And as opposed to it, SVGs do all better. That does not seem to be what I have been doing for 38 years now. I think SVGs are truly one of the most challenging cases. And in preparing for this talk, I said, okay, hold on, let's try to make it abundantly clear what may be the issue here. So here is I have no idea why this is not running. Okay. Cannot play. Wow. I just checked it outside and it was playing. Danny or your group?
You can tell us, Dr. Mehta, more or less.
So basically this is two vein grafts. One is recently placed with the focal stenosis, 10-minute case, a single stent, perfect result. The second is an 18-year-old diffuse degenerated vein graft, and the angiojet wasn't available, and I tried everything, filter wire, aspiration, everything, and the post result is worse than the pre. And this is you truly have to appreciate, diffuse degenerated vein graft, and therein lies this particular message, which I think is the essence. Not all SVG are the same. They're not. You know, once you have somebody presenting fairly early, something discrete, straightforward, that's a totally different ball game than a diffusely degenerated vein graft. So without going into these details, trying to analyze the aspects of the Proctor trial and their recommendations that let's abandon the strategy of going after the native and try to chase some of these saphenous vein grafts almost in an exclusive manner. So here are some of my recommendations, and besides that, let's review for a moment how should you be approaching SVG. So people in training, if you're doing a lot of STEMI, I can tell you this is a tested technique for almost 26 years of doing STEMI. Whenever you have a patient with a previous vein graft presenting with the large acute MI, chances are it is going to be the vein graft to the right. Most of these patients have a lima. LAD is going to be okay. Hardly ever do you see a patient with the vein graft to the circumflex presenting with the large. So most of the time it's the right to use a multi-purpose guiding catheter to start with. I think if I have one single catheter, give me a AL1 and I'll get you every vein graft. I'll be able to treat it, including the downward facing the right coronary artery for which we use the multi-purpose. Distal emboli protection devices, despite their guidelines, although they have been slightly degraded, my issue is one of, I'm quite ambiguous about it. We'll probably use it in the second case which I showed you, the diffuse degenerated but straightforward discrete lesions. I don't think you need it. My best, and this is the double whammy today which I'm facing here, and which I want to convince all of you are going to be facing. My best 5 STEMI cases each year in the last 25 years have always been saved with the AngioJet. An absolutely fantastic device, and to make our life miserable, it has been withdrawn from the market. So we don't even have the AngioJet now. There wasn't enough sales for it, and Boston Scientific is no longer making the coronary angiojet. I thought this was a Miami phenomena, but I just confirmed it right here at the meeting. So there you are left. Now, the penumbra is a good device, but believe me, it is not the mechanical thrombectomy, the aspiration which is possible with the angiojet. I have always advocated, this is again for STEMI, I'll show you in a moment, but I think it is applicable to large, to vein grafts as well, what I call it a thrombus grade guided management strategy. And of course, this is pretty simple, that if there is one situation you don't want to overexpand the stent, you will only cause further distal embolization, is to use a high pressure balloon for stent expansion. And it was probably for that purpose we used to use a lot of the self-expanding wall stents in vein grafts before. And of course, the last part, probably the most important, is abundant use of intragraft vasodilators. So this is what I've been practicing for STEMI. It may help you to have this kind of an approach for SVG also. One shot, one single angiogram, you're able to determine the thrombus grade. No grade, you could probably directly stent, which is quite rare in a vein graft. Something more than that, aspiration, and beyond that, which used to be angiojet, your probable best opportunity now is the penumbra. When you're approaching anything with the slow flow, no flow, rule out a mechanical cause, and there are some tips and tricks here of using the filter and aspiration thrombectomy, which this is a published chart. I think on the right-hand side, the technical tips of use, I think you'll find it very useful. The most important lessons I have learned while using the angiojet is that often you're not going through the entire length of the disease segment until you're able to do that. Often what happens, the challenge is that if you haven't done enough of these cases and at 3 in the night you have a large STEMI with a large RCA, you're a little concerned trying to advance it all the way distally. It tracks very beautifully, easily 6 French compatible. A lot of people even do it radial cases. I have not. But this discussion may be only historical now that this device is not available for the coronary application. Pharmacological management, 3 drugs listed at the bottom: nitroprusside, adenosine, verapamil. My favorite, always a default, has been nitroprusside, just because I have used it all along. Always better to use it through a microcatheter. You deploy it, deliver it distally. But believe me, I have also used it often through the guiding catheter. As high a dose as the patient can tolerate. Patient gets a little hypotensive. I use neosynephrine without any consequences. What is my take-home message today? In the environment where the Proctor trial, I sincerely believe, has probably wrongly guided us towards going for saphenous vein graft as opposed to doing native coronary arteries. I think SVGs are the absolutely true type 3 lesions. I mean, you need to approach all of them with humility. They will all cause distal embolization, and if you're not careful with your thrombectomy technique and with using vasodilators, you will pay the price. It requires clinical judgment. I think straightforward, discrete SVG, I think treat them exactly, and that is where I suspect the Proctor trial had a lot of these. I have no issue whatsoever. A lot of these can be stented. DS, I think, is a good possibility. I don't think there is too much data so far from drug-coated balloon, although possible, just that they are often of a 4.5 and 5 millimeter in caliber. Differentiated strategy, once again, focal SVG I think is a good idea, but that second case, degenerated SVG, I would any day look into the possibility of opening the native coronary arteries, even if it is a CTO. And the last part is be compulsive about thrombus management and using intra-graft vasodilators. Thank you.
Thank you very much, Dr. Mehta. Wonderful review for the graft versus the native. Now we have one of my best fellows ever, who now is a director, Dr. Parasuram, but AI, Sophia, does it better than me.
I now invite Dr. Parasuram Krishnamurthy, Director of the Structural Heart Program at the University of Oklahoma. Please welcome Dr. Parasuram Krishnamurthy.
Thank you, Dr. Moreno. I think the AI did a great job. Tough one, but Sophia did great. I want to pitch, like everyone, thanks to Dr. Sharma, Dr. Kinney, and Dr. Maran for this kind invitation. It's always great to come back to Sinai. So in the next few minutes, we're going to discuss AS and CAD, which to treat first. If at all you need to treat the CAD. These are my current disclosures. The outline of the talk is we're going to go over a case and then review the challenges that we have in managing CAD and AS and what current evidence that we have in terms of guideline recommendations. Case is a 79-year-old male who was transferred to us from an outside hospital for acute hypoxic respiratory failure. He had all the traditional risk factors, biventricular dysfunction with a left ventricular EF of 30%, moderate to severe MR. He also had, unfortunately, his status post AKA, which is because of a neck fash. And his hypoxic failure was predominantly because of a tracheal stenosis that was seen on a CT scan at the outside hospital. So initially he underwent the tracheal stent with interventional pulmonology, and then he had cardiac evaluation because he had an NSTEMI with a troponin of 3,053, and these were his other labs. These were his medications, which was guideline-directed medical therapy, and his EKG was pretty unimpressive except for non-specific STD changes. And his echo, which we'll review in the next few slides, showed an EF of 30%, severe low-flow, low-gradient aortic stenosis, moderate to severe MR, and moderate pulmonary hypertension. These are his echo images. You can actually see the leaflets are densely calcified, not a lot of AI, moderate to severe MR. There's some limited excursion of the leaflets, but dense calcification and severe MR seen on the two-chamber view. So valve area by different modalities is almost severe, or you can actually, by definition, say severe is VTI, and velocity valve area was less than 1 centimeter square. And these were his severe MR from different views. And this was his coronary angiogram. So he actually has looks like a subacute occlusion of the prox RCA. There might be some bridge collaterals, which has faint antegrade filling of the distal vessel that you can see that goes here, but it's not very clear. And this was his left system. He actually has a 90% occlusion and a subtotal occlusion of the prox LAD and big ramus. So he actually has just a circumflex that is off and also a subtotal OM2 or distal circ that you can call. And we can clearly see left to right collaterals from the septum, from the left to the right, which makes it wonder that the RCA is probably a subacute to chronic occlusion. And we took him off the table, of course, and then he also got a CT scan to evaluate his aortic valve. So his aortic valve was trileaflet, his calcium score was 1926. All his other parameters were feasible for a short frame, balloon expandable transfemoral TAVR, and peripheral anatomy was appropriate as well. So he was discussed in our heart team meeting, and his operative mortality STS score was 6.9%, which is intermediate to high, but still with all the risk factors, frailty, poor baseline status, low EF, he was deemed very high surgical risk by our surgical team. So in summary, we have a 69-year-old male with traditional risk factor, severe biV dysfunction, frailty, and comes in with an NSTEMI, decompensated heart failure, and also now found to have severe 3-vessel CAD and low flow, low gradient severe aortic stenosis, who's deemed not a surgical candidate. So what are the next best steps that we have? Continue medical therapy only, high-risk CABG plus AVR, which is deemed out, transcatheter approach, PCI plus TAVR. If transcatheter approach, PCI followed by TAVR, or TAVR followed by PCI. If TAVR followed by PCI, was it in the same index procedure or at a delayed time? Options for MCS, and a hybrid surgical percutaneous approach where you say you fix one and the surgeons fix another one. Or finally, unfortunately, no options, palliative care. So we went ahead with PCI approach first. For this patient, we got a vein, the right heart cath was done, which actually showed severely decreased cardiac output and cardiac index. His index was 1.8. And so I actually upfront went with an idea of doing some kind of MCS. If I'm able to actually do an impeller, that'll be great. So I did two precloses. Even if it fails, the impeller doesn't go in, then we have a balloon pump that we can do through a 9-French system. And thankfully, the impeller was actually not so hard to get in. It was a little bit struggle, but not so hard. And these are our pictures now. So our strategy was just to fix the LAD and the ramus. And since the RC is well collateralized, and since there's a lot going on, we wanted to do a minimal approach. We did a atherotomy and a drug-eluting stent for both, 3.5, and we posted with the photo. And this was ramus. And this was the final picture here. So the LAD PCI and the ramus PCI went out fine. And we can see that the distal circ subtotal is also obvious, and the collaterals from left to right, you can actually see it obviously. So impeller was weaned off in the cath lab, and the patient was discharged day 2 after the PCI. And he was followed up in the valve clinic last month, and he's coming back for a transfemoral TAVR in 2 weeks for a 26 sapien 3 Alto Resilia valve. So the next few minutes, I'm going to go over what are the challenges we have in management of CAD with AS. Unfortunately, they happen more often, and we all know that in the era of complete revascularization, we believe that that reduces the risk of procedural MI. This is true without a valvular heart disease, but we also know that coronary access and reaccess could be challenging, especially when you have a prosthesis across the coronaries. And the other clinical challenges, it's hard to differentiate the symptoms, whether the symptoms are coming from coronary disease or from the aortic stenosis, as there's a significant overlap. And routine ischemic workup for CAD is very variable in pre-TAVR patients. Some of the programs do TAVR CTA and try to use that to assess your coronary status. And some of the programs are limited in doing that. And sometimes your anatomy is limiting because you have significant calcium on the coronaries and you can't really assess your percentage stenosis. And you have to now left with the tough choice of selecting patients for routine invasive coronary angiogram prior to TAVR. This is very important, especially since now we're expanding TAVR to low-risk young patients, so you don't want to take a chance and offer TAVR in someone who may have significant CAD. So if you look at this, pros and cons of balancing differing PCI before TAVR or PCI first, the pros of differing PCI is you decrease the bleeding risk because you're not going to subject these patients to DAPT. The periprocedural MACE is questionable. There's a theoretical chance that after the TAVR, if they have significant CAD, they may have significant MACE. They may or may not be able to tolerate rapid pacing with critical lesions during your TAVR. And also, we don't really know when to do these PCI after the TAVR. If you look at the PCI first strategy, you know that since you're fixing these ischemic lesions, your mid to long-term MACE outcomes are lowest, but it also puts you at a little bit of a risk of post-procedural bleeding because these patients need DAPT. And of course, more procedures, healthcare burden, and cost. And we don't know what to deal with this AS when we do the PCI, especially if the PCI requires extensive debulking. Do we need to do a BAV, or can we actually bail out just doing the PCI without a BAV? And if you need an MCS in patients with severe AS, you have those challenges as well. The absolute contraindication of doing any MCS through the ventricle is if you have a valvulity of 0.6 centimeters square or less. Can consider BAV, but if you do BAV, you may worsen or cause AI. And there's a technique called shoehorn technique where you have a gentle balloon inflated across the aortic valve, and as the balloon is inflated, you actually push the impeller down underneath, like how you push using a little bar to put your shoes in. So that's a shoehorn technique. And how access for PCI, single access, if you do impeller, will that be okay? And duration of LV support, we don't know. Can these patients safely come off impeller, especially with AS after you have done a lot of coronary work? And the other option is doing PCI and TAVR at the same time, which we don't do it in the US for financial cost burden and increased burden for the patient as well. And other MCS options are also options. So we have very limited evidence. So in the next 1 minute, I will go quickly through what evidence we have. So there's actually 3 randomized trials which have looked into it, and 2 of them are very recent. The Notion 3 trial, which came last year, showed that if you do PCI guided by FFR in these patients with severe AS prior to the TAVR, your 2-year MACE outcomes are actually lower compared to the patients who went to TAVR without a PCI. However, these patients who got the PCI got increased bleeding risk. And in that context, the PRO-TAVI trial, which is one of the late breakers in the ACC, where they randomized patients into deferral of PCI and PCI before the TAVI group. What they found was there was no significant difference. It was not a non-inferior strategy. It was significant for that. However, it was also not superior. So doing deferring PCI and proceeding with TAVR was not non-inferior. And that's from a primary endpoint, composite standpoint, and also from the ischemic standpoint, it remained the same. And there was no significant difference within any single individual outcomes in the composite endpoint. However, in the bleeding group, as one may expect, in the patients who got the PCI, there's an increased risk of bleeding because these patients are subjected to DAPT. And what is our current guideline recommendation? The 2020 ACC is what we have the latest, and we're waiting eagerly for the guidelines from ACC coming up soon in the next few months. It's a class 2A. And the recent guideline from 2025, if you actually have a more than 90% coronary artery stenosis with a diameter vessel of 2.5 millimeter or more, and it may be reasonable to consider a PCI first. So take-home messages. CAD is very oftenly seen in patients with severe AS, almost about 50% of the time. Routine PCI can be safely deferred if there's no left main or significant proximal CAD. You have to have a patient-tailored approach, assessing the bleeding and ischemic risk, not just the coronary anatomy, but also the annular anatomy for TAVR, especially small annulus, choice of one valve versus other. Example, choice of a long frame self-expanding valve, which makes coronary access challenging compared to a short frame balloon expandable valve. And lifetime management is very important, especially since we are offering these to low young risk patients. Thank you for your time.
Beautiful.
Okay, thank you, Parasuram. Dr. Kinney wants us to go to room 2 actually.
And do the case and then say bye-bye.
Yay.
All right. I know you are on there before we give our raffles here out.
No, first and foremost, how was the AI assistant? People have used the AI assistant. Any comments?
Those who did the 2 cases, remember?
Yeah.
Anybody, any input on that?
So we know that more than 50 people use it.
Good.
So raise your hand who like it. Yeah, we have several hands. Complete success, Dr. Kinney.
Excellent, excellent. Okay. Next year we'll be doing more and more.
Although your Sophia had a lot of controversy.
No, I told you, you need to embrace and, go with the flow. Don't stay away from it. Yeah, embrace AI. Okay, so 64-year-old patient, if you see that, diabetic hypertension, has had prior PCIs, and we're going to show what we see. So the right coronary artery, which has had PCI, looks okay. So LAD itself, PCI area looks okay, but if you see that, ramus is fine, but this circ lesion was something new, which is ostial circ and then OM1. After that, you see distal circ that is total. The question would be that do we do something about it or leave it on a small vessel? So what we decided to do was just take care of the ramus and the proximal circumflex. So the question is, how would we tackle this situation? Various options: cutting both area, stent one, and leave it alone, versus use DCB in one arm, stent in another arm. So I think we'll just say what we did. We just did a cutting balloon in both the arms. Okay, 275. We went real high pressure. And what we like to do is, if we decide to do DCB, you go back with a regular balloon, go with a nominal atmosphere and leave it for 2-3 minutes. That's what we did. Then we did there's a cutting balloon there. Then we left the DCB, which is for at least 1 minute. If you see there, 3 or 20 DCB. And this is the final result.
Very good.
Now, before we say, we have all the fellows outside, right?
While you are gathering your fellows, let me give, they're coming, take a few minutes.
Yay.
So, as we usual, we get some
We
raffles
saw
here.
you.
Yeah. Those who went to the booth, there are the Amazon raffle, the Amazon gift card of $250. And they'll go to, one is Dilasha Kumanaya. Beautiful.
Oh, bravo.
Okay, Dilasha from Morningside, right there. Then second is Angela Townsend from Jamaica. Okay, so they are going to you'll get a $250 Amazon gift card. They are not ready yet. Okay, with that, we want to give something a little memorable, iPad Pro. Okay.
Wow.
Now, the rule is person has to be here. And I'm going to ask now Pedro to pick up one.
Yay.
All right, pick up one.
Got it.
Good. Look for the last 3 numbers, 3 digits. I think that should be good enough.
588. 588. Not here. 1,
Good.
2.
Let's go next one.
Okay. The next one is 609. Yes.
609. Let's come. Okay. All right. What's your name? 2G from where? All right, from Mount Sinai.
Yes,
2G.
Susi.
Fantastic. Which one is yours? Huh? Oh, yeah. So that will be mailed. So they will mail it. We have all the information with a mailing address or so. They will mail apparently the gift card, right? Gift card will be sent for $250. Why 588 just woke up? Go on, my friend, we'll figure it out. From our side, we are done. There is only one left. Bye-bye. Okay,
the fellows.
All right, Anu, with you now. All right, guys, go back. Good.
Okay, if you see here,
Yeah.
this is the new era. We actually have an army of fellows with us. Okay, between the peripheral, IC, structural, peripheral. But in the new era, looks like only attendings stay here. All the fellows are gone. I can't find them anywhere. Yeah, we only have a couple of them left right here. We have Swati
Yes, we have Gaurav, who is structural, and Sabina, who is an interventional fellow, but then she's going to stay as a structural fellow. And we just want to say thank you from us and our attendings that helped me and Dr. Sharma. Amit was mostly with Dr. Sharma. We had Joe Sweeney, who is always with me, the duo here. And this time we had a new person, Isha, who actually helped us in that very tough RCA. Remember Pedro Moreno? What did you say about that RCA case? Yeah.
They go.
And we'll.
Beautiful. All right. With that note, we'll
if anybody want the KTT cap, we have our KTT member who is wearing the KTT cap here. Okay.
Okay.
Thank you very much, and we'll see
Fantastic.
you next year.
Okay, just a few housekeeping time. Now, I think the boat probably will start by, because time is Kim or anyone, probably around 7:15, 7:20. You have enough time to get to it. Second, next year, Juneteenth is on 19th June, but will be celebrated on 18th. So we will be again on Thursday, June 17th, 2027. 16th our NurseTech Symposium, and 17th is the same. So one day early, because the Juneteenth will be celebrated on Friday. Now, year after, Juneteenth will become on Sunday. Remember, it go by one day. So that when they will celebrate, we do not know. Hopefully they don't celebrate that time on Friday, maybe Monday. But that will be again, but next year we want to just make sure, hope it will be right here in Marriott Marquis on June 17th, 2027. With that, thank you all my faculty who came internationally and locally and nationally, and all the audience at 6 o'clock. It's still good amount of people, fantastic. And the whole purpose was to teach. Everybody learn, take to their practices, and you saw how those tough cases, we made them simple. And I always say the rotational atherectomy makes tough case or complex case simple. And that's what we showed it today. Thank you very much.
One